So let's discuss the next topic now after the lunch break. And the next topic would be lateral wall of nose. Let's start the next topic, lateral wall of nose. Very, very important topic now. And lateral wall of nose has got a couple of things to understand. Now, first of all, what is the lateral wall of nose? When I say lateral wall, first of all, you tell me what is the medial wall of nose. Everybody. What is the medial wall of nose? This one, beta. What is the medial wall of nose made by septum? Medial wall of nose is made by septum, beta. But what I'm not going to talk about the medial wall as of now. Medial wall I'll do later on. I'm going to talk to you about the lateral wall first. This wall, beta. So lateral wall, if you see over here, it has got many projections. Can you see projection here, and there is another projection here. These projections are called turbinates, beta. Turbinates. Now look at the first thing in your notes. Lateral wall of nose has got few things. What are the few things? Number one, it has got a turbinate, beta. Just write down one thing. It has number one turbinate. It has number one turbinate, beta. Number one is turbinate. What is turbinate? Turbinate is a projection on lateral wall of nose. I told you lateral wall of nose has got a few projections, and these projections are called turbinates. And turbinate means the lateral wall is not smooth wall, it has got some projections, and those projections are called turbinates. It's a projection on the lateral wall of nose. There are three turbinates, beta. Inferior turbinate, middle turbinate, superior turbinate. IT, MT, ST. IT, MT, ST. Everybody speak with me, beta. There are three turbinates. Which are three turbinates? What is a turbinate? First of all, turbinate is a projection on the lateral wall of nose, and there are three turbinates: inferior turbinate, middle turbinate, superior turbinate. Inferior turbinate, middle turbinate, superior turbinate, beta. Am I clear? Now, IT, MT, ST. Now, every turbinate has a bone inside that, beta. And that bone is called the concha. It's a bony part of turbinate. Concha is a bony part of turbinate. Okay. Every turbinate has got some bone inside that, and that bone is called concha. And how many turbinate we have? Three. Speak up with me about three turbinate. Inferior turbinate, middle turbinate, superior turbinate. Every turbinate has got some bone into that, and that bony part of turbinate is called concha. So, of course, there are three concha. Inferior concha, middle concha, superior concha. Okay. Now, inferior concha is an independent bone. It's not a part of any bone, beta. Write down MCQ, beta. Anatomy question. Which concha is an independent bone? Inferior concha is an independent bone. It's not a part of any bone, beta. Inferior concha is an independent bone. It's not a part of any bone, bache. Inferior concha is an independent bone. It's not a part of any bone, beta. Okay, bache. Fine. Inferior concha is an independent bone. It is not a part of any bone, beta. When I say independent bone, you got two tibia. Yes. Two fibula. Yes. Two femur. Yes. Similarly, you got two concha also. Inferior concha. Okay. But middle concha and superior concha are part of ethmoid bone, beta. Superior concha and middle concha are part of ethmoid bone, beta. Okay, am I clear, beta? Superior concha and middle concha are part of ethmoid bone, beta. Okay, bache. So my concept is very clear that turbinate is a projection on the lateral wall, and the bone within the turbinate is called concha. There are three turbinate: inferior turbinate, middle turbinate, superior turbinate. Within them, there are three bones called inferior concha, middle concha, superior concha. And inferior concha is an independent bone, but middle and superior concha are part of ethmoid bone. You will say, Rajiv, show us where they are. Where they are, na? Now let me show you first of all the skull, beta. Let us see the skull. From skull, it's better for you to understand. Now please see, this is human skull. Okay. Now this is your lateral wall of nose. Everybody clear? This is your lateral wall of nose. Lateral wall. Can you see lateral wall? Lateral wall of nose. Now on the lateral wall, if you see, can you see this one, beta? This is inferior concha, beta. Can you see? The lateral wall has a bone over there. This is called inferior concha. Okay, concha. Now please look at screen, beta. Now please see, if concha is covered by mucosa, it becomes inferior turbinate, beta. Okay, concha plus mucosa is turbinate, beta. Okay, once again see, beta. This is inferior concha as of now. But if I cover this inferior concha with mucosa, it becomes turbinate, beta. Concha plus red mucosa is equal to turbinate, beta. Am I clear, beta? Is it clear to everyone? Very good. So concha is clear, turbinate is clear. So this is turbinate. Inferior turbinate is in that inferior concha. So middle turbinate, middle concha. Superior turbinate, superior concha. Very good. Now, can you see, beta, over here? You can see there is some space below the turbinate, beta. Every turbinate has got some space below that, if you see. Now, this space is called meatus. Next topic, meatus, beta. Write down. Next one, beta, meatus, beta. Meatus. Now, meatus is the space below the turbinate, beta. Meatus is the space below turbinate, beta. Meatus is space below turbinate. How many turbinate we have? Three. How many meatus we have? Three. Okay. Inferior meatus, middle meatus, superior meatus. Look at my hand, beta. Look at my shoulder. This is inferior turbinate. This space is called inferior meatus. Middle turbinate, space below middle turbinate, middle meatus. And so superior turbinate, superior meatus, beta. Okay. Now, one fourth thing, beta. This is number 3, beta. Number 1, number 2, number 3. Number 4. Number 4 is sphenoethmoidal recess. Sphenoethmoidal recess, but S-E-R. S-E-R, beta. Sphenoethmoidal recess. It is area above superior turbinate, beta. It is area above superior turbinate. It is area above superior turbinate. It's area above superior turbinate, beta. Area above superior turbinate. Okay, okay. Now everybody draw a diagram with me, everyone. All of you draw a diagram on the side with me. Please draw lateral wall of nose. All of you draw a diagram with me, lateral wall of nose, everyone. Okay. This is the septum. 3 turbinate on one side, 3 turbinate on the other side. This is the lateral wall of nose. Okay, bache, lateral wall of nose. Okay. Let us label it, my dear friends. IT, MT, ST. IM, MM, SM, SER. IM, MM, SM, SER. Very clear, beta. IM mane inferior meatus. MM mane middle meatus. SM mane superior meatus. And what is SCR, beta? Full form of SCR is sphenoethmoidal recess. SCR is sphenoethmoidal recess, and this is area above superior turbinate, beta. Sphenoethmoidal recess, it's the area above superior turbinate, beta. Am I clear, beta? Fine. Everything is what, beta? This is what a lateral wall, lateral wall, lateral wall. Okay. You will say, Rajiv, this is okay, but what about the actual anatomy, beta? This is the line diagram, is very easy to make. Let us see the actual anatomy inside the nose, beta. How does that look like, beta? Okay, first of all, this is the endoscopic setup, beta. This is the endoscopic setup, and let me go to the, where are we, beta? We are actually having a cadaver here. This is the endoscope, and then we are going to enter the nose from here, beta. Okay, which side of nose we are entering? Left nasal cavity. Look at ऐसे, either left nasal cavity. Okay, now please focus on the beginning, beta. This you are entering the left nasal cavity, beta. Okay, left nasal cavity. Can you tell me, if this is left nasal cavity, what is this wall? This wall is septum, beta. And this is the lateral wall of nose. Septum, lateral wall of nose. On the lateral wall of nose, we would see some projections called turbinate, beta. Let me show you turbinate, beta. Can you see over here? This is the lateral wall of nose. This is the projection over here. This projection, beta. This is called middle turbinate, beta. This is middle turbinate, and space below that is called middle meatus. Please see, this is septum. This is lateral wall. Lateral wall has projection. One projection visible here is middle turbinate. This is middle turbinate, and this space is called middle meatus. Okay. Now, let us see further, beta. Can you see inferior turbinate, beta? Again, lateral wall of nose. This is middle turbinate. This is which turbinate? Inferior turbinate, and space below that, this is called inferior meatus, beta. Am I right? Inferior meatus. Let's go further. Now, this is inferior turbinate, inferior meatus. Now I am going to go like this, beta. Please see. I am going to take the endoscope to the end of the nose, beta. End of the nose, till the end of the nose. And when you will go along the endoscope, with the endoscope, you go to the end of the nose, you will see turbinates are running all along the length of nasal cavity till the end, beta. Inferior turbinate, you will see till the end you will go like that, beta. Let us go till the end of the nose, beta. I'm going deeper and deeper in the nose like that. Endoscope, 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 endoscope. And then suddenly the nose ends over there, and there's an opening over here. This opening is next part of your nose, beta. Everybody see your note, beta. The next part is choana. Everybody look at the next part. Choana is the posterior opening of nasal cavity. This is choana. Everybody look at your note, beta. Choana, not concha, choana. This is choana, beta. C-H-O-A-N-A. Choana is the posterior opening of nasal cavity. Am I clear, beta? Choana, this right now in front of you is this opening. This is choana. Choana is the posterior opening of nasal cavity, not concha. Concha is the bony part of turbinate. Choana is the posterior opening of nasal cavity. Choana is the posterior opening of nasal cavity, beta. Choana is the posterior opening of nasal cavity, beta. Am I clear, beta? Fine. Fine. Okay, fine. Chalo. So concha is clear. Choana is clear. Fine. Concha is clear. Choana is clear. Everybody clear? Now let us start the next disease, beta. Before we go there, let me show you one more video, beta. Everybody, what is this turbinate? Inferior turbinate, beta. Can you see there's a bone in that when you move it? That bone is called inferior concha. And when I put my endoscope here, I am entering the inferior meatus, beta. Once again, beta, this is the inferior turbinate on the lateral wall of nose. The bone in the inferior turbinate is called inferior concha. Concha. Can you see the haddi is moving? When you enter the endoscope over here, this is inferior meatus, beta. So clear? Turbinate, concha, meatus, choana, sphenoethmoidal recess. Concha and choana, don't confuse. Concha is the bony part of turbinate. Choana is the posterior opening of nasal cavity. Am I clear, beta? Fine. Chalo. Let's go further, beta. Right. Next one, beta. Next one. Next is choanal atresia, is a star topic of your paper, beta. Pediatric or ENT both. Now I know what is choana. Choana is the back opening of the nasal cavity. Anybody will tell me what lies behind choana? Naak ke piche kya hota hai? Nasopharynx. So behind the choana is the nasopharynx, beta. Sometimes this choana is blocked. Choanal atresia, it's a congenital disease due to persistence of bucco-nasal membrane. It's a congenital disease due to persistence of bucco-nasal membrane. It's an embryological error, beta. Now, bilateral complete choanal atresia is a neonatal airway emergency. Bilateral both side, complete choanal atresia means choana is completely blocked in some neonates, beta. But this is an airway emergency in a newborn child. Why? Write down why. Write down. Because neonates are obligatory. Neonates are obligatory nasal breathers. MCI question, beta. Because neonates are obligatory nasal breathers. Because neonates are obligatory nasal breathers, beta. Obligatory nasal breathers. This means what, beta? How many ways you know of breathing? 2 ways. Nose, mouth. Sometimes you get cold, your nose is blocked, and you can breathe through the mouth. You can breathe through the mouth also, no? You know an alternative way of breathing. But the newborn baby, which came just out of the mother's womb, only knows one way of breathing, and that is a nasal way, beta. Neonates are obligatory nasal breathers, means they only know one channel of breathing is nose breathing, beta. They don't know they can keep the mouth open to breathe and survive also. Okay? So what are the babies delivered? Immediately after birth, because both side choana is blocked from behind, beta. This is bilateral, complete choanal atresia. So this baby right after birth, the blue baby is there, beta. Blue baby means the Sinuses. But as the baby cries, for crying, he has to open the mouth. When he opens the mouth, he has inspiration. The oxygen goes inside, suddenly the baby turns pink, beta. But when the baby stops crying, again the baby turns blue. So blue baby turns pink on crying, beta. Blue baby turns pink on crying is the classical MCQ of pediatric, beta. Blue baby turns pink on crying is the classical question of the pediatric. Oh, right after the birth, the baby is Sinosed. But the moment baby cries. To cry, the baby has to open the mouth. Okay, the blue baby turns pink on crying is a classical indication of the question of choanal atresia. Now, immediate treatment. Immediate treatment is put wide bore nipple in child's mouth, beta. Beta, please see, think like a doctor, beta. Think like a common sense person even, beta. You want to keep the mouth of the baby permanently open, beta. You want to keep the mouth of the baby permanently open. Look at screen, beta. How would you keep the baby's mouth permanently open? You would put a wide bore nipple in patient's mouth or child mouth. Can you see newborn baby? You just put a wide bore nipple in child's mouth so that the mouth is open, beta. Okay? This will be the life-saving thing for the child, beta. This is a newborn baby just delivered, he may die actually. If you put a wide bore nipple or an oropharyngeal airway, like this, beta. If you put the wide bore nipple in child's mouth or oropharyngeal airway, this will save the baby, beta. Okay? Now write down, beta. Come back to the notes, everyone. Okay, put wide bore nipple or oropharyngeal airway or oropharyngeal airway in child's mouth. Oropharyngeal airway in child's mouth. This will save the baby, and this is called McGovern's technique. Very, very important question. Already came in MCI, beta. Choanal atresia is an important topic, beta. This is called McGovern's technique. When you put a wide bore nipple in child's mouth, this is called McGovern's technique, beta. McGovern's technique. McGovern's technique, beta. Okay, bache, fine. Okay, now what to do next, beta? This is save the baby, fine. After that, put an arrow. After that, you do what? You do tracheostomy. Then you save the baby tracheostomy. Immediately, within 1 hour, you do the tracheostomy. First, right, you are a pediatrician, you save the baby by putting a wide bore nipple in child mouth. You call the ENT people, they do tracheostomy. Then surgery, corrective surgery at 1 year of age. Surgery at 1 year of age. Surgery at 1 year of age. Okay, bache. Whatever, you have to make a hole in the choana, you have to do at 1 year of age. Let us revise choanal atresia. First of all, what is choana? Choana is the posterior opening of nasal cavity. Sometimes this choana may be blocked since birth, and that is called choanal atresia. Choanal atresia is an embryological problem, congenital problem. It is due to persistence of which membrane? Bucco-nasal membrane. Okay. But problem is bilateral complete choanal atresia is a neonatal airway emergency. The child may not survive for even 1 hour because neonates are obligatory nasal breather is MCI question. Classical pediatric question will be blue baby turns pink on crying. You know, because the baby is cyanosed, but as the baby opens the mouth to cry, the oxygen goes, lung and heart are normal, the baby turns normal, actually, pink. But the moment baby stops crying, again turns pink. Beta. You want to make sure that the patient child's mouth is permanently open. So what you do is put a wide bore nipple or oropharyngeal airway in child's mouth, and this is called McGovern's technique. Important question, very important question. After that, you do tracheostomy, save the baby. Within 1 hour, you do the tracheostomy. After 1 year, you do the surgery to open the choana permanently. Beta. Am I clear, beta? Now let's go to the next page. Beta. Everybody, let's start the next concept. This was the lateral wall of nose. Everything we did about the turbinate clear. Okay, below the turbinate is meatus clear. Then in the turbinate bone is clear, concha. Then sphenoethmoidal recess is above the superior turbinate. Then choana is the posterior opening of nasal cavity. Now, next one. Mucosa, sinuses are what? Write down. Sinuses are mucosa lined in the one had air-filled hollow cavities in skull bones. Sinuses are mucosa lined air-filled hollow cavities in the skull bones. Your skull is a hollow skull, beta. Human skull is a very light skull because this has got lot of hollow cavities. Okay, if you see the human skull is like this, beta. In the skull, there are a lot of cavities like that. These cavities are called sinuses. Look at your note, beta. Sinuses are mucosa lined, add the word air-filled hollow cavities in the skull bones. Now, they contain air, beta. Look at this, beta. They contain air, bache. They contain what? Air. 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 Okay. Now, when the air will enter them, beta, they are ventilated during expiratory phase of respiration. So, air enters the sinuses during which phase of respiration? Expiratory phase of respiration, beta. Okay, next line. They are ventilated during expiration. Mind you guys, lungs are ventilated during inspiration. Sinuses get air during expiration, beta. Reverse. Okay. Now, what are they doing, beta? Now, look at skull, beta. This is your maxilla. This is your maxillary sinus. Am I clear, beta? Maxilla, maxillary sinus, beta. This is your maxilla. This is your maxillary sinus, beta. Frontal bone, frontal sinus, beta. Mind you, they are air-filled, okay? But important thing is they are mucosa lined, beta. They are lined, they are not bare inside, they are mucosa lined, okay? Now, what do they do? The mucosa is secretory in nature. It produces what? Mucus, beta. Mucus. Sinuses are continually producing mucus, and that mucus comes into the nose, beta. Am I clear, beta? The sinuses produce mucus, which is drained in the nose. Okay, read the third line. Sinuses produce mucus, which is drained in the nose. That's why the topic name is nose and paranasal sinuses. You cannot see nose and sinuses separate from each other because all sinuses are eventually draining into the nose only, beta. Am I clear, bache? All sinuses are draining into nose only. Okay? Am I clear, beta? Fine. Very good. Very good. So this is about the sinuses, beta. Okay. Now basic orientation. How many sinuses we have? 4 pair, beta. 4 pair. Pair, not 4 sinuses, 4 pair of sinuses. Very simple, beta. Name of the bone is the name of the sinus. Maxilla bone, maxillary sinus. Frontal bone, frontal sinus. Sphenoid bone, sphenoid sinus. Ethmoid bone, ethmoid sinus. Okay, beta. Number 1, maxillary sinus, beta. Maxillary sinus, number 1 is maxillary sinus, beta. Now, maxillary sinus, write down. It's also called as antrum of Highmore. It's also called as antrum of Highmore, beta. The first sinus is maxillary sinus. It's also called antrum of Highmore, beta. Whenever you see the word antrum, think of maxillary sinus, beta. Like antral polyp, antral wash, matlab maxillary sinus problem, beta. Antrum, which sinus? Maxillary sinus. Okay, it's also called as antrum of Highmore, beta. It is largest sinus. Its volume is 15 milliliter. It is largest sinus. Its volume is 15 milliliter. Okay. Number 2, frontal sinus. Number 3, sphenoid sinus. Sphenoid sinus. Number 4, ethmoid sinus, beta. Number 4, ethmoid sinus, beta. Okay. Ethmoid sinus is also called as ethmoid air cells, beta. Ethmoid sinus is also called as ethmoid air cell, beta. Now, what is the difference between sinus and air cell? Look at me, beta. Look at your room. Look at your room is one big cavity. Your room. Look at your room where you're sitting right now. Your room is one big cavity. One big cavity in a bone is called sinus. But have you seen a honeycomb, beta? Madhumaki ka chhatta dekha, honeycomb. If you divide this room into small spaces, the collective name of the room is sinus, but individually every small space is called air cell, beta. A small cavity in a bone is called air cell. A big cavity in a skull bone is called sinus. Maxillary sinus is single cavity in the bone. But ethmoid bone has got small hollow cavities. Those are called ethmoid air cells, collectively called ethmoid sinus, beta. So air cell is a small air cavity, beta. Now where the hell is ethmoid bone, beta? Where the hell is ethmoid bone, beta? Ethmoid bone. Now, I know you know, below the orbit is maxillary sinus, maxilla. Above the orbit is frontal bone, frontal sinus. Behind the orbit in the skull is sphenoid sinus. But where is the ethmoid bone? Actually, I could never understand it. Where is the ethmoid bone in my MBBS days? But I could really not understand where is the ethmoid bone and all that. In fact, I was not really that keen to learn anatomy. In fact, I don't know. You know, in the first year, I was not in the mood of studying. Actually, to be very honest with you, I was not in the mood of studying too much. I was having very clear thing that, okay, I have now entered the medical college. Somehow, I'll pass. And you know what? I'll just have fun. You know, first year, I really, you know, first year, second year also, third year also partly, I had a lot of good time. I mean, anatomy was not my, at that time, now I understood it because when I read surgery, when I read orthopedic, I read the anatomy later on retrospectively. But in first year, second year, and third year also half of that, I was not too much engaged to study. A lot of things that were happening at my life actually. You know, medical life in India is a very interesting life. Not that interesting as it can be in Russia or China or Ukraine or Philippines or anywhere. But yes, but still India also, there are a lot of interesting things are happening in life actually. So I remember, you know, ethmoid bone, I remember first test of mine in ENT, in anatomy in first year. After 2-3 months, there was a test of lower limb. Half of lower limb was coming in the exam. I did not know much about lower limb, to be very honest, at that point in time. Whatever I could learn from, you know, friends and all that, from Viva and all, little bit. But a theory paper now. Now, theory paper is a hell lot of a job, you know what. You know, theory paper is a lot of problem, you know what. You have to write. And I didn't have time to study because I was having, you know, some movie going on, some college function going on, something else. And I asked one of my seniors that what actually is the main point. He said, you know, there are 3 joints actually. Knee joint, hip joint, ankle joint. Every day, every session, they will ask you one joint for sure. Long question of joints actually. So, not that joint, but, you know, joint, bone joints. So he told me, you know, that this time it will be most probably ankle joint because every time they are asking knee joint. Hip they never ask. Generally they ask either knee or ankle. This time ankle will come. And I read ankle joint completely. I remembered, crammed it up, somehow ankle joint. And you know, on the exam day when they distributed those question papers, I saw again, it was again knee joint. Again knee joint, you know what. But I did not lose, you know, that strength. I broke the ankle and made a knee out of that. I wrote something. I filled 3-4 sheets. And you know what happened was, when the result came, I also passed. I got to know one very secret of medical college in India, that they don't read the theory papers, beta. They just weigh the theory papers and they say everything is filled, at least they pass you. So that was my first year actually going on and on and on. I remember first time when I was having Viva in physiology. This physiology teacher, you know, India, they don't teach you much. But the only problem is in your medical colleges and universities in India, the difference is, they don't teach you much, they don't ask you much also. Somehow they pass you, you know, 1 time, 2 times they'll pass you. Here, passing, failing is a serious affair actually, of Viva particularly. They'll fail you. Very easily they fail you. The passing exam is a very serious affair here, but a lot of questions are asked and detailed question, high level question. Physiology, you know what, he asked me a question in my first year, like first year was 1993, you know, you were not even born actually. You know, like, he asked me, Rajiv, what is the difference between Hutchinson scoria and Sydenham scoria? I did not know that, honestly. I thought, I don't know it, but I was not able to recall, did he ever teach in the class? In his class, I was sitting every time, actually. Every time I was sitting in his class, listening to what he's saying, actually, not noting down, but I did not remember that he even taught the topic like that. And in my heart, I was thinking that, did you ever teach this topic? You know what? I only knew 2 Korea at that time, South Korea and North Korea. No other Korea, actually. So, you know, India or other places, most of the teachers, except for few, the few teachers were very good teachers. You must be having university, very good teachers also. There are good teachers also. But most of the teachers, ऐसे पढ़ाते हैं समझ ना आ जाए कहीं, ऐसे पढ़ाते हैं समझ ना आ जाए कहीं, लेकिन वाइवा वाले दिन ऐसे पूछते हैं जैसे सब पढ़ाया हो. You know, ऐसे पढ़ाते हैं समझ ना आ जाए कहीं, लेकिन वाइवा वाले दिन इंडिया में ऐसे पूछते हैं जैसे सब पढ़ाया हो डिटेल में बेटा. And that brings a lot of, you know, mediocrity in your mind that, okay, I don't know this, I don't know that. But I was happy with it. I don't know it, I was happy with it, to be very honest. But third year, later part of third year, I started liking medical science, really. Because I started getting interested into clinical part of the stories. But the clinical medicine, surgery, orthopedics, gynae, pediatrics, derma. This was like my forte, actually. I was liking it, actually. So, but first year, second year, very weak. Actually. So, ethmoid bone, I never knew where the hell it is. I know below the orbit is maxillary sinus. Above the orbit is frontal sinus, frontal bone. Behind the orbit in the skull is sphenoid. Okay, I know that. But ethmoid मुझे कभी समझ नहीं आया. Now, ethmoid is a single bone between 2 orbits. Beta. इधर देखो, please see on the screen. Beta. Ethmoid is a single bone between 2 orbits. Okay, let me draw. This is your ethmoid bone. Beta. Let me draw with other color. Beta. This is your ethmoid bone. Beta. It has got 2 halves. Those 2 halves have got some air cell, and those cells are called ethmoid air cell. They are the ethmoid air cell. It's a single bone between 2 orbits, and these black bag cells are ethmoid air cell, collectively called ethmoid sinus. Beta. What lies above the brain? Above the nose is brain. Beta. Brain is there. Beta. Now, in the roof of the ethmoid bone, you have got small holes, which are called cribriform plate. Cribriform plate. Beta. Cribriform plate. And through the cribriform plate, what passes is some neurons. Beta. Which neurons? Olfactory neurons. The diagram is drawn in your notebooks. Please see that olfactory neuron, beta. Can you see olfactory neurons pass through cribriform plate, beta? Can you see, beta, this picture? I know now. Oh, ethmoid bone is between two orbits. Okay, okay, fine. It's a single bone between two orbits, beta. It's clear, beta. It has got some cell called ethmoid hair cell. Above the roof is the brain, and in the roof of the ethmoid bone there is some hole called cribriform plate. Through the cribriform plate, what passes is olfactory or smell neurons, beta. Is this diagram clear to all? Now get back to your own notes and let's label that also, beta. I think it's already labeled beautifully over there. It is written that ethmoid is a single bone between two orbits, beta. Okay, fine. This is clear to all, beta. Everybody, this is ethmoid bone. Can we write one word over here, brain, beta? So that I know roof of nose is base of brain. Roof of nose is base of brain, beta. Roof of nose is base of brain, beta. Roof of nose is base of brain, beta. Roof of nose is base of brain. Okay, bache, fine. Now let us discuss ethmoid hair cell, beta. Ethmoid hair cell has two groups, beta. Has two groups. Everybody come over here. Ethmoid hair cell has two groups, anterior group and posterior group. Now this is a number of cells, beta. Number 2 to 8, 1 to 8, beta. Number 2 to 8 and 1 to 8. Anterior are 2 to 8 number, that there may be 2 cells to 8 cells. Posterior are 1 to 8, beta. How anterior, posterior? Look at me, beta. Orbit, in between the two orbits there is ethmoid as a block. Ethmoid is between the two orbits. It's a big block like that. In the front part of the ethmoid there are anterior cells, back part posterior cell, and anterior are 2 to 8 in number, posterior 1 to 8 in number, beta. Now anterior 2 to 8, put a circle around 2. These two are constant cells, beta. These are constant cells, beta. Constant cells. Now two anterior ethmoid hair cell, beta. Two anterior ethmoid hair cell are constant. Anterior ethmoid hair cell. Posterior are not significant, beta. Posterior, forget about it. Posterior has got no question. Posterior is 1 to 8, it's irrelevant. Anterior are main thing, beta. We say 2 to 8 in number, 2 are constant cell and 2 anterior ethmoid hair cell are constant and they are named as, 2 constant cells, they are named as bulla ethmoidalis and agar nezae. Bolo beta, naam bolo mere saath, speak up, you will get more related to the name. 2 anterior ethmoid hair cells are constant and they are named as number 1 bulla ethmoidalis, number 2 agar nezae. Bulla ethmoidalis, number 2 agar nezae. Now bulla ethmoidalis is constant and largest anterior ethmoid hair cell. Constant, the main thing is large. Put a star on the largest. Largest, beta. Constant and largest anterior ethmoid hair cell. The biggest cell is called bulla ethmoidalis. This is MCI question, beta. MCI question. And agar nezae, AGGR, agar nezae is anterior most anterior ethmoid hair cell. Anterior most. Agar nezae most anterior cell. You know anterior ethmoid hair cell. Anterior means towards the eyebrow side, front side. Out of those group, the most anterior cell is called agar nezae, beta. Agar nezae most anterior cell. Agar nezae सबसे आगे होता है, beta. Agar. If you just know little bit of Hindi, write down AGGER. If you see AGGE, in Hindi is called आगे. आगे means most anterior. If you read AGGE, आगे से आगे, if you know Hindi, आगे in Hindi means anterior. आगे, front, आगे, interior. अपने आप क्वेश्चन गलत नहीं होगा, है ना? agar nezae आगे. Okay, fine, beta. Fine, beta. Now, is it clear, beta? Fine. Okay. So let us revise up to this much. Up to this much. This is both are MCQ, beta. No hurries, beta. No hurries. Let us revise, beta. Let me. Ethmoid hair cell have got two groups. Anterior group, posterior group. Anterior are 2 to 8 in number. Out of the 2 to 8, look at your note, beta. 2 are constant cell. These two cells are named as bulla ethmoidalis and agar nezae. Look at your notes. Bulla ethmoidalis and agar nezae are constant cell, are anterior ethmoid hair cell. The speciality of bulla is it's the largest cell. The speciality of the agar nezae is it's the anterior most cell. I repeat, beta. Bulla ethmoidalis and agar nezae both are anterior ethmoid hair cell. Number 2, both are constant hair cell. Only difference is bulla is the largest cell and agar nezae is the anterior most cell. So largest anterior ethmoid hair cell is bulla ethmoidalis and most anterior ethmoid hair cell is agar nezae. All of us have these two cells for sure. Okay. Now, next paragraph. Next page, beta. In some people, ethmoid hair cells can grow at 3 unusual areas. In some people, ethmoid hair cell can grow at 3 unusual areas, beta. All of you, beta, draw 3 arrows. 3, highlight about 3. 3 arrow, 1, 2, 3. 1, 2, 3 unusual areas. This is seen in some people. But bulla ethmodalis, agar nasai is in everyone. But these 3 cells are say there in someone. If the cell are in the orbital floor, they are called Heller cell. Heller cell. Okay. Close to optic nerve, they are called ONOD cell. ONODI. ONOD cell. ONODI. ONOD cell. ONODI. ONOD cell. On the side right, ONOD. ONODI. ON माने optic nerve. कभी गलत नहीं हुआ. You'll never go wrong in the paper. ONOD. 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 ONODI. ONOD first letter is ON. Optic nerve. If a cell is close to optic nerve, it's called ONOD cell. ONOD. ON. Optic nerve. अपने आप कभी गलत नहीं हुआ. And third one, inside middle turbinate, it's called concha bullosa. Concha bullosa. Concha bullosa. Concha bullosa. Okay. Okay, bache, fine. Let us revise once again, beta. Everybody speak with me. 5 cell, 5 MCQs, beta. Everybody, 5 cell total. 2 are constant and these 3 are variable. May be there, may not be there. First 2 constant cell. Bolo bache. 2 constant cell. Everybody, are you feeling sleepy? Get up, leave the chair, wear the shoes, beta. If you are feeling sleepy after lunch, if you ate 1 kilogram of rice with sambar, dal and everything, no human can wake you up, beta. You are bound to really, you know what? So better leave the chair, roam around in the room, take the device in your hand and just roam around. Okay? Revise with me, everyone. Leave the chair. Leave the chair. Get up. Get up. करने से ही होगा बेटा. नींद को छोड़ना पड़ता है. नींद हमें कभी नहीं छोड़ती है. Sleep will never leave us. We have to leave the sleep and really do something worthwhile. Okay? Leave the chair and get up and roam around in the room for a while. Stretch yourself for some time so that you feel little energetic. Now 2 cells are constant. Speaker. Number 1, bulla ethmodalis. Number 2, agar nasai. Speciality of bulla ethmodalis is largest anterior ethmoidal cell. Agar nasai, bolo, agar nasai, anterior aage, anterior most, anterior ethmoidal cell. These 3 cells are seen in some people. If ethmoidal cell grow in the orbital floor, it's called Heller cell. If they grow close to optic nerve, it's called ONOD cell. ONOD, ON means optic nerve. ONOD, optic nerve. ONOD, optic nerve. If they grow inside middle turbinate, it's called concha bullosa. Very good. If they grow inside middle turbinate, it's called concha bullosa. Beta. Concha bullosa. Am I clear, beta? Concha bullosa. Beta. Am I clear, beta? Fine. Concha bullosa. Okay. So I'm done. 5 cells. Let us do the next one, beta. Structures draining in nasal cavity. Okay. Now nasal cavity. I hope you remember this picture, beta. Everybody, do you remember this picture, beta? Everybody, can you see that? Anybody can tell me what is this IT? IT, MT, ST. What is IT? Yes, inferior turbinate. What is MT? Middle turbinate. What is ST? Superior turbinate, beta. Now what is IM? IM is inferior meatus, MM middle meatus, SM superior meatus. What is SER? Everyone, try to do this. SER. What is SER? Spheno-ethmoidal recess. It's area above superior turbinate. Now in these 4 areas, IM, MM, SM, SER, there are few things draining over there, beta. Okay? Let us see them. Beta. Number 1, nasolacrimal duct in the inferior meatus, beta. Nasolacrimal duct in the inferior meatus, beta. Okay. Maxillary sinus, frontal sinus, anterior ethmoidal cell drain into middle meatus. Maxillary sinus, frontal sinus, anterior ethmoidal cell drain into middle meatus. Okay. Now, posterior ethmoidal cell drain into superior meatus, and sphenosinus drain into sphenoethmoidal recess, beta. Sphenoethmoidal recess. Am I clear, beta? Let us revise once again, beta. Everybody, let us revise once again. What structure drain into inferior meatus? Inferior meatus. Nasolacrimal duct drain into inferior meatus, beta. Okay. Now, what structures drain into middle meatus? Maxillary sinus, frontal sinus, anterior ethmoidal cell. Okay. Then, what structure drain into superior meatus? Posterior ethmoidal cell. And what structure drain into sphenoethmoidal recess is sphenoid sinus, beta. Once again, speak with me, beta. Which structure drain into the inferior meatus? Nasolacrimal duct. Which 3 sinuses drain into the middle meatus? Maxillary sinus, frontal sinus, anterior ethmoidal cells. Posterior ethmoidal cell drain into superior meatus, but sphenoid sinus drain into sphenoethmoidal recess, beta. This you have to memorize properly. Okay. Now, there is surgery called chronic dacryocystitis problem, beta. Chronic dacryocystitis. What is ophthalmology problem? Okay, write down. It is lacrimal sac infection. Lacrimal sac infection. Dacryo mane lacrimal, cysto mane sac, itis mane infection. Dacryo mane lacrimal, cysto mane sac, itis mane infection. Chronic dacryocystitis. Chronic dacryocystitis, beta. Chronic dacryocystitis. Okay. This is the patient, beta. This is the patient, beta. Chronic dacryocystitis. Can you see, beta? This is the patient over here, beta. Now please see, Please see, where is your lacrimal gland, everybody? Where is your lacrimal gland? Not here, beta. Lacrimal gland is the outer part of the eye over here. This is lacrimal sac. Lacrimal sac. You know, lacrimal sac goes into nasolacrimal duct and that goes into your nose, beta. Sometimes the duct gets blocked and the sac gets infected. This is called chronic dacryocystitis. Chronic dacryocystitis mane dacryo mane lacrimal, cysto mane sac, itis mane infection. Okay. In this we do a surgery called DCR. What is the name of surgery? DCR, beta. Dacryocystorhinostomy. Look at the name of surgery, beta. Dacryocystorhinostomy. Look at the name of surgery. Dacryocystorhinostomy, beta. Dacryo means lacrimal. Dacryo mane lacrimal. Cysto means sac. Lacrimal sac. Rhino mane nose. Ostomy mane open. Lacrimal sac opening in the nose, beta. Guys, naturally, sac doesn't open the nose. Sac makes the duct. Duct open the nose in the inferior meatus. But in some people, duct gets blocked and they get infection of the sac and called chronic dacryocystitis. So what we do, we forget about the duct. We just open the lacrimal sac in the nose directly. The surgery is called DCR. Dacryocystorhinostomy. Lacrimal, dacryo, cysto sac. Dacryocystomy is lacrimal sac. Open in the nose, rhinostomy. To open the lacrimal sac directly into the nose, the surgery is called DCR, beta. Now, DCR opening is made in the middle meatus, beta. This is an important question. DCR opening is made in the middle meatus, beta. DCR opening is made in the middle meatus. DCR opening is made in the middle meatus, beta. Am I clear, beta? You say, Rajiv, what does it mean? I'm saying, just hear me carefully. Natural opening of nasolacrimal duct is in the inferior meatus, beta. Please understand. Look at screen, beta. If I can tell you over here, please see on the screen. This is your eye. Okay. Okay. This is your upper canaliculus, what here? Lower canaliculus, common canaliculus, lacrimal sac, then duct, and duct open to the inferior meatus. Duct open the inferior meatus. Okay. Now, the duct got blocked. The duct got blocked, beta. Okay. The sac got the infection. This lacrimal sac got the infection, and this started making the pus, and that's why you saw such kind of swelling in the medial canthus. Now what you want to do is, you want to forget about the duct. Duct is useless now. Okay. What you want to do, you want to make opening of the sac in the nose directly, beta. This surgery is called DCR surgery, and the DCR opening is made in the middle meatus, beta. Please see, this is pathology, beta. The duct got blocked, the sac got infected, the duct is useless now. The natural opening of the duct was in the inferior meatus, but the surgical opening of DCR mane dacryocystorynostomy mane lacrimal sac opening directly in the nose is made in which meatus? Middle meatus. I hope this is clear to all. Ophthalmology topic. Okay. Now, for DCR surgery, we use endoscopic DCR punch. For DCR surgery, we use endoscopic DCR punch, beta. For DCR surgery, we use endoscopic DCR punch, beta. For DCR surgery, we use endoscopic DCR punch. Endoscopic DCR punch, beta. Am I clear, beta? For DCR surgery, we use a punch called endoscopic DCR punch, beta. Endoscopic DCR punch, beta. Endoscopic DCR punch, beta. Can you see, beta, over there? Can you see endoscopic DCR punch? Can you see this instrument was probably there in the last exam, probably. This kind of up one turn instrument with a punch like thing over here, this endoscopic DCR punch, beta. Endoscopic DCR punch, beta. Can you see? Endoscopic DCR punch. This kind of punch, beta. Punch means to eat away the bone, because when you have to make an opening in the lacrimal sac, you'll have to remove some bone from here, and that bone removal, you do the punch called endoscopic DCR punch, beta. It's called endoscopic DCR punch, beta. Okay? One more thing, beta. Right, beta? One anatomy. Direction of NLD. Direction of NLD, beta. Direction of NLD. Direction of NLD is downward, backward, laterally. How to remember? Downward, backward, laterally, beta. Double. How to remember, beta? Double, beta. Double. DOUBLE. Just remember double, beta. LL. Downward, backward, laterally, beta. Downward, backward, laterally. Downward, backward, laterally. Double. Just for MCQ of your anatomy, ophthalmology, you know what is the direction of NLD? Downward, backward, laterally. Direction of NLD, downward, backward, laterally. Downward, backward, laterally. Downward, backward, laterally. Double. Downward, backward, laterally. Downward, backward, downward, backward, laterally. This much is done. Everybody, can we quickly revise, beta? Can we quickly revise, everybody? What opens in the inferior meatus? Inferior meatus, what opens this? Inferior meatus, everybody speak up. Inferior meatus, what opens this? Nasolacrimal duct. What open in the middle meatus? Number 1, maxillary sinus. Number 2, frontal sinus. Number 3, anterior ethmoid air cell. Now, what open in the superior meatus? Posterior ethmoid air cell. What open in the sphenoethmoidal recess? Is sphenoid sinus. But surgical opening of DCR, decreased created in the middle meatus. Okay? And for that we use a special punch called endoscopic DCR punch. Beta. Endoscopic DCR punch. You will say, Rajiv, are these openings really visible? Let me try to show you if possible. Beta. Okay, please see over here. Beta. Please see over here. What is this turbinate? Beta? Inferior turbinate. Okay? Can you see inferior turbinate? In the inferior turbinate we have a bone called inferior concha. Inferior turbinate. Bone in that inferior concha. If I put my endoscope here, where I am entering? Inferior meatus. Beta. Let us enter the inferior meatus and you tell me where I am entering right now. First of all, can you see I am entering into the inferior meatus. Beta. Now you tell me which structure opens in the inferior meatus. You tell me which structure opens in the inferior meatus. Can you tell me? Which structure opens in the inferior meatus? Yes, correct. Nasolacrimal duct. So let us find out the opening of nasolacrimal duct. Beta. If I am not lying, there should be an opening of nasolacrimal duct. Beta. I should be able to see the opening of nasolacrimal duct. Right now, my endoscope is in the inferior meatus, and this is the beautiful opening of nasolacrimal duct. Beta. Okay, bache, once again, beta. This is the inferior turbinate. Beta. Inferior turbinate, and my endoscope goes in the inferior meatus, and I am trying to find out the opening of nasolacrimal duct, and I should be able to find it over here. Right now, my endoscope is in the inferior meatus, and this is the opening of the nasolacrimal duct. Okay, everything is there, beta. मैं कहानी नहीं बना रहा बेटा मैं कहानी नहीं I'm not creating a fantasy world over here. This is all scientific anatomy beta. With endoscope it is so easy to now see everything and you can trust the anatomy now more. Okay, this is a nasolacrimal duct in the inferior meatus beta. Okay, bache, fine. This was a very important page beta. Please say in the last one page na, there are 5 ethmoid cell and 5 drainage point, and this page is a super duper page for the MCQs beta. This page is a very wonderful page for the MCQs of a nose beta. So this page is very important. Okay. Now let us start middle meatus. Let us start middle meatus. Middle meatus is the most important area for sinus drainage. Middle meatus is the most important area of sinus drainage. You just saw that in the middle meatus we have got 3 sinuses opening. Just look at your notes and tell me what are 3 structures draining into the middle meatus. Number 1, maxillary sinus. Number 2, frontal sinus. And number 3, anterior ethmoid air cell. Now middle meatus is very important meatus. It is the most important area of sinus drainage. Now it has number 1, bulla ethmoidalis. BE. Bulla ethmoidalis, okay. Within the middle meatus, you will see the largest cell of the ethmoid, and that cell is called bulla ethmoidalis. Number 2, uncinate process, UP. Uncinate process, draw beta. It's a sickle-shaped bone. Uncinate process is a sickle-shaped bone. Draw the sickle, beta. It's a sickle-shaped bone. Draw the sickle over there. It's a sickle-shaped bone which covers bulla ethmoidalis. It's a sickle-shaped bone which covers bulla ethmoidalis. Okay. And number 3 is ethmoidal infundibulum. Ethmoidal infundibulum, beta. Ethmoidal infundibulum. It is a space between BE and UP. Put an arrow. Bulla ethmoidal infundibulum. Put an arrow like that. It is space. It is the space between BE and UP. What is BE? Bulla ethmoidalis. What is UP? Uncinate process, beta. Okay. BE and UP, beta. Okay. BE and UP. Okay. Now, where are all these things? Where are all these things, beta? This is actually in the middle meatus, beta. This is all in the middle meatus, beta. This all is in the middle meatus, beta. Okay. Now look at screen, everyone. Let me show you the picture of the middle meatus, and then we can understand it better. Everybody, look at the screen, beta. Now this is your middle turbinate, beta. Let me label it for you. Now everybody, please focus. This is your middle turbinate. This is your lateral wall of nose, and from the lateral wall there is a projection called middle turbinate, beta. Am I clear, beta? Lateral wall of nose, and this projection is called middle turbinate, beta. Let me remove the marking so that we keep the diagram clear, beta. Okay. Now this is your middle turbinate. Okay. This space is called, this whole space is called middle meatus, beta. This whole space below the middle turbinate is called middle meatus. This is the middle meatus which you want to study now. This black marked area, beta. Below the middle turbinate we have an area called the middle meatus now. Now look at screen, beta. Look at screen. Now this middle meatus, this is a sickle shaped bone here. which is called uncinate process, UP beta. This cell behind that is called bulla ethmoidalis. Okay, this is the bulla ethmoidalis beta. And the space between the two is called ethmoidal infundibulum. Ethmoidal infundibulum. Now let me remove the marking and tell you again beta now. Everybody, this is middle turbinate. This is middle meatus. Now this is uncinate process. This is called bulla ethmoidalis. And the space between the two is called ethmoidal infundibulum. EI beta. Ethmoidal infundibulum beta. Can you see beta? Middle turbinate is this one. The space below that is the middle meatus. In that you have got a bulla ethmoidalis, the largest cell. It is covered by a sickle-shaped bone called uncinate process, and there is some space between the bulla and uncinate, and that space is called ethmoidal infundibulum. Look at my hand beta. You are in the middle turbinate. This is bulla ethmoidalis. Bulla ethmoidalis is hidden. You can't see bulla very clearly. Why? Look at my hand beta. Bulla is covered from your view by a sickle-shaped bone called uncinate process. Uncinate process. Okay. Now this hand is bulla and this hand is uncinate. From the side, if you see, between the bulla and the uncinate, there is a hollow space. This space is called ethmoidal infundibulum. This hand is bulla, this hand is uncinate. Between the two, they are not attached to each other. They are away from each other. The space between bulla and the uncinate is called ethmoidal infundibulum. Beta. Ethmoidal infundibulum. Am I clear? Fine. Okay. This is always middle meatus. Beta. This is always middle meatus. Okay, bache? Fine. Is it clear to all? Middle meatus clear? Okay. Now, everybody tell me, which three sinuses drain into middle meatus? Speak up, read your notes and tell me, everybody should speak now. Which three sinuses drain into middle meatus? Which three sinuses drain into middle meatus? Number 1, maxillary. Number 2, frontal. Number 3, anterior ethmoid. Maxillary, frontal, anterior ethmoid, they drain into the middle meatus. But middle meatus is a very big area, beta. Very big area. Which part of middle meatus, beta? Then somebody asked me, where is Chennai? I said Chennai is in India. Correct? Chennai is in India, but I should have said specifically, Chennai is in Tamil Nadu state of India. Similarly, three sinuses drain into middle meatus. Correct? But which part of middle meatus? Three sinuses drain into the ethmoidal infundibulum area of middle meatus. This area. The area which is going between the two. In this area, three sinuses open. Actually, that's why you are not able to see them better. Three sinuses drain into the ethmoidal infundibulum area of the middle meatus. Okay? And this whole complex is called osteomeatal complex. Beta. Look at your note. Beta. This whole complex is called osteomeatal complex. Beta. Three sinuses drain into the ethmoidal infundibulum area of middle meatus. This whole unit is called, write down, this whole unit is called osteomeatal complex. Osteomeatal complex. This whole unit is called osteomeatal complex. Okay, osteomeatal complex. This whole unit is called osteomeatal complex. Osteomeatal complex, beta. Everybody look at screen, beta. Look at screen, everyone. Please see on the screen, everyone. Just see over here, beta. What is this turbinate, beta? What is this turbinate? This is middle turbinate. Can you see? It's a projection from the lateral wall. What is this meatus? Middle meatus, beta. Can you see middle turbinate, middle meatus, beta? Please see. This is the middle turbinate. What is moving is middle turbinate, and where he is entering is the middle meatus, beta. Now, in the middle meatus, you can see there is a sickle-shaped bone, beta. There is a sickle-shaped bone over here. Can you see this sickle-shaped bone? This is middle turbinate. It's a projection from the lateral wall. This whole area is called middle meatus. In this area, we can see a sickle-shaped bone. This sickle-shaped bone is called uncinate process, and behind that, a cell is hidden over there, and that cell is called bulla ethmoidalis. Look at me, beta. Let me show you. Can you see, beta? Behind that, can you see this cell, beta? This is uncinate process. This is what, beta? Bulla ethmoidalis. Okay, what he is moving is middle turbinate. Where he is entering is middle meatus. This is bulla ethmoidalis covered by uncinate process, beta. Okay, now please see, he'll be touching it one by one, beta. Can you see, beta? He touches now what? Bulla. Now he touches what? Uncinate. And now the instrument goes between the two. And right now the instrument is in ethmoidal infundibulum. The instrument went between the two, beta. Once again, beta. Please see, beta. He touches the bulla. Then he touches uncinate. Then instrument goes between the two, and right now the instrument is in the ethmoidal infundibulum. It is in this area, three sinuses open, beta. Maxillary, frontal, anterior ethmoid. Am I clear, beta? Fine. Okay. I hope you are able to clear, beta. Tell me, because these all things I never understood in my life, beta. In my MBBS days, I could never imagine what is middle turbinate, middle meatus, where is the uncinate, where is the bulla. I could hardly understand what they are, beta. I hope you could understand, beta. I hope you could understand. Tell me in the chat box or telegram, are you able to conceptualize where is this middle turbinate, where is this middle meatus, where is uncinate, and where is bulla, and all these things are, at least you know it is inferior turbinate, inferior meatus and all that. Okay. Now, let's go further. Now this whole unit what you did just now, bulla, uncinate, infundibulum, this whole unit is called osteomeatal complex. Beta. If OMC is blocked due to mucosal edema, by chance edema happen. Beta. If OMC is blocked due to mucosal edema, this whole area, bulla, uncinate is blocked due to mucosal edema, there will be blockage of sinus drainage. Beta. Blockage of sinus drainage. Beta. Blockage of sinus drainage. Okay. And that will lead to sinusitis, beta. I hope you remember, beta, sinuses produce mucus continuously. Sinuses produce mucus continuously, beta. And if the drainage is blocked, because OMC, osteometal complex, is the area where the sinus drainage is happening. If that area is blocked due to infection, then edema happens. Edema means blockage of sinus drainage. And if anything which blocks the sinus drainage will lead to sinusitis. And if it is more than 3 months, it is called chronic rhinosinusitis. Guys, in sinusitis, the main culprit is nose. Because where is the drainage of sinuses? In the nose. Where is the blockage of sinus drainage happening? In the nose. Because of the infection of the nose, sinuses are getting secondarily infected. Beta. That is why the disease is not called chronic sinusitis. We call it chronic rhinosinusitis. Look at the name, beta. Rhino means nose. If nose is the main culprit, the name of the nose should come before the sinus name, beta. Chronic rhinosinusitis, beta. Okay? The nose name is coming before that sinus name, beta. Because the primary problem in sinusitis is the nose, beta. Nose. Am I right? Nose, beta. Now, chief complaint. What are the chief complaints of this patient, beta? Number one, nasal blockage. Please say edema, na? Congestion. You call it congestion. I told you, main symptom will be of nose because the main culprit of sinusitis is nose. So, main symptom are of actually the nose only, beta. Number two, purulent nasal discharge. Nose has infection, na? So, nose has got, greenish, yellowish pus coming. Every time you're using, handkerchief to clean the nose is full of greenish, yellowish pus, beta. Post nasal drip. What happens, beta? When you do like this, a greenish pus comes in your throat. That is post nasal drip. Yellowish pus comes in your throat. Doctor, when, like you do like this, beta. Sometimes normal people, they do like this. Some mucus comes in your throat, na? That is normal thing. Normal thing, na? Mucus has to come. Your nose, sinuses produce mucus. Where does it go? Back of your nose, beta. It goes back to your nose and you go to pharynx, then you swallow it, beta. Then you digest it. It's protein only. Protein. Achhi baat, protein hai. You are not supposed to spit it out. Okay? Some people come to my clinic and they say, Rajiv, when I do like this, something comes in my throat, whitish. I said, what the problem? Band kar dun kya? Shall I stop that? That's a normal, like outside you're sweating. Sweating is the natural way of keeping your temperature okay. Similarly, mucus is the natural way of keeping the internal system moist, beta. It's like something coming in your throat is not a disease. It's not, you're supposed to swallow it. No, don't get conscious of it, beta. But if the greenish pus comes or yellowish pus comes in your throat from your nose, it's called post-nasal drip, beta. Then decreased sense of smell. Guys, when the nose is blocked, less air go and less smell also, beta. Because smell goes via air. Decreased sense of smell. And office headache. Office headache is seen in frontal sinusitis. Office headache means MCQ, daytime headache, beta. Daytime headache. Office headache is a word linked with frontal sinusitis, beta. Office headache is linked with frontal sinusitis, beta. Okay, write down. Cheek pain. Cheek pain is linked with maxillary sinusitis. Cheek pain is linked with cheek. Of course, cheek pain will be maxillary sinusitis, beta. Now, one more thing, beta. Just write on the side. Pain at bridge of nose. Pain at bridge of nose or medial canthus of eye. This is a feature of ethmoid sinusitis. Pain at bridge of nose or medial canthus of eye is feature of ethmoid sinusitis. Look at me, beta. Bridge of nose. This is the bridge of the nose, beta. Either pain ho raha hai. Look. At the medial, this is also medial canthus of eye, beta. The question may say pain at bridge of nose, this one, or pain at medial canthus, same one. And I know between the two orbit, which bone is there? Ethmoid bone. So pain at bridge of the nose or pain at medial canthus of the eye is suggestive of ethmoid sinusitis, beta. Okay, bache, fine. Am I clear, beta? Pain at bridge of nose or pain at medial canthus of the eye is suggestive of ethmoid sinusitis. Okay. Once again, let's revise. Office headache, frontal sinusitis. Cheek pain, maxillary sinusitis. Pain at bridge of the nose or pain at medial canthus of the eye is feature of ethmoid sinusitis. This will be clinical question or clinical story over there which might help you in the exam, beta. Okay, bache, fine. Now, investigation, beta. Investigation. Number one, nasal endoscopy is the best investigation, beta. nasal endoscopy is the best investigation. Nasal endoscopy is the best investigation, beta. Best investigation. Okay. It has 3 passes. It has 3 passes. 3 passes. First pass, along inferior turbinate. Second pass, above middle turbinate. Third pass, inside middle meatus. Endoscopy has got 3, highlighted about 3 passes, beta. 3 passes. The endoscopy is checking the 3 different areas, and you pass the endoscope at 3 different points, and that's why they say endoscopy has got 3 passes, beta. Can you see what endoscopy, beta? Endoscopy, you are passing the endoscope in 3 different areas. First pass, second pass, third pass. Let us revise with me, beta. The first pass is along the inferior turbinate. Second pass above the middle turbinate. Third pass inside middle meatus. Once again, beta. First pass, second pass, third pass. Everybody, first pass is along the inferior turbinate. Second pass is above the middle turbinate. Third pass is inside the middle meatus. Once again, and nasal endoscopy has 3 passes, beta. Bolo, beta. Bolo, beta. First pass along inferior turbinate. Second pass above middle turbinate. Third pass inside middle meatus. Okay. Think like a doctor. You are sitting with me in the ENT OPD. The patient came, doctor, for last 3-4 years. I have this problem of nasal discharge. There's a headache, my nasal blockage, and there's a personal drip also. And I will do endoscopy first of all. You and me will do endoscopy together. You'll see 3 different areas. Then number 2, think like a doctor. We'll advise what? Number 2, X-ray. Very good. X-ray, beta. Then we go for X-ray, bache. X-ray. The X-ray, very important question. Best X-ray view for sinuses is Waters view, beta. Best X-ray view for sinuses is Waters view. It shows all sinuses except posterior ethmoid. Both are MCQ, beta. Best X-ray view for sinuses is Waters view, beta. Yaar water view. Yaar best X-ray view for sinuses is Waters view. It shows all sinuses except posterior ethmoid, beta. It shows all sinuses except posterior ethmoid, beta. Okay, beta. Fine. Now, water view, one line, beta. Water view is occipito-mental view. This is an important question, beta. Water view is occipito-mental view. Occipito-mental. Look at me, beta. Occipito matlab ye. Mentum is chin. Mentum is chin, beta. Occipito-mental. The beam goes like this. Occipito-mental view like this. Occipito-mental view. Okay. Now, it is done with open mouth, beta. Pani kaise peete hain? Water, pani. How do you drink water? With open mouth, na? Remember? How to drink water? How you do water view? Water view. How to drink water, beta? Can you drink water with closed mouth? No. Water view, beta. Water view done with open mouth. Open mouth. You only drink water with the open mouth. So water view is done with the open mouth. Open mouth. Why? To include sphenoid sinus in the X-ray. Why we open the mouth in this X-ray? Because to include sphenoid sinus in the X-ray, beta. To include sphenoid sinus in the X-ray, beta. Okay, bache, fine. Let us interpret this X-ray. It is important, beta. This is important, but everybody, the X-ray should, at least one sinus you should be able to find it out. Now, everybody see the water view. This is the water view, bache, water view. Anybody, now please tell me, what is this O? What is the O, beta? O means orbit. Yes, orbit. I can see orbit. Very good. Below the orbit is M. What is M, beta? What is M? Which sinus, everybody? Which sinus, beta? Below the orbit, which sinus? Can you see the hollow cavity? Maxillary sinus. Now, above the orbit is which sinus? Frontal sinus. Frontal sinus. Can you see frontal sinus, beta? Let me enlarge it for you. Can you see small hollow cavity, black color cavity? Frontal sinus, beta. Above the orbit is frontal sinus. Below the orbit is maxillary sinus. And through the open mouth, you see which sinus is the sphenoid sinus. Sphenoid sinus. Ethmoid are not sinuses. They are hollow cell. Cells are very difficult to be seen, beta. Very minimal cell can be seen somewhere. At least posterior cannot be seen, beta. Once again, let us revise this much. The best X-ray view for sinuses is Waters view, beta. It shows all sinuses except posterior ethmoid. Water view is occipito-mental view. It is done with open mouth to include sphenoid sinus in the X-ray. Okay, बच्चे, इतना याद हो गया? ठीक है. Now, best X-ray view for all sinuses, beta. Individual sinuses. Everybody open up now. Next one. Best X-ray view for individual sinuses. Individual sinuses, beta. Okay. Number 1, maxillary sinus is Waters view. The best view for maxillary sinus is Water view. For frontal and ethmoid is Caldwell view. Caldwell view. And for sphenoid is X-ray skull lateral view. X-ray skull lateral view. And for sphenoid, X-ray skull lateral view. Okay, bache. Best X-ray view for sinuses. Best X-ray view for sinuses in maxillary sinus is Waters view. For frontal ethmoid is Caldwell's view. For sphenoid is X-ray skull lateral view. Once again, speak with me, beta. Best X-ray view for sinuses individually. For maxillary sinus, the standard view, Water view. Frontal ethmoid, Caldwell's view. For sphenoid, X-ray skull lateral view. Okay. Now, number 3, CT scan, beta. CT scan is best radiological investigation for sinuses. CT scan is nothing but 100 X-rays together. One CT scan means 100 X-ray together. Of course, CT is the better than X-ray. CT is best radiological investigation for sinuses. Now treatment. Think like a doctor. You and me are treating the patient together. It's a case of chronic sinusitis. You've done the endoscopy, you've done the X-ray, you're sure about diagnosis. Now treatment plan. Antibiotic because of infection. And decongestant. Why? Because of edema. Because what is the cause of sinusitis? Blockage of sinus drainage. So you have to decongest, decrease the edema. For how many weeks you have to give the decongestant antibiotic? For 3 weeks. If this therapy fails, then we do surgery. The surgery is called FES. Beta. Everybody speak the full form of FES with me. FES. Bolo beta, padke bolo. FES is equal to functional endoscopic sinus surgery. Functional endoscopic sinus surgery. Beta. FES is functional endoscopic sinus surgery. Beta. Functional endoscopic sinus surgery. Beta. Functional endoscopic sinus surgery. Beta. Functional endoscopic sinus surgery. Am I clear? Beta? FES. So we have discussed sinuses, we discussed why sinusitis happens, symptom of sinusitis, investigation, endoscopy, X-ray, CT scan and treatment plan. Beta. If the medical treatment fails, then FES, full form of FES, bolo dobara, FES, full form, functional endoscopic sinus surgery. If you don't get the treatment done, there can be complications also. Complications are 3 and the 3 MCQs also. Number 1 is orbital infection. Everybody, you have to answer this question with me. Everybody, you have to answer this question to me, the orbital infection. Beta. Please see on the screen. Beta. Now you tell me, which sinusitis has got highest chance of causing orbital infection? Which sinusitis can cause maximum chances of orbital infection? Beta. You tell me which sinus is between 2 orbits. Between 2 orbits, which sinus? Ethmoid. So please see, ethmoid is here, na beta. Ethmoid is here. From here, it can go very easily into the eye, beta. Okay, MCQ. First question. The orbital infection is most commonly seen with ethmoid sinusitis. When I know the anatomy, I will have clear understanding also. I know ethmoid is between 2 orbits. So ethmoid sinusitis has got maximum chance of causing orbital infection. Okay, beta, fine. Number 2, mucocele formation. What is mucocele? Mucocele is sinus expansion due to mucus collection. I told you, in sinusitis, mucus collects in the sinuses. Due to pressure of the mucus, the sinus start expanding in size, beta. Sinus start expanding in the size, beta. Look at screen, everyone. Look at screen, everyone. This is the mucocele, beta. What is the mucocele, beta? See, this is the normal sinus size, beta. Normal sinus size, beta. Am I clear, beta? But due to pressure of the mucus, this sinus became bigger in size, beta. Okay, can you see? This is normal sinus. Can you see there's a big swelling over here? Mucocele means the sinus expansion due to mucus collection. The room became bigger. Look at your room, beta. All of you sitting in the room. Look at the room, beta. There's so much of pressure of mucus in the room that it pushes the wall of the sinus away and the mucus expands the sinus, and that is called mucocele, beta. Mucocele. So expansion of sinus due to mucus collection is called mucocele. And write down, beta. Can you see, beta? Mucocele is in which sinus? You can see. Which sinus is sinus? Frontal sinus, beta. Very good. Frontal sinus. Write down. Mucocele are most common in frontal sinus, beta. Mucocele are most common in frontal sinus. Second question, beta. Frontal sinus. Mucocele are most common in frontal sinus, beta. Now third one, beta. Osteomyelitis of frontal bone, beta. Now this is important, beta. Please understand. Please understand. Guys, please see. What is sinusitis? Sinusitis. Look at my hand, beta. This black is the mucosa of the sinus, beta. Okay, this is the bone. My hand is the bone, beta. Okay. So long as infection in the black cloth, it is called sinusitis. One day, it will enter the bone of the skull. What is this bone, beta? Frontal bone. And that bone infection is called osteomyelitis. Now, osteomyelitis of the frontal bone. Please look at this, beta. Osteomyelitis of the frontal bone will lead to this one, beta. Can you see? There is an abscess formation in the frontal area. Okay, osteomyelitis of frontal bone, it can lead to subperiosteal frontal abscess. Subperiosteal frontal abscess, it is called, very, very important question, it is called Pott's puffy tumor. It's called Pott's puffy tumor, beta. It's called Pott's puffy tumor. Everybody, P or double T, Pott's puffy tumor. It's not a tumor, that's why it's MCQ, beta. They can easily confuse you. It's a Pott's puffy tumor, it's not a tumor, beta. Pott's puffy tumor is not a tumor. Oh, it's just like, it's nothing. It's a Pott's puffy tumor is not a tumor. Okay, Pott's puffy tumor. Am I clear, beta? Pott's puffy tumor, beta. Okay, bache, Pott's puffy tumor. Pott's puffy tumor. Okay, bache, fine. So, Pott's puffy tumor, how does it present? Put an arrow. It presents as painful, red, forehead, swelling. Clinical picture. See oblique, clinical picture, painful. It will be infection of frontal bone. Abscess over there, painful, red, infection, forehead swelling. So painful, red, forehead swelling, it's Pott's puffy tumor. None of you will forget this question, beta. Pott's puffy tumor is very, very important. Pott's puffy tumor is very, very important, beta. Please understand. that it's not a tumor, it is subperiosteal frontal abscess. Beta. It presents as painful red forehead swelling. Beta. Everybody, let's revise these complications. Beta. Okay, fine. Please see you now. Orbital infection are most commonly seen with ethmoid sinusitis. Mucoceles are most common in frontal sinus. And subperiosteal frontal abscess is also called as Pott's puffy tumor. P-O-T-T, Pott's puffy tumor. It presents as painful red forehead swelling. Beta. Painful red forehead swelling. Am I clear? Beta? Fine. Okay. Ciao. After this discussion of sinusitis, complications and all that, let us discuss the next topic of development of sinuses. The sinuses appear in this sequence. Just add one word, beta, in this sequence. Beta, this sequence. Radiologically, sinuses appear in this sequence. M, E, S, F. First to develop is M, last to develop is F. Beta. So M, E, S, F. Beta. Means the first sinus to appear in human is maxillary. The second one is ethmoid. The third one is sphenoid, and the last one is frontal. MESF beta. MESF beta. Maxillary, ethmoid, sphenoid, frontal. MESF. First to develop is maxillary, last to develop is frontal beta. Now some questions. Some questions are M and E are present at birth. Some general question. M and E are present at birth beta. Maxillary and ethmoid are present at birth. E is most developed at birth. E is most developed at birth. Okay. Sphenoid appears at 4 years of age. Frontal at 6 years of age. Sphenoid at 4 years of age and frontal at 6 years of age. Okay, beta, fine. Fine, beta. MESF, beta. A lot of question here, beta. First sinus to develop in human, maxillary. Last sinus to develop in human is frontal. Which two sinuses are present at birth? Maxillary and ethmoid are present at birth. Which is most developed sinus at birth? Ethmoid. Then very important question from forensic medicine point of view, beta. Forensic, why? You have a dead body, you find out this, want to find out the age of the dead body, beta. Then you go to X-ray done, get the X-ray. Sphenoid appears at 4 years of age, frontal appears at 6 years of age. If there is a dead body, you get the X-ray done and there is a frontal sinus there. It means that minimum age will be 6 years, beta. Okay? Because frontal start appearing on the X-ray at 6 years of age, beta. Am I clear, beta? MESF, beta. This is what? MESF, beta. Okay, beta. Fine. Okay. Now, next one, beta. Next one. Now, general points, beta. Let us do some general points. The general point, most common benign tumor of sinuses is osteoma. Most common benign tumor of sinuses is osteoma. And osteomas are most common in frontal sinus, beta. You know, most common benign tumor of sinus is osteoma, and osteomas are most common in frontal sinus, beta. Osteomas are most common in frontal sinus. If you see some X-ray, sometimes you see osteomas there, beta. Let me show you. Oh, now please see. If I show you this X-ray, then you don't see anything, beta. This X-ray looks normal to you. Let us deep dive into it. Let us deep dive into it. Please see over here, beta. Which view is this, beta? Yes, you know, X-ray PNS water's view with open mouth. Can you see this one, beta? Everybody focus in this area. This is the osteoma. Just see in this area, beta. This is osteoma. This is the osteoma. Please see on the X-ray, beta. This is the osteoma. Can you see a bony swelling over there? This is the osteoma over there, beta. Okay, osteoma. Okay, fine. Osteoma. So can you see now osteoma, beta? Now your eyes are straight going into this area, beta. Oh, I can see osteoma, beta. First time we don't see anything in any MRI or CT scan or ECG or EEG or anything. We don't know anything. But you know, one time you see, other time you learn, then you revise, then your eyes will straight away go over there, beta. This is called the process of learning. No, ऊपर से कोई पढ़ के नहीं आता है बेटा. Nobody gets the knowledge from the Almighty. We all struggle to learn, then we struggle to remember, and then we know it. Then we know it. That's all. Now if I flash this, now once again please, when I flash this, now your eyes will straight away go over there, beta. Okay? You know Kabir says that. Kabir says that that करत करत अभ्यास के जड़मत होत सुजान. रसरी आवत जावत है सिल पर पड़त निशान. मतलब in English it says that when you do a lot of time practice, it becomes a habit, beta. And he's given an example that if on a stone the rope passes again and again, to just bring the water out of the well, the rope passes over the stone. Even that stone gets an imprint of the rope actually. So once you revise and re-revise, believe me, your brain will be looking for that data very easily, beta. It's objective paper. In front of you there will be a lot of question statements, but there are 4 choices. Your brain has to find one out of those 4, and if you practice it well 3-4 times, you will say, oh, this is the case, beta. But first time, 2 time, you would not remember, beta. Don't really over judge yourself. If you are revising and forgetting, it's a natural process, beta. It's just one layer formed. One more revision, one more layer formed, one more revision, oh, one more layer formed. Now last look before exam. some questions done here and there, some discussion happened with friends, some statement said by the teacher, some, a friend asked a question, some telegram story, some YouTube stuff and all that. All these make the collective impression in the exam, and there you are there on the front of the screen, and some data from your brain has to match the data in front of you. Beta. Have hope, have faith, will make it happen. Don't overjudge yourself and don't get disheartened every evening. Beta. Pull up yourself, maintain that, tell it to yourself, whichever people have done it in the past, if they could do, I can also do. Before you uninstall Instagram, go to the, or Facebook or anything, please be away from all these grams and books. Beta. Instagram, Facebook, etc. Please be away from them. If you only one picture you keep in your phone is of that senior, which had the best time in the university, which did everything possible on the planet to enjoy, and today, in the market, the news is even he has passed. Beta. Even he has passed. Beta. One of your seniors must be there in your head, who had the wonderful life all those 5-6 years. Beta. Who had all possible things to really do, who had the most fun in the college, who did all these fights and everything possible. But in India, now when he came back, he also passed. Take a screenshot of his profile picture from Instagram or Facebook and make that picture screensaver of your phone. Beta. Whenever you feel doubtful about your performance in the exam, that whether you pass or not, look at his picture and look at him and say, if he can pass, then I can also pass. If he can pass, then I can also pass. Beta. It's not a screensaver. Beta. It's a soul saver for us. Because our soul actually gets too much tricky, jittery, scared in between. Beta. When your internal self is scared at what will happen to me, look at this screensaver picture of you, that senior of yours who had the best time in the university, who passed after coming to India, and tell it to yourself, if he can pass, then what's the problem with me? Even I can pass. I may not have passed last time, okay, or last time even, but this time I'm doing the right things and I'll pass. If he can pass, then I can also pass. Na, beta. Let us draw inspiration from such people also, but that's the last visit for you on any Instagram or Facebook. Beta. After that, no more Instagram, no more Facebook till 4th of June evening. After 4th June evening, freak out. You're allowed to freak out. You're encouraged to freak out, in fact. Now, next topic. Beta. Nasal polyp. Nasal polyp, beta. Let us discuss now. Next topic, nasal polyp. That's a clinical topic, beta. First of all, I want you to look for how the polyps look like, beta. The polyps, how do they look like? Let me show you. That's the look of the polyp, beta. Can you see in the nose? This is the examination finding, and use some grape-like mass, beta. Grape-like mass over there. That's a polyp, beta. And even this one is a polyp, beta. Can you see polyp over there? A grape-like mass in the nose is a polyp. Now, what is a polyp? Look at your notes, beta. Look at your workbook. Just see. Polyp is prolapsed, pedunculated edematous mucosa of sinuses. Prolapsed, pedunculated edematous mucosa of sinuses. 3 words, beta. Prolapsed, pedunculated edematous mucosa of sinuses. Basically, too much edema of the mucosa of sinuses becomes the polyp, beta. What is the etiology? Etiology is chronic infection or allergy. Chronic infection or allergy. For last few years, sir, I've got sinusitis. For last few years, I have got allergy to dust. I keep sneezing when I go to the dusty environment. Okay. Then every infection or allergy brings inflammation. Inflammation brings edema. Too much of edema makes the polyp. Too much of edema makes the polyp, beta. Too much of edema makes the polyp, beta. Too much of edema makes the polyp, beta. Am I clear, beta? Too much of edema makes the polyp. Look at me, beta. Look at me. Now, please see. Look at me. Look at my black, this thing. This is a mucosa of the sinus, beta. Now, what happens is, last 5 years, infection or allergy was there. Every infection or allergy brings inflammation. Every inflammation brings edema. But after 5, 6, 7 years, the edema of the mucosa became so much that mucosa could not tolerate the weight of the edema. Due to weight of the edema, now the mucosa has started hanging. That edematous mucosa which is hanging now is called a polyp. Polyp. Look at the 3 words, beta. Polyp is prolapsed, pedunculated edematous mucosa, beta. 3 words. Prolapsed. Look at definition. Too much edema of the mucosa which is now hanging is called polyp. In a simple meaning, beta, too much of edema is polyp. Too much of edema is polyp, beta. Too much of edema is the polyp, beta. In a very simple way, too much of edema will be the polyp, beta. Am I clear, beta? Fine. Too much of edema will be the polyp, beta. Okay, fine. Now, next one, beta. Next one. The polyp are of 2 types, beta. Polyp are of 2 types. One is enteroconal polyp, other is ethmoidal polyp or nasal polyp. First of all, let us start the enteroconal polyp, beta. Let us start there are 2 types of polyp, enteroconal polyp and ethmoidal polyp. Now, everyone, can you tell me which sinus is called antrum? Anybody? Which sinus is called antrum? Antrum means which sinus? Bolo beta. Which sinus? Maxillary sinus, beta. Antrum. Antrum is maxillary sinus, beta. What is choana? Anybody? What is choana? Can you tell me choana? Choana is the posterior opening of nasal cavity. Choana is the posterior opening of nasal cavity. Enterochoanal polyp. The name shows everything, beta. The polyp arises from maxillary sinus and grows posteriorly towards choana. It arises from maxillary sinus and grows posteriorly towards choana, beta. So look at the name, beta. Enterochoanal polyp. Entra means maxillary sinus. Choana means posterior opening of nasal cavity. The polyp arises from maxillary sinus. Enterochoanal. The polyp arises from maxillary sinus and grows posteriorly towards choana. So put an arrow. Therefore, it can be seen on posterior rhinoscopy. Okay, we do posterior rhinoscopy in the bracket with the mirror. We see the nose from behind with mirror, beta. Posterior rhinoscopy we do with the mirror, beta. Mirror. Now, next point is it's more common in children. It is due to infection. Children, infection, single, unilateral. It is more common in children. It is due to infection. It is single, unilateral, beta. Infections, unilateral. Single, unilateral, beta. It is more common in children. It is due to infection. It is single, unilateral. Treatment is surgery called FES or endoscopic polypectomy. The best word is FES, or if this is not choice, then endoscopic word should be there, beta. Because it is a very posterior polyp, beta. Polyp is at the back of the nose, so you might leave some part of it. So better do surgery endoscopically. The right word is FES or endoscopic polypectomy. Everybody tell me what is full form of FES, beta. Bolo full form FES. Functional endoscopic sinus surgery. FES bolo beta. Functional endoscopic sinus surgery. FES, functional endoscopic sinus surgery, beta. FES. Okay, bache, FES or endoscopic polypectomy. Endoscopic polypectomy, beta. Okay, bache. Let me try to show you that how we do the FES, beta. Or how do the surgery, beta. Now, please see on the screen. In front of you is a big polyp, beta. Can you see a big polyp? Polyp is nothing but too much of edema mucosa which is hanging. This is polypoidal mucosa which is a polyp now, beta. Too much of edema. Can you see a big grape-like mass? Single mass. It's enterochoanal polyp, beta. Okay, it is unilateral polyp, beta. Unilateral polyp, single polyp. So you get your surgery ready. First of all, you have to just break the origin of polyp, beta. The polyp is originating from this point. Can you see? This is the origin of the polyp. From maxillary sinus, let us break it, beta. Let us break it. Polyp arises from maxillary sinus, let's break it. Free, polyp is free. Now you hold the polyp like this. And you bring the polyp out in single mass. It's a single mass, unilateral mass. Can you see big polyp coming out of the nose? This is enterochoanal polyp, endoscopic surgery, beta. Okay? This is a big polyp over there. Okay, bache? Enterochoanal polyp. Can you see big polypoidal mass? This is enterochoanal polyp, beta. Am I clear, beta? Fine. Now, let us go further, beta. The other polyp is, the second polyp is ethmoidal polyp, beta. Ethmoidal polyp, also called as nasal polyp. Nasal polyp. Whenever the MCQ only uses the word nasal polyp, you please consider it as ethmoidal polyp. Okay, beta. Now, they arise from ethmoid air cells, beta. S. You know, ethmoid air cell are 2 to 8, 1 to 8 number, multiple cell. Okay. Ethmoid air cell. Now, please see, they are more common in adult. They are due to allergy. They are multiple bilateral. They are multiple bilateral. But everybody compare it. Okay. They are more common in adult. They are due to allergy. They are multiple bilateral. On this side, please see. On this side, please see. Children, infection, single, unilateral. On this side, it's totally reverse. Adult, allergy, multiple, bilateral. Please see, enterochoanal polyp is more common in children. It is due to chronic infection. It is single, unilateral, beta. But ethmoidal polyp are more common in adults. They are due to allergy. They are multiple. They are bilateral. Why multiple, beta? Why multiple? Because ethmoid air cells are 2 to 8 in number. 1 to 8 in number. So every cell, one polyp. Every cell, one polyp. Multiple polyp. Why bilateral, beta? Why bilateral? Allergy. The cause of allergy. Allergy has to be bilateral. Nobody says in the clinic, Rajiv, I have got right side allergy, beta. Can you say, I have right side allergy, beta? Allergy is allergy, beta. Throughout allergy. Allergy cannot be right. Infection can be right side, left side. Allergy has to be both side, bilateral. So you tell me, beta, treatment. Can you cure allergic problem with surgery, beta? Can you cure, can you finish it off with surgery? No. The treatment is not surgery. The treatment is topical corticosteroid nasal spray. The treatment is topical corticosteroid nasal spray, beta. You have to use this spray, beta. Topical corticosteroid nasal spray, beta. Topical corticosteroid nasal spray. Like this, beta. You spray the nose like this, beta. Topical corticosteroid nasal spray. For example is fluticasone, beta. For example, fluticasone, beta. Anybody, what is the basic cause of polyp? What is the basic cause of polyp, beta? Polyp is due to what? Inflammation. And what is the basic role of a corticosteroid? Anti-inflammatory. Logic, beta. Logic. Polyp is due to inflammation. And steroid is anti-inflammatory, beta. That's why you're putting anti-inflammatory drug in the nose, beta. Okay, example, fluticasone. Am I clear, beta? Fine. Fluticasone. Now, please see, there is a triad called a Samter's triad, beta. This is the MCI question, beta. Samter's triad, write down. Allergy to NSAIDs, mean like aspirin, asthma, again allergy, nasal polyp, again allergy. I told you nasal polyp means ethmoidal polyp. Allergy to NSAIDs, asthma and nasal polyp. Allergy to NSAIDs, asthma and nasal polyp. Symptoms triad, allergy. Beta. This is important for pharma question also. Beta. It's a triad of allergy. Symptoms triad is triad of allergy. Let us revise symptoms triad. Symptom triad, write down allergy to NSAIDs, particularly aspirin allergy will be mentioned. Patient has got asthma attacks also and nasal polyp, which are ethmoidal polyp. In the bracket, you can write down nasal polyp is, when I say nasal polyp, I mean ethmoidal polyp. Am I clear? Beta? Fine. Now, just on the side, please write down one thing. This is a mirror, beta. This is posterior rhinoscopy mirror, beta. What is the name of the mirror? Posterior rhinoscopy mirror. Write down the side. Posterior rhinoscopy mirror is an angulated mirror, beta. Posterior rhinoscopy mirror is an angulated mirror, beta. Angulated mirror. Angulated. I hope you remember. If you want to write again, IL mirror. Anybody? IL mirror is which type of mirror, beta? IL mirror is a straight mirror, beta. I hope you remember what is IL full form. Indirect laryngoscopy, beta. Indirect laryngoscopy mirror is a straight mirror. Indirect laryngoscopy mirror is a straight mirror, beta. I hope you remember last class of larynx, the IL mirror was a straight mirror, but can you see this mirror is angulated? Can you see angle over here, beta? Can you see angle over here, beta? This is the angulated mirror, beta. Angulated mirror, no? Angulated mirror. Okay, let me remove the marking and you see, I can see clearly, it's not a straight mirror, it's a teda-meda mirror, PR mirror. So I have got two mirrors in ENT. IL mirror. What is IL mirror full form? Indirect laryngoscopy mirror is a straight mirror. But this is a PR mirror, posterior rhinoscopy mirror is an angulated mirror, beta. This is an angulated mirror. Angulated mirror, beta. Am I clear, beta? Angulated mirrors. Am I clear, beta? Fine. Very good. Chalo. Guys, one thing I left. One student reminded me that. Thank you very much. I love it. I love it. Thank you very much who reminded me. One thing I forgot to mention, this one, beta. Go to the last page. Previous page, beta. Above the nasal polyp. Above the nasal polyp. We said that osteomas are most common in frontal sinus. Okay. One more thing over there was most common fungus to cause sinusitis. But wherever the fungus come, don't write candida. Every fungus candida. Every bacteria staph aureus. No. Fungus to cause sinusitis most commonly is Aspergillus fumigatus. Aspergillus fumigatus, beta. Fumigatus. Okay. Most common fungus is to cause sinusitis is Aspergillus fumigatus, and most common site of Aspergilloma. Aspergilloma is equal to fungal ball, beta. Is equal to fungal ball is maxillary sinus, beta. Most common site of Aspergilloma formation or fungal ball. The fungus hyphae, like a ball of the fungus hyphae forms in which sinus most commonly? Maxillary sinus, beta. Osteomas are most common in maxillary sinus and the fungal balls are most common in maxillary sinus. Osteomas are most common in frontal sinus and fungal ball or Aspergilloma are most common in maxillary sinus. Once again, osteomas are most common in frontal sinus and the fungal balls or Aspergilloma are most common in maxillary sinus, beta. Okay, very good. Let us go to the next topic, beta. Sinus malignancy, everyone. Sinus cancer. There are two questions on this which are popular in EPG also, and you must know about them. First of all, the most common sinus involved is maxillary sinus. Maxillary sinus, beta. Most common sinus involved is maxillary sinus, beta. Guys, there are a lot of most commons now. Why not write on the side, beta? Mucocele are most common in frontal sinus. Mucocele most common in frontal sinus, beta. Okay. Then osteoma in frontal sinus. Osteoma, frontal sinus. Two frontal, two maxillary. Aspergilloma most common in maxillary sinus. Malignancy, maxillary sinus. 4 MCQs in front of you. This is what I say 20th copy. 20th copy means summarize the data. Make your own one-liner copy, beta. Make your own summary copy of the important concept. Don't write everything in that copy. Only very key point, very selective key point, because we have to prepare what we are going to revise from 28th of the May to the 3rd of the June right from now. Let us be systematic. Let's not do hard work. Let's do smart hard work, beta. We should be knowing that We should be knowing what I'm going to read on 28th, 29th, 30th, 31st, 1st, 2nd, 3rd May, 7th days, last 7 days. What I'm going to read? All classifications, all staging of tumors, all ECG findings, all, the one-liner questions, all the important images I must revise, all the 20th copy data I'm going to revise, all the, important point I've highlighted in my, notes. In the ENT copy notebook, there is MCQ written in the red box. I'm going to read all those them in 1 hour. So I should do preparation of the last 1 week, what to study now onward, beta. Let us give a command that, okay, 28, 29, 30th, 31st of May, 1st, 2nd, 3rd of June, 7 days, I'm going to read all these data once again, 2 times, 3 times. You know what? That's how it's going to really, help us in the exam, beta. Okay? I don't believe in hard work only. The idea is about smart hard work. Smart hard work, बेटा, है ना? पढ़ाई वही काम की जो लास्ट दिन नंबर लेके आए बेटा. वरना पढ़ाई का अचार डालना है. किसका पढ़ने का मन करता है भाई? मेरा तो नहीं करता. मेरा तो बिल्कुल नहीं करता. जब तक पेपर नहीं होता तो मैं कहाँ पढ़ता हूँ भाई? नहीं पढ़ता था मैं. Let us be very clear about it. पढ़ाई वही काम की जो लास्ट दिन काम आए बेटा. वरना क्या करना है ना पढ़ के. आखिरी दिन दिमाग में है तो पढ़ाई फायदा है. आज हमने पूरा इनफर्टिलिटी पढ़ लिया OBGY में बैठ के. You read whole of infertility in out of OBGY notes, completed it. But you could never revise that. You could not see the important part of the infertility in last 1 week before exam. How would I memorize it? How would I recall it, beta? Let us not expect the unnatural thing out of us. Let us not be overcritical about us, beta. Let us not keep really, sort of shamming ourselves again and again. Okay, I forget. Everybody forgets, beta. The people who perform better than us, they are more systematic people. That's all. If they can do, we can also do. If they can do, we can also. Only thing is that we have to follow somebody's footprints. That's okay. We'll follow that. If this path goes to the success, I don't have any problem. I'll walk and really go that. Okay, if this path goes to success, it's okay, no problem. So there are certain rules actually which is applicable to everyone. And this one rule is that we must make sure that whatever we read, we should encounter that 3 times more time plus one last look before exam also. Beta. I'm reiterating it again and again and again because this exam is doable, beta. Have faith in what I'm saying. This exam doable. Every second question of the exam, even if you know, you pass the exam, beta. It's doable exam, beta. I know last time we could not do it. I can feel that pain. If you can hear that pain within my voice, I can feel that pain when you say that. But okay, we failed, no problem. But this time we'll correct it. This time we'll make it happen, beta. Every evening we cannot afford to become low, and every evening we cannot afford to go think that okay, why my friends passed and why I did not pass. That thing is over, beta. 3 months are left, and then we are in the same league, beta. No problem, no problem. I know it's painful, but can we do something about it? Yes, only one thing. We can do more hard work this time. I know it's painful, but can we do something about it? Yes, we can do one thing. What? More systematic hard work this time. That's all. Okay? Now, come back. Let's go further, bache. Most common sinus to develop cancer is maxillary sinus. Now, risk factor. When we say risk factor, दो चीजें बदनाम है बेटा. दो चीजें बदनाम है. Cigarette, alcohol, cigarette, alcohol, cigarette, alcohol. Here, no cigarette, no alcohol. There is some other thing. Occupational exposure to, number 1, nickel. Number 2, wood dust. Nickel, wood dust, beta. And most importantly, nickel exposure lead to squamous cell carcinoma and wood dust lead to adenocarcinoma. And that's why adenocarcinoma is equal to wood workers carcinoma. Wood dust lead to adenocarcinoma, also called as wood worker carcinoma, because wood dust exposure is seen in carpenters. And carpenters, the woodworker, develop adenocarcinoma. Very interesting observation is the risk factors are very unique. It's not cigarette, alcohol here. It is occupational environment where you work. In that environment, some people are exposed to nickel, particularly steel industry worker. Nickel exposure lead to squamous cell carcinoma of sinuses. And very interestingly, the carpenters, the wood dust exposure lead to adenocarcinoma. Therefore, adenocarcinoma is also called as wood workers carcinoma. Adenocarcinoma also called as wood workers carcinoma. Okay. Now, it's the same topic, beta. It's not a different topic. Same topic. There's a very, very famous question, Ongren line, beta. Visual question also. Ongren line, it is from, look at screen, beta. First of all, see, that's the Ongren line, beta. This is the Ongren line, beta. This one. It is from what to what, beta? Can you see? Ongren line is from medial canthus to the angle of mandible. You know medial canthus of the eye, the medial point of the eye to the angle of mandible, beta. Okay, write down. It is from medial canthus to angle of mandible. Medial canthus to angle of mandible. It is from medial canthus to angle of mandible, beta. This is a very important question, star question, beta. It is from medial canthus to angle of mandible. Medial canthus to angle of mandible, beta. Okay, fine. Now, it is used for prognosis assessment of cancer in maxillary sinus. It is used for prognosis assessment of maxillary sinus cancer, beta. It's not, Ongren line is not for surgery. It's for the assessment of prognosis of which cancer? Cancer of maxillary sinus. Okay. Ongren line is used for which cancer? Cancer of maxillary sinus, beta. Now, what is the meaning of this line, beta? Look at screen, everyone. First of all, see what is the meaning of this line, beta. Now, see over here. Please see. This is your medial canthus, beta. This is your angle of mandible. Let me join this with a line. This line is called the Ongren line, beta. Ongren line is from medial canthus to angle of mandible. Now, any tumor which is above this line, beta. Can you imagine this tumor is above this line? If the tumor is above this line, it will have poor prognosis because of early orbital involvement. If a cancer of the maxillary sinus has crossed this line, it has got poor prognosis due to early orbital involvement. Am I clear, beta? The Ongren line is not for surgery. Ongren line is to assess the prognosis in a case of cancer of maxillary sinus. Any tumor above this line has poor prognosis due to early orbital involvement. Okay, now look at your notes, beta. Due to early orbital involvement. Okay, tumor above this line has poor prognosis due to early orbital involvement. Tumor above this line has poor prognosis due to early orbital involvement, beta. Okay, bache, fine. Okay, tumor above this line has poor prognosis due to early orbital involvement, beta. Now, let's go further, beta. Now, everybody clear? Ongren line is clear? Visual question is clear? Okay, what is the treatment of this cancer, beta? Total maxillectomy by Weber-Ferguson approach followed by radiotherapy. Okay, total maxillectomy by Weber-Ferguson approach followed by radiotherapy. Okay, yesterday, day before, laryngeal cancer was total laryngectomy. Now, maxilla cancer, total maxillectomy. Name of approach is Weber-Ferguson approach followed by radiotherapy, beta. Guys, please do not forget Ongren line, beta. This is a damn important topic. Ongren line, 3 points to remember. Number 1, Ongren line is used in which cancer? Cancer of maxillary sinus. Number 2, it's from medial canthus to the angle of mandible. Then third is, any cancer above this line will have poor prognosis due to early orbital involvement. Ongren line should not be forgotten by anyone, beta. Next one, Ringet's tumor. Ringet's tumor. Ringet's tumor is also called inverted papilloma of nose, beta. Ringet tumor is also called as inverted papilloma of nose, beta. Okay. Site of origin is lateral wall of nose. Site of origin is lateral wall of nose, beta. Site of origin is lateral wall of nose. Lateral wall. This is a point to be remembered, beta. It does not arise from septum. Site of origin is lateral wall of nose. Okay. It is more common in males. More common in males, beta. The tumor, why it's called inverted? It grows inward, beta. Why it is called inverted? It grows inward, therefore called inverted papilloma. Please look at me, beta. Papillomas grow outward. Outward. This papilloma pathologically grows inward, beta. Downward into the mucosa, submucosa and all that. That's why somebody called it the inverted papilloma. 2 questions to remember. One is, what is Ringet's tumor? Ringet's tumor is inverted papilloma of nose. Ringet's tumor is inverted papilloma of nose and site of origin is lateral wall of nose. Okay. More common in males, yes. It grows inward, grows inward, so called inverted papilloma. Put an arrow. Put an arrow. Write down, put an arrow. Therefore, it is locally invasive tumor. Therefore, locally invasive tumor, beta. Because it grows inward. Okay, therefore, it's a locally invasive tumor, beta. Locally invasive tumor, beta. Okay, bache, fine. Chalo. Next topic. Mucormycosis, beta. The black fungus story of last year, Delta virus time, beta. Mucormycosis is seen in 3 groups of patients, beta. HIV positive patient, young diabetic patient and COVID-19 patient. Who can forget Delta virus? COVID-19 patient, beta. HIV positive patient, young diabetic patient, COVID-19 patient. Matlab, the story of this question can start with one of these words. A HIV positive individual or a young diabetic patient or a patient of COVID-19, beta. So, these all things are important for any disease to be diagnosed by you in an easy manner, beta. Okay. So, it is either an immunocompromised patient or a diabetic patient or a COVID-19 patient. It is caused by which fungi? Mucor fungi, beta. Mucormycosis, fungus, na? Black fungus story, beta. Now, what is the special property of mucor? Underline, it's angio-invasive fungus, beta. Look at me, beta. Angio-invasive, matlab what? It grows into the blood vessels and via blood vessel, it enters the orbit and then the brain, beta. From nose to the orbit and brain, beta. It's a very risky disease, beta. Hence, grows from orbit, nose into orbit and brain, beta. Put an arrow. Therefore, life-threatening disease, beta. Don't you think so? Something which grows in the brain will be life-threatening disorder, beta. Life-threatening disease, beta. Life-threatening disease, beta. Okay, bache? Fine. Now, clinical, just on the side, write down. Right, on the side bar. When I say side bar, beta, I'm not sure about the bar, beta. Side bar, the side, column of your paper. Just write over there, write down. Angio invasion leads to ischemic necrosis, therefore blackish appearance. Beta. Angio invasion lead to ischemic necrosis. If the blood vessels are blocked with the fungus, the blood supply stops the area, and that causes ischemic necrosis, and necrotic tissue look black in color, beta. Dead tissue, na? Dead, blackish appearance. Okay, bache, fine. Now, what are the chief complaint, beta? Blackish nasal mass, blackish discoloration around the eye. Everybody write the thing black, beta, and put a circle. Black is the hallmark of it. Black is not the color of fungus, beta. Black is the color of tissue. Because why the color tissue black? Because the fungus blocks the blood vessels, and that lead to ischemic necrosis, and necrotic tissue, dead tissue look black, beta. Blackish nasal mass or blackish discoloration around the eye, beta. And then we have got cheek swelling, pain, numbness, oblique, diplopia. Eye feature, eye is also involved, na? Diplopia. And then you can have the blurred vision also. The eye feature also, the blurred vision. So blackish nasal mass, blackish discoloration around the eye, cheek swelling, cheek pain, cheek numbness, but eye feature also, beta. Diplopia, blood, must have seen, but a lot of people had ocular problem also because the fungus goes into the eye also, beta. Okay. Drug of choice. Liposomal amphotericin B. Liposomal amphotericin B, beta. Very, I'm sure you would have heard this word in the news and everyone, beta. Amphotericin B, beta. Which type? Liposomal type, beta. The liposomal variety is more safe, beta. Liposomal amphotericin B was actually the drug which was very much in demand in the last year, was this drug, beta. Liposomal amphotericin B plus debridement. Don't forget, beta, dead tissue should be debrided also, beta. Don't forget, it is not just this one, plus debridement also, beta. Debridement also. Debridement is dead tissue. Debridement, I hope debridement is also done. It is written over there in your notes also. Debridement is done first, beta. It's a rule. When there is a dead tissue in your body, please remove it, beta. Otherwise, the body will not respond to the treatment also. Okay? Debridement. Debridement also, beta. Plus debridement. Okay? Fine? Cha. Fine, beta. Guys, this is a very wonderful clue in the question. Something black in the nose, something black around the nose in a young diabetic patient or HIV positive patient or a COVID-19, that is definitely mucormycosis, and the drug of choice will be liposomal amphotericin B plus debridement should also be done first, beta. Okay? Now, let us go to the next topic, VMR, beta. Vasomotor rhinitis. Everybody, vasomotor rhinitis. VMR, vasomotor rhinitis. Vasomotor rhinitis. It is parasympathetic overactivity in nasal mucosa. Vasomotor means something like the autonomic system, beta. Vasomotor. In you and me or normal people which do not have any disease of nose like this, in them sympathetic system of nose supply is equivalent and opposite to parasympathetic supply of the nose, beta. I hope sympathetic and parasympathetic, two wings of the autonomic system, are opposite to each other, beta. But in these people, what happens is one part gets more dominant, and that part is parasympathetic element, beta. There is parasympathetic overactivity in nasal mucosa. Now, clinical presentation, beta. On change of temperature, doctor, when I get up in the morning, my room is very cozy. My heater is on in the room, and I go out of the room in the fresh air. Outside air is very chilly, very cold air. Suddenly, I start feeling irritation in my nose feels itchy, and lot of watery secretions start coming from my nose. What happened, beta? Change of temperature will stimulate your autonomic nervous system. In this case, parasympathetic system gets overactivated. And I hope you remember, parasympathetic innervation increases the secretion of the glands. Parasympathetic system increases the secretion of the glands, beta. And in this case, parasympathetic system is overactivated on change of temperature. And that's why lot of secretion, lot of watery rhinorrhea start coming from the nose, beta. Doctor, when I go out of the room in the fresh air which is colder, my nose feels itchy and a lot of watery discharge comes from my nose. That's a typical picture and complaint of this patient, beta. On change of temperature, patient gets excessive watery rhinorrhea and itching in the nose, beta. And itching in the nose, beta. you should know as a doctor. You know what, that's diagnosis, beta. Doctor, when I go out of the room, I feel it's very cold air outside, my nose feels itchy, and a lot of watery secretion comes from my nose, as if somebody opened the tap like that. Excessive watery rhinorrhea and itching in the nose. Treatment of VMR is surgery, beta. Surgery. Surgery, beta. What is the name of surgery? Vedian neurectomy. How to remember, beta? VMR, V ka badla V, beta. Vedian. V for V, beta. V for V. Vedian. V for VMR, V for Vedian. V for VMR, vasomotor rhinitis need Vedian neurectomy. Vedian neurectomy. Vedian nerve, anatomy question, nerve of pterygoid canal. Put an arrow. This nerve gives autonomic nerve supply to nose. This nerve gives autonomic nerve supply to nose. We have to cut that nerve, beta. This nerve gives what? Vedian nerve, also called as nerve of pterygoid canal. This nerve gives autonomic nerve supply to nose, beta. Autonomic nerve supply to nose. This nerve gives autonomic nerve supply to nose, beta. Okay, bache, fine. Okay, bache, what is the point to be remember? VMR, full form is vasomotor rhinitis. V for VMR, treatment is V for V, beta. V for V. V for which nerve to be cut? Vedian neurectomy. Vedian nerve, also called as nerve of pterygoid canal, and this nerve is responsible for giving the autonomic nerve supply to nose, beta. One question, beta. Now one more question is rhinitis medicamentosa. Rhinitis medicamentosa is a pharmacology question also, beta. This can be pharmacology question also. Rhinitis medicamentosa, it is cause. What is cause? I don't know cause, beta. Cause word. Cause is prolonged use, write down the word cause, prolonged use of decongestant nasal drops. Prolonged use of decongestant nasal drops, beta. Prolonged use of decongestant nasal drops, beta. Prolonged use of decongestant nasal drops. Have you heard this? Have you seen this medicine ever? Otrivin. Have you seen this medicine ever? Otrivin, beta. Otrivin. Otrivin. Suna we have Otrivin, beta. Otrivin. Xylometazoline. Xylometazoline. What are they? They are decongestant nasal drops. When your nose is blocked, you put these drops, you feel much better. They are very good medicine. I'm not saying they're not. I'm using it in my patient very often, beta. Very often. You can use it for 1 day, 2 day, 3 day, 4 day, 5 days, 6 days. No problem. 1 week also, no problem. But if you start using for months and months and months, your system will be dependent on this drug, beta. Now when you put it, your nose opens, the effect finishes, the nose gets blocked. Because your system got dependent on this decongestant. Look at that, beta. Causes prolonged use of decongestant nasal drop, beta. Prolonged use of decongestant nasal drops, beta. For example, xylometazoline or oxymetazoline. Right, now put an arrow. This leads to rebound congestion. This leads to rebound congestion, beta. This leads to rebound congestion. Rebound congestion means the moment the effect of decongestant finishes, there is a reflex congestion, beta. Your system has got dependent on that drug, and the moment the effect finishes, there is a rebound vasodilatation and congestion, beta. Now what's the treatment? Under the treatment, number 1, stop these drops. Number 2, start steroid spray, beta. Please don't forget, start steroid spray. Of course, stop these drops. But patients say, doctor, I'm ready to stop the drops, but I'm not able to breathe. Okay, I've done something wrong, fine, but I'm not able to breathe. Then what shall I do? Start steroid spray. You know why? When you put a steroid spray in the nose tissue start getting shrunken, and when they turbinate, when they shrink in size, at least you will have more breathing space to be opened, beta. So steroid induces a little bit shrunken changes in the tissues of the nose, and that's why the nasal pathway start becoming open, beta. Okay, bache, fine. Now, let us start the next topic. Olfaction. Oh, very good. Olfaction is equal to sense of smell. Olfaction is equal to sense of smell, beta. Olfaction is equal to sense of smell. Sense of smell. Olfaction. Olfactory epithelium lines upper 1/3 of nasal cavity, means roof of nasal cavity, beta. Olfactory epithelium lines upper 1/3 of nasal cavity. This is your olfactory epithelium, beta. This is your olfactory epithelium. Olfactory epithelium lines upper 1/3 of nasal cavity. Anybody you can tell me, what are these neurons, beta? What are these neurons, beta? Olfactory neurons pass through which plate? Cribriform plate. Remember the diagram, beta? Olfactory neuron pass through cribriform plate. Now, at this moment, everyone, if you're doing active revision with the sports shoes on, then you will go like this, beta. Oh, everybody go to page number 15, beta. Everybody open up your book, page number 15. Everybody go to page number 15, bache. Let me tell you how to revise medicine, surgery and all that, beta. Not ENT and all. ENT is, you can do on your own also. I'm telling you, beta. ENT तो बहाना है. ENT is an excuse. मुझे तुम्हें पास करवाना है भाई. I want to see you pass to stand on one side of the other side of 150. So all these things are my own, failures, which I'm telling you. Okay, page number 15, okay? Okay, yeah, it's a cribriform plate, ethmoid bone, olfactory neuron passing through there. Now we come over here and correlate, correlate, okay? That's how we'll revise, beta. This will make us confident about our notes. Yes, I know them, beta, okay? Chala. So olfactory epithelium lines upper 1/3 of nasal cavity, okay? Fine. Now, olfactory neuron pass through which plate? Cribriform plate. Fill in the blank, beta. Olfactory neuron pass through cribriform plate. Cribriform plate. Olfactory neuron pass through cribriform plate. Anybody with a part of which bone? Part of which bone? Ethmoid bone. Yes, I know. Part of which bone? Ethmoid bone, beta. Olfactory neuron pass through which plate? Cribriform plate, which was the diagram of which bone? Ethmoid bone. Try to correlate. Oh, page number 15. If I am in your shoes, I'll write on here page 15, beta. I'll try to write page 15 here. Oh, I'll just correlate. Oh, page 15 and the same diagram was there. Okay, fine. Now, next one, beta. Anosmia is total loss of smell. Anosmia is total loss of smell, beta. Total loss of smell. Okay. Then hyposmia, decreased sense of smell. Of course, hypo is lower. There is smell but less smell. Okay. Hyposmia is decreased sense of smell, beta. Now, what are the causes, beta? What are the causes of this, beta? Causes, put a bracket, causes. Causes, beta. Smell nahi aa rahi hai, smell nahi aa rahi hai, smell nahi aa rahi hai, no smell, no smell, no smell. What are the causes of this, beta? There are two causes. Smell nahi aa rahi hai, smell problem, two causes. What are the two causes? या तो नाक बंद है, either nose is blocked, या तो नाक बंद है, या दिमाग बंद है, या तो नाक बंद है, या दिमाग बंद है. Means either the nose is blocked or the brain is not able to sense the smell. How we smell, beta? There's a tea in my cup. How I'm smelling this? Okay, which kind of flavor it is? This air carries the aromatic smell to my nose, beta. If nose is blocked, for example, there is polyp in the nose. If your nose is full of polyp, how will you smell, beta? So obstructive cause, nasal polyp. Other is neurological cause, brain problem, neurological cause, brain problem, okay, like head injury. What goes wrong in head injury, beta? Look at me, beta. In head injury, what will happen? Look at screen, beta. In head injury, look at me, beta. Somebody fell down, the skull hits the ground like this. Don't you think so? This is going to cut all the nerves, beta. The fracture might damage all the olfactory neurons and then you permanently lose the smell, beta. So head injury patient can complain of anosmia after recovery. Because head injury fractures may damage all the olfactory fibers, beta. Okay, then COVID-19. Who can forget COVID-19, beta? Oh, this is the MCQ, beta. COVID-19 question of August 2020 MCI paper. August 2020 MCI paper, beta. If you remember, August 2020, there was COVID has started. There's a lockdown going on. They asked the question: a medical student with a travel history from China, exactly the same language. Medical student with travel history from China has developed fever, throat pain, running nose, and is complaining of loss of sense of smell. What is the most probable diagnosis? COVID-19. COVID-19, na? COVID-19, how many people suffered smell issues? But fortunately recovered, most of them recovered, beta. Okay? And number 3, Parkinsonism. Then Alzheimer's disease, beta. Alzheimer's disease, beta. Parkinsonism is an ultra important topic of medicine, beta. Parkinsonism, Alzheimer's, epilepsy, stroke, multiple sclerosis are 5 important topics of CNS, beta. I repeat, Parkinsonism, epilepsy, Alzheimer's, multiple sclerosis and stroke are 5 very important topics of CNS in medicine, beta. We will not leave these topics. We will not really go to the exam without doing these topics properly, beta. We know that they are important. We should not keep our eyes shut. We should really jump into them, learn them, revise them, beta, as much as possible. I may not be the perfect one. I'm not the best one. I don't want to be the best one. But I'm doing my best. I'm not the best, but I'm doing my best. They're 2 different things, beta. Being best is tough, is laborious, is boring, beta. Being best is too much of task to carry. I'm not the best, but I'm doing my best. May God bless my hard work. That's what I have been doing all through my life, I think. Since the time I learned all these things, actually, in my PGE preparation days, that was the time it changed me big time, actually. And I'm sharing the same with you as well. Because I know all these questions keep bothering us. How much is sufficient, beta? We don't know, but you can't do everything about everything. But you know what are important things and definitely do that in proper way, beta. I'm not the best, but I'm trying to do my level best. How to do my level best? To keep your eyes and ears open. What question is being discussed? What question came in last 4 years session of MCI paper? Those topics are important. I don't want to keep my eyes shut on for those topics. I want to study epilepsy. I want to study Parkinsonism. I want to know pharmacology of anti-epileptic drugs. I want to know the pharmacology of Parkinsonism management. I know they will be asked again, but I'm not the best, but I'm doing my best in the given scenario. May God bless my hard work. That's how the life will keep on, giving us challenges. But if we just stick to this rule, basic rule, we'll sail through most of them, beta. We'll sail through most of them. Okay. Now, one more question of gynecology, Kallmann syndrome, beta. Kallmann syndrome is anosmia plus hypogonadism. Anosmia plus hypogonadism, beta. Smell problem with the infertility problem. Beta. Hypogonadism is equal to infertility, beta. Sometimes they write infertility. Okay, anosmia with hypogonadism or infertility is syndrome called Kallmann syndrome, beta. Kallmann syndrome. Kallmann syndrome. Anosmia plus hypogonadism is Kallmann syndrome, beta. So I remember smell problem, fertility problem combined together is Kallmann syndrome, beta. Okay. Now, a patient of anosmia, next, this is a very famous question, beta, of MCI. A patient of anosmia can still sense ammonia, beta, NH3. Why? Because it's not a smell, it's an irritant. It is sensed through trigeminal nerve. Two question, beta. A patient of anosmia can still sense ammonia. Ammonia is not a smell, it's an irritant. It is sensed through trigeminal nerve. It is sensed through trigeminal nerve. Ammonia is not a smell, it's an irritant. It is sensed through trigeminal nerve, beta. So two question here, ammonia and trigeminal nerve. There are two question here, ammonia and trigeminal nerve, beta. Okay, bache. Guys, can you see this question, beta, everybody? MCI question. How this question is twisted now. A patient in ENT examination was found to be non-responsive to smell of tea, coffee and asafoetida. Non-responsive to tea, coffee, tea and asafoetida. What is asafoetida? Hing, beta, hing. You know hing? Hing is a very powerful spice which we use in a lot of Indian dishes, actually. It's a very powerful spice. Somebody who cannot smell hing even, he is suffering from anosmia. This patient is suffering from anosmia. He is able to respond to which agent? Ammonia. Wow, ammonia, beta. This is called clinical question, beta. Clinical scenario. They say it's very difficult. I say difficult look like, but common sense if intact and you just don't over-dissect the question. So non-responsive to smell of, he's talking smell of coffee, gone. Tea, gone. Hing, gone. Then which agent can, oh, anosmia patient can still smell ammonia, beta, ammonia. Are you able to really, everybody say yes or no in the chat box or telegram? Could you really understand this question? Could you respond to this question and you convince you can handle such question in the exam? Say yes or no in the chat box or in telegram, beta. Am I clear, beta? Fine. Are everybody okay? Okay. Now, can we do another question, beta? Fracture of nasal bone. Nasal bone fracture. The ideal treatment is immediate reduction of 48 hours. Put POP cast only or reduction of 7 days? Answer is immediate reduction, beta. No swelling mentioned. Huh? If swelling is given in the question, then you wait for 7 days and then do the reduction. The answer to this question is A, beta. A. Nasal bone fracture should be reduced immediately before swelling comes. But if question already says swelling is present, then you mark D, beta. Reduction after 7 days, beta. Somebody is asking Samter triad, beta. Samter triad is more of, allergic triads. Samter triad is allergic triad. Samter triad means allergy to aspirin. There is asthma along with that, and there is a polyp formation in the nose also, beta. Okay, now. Can you tell me, beta? Ongren line is used for which of the following, beta? Ongren line is used for which of the following? Ongren line. Total maxillectomy, partial maxillectomy, prognostic evaluation, or laryngectomy in cancer larynx. Ongren line came where, beta? Was it for surgery or was it for prognosis, beta? It was for the prognostic evaluation of the carcinoma of the maxillary sinus, beta. I hope you remember, Ongren line is not for the surgery. It is for the prognostic evaluation of the cancer of the maxillary sinus, beta. Am I clear, beta? Is the question clear? C. Okay, fine. Which of the following is the best description of Pott's puffy tumor? I hope you remember, Pott's puffy tumor is not a tumor. It's not a tumor, beta. It is what, beta? Pott's puffy tumor is what? Subperiosteal abscess of frontal bone, beta. I hope you remember, the Pott's puffy tumor is not a tumor, beta. It is actually subperiosteal abscess of the frontal bone. It's not a tumor. C is the answer, beta. C is the answer. Am I clear, beta? Subperiosteal abscess of frontal. Subperiosteal abscess of the frontal bone. Pott's puffy tumor is not a tumor. It's an abscess of the frontal bone, beta. Now this, please look at the clinical question of your future paper, beta. 29-year-old HIV positive individual present to emergency in critical state with deranged vital. Examination shows a blackish necrotic debris in the nasal cavity with the necrosed skin external nose. What the treatment of this patient is? What is the treatment? This is black color. What is this, beta? This is what, beta? Mucormycosis. Now, answer is amphotericin B, beta. A. Can you see, beta? They look like clinical question, but you know what is asking simply? Drug of choice of mucormycosis, amphotericin B. That's all. You know, a lot of questions are like that. They look like clinical, they look like very story based, but if you know the essence of blackish thing in the nose, mucormycosis, drug of choice is amphotericin B. Plus debridement also, by the way. In fracture maxilla, most commonly nerve involved is, if you remember maxilla, which nerve? Infraorbital nerve, supraorbital nerve, trochlear nerve or mandibular nerve? Maxilla, which nerve is there, beta? Infraorbital nerve, beta. A. Remember cheek anesthesia, infraorbital nerve injury, maxilla fracture. Okay? Very good. Onod cell, Onod, O-N, optic nerve. Onod optic nerve, Onod optic nerve, beta. Onod optic nerve, O-N, optic nerve. Onod cell, Haller cell. Onod optic nerve, Haller cell orbital floor, beta. D is the answer, beta. A is reverse, beta. A reverse. Onod optic nerve, Haller orbital floor. Okay, Onod, O-N, Onod optic nerve, Haller orbital floor. Which is not true statement. Osteomas are most common in frontal sinus, correct. Malignancy is most common in maxillary sinus, correct. Fungal ball or aspergillomas are most common in ethmoid sinus, wrong. In maxillary sinus. Fungal ball are most common in maxillary sinus, beta. Mucocele are most common in frontal sinus, beta. C is the answer, which is not a true statement, not. Fungal ball are most common in maxillary sinus. Osteoma, frontal sinus. Mucocele, frontal sinus. Malignancy, maxillary sinus. Fungal ball, maxillary sinus, beta. Okay. The radiological presence of which sinus appears at 6 years of age, beta? 6 years. Remember? M, E, S, F. Sphenoid at 4 years, frontal at 6 years, beta. The answer is frontal sinus. Sphenoid comes at 4 years, frontal comes at 6 years, beta. Answer is 6 years, frontal sinus. Chalo. Let's go back to the notes, beta. Chalo. There are a few questions like that. Next topic is nasal septum and its disorders, beta. Next topic. Nasal septum and its disorder. First of all, nasal septum, put an arrow, it makes medial wall of nose. We have discussed the lateral wall of nose adequately. Let us come to the medial wall of nose, beta. Okay, now, septum is made of 7 parts, beta. 7, put a 2 arrow, 3 major, 4 minor. Septum is made of 7 parts, 3 major, 4 minor. 3 major, 4 minor. 3 major are, number 1, septal or quadrangular cartilage. Number 2, perpendicular plate of ethmoid. Number 3, vomer. Number 3, vomer, beta. Okay, bache, fine. Now what is it, beta? Number 1, this is number 1, beta. Number 1, number 2 and number 3, beta. Let us revise, beta. Number 1, septum has got 3 major parts. Everybody speak with me, beta. What are 3 major parts, beta? Number 1, septal cartilage, also called as quadrangular cartilage. Number 2, perpendicular plate of ethmoid. And number 3, vomer. Once again, beta, septum is made of 3 major parts and 4 minor parts. The 3 major parts are, everybody speak with me. Number 1, label it, beta. Number 1, septal or quadrangular cartilage. Number 1, put a number 1 here, beta. Number 2, perpendicular plate of ethmoid. And number 3, vomer bone, beta. Vomer. 1, 2, 3, beta. 1, 2, 3. So these are 3 major parts, beta. And then comes the 4 minor parts, beta. Write down 4 minor parts. 4 minor parts. Number 1, spine of maxilla, spine of frontal bone, spine of maxilla, spine of frontal bone, rostrum of sphenoid, and crest of palatine and maxillary bones. Crest of palatine and maxillary bones, beta. Crest of palatine and maxillary bones, beta. Okay, fine. Let us revise once again. 4 minor parts. Speak with me, beta. बोलने से याद होगा बेटा, ये तो रट्टा मारने वाली चीज है. Spine of maxilla, number 2, spine of frontal bone, rostrum of sphenoid, crest of palatine and maxillary bones. Okay, let's once again see the 7 part. बोलो मेरे साथ बोलो. 3 major part, 4 minor. 3 major part. Number 1, Number 1, septal or quadrangular cartilage. Number 2, perpendicular plate of ethmoid. And number 3, vomer. These are 3 major parts. Then comes up 4 minor parts. Number 1, spine of maxilla, spine of frontal bone, rostrum of sphenoid, crest of palatine and maxillary bones. How the question come in the exam? Look at me, everyone. Which of the following skull bone does not contribute to formation of septum? Which of the following skull bone does not contribute to formation of nasal septum? Number 1, sphenoid. Number 2, palatine. Number 3, frontal. Number 4, lacrimal. What is the answer? Lacrimal. Sphenoid is here. Frontal is here. Palatine is here. But lacrimal bone never came. That's how they make the question. Okay, fine. Now, next topic is DNS. Deviated nasal septum. DNS, very, very common problem. Everybody draw a picture here, beta. Just here, draw on the side a picture. Like that. Or everybody just draw a picture like that. DNS, beta. Okay, everybody draw a picture. DNS, septum is deviated to one side, beta. Very common condition. Very common condition in the practice also. DNS, it can lead to a lot of things, beta. DNS can lead to nasal blockage on deviated side. Nasal blockage on deviated side. It can lead to nasal blockage on deviated side and crust formation on patent side. Crust means dried mucus due to increased airflow. Crust means dried mucus due to increased airflow, beta. Everybody look at the screen, beta. This is your DNS, inferior turbinate, inferior turbinate, beta. Now please look at screen and tell me this side flow is less. So nasal blockage on the deviated side. But this side flow is more. Flow is more than required, beta. This side flow is less than required. This side flow is too much, more than required. Now too much of flow is also a problem. Too much of flow causes dryness. The nasal mucus become dry and there are scale formation in the nose which are called crust, beta. Crusting in the nose, beta. What will happen due to this increased airflow? The nose will be having crust formation in the nose, beta, like this. Beta. Can you see crusting? Like this, beta. Nose will have crust formation in the nose. What is the crust? Look at your workbook, beta. Crust, this is crust, beta. Crust means dried mucus due to increased airflow. Now think like a doctor, Nasal airflow, both sides should be medium flow, beta. Less flow causes blockage feeling, more flow causes dryness feeling, beta. But fortunately, nature would stop it after some time. How? Nature increases the size of inferior turbinate on the patent side to decrease the flow on the patent side also, to make it optimal. Now, look at the next point, beta. Look at the next point. There is compensatory IT, T capital, beta. T capital. Put an arrow like that, beta. Therefore, beta. So relate kar lete hain. There, put an arrow, therefore. Just this crust formation of patent side, crust means dried mucus due to increased airflow. Therefore, nature try to compensate. Nature doesn't want crusting, beta. Nature doesn't want crusting. So that nature causes compensatory inferior turbinate hypertrophy on the patent side in the bracket ITH, beta. Everybody label it ITH. This is ITH, beta. Can you see in the diagram? Can you see the inferior turbinate became bigger in size? Okay. ITH, inferior turbinate hypertrophy on the patent side. ITH on the patent side, beta. Okay, bache? So nature does what? Nature doesn't allow this to happen, beta. Nature is going to save you. Nature is going to save you by what is going to increase the size of inferior turbinate, ITH, beta. Now ITH gives appearance of mulberry-like appearance of nasal mucosa, beta. Now look at your note, beta. How does ITH look like? ITH, inferior turbinate hypertrophy, gives mulberry appearance of nasal mucosa. MUL, irregular appearance, beta. Mulberry appearance of nasal mucosa. ITH gives mulberry appearance of nasal mucosa. ITH gives mulberry appearance of nasal mucosa. Okay, can you see beta mulberry appearance, beta? The is irregular kind. What have you seen mulberries, beta? Have you seen mulberries? You're not seen mulberries? I brought few mulberries for you, beta. This is mulberry, beta. Okay. Can you see mulberry? Red granular kind of picture. So turbinate look like mulberry, beta. Mulberry appearance of nasal mucosa. Okay, mulberry appearance of nasal mucosa is a feature of ITH. What is ITH? Inferior turbinate hypertrophy. Okay, beta, fine. Mulberry appearance of nasal mucosa, beta. Now, DNS can cause hyposmia. DNS can cause sinusitis. DNS can cause epistaxis. DNS can cause extranasal deformity. DNS can cause headache. The headache is also called as Sludder's neuralgia. It's like a pain, like a neuralgic pain, beta. Sludder neuralgia, put an arrow, also called anterior ethmoidal neuralgia. It is due to contact between DNS and middle turbinate. When the DNS start touching the middle turbinate, then it leads to excitation of the anterior ethmoidal nerve, and that leads to pain, and that headache is called sludder neuralgia or anterior ethmoidal neuralgia. Beta. Okay, am I clear, beta? Fine. Treatment of DNS is surgery called septoplasty. Treatment of DNS surgery called septoplasty. Septoplasty, beta. Septoplasty. Okay. Let us revise these things, beta, one more time. What is full form of DNS? DNS is deviated nasal septum. Now, DNS can lead to nasal blockage on the deviated side and crust formation on the patent side. Look at your note, beta. Crust means dried mucus due to increased airflow on the patent side. But nature would not allow it for a very long time. Nature will cause compensatory ITH on the patent side. What is ITH? Inferior turbinate hypertrophy. ITH gives what type of appearance? ITH gives mulberry appearance of nasal mucosa. Number 4, DNS can lead to hyposmia, smell problem, smell, flow, less flow means less smell, sinusitis, because DNS can block the flow of the sinuses, bleeding from nose, dryness, epistaxis, outside nose will be deformed, and then there will be headache called sludder neuralgia, which is due to contact between the DNS and middle turbinate. Okay, beta. Now, the treatment of DNS surgery called septoplasty. Now, there is a funny word called septodermoplasty. Just to make sure that you don't confuse the two words, septoplasty is very common surgery. But septoplasty means to make the septum straight. But septodermoplasty, this surgery is done to prevent, not present, but prevent, P-R-E-V-E-N-T, V. Prevent recurrent epistaxis in a particular disease called Rendu-Osler-Weber disease. Just one-liner question, beta. Why I'm telling you is a PG question, not MCA question, but you never know one-liner question. Septodermoplasty. Everybody knows septoplasty. Very common surgery. But septodermoplasty is a special surgery. It's a rare surgery. It's a rare surgery, beta. Rare one. Light on the bracket, rare. It's a rare surgery. It is done to prevent recurrent epistaxis in Rendu-Osler-Weber disease, beta. Rendu-Osler-Weber disease, beta. Rendu-Osler-Weber, 3 different people. पूरी full street का नाम है बेटा, पूरे मोहल्ले का नाम है, पूरी गली का नाम है. Rendu अलग, Weber अलग, Osler अलग. All the literature is European, beta. Whatever we read in India, in allopathic science is European literature. Indians never wrote literature, beta. Indians never wrote medical literature. Have you ever heard Gupta ji syndrome, Sharma ji sign, Reddy syndrome, or any Indian name syndrome? Beta. Never. We have never heard. But that does not mean that these syndromes only occur in the Europe or America. These syndromes occur much more commonly in India than any other place in the world, actually, I would say. Because every 6th human on the planet is Indian. Every 6th human on the planet is Indian, beta. How can we not have? We will have these diseases. They look like European, but they are Indian diseases, beta. ये हमारी disease है, beta. यार 3 Idiots में डायलेक्ट था, 3 Idiots में डायलेक्ट था ना, ये एक डायलेक्ट था ना कि बोल ये रहे हैं, शब्द हमारे हैं. बोल ये रहे हैं, शब्द हमारे हैं. You know what? That kind of thing, beta. Diseases named are European, beta, but they belong to Indian, population, because we are, every 6th human on the planet is Indian, beta. Canada is 2nd largest country in the world. Population of 3 crore 20 lakh. 2nd largest country in the world area-wise, population 3 crore 20 lakh. These many people just take bath on one day on the occasion of Kumbh Mela in Uttar Pradesh. इतने लोग तो कुंभ के मेले में नहा के चले जाते हैं हमारे यहाँ पे एक दिन में ही. Can you imagine? Nearly we're touching 1.4 now. So we, as Indian doctors, get to see all these diseases much more common than the European or Canadians or Americans, beta. That is for sure. So don't go on the fancy names. They are there in India. So septodermoplasty is a rare surgery done for a rare disorder called Rendu-Osler-Weber disease. Now, one more question of NEET PG, beta. Most common long-term complication of FES or septoplasty. Write down. The highlight word is long-term, beta. Most common long-term complication of FES or septoplasty is, write down, Sinuses formation. Sinuses मतलब adhesion formation. Sinuses or adhesion formation. Sinuses मतलब चिपक जाना. Sinuses मतलब to attach with each other, beta. Sinuses or adhesion formation. Adhesion formation. Can you see this picture, beta? Turbinate, inferior turbinate and septum, they got glued to each other, they got adherent to each other, and this is called Sinuses. Sinuses. Why? When you did surgery, you made a raw area here, you made a raw area here, and 2 raw areas want to fuse with each other, beta. And that fusion, that adhesion is called Sinuses. Can you prevent it? Yes. After surgery, if you apply a medicine over this area, if you paint this area with some medicine, that will decrease the chance of Sinuses formation. What is the name of that medicine? Write down. Treatment. Local application of mitomycin C. Second question, beta. Local application of mitomycin C reduces Sinuses formation. Local application of mitomycin C reduces Sinuses formation, beta. Am I clear, beta? Local application of mitomycin C reduces Sinuses formation. So 2 question beta. Most common long-term complication of FES or septoplasty is synecdoche or adhesion formation. Adhesion माने to get attached, मतलब चिपक जाना आपस में. This is synecdoche beta. You can very clearly see turbinate got adherent to septum. This is the synecdoche beta. Can you prevent it? Yes, local application of mitomycin C reduces synecdoche formation. Okay, fine. Now, let's go further beta. Everybody, next topic is septal hematoma. Septal hematoma beta. Septal hematoma. Next topic, septal hematoma. Septal hematoma. Look at screen beta. What is the cause of hematoma? Of course, look at screen beta. Cause is what? Trauma. Some history of trauma. Somebody punch your nose beta. Trauma. Cause is trauma. The important point is hematoma is bilateral. Look at screen beta. It is bilateral. Can you see both sides is hematoma beta? This side also, this is a swelling, blood collection here, hematoma. This is also beta, hematoma. It's a bilateral problem beta. So after trauma, both side nose got blocked. That's a typical scenario beta. Now read your notes beta. Read your notes. Septal hematoma is due to trauma. It is bilateral beta. Write down what it is beta. Try to make it. It is bilateral. Chief complaint is nasal swelling and bilateral nasal blockage. The key word is bilateral. Highlight the word bilateral. They will give you a history of trauma beta. After trauma, the chief complaint will be after trauma. After trauma, patient has nasal swelling and bilateral nasal blockage. Treatment is aspiration. That is the question beta. MCQ. That's the MCQ. What is the treatment of this beta? Aspiration beta. Treatment is aspiration. Put a needle, suck it out. Otherwise, it will convert to septal abscess, which will convert to septal perforation. Otherwise, look at your note beta. Otherwise, it will convert to septal abscess, which will convert to septal perforation beta. Septal abscess, which will convert to septal perforation beta. Otherwise, it will convert to septal abscess, which will convert to septal perforation beta. Everybody look at screen beta. Let us read this question. Please see on the screen beta. 7-year-old child while playing fell down. Trauma. He has developed a nasal blockage on both sides. Both sides nose got blocked. And there is swelling around the nose. Trauma leading to swelling and bilateral nasal blockage. It's a case of septal hematoma. This is how they make stories in the medicine, surgery, pediatric. When you know the essence of question, then you know the answer. Treatment of this child is aspiration of septal swelling. A. This is what the clinical scenarios are. But when you practice more MCQs of medicine, surgery, pediatric, orthopedic, you start getting to know, oh, which question is asking, I know that. Oh, it's Crohn's disease, it's ulcerative colitis, it's sigmoid volvulus, it's intersusception, it is colorectal carcinoma. No, it's actually Zollinger-Ellison syndrome. No, it is actually some like, you know, esophageal atresia or something like that he's asking like that. So you start getting hang of the question by solving the question, you know, of the different clinical subjects like that. But they are not that difficult as market may be telling you. Not all of them are easy. I will not lie to you beta. But yes, there are many questions which are doable question, and in the exam you have to know every second question to pass the exam beta. Believe me, have faith beta. May God bless your hard work. I can't predict who passes, who does not. But if we follow this path of practicing questions, solving, revising and all that, we're collecting so much of data and so much of familiarity with the questions already being asked in the exam, that on the exam day we'll see a lot of questions and we say deja vu. You know deja vu? There's a familiarity there beta. Okay? Next topic, septal perforation bache. Septal perforation. Septal perforation, can you see beta hole beta? This is the hole over there. This is the perforation beta. Septal perforation, the cause is trauma. Trauma is the cause. Trauma is the most common cause. Septal surgery. Cocaine snorting. You know cocaine, look at beta, cocaine, you know, cocaine snorting beta. And cocaine is a vasoconstrictor. Cocaine is a vasoconstrictor beta. It causes ischemia of your septum. Look at me beta. You know, you're daily inhaling a vasoconstrictor agent. It's going to cause ischemia and that is going to cause necrosis. And that's why cocaine addicts commonly have septal perforation beta. Cocaine addicts will have septal perforation beta. Then TB, lupus, leprosy will cause perforation of cartilaginous part of septum. I hope by now you know septum is made of 7 parts beta. Only 1 part is cartilage. Rest is bony part beta. Okay. Most of the disorders of perforation are in the cartilaginous part. But one unique disease which causes perforation of bony part, you must not forget, and that is tertiary syphilis beta. Tertiary syphilis. Not syphilis, but this is a star question. Bony part. Syphilis causes perforation of bony part of septum. Which of the following diseases cause perforation of bony part of septum? Syphilis particularly beta. Syphilis causes perforation of bony part of septum beta. Okay, bache. And finally, vaginous granulomatosis. Vaginous granulomatosis beta is again a disorder, autoimmune, perforation of both parts beta. But the question only comes of the syphilis beta. Don't forget which disease causes perforation of bony part of septum? Syphilis. Which syphilis? Tertiary syphilis beta. Now there is a hole in the nose beta. Chief complaint is whistling sound beta. दिन रात सीटी बजाते रहोगे आप. You know what? There is a whistling sound coming from your nose. Every time you breathe, तुम्हारी सीटी बज जाएगी. You know, very annoying for the family member who sleep next to you. If your wife is sleeping next to you, she would really kick you out of the house, you know what. But there's an advantage also, you know what. If one family member is whistling all through the night, then there won't be any theft in the house. Then you need not keep a watchman for the house. One member is already whistling in the house better. So that's also an advantage, but it's very annoying for the family member. So you have to stop it. You have to close it. Treatment is surgical closure of the perforation using septal buttons. Put an arrow. These are septal buttons. These are the picture is of septal buttons. Surgical closure of perforation using what? They are the button. Can you see buttons like thing? They are ready-made buttons which you put in the nose to close the perforation. Surgical closure of perforation using septal buttons, also called as septal obturators. They are made of silastic. The material is silastic. This is made of which material? Silastic. Just for information, not a question. You should know silastic is the material used very commonly in medical science for making different prostheses. So it's called septal button or septal obturator. This one septal button or septal obturator. It is made of silastic. Silastic is a special type of plastic, and this is used to close the perforation. Septal hematoma, septal perforation is important topic. Septal hematoma is very common in practice. I remember one of my friends and me were going for the lunch. From hospital we went to the lunch. It was his birthday actually. And we went to a very good place to eat. Actually, we were planning to spend some time together. And there was malls have got these malls are super clean malls. And there were big glass gates nowadays. Big glass gates. They are so clean. Sometimes they're not visible. This glass gate had got two pans actually. One pan was open, other was closed. Okay, one door was closed, other door was open. I passed through the open door, and this fellow passed through the closed door. When he was passing, and he smashed his head into the glass, and suddenly it hit the nose from front, and he had a septal hematoma. Septal hematoma. I've seen it practically, live hematoma I've seen actually forming. So it's trauma there. If you don't drain the hematoma, perforation can happen. Okay, one question out of perforation is tertiary syphilis cause perforation of bony part of septum. Please don't forget this one. This is important. Tertiary syphilis, bony part of septum. Okay, fine. Okay. Chalo. Now, the first topic is atrophic rhinitis. Everyone open your notes now. Everyone open your notes. Atrophic rhinitis, the first topic, also called as ozena. Ozena. Wherever you see the word ozena, you think of atrophic rhinitis. Now, what is atrophy rhinitis? Atrophic rhinitis means the tissue gets shrunken. It is atrophy of turbinates. Atrophy of turbinates, mucosa, submucosa and underlying bone. The turbinates, look at this picture. Look at this picture. The turbinates have become very small in size. Atrophy means they get shrunken. Okay. Next line. It is more common in females. Next line. It is more common in females. It is more common in females. It is more common in females. It's more common in females. Am I clear? What are the causes of it? Causes. Number one, autoimmunity. Autoimmunity means tissue destruction. So tissue are being atrophied. Then vitamin D deficiency, because some people said all are possible hypotheses. Some people say the tissue, the vitamin D is deficient. That's why these bones get shrunken. Some people say it's estrogen deficiency. Female, it's more common in female. Estrogen deficiency, estrogen deficiency. Then infection by, yes, this is MCQ. Infection by Klebsiella ozinae. MCQ. Infection by K mane Klebsiella ozinae. Do remember the infection. The other are also all of these are hypotheses. None of them is proven. Infection by Klebsiella ozinae. Okay. Infection by Klebsiella ozinae. Okay. Now, examination. Number one, shrunken turbinates. Did you see this picture? The turbinates are shrunken actually. And the cavities of the nose become very spacious. So, number two, roomy nasal cavities. Shrunken turbinates. Number two, roomy nasal cavities. If the turbinates are shrunken or atrophied, don't you think so? The turbinate, if they get shrunken, the nose will become very wide inside. More wide cavity means more air going in the nose and more dryness actually. So, there will be crust formation in the nose. I told you, nasal airflow should be medium flow. More airflow causes dryness. And crust means what? Crust is the dried mucus. Crust means dried mucus. Now, this crust is a big problem. Crust is the main hallmark of the disease. Crust is a big problem. This crusting is a big problem. This crusting is a permanent feature of this patient. Wide cavity, but they are blocked with the crust. Now, this crusting will lead to two problems. Crusting will lead to two problems. What are two problems? Number one, two complaints. Number one, nasal blockage. Please look at this. The cavities are so wide. The nasal cavity are so roomy nasal cavity, but the patient is still not able to breathe. Why? Because they are not open cavities. They are blocked with the crust actually. Okay. And there is a bad news. The bad news is that patient has got bad smell from herself. Why? Could you see that? These Crusts are yellow infected crusts, beta. Can you see? The crusts are yellow infected crusts, and don't you think so? These crusts will emit bad smell. The bad news is that patient emits bad smell. There's a very bad smell coming from the patient. But you know, the good news is patient has anosmia. Wow. Patient has anosmia. Patient emits bad smell. That is your problem. Patient could not smell anything. Wonderful. Patient से smell आती है, वो तुम्हारी problem है. Patient को कोई smell नहीं आती, ना अच्छी ना बुरी. Wonderful. Thank God anosmia है. Wow. Anosmia is good for health. Okay, for this patient. Okay. Okay. Now, but patient has anosmia. This is called merciful anosmia. Very possible question again, beta. Merciful anosmia. Very possible question this time again, beta. Merciful anosmia. This is called merciful anosmia, beta. This is called merciful anosmia. Merciful anosmia. Okay. Now, treatment is alkaline nasal douching mane. Douche mane wash. Wash your nose once in a week. Douche mane wash, beta. What is douching? Douche mane wash, beta. How we do the douching? Douche mane wash. There is a special powder. Look at me, beta. You take 1 spoon of that powder, dissolve in water, you know, make a solution of that, fill that water in the syringe like a holy pichkari, you know, jet. Put that jet of that solution in your nose, let the crust come out, beta. Okay, at least wash the nose at least 1 time in a week. That will take the crust out and that will give a lot of relief to the patient. Now this powder, this alkaline nasal douching powder contains 3 things, and that is the MCQ, beta. What are 3 things? MCQ, beta. MCQ. There are 3 components of the powder. The powder contains sodium bicarbonate, sodium biborate, and sodium chloride. Sodium bicarbonate, sodium biborate, and sodium chloride, beta. Sodium bicarbonate, sodium biborate, and sodium chloride, beta. Sodium bicarbonate, sodium biborate, and sodium chloride, beta. Okay. The 3 components of this powder are sodium bicarbonate, sodium biborate, and sodium chloride, beta. Once again, beta. The alkaline nasal douching powder contains 3 things, beta. It's a combination of 3 things. Number 1, sodium bicarbonate, sodium biborate, and sodium chloride, beta. Now, if you don't want this, we have a surgery option, beta. There are 3 surgeries. Young's operation, not done these days. Number 2, modified Young's operation. We are doing modified Young. Put a star here. This is what we are practically doing today. Modified Young, not Young. Young operation is not done nowadays. We are doing modified Young's operation nowadays, beta. What is modified Young operation? It is partial closure of both nostrils. You are stitching both the nostrils, beta. We are partially closing both nostrils. Partial closure of both nostrils, beta. Partial closure of both nostrils. Partial closure of both nostrils, beta. How we do it? Look at screen, beta. Look at screen, everyone. You are actually putting a stitch on the entrance of the nose to close the entrance half. Look at me, beta, here. Here, beta. Look at me, beta. Let me close this entry point of the nose. You close the entry point half, beta. Half you close it. Why? What is the problem in atrophic rhinitis? More air is going inside, more dryness, more crusting, and crust give bad smell from the patient, blockage to the patient, beta. If you close the gate half, less air will go inside, less dryness, less crusting, beta. So basically, you're closing the gate of the nose half, so that less air go inside, so less dryness, less crusting happen, beta. So modified Young, please look at this diagram also, this picture also. Somebody is applying a stitch at the entrance of the nose, and that's modified Young's operation, beta. And third surgery is Luton-Slager operation, beta. Luton-Slager operation. L-A-U-T-E-N, Luton-Slager operation, beta. Luton-Slager operation. S-L-A-G-E-R. beta. Luton-Slager operation. Okay. Okay, brothers. Luton-Slager operation, beta. But please remember modified Young not to be forgotten, beta. Okay. Now let us see the salient point of disease. One is atrophic rhinitis, is atrophy of turbinate, also called ozena. Please understand this disease is more common in female, beta. Female. Which bacteria? Klebsiella ozene. Then don't forget crusting, wide roomy cavities, and bad smell from patient anosmia. Do not forget merciful anosmia. An alkaline nasal douching powder contains 3 things: sodium bicarbonate, sodium biborate, and sodium chloride. Don't forget this. Modified Young's operation, please keep in mind, it is partial closure of both nostrils, beta. Second disease, beta. Rhinoscleroma or woody nose, beta. Rhinoscleroma, woody nose. Scleroma means hard. Always when you read, please think about the name of disease, beta. When you read the disease, think about rhinoscleroma. Scleroma means hard. It's called woody nose, beta. Woody nose. Anybody can tell me what was potato nose, beta? Potato nose was what? Rhinophyma. Phyma. Potato nose, na? But scleroma means hard nose, woody nose, beta. Okay? Potato nose was ompuri. Remember, potato nose was hypertrophy of sebaceous glands here, beta. That's separate disease. Rhinophyma is potato nose, right? Hypertrophy of the sebaceous glands, beta. But this is something else. Rhinoscleroma. Okay? Rhinoscleroma is woody nose, beta. It is chronic granulomatous infection of nose by Klebsiella rhinoscleromatis, beta. Klebsiella rhinoscleromatis, also called Frisch bacillus. Frisch bacillus. It is more common in North India, beta. North. UP and Rajasthan. Uttar Pradesh, Rajasthan. The disease of rhinoscleroma is reported more commonly from North India, particularly UP and Rajasthan, beta. Okay. Now it has 3 stages. It has 3 stages, beta. Number 1, atrophic stage. First stage is atrophic stage, is like atrophic rhinitis. Put an arrow. Put an arrow. Roomy cavity, crust, and bad smell. 3 things, beta. In the beginning, same symptoms will come as shown in atrophic rhinitis. Bad smell, roomy cavity, crust formation. In the beginning, the first stage is atrophic stage, is like atrophic rhinitis. So patient will be having same symptoms as bad smell from the patient, roomy cavity, crust formation, beta. But then come the granulomatous stage, and that leads to hard external nose, beta. Please look at screen, beta. The first stage is like atrophic rhinitis, but then can you see granulomas formation in the nose, beta? Did you notice any such thing in atrophic rhinitis? You tell me, in atrophic rhinitis, did you notice any outside change in the nose? No. Did I say that outside of the nose shape changes? No. Atrophic rhinitis is inside only, beta. Okay. But rhinoscleroma will be having first stage as atrophic rhinitis, but along with that, second stage will come later on, and that will lead to granuloma formation in the nose, and that is called woody nose or hard nose, beta. Okay. That feel of the nose becomes like a wood piece, beta. Irregular, hard, wood like a piece, beta. And number 3 is stage of fibrosis, beta. Number 3 is fibrosis stage. Okay, bache, fine. Now, biopsy is a famous question, beta. Biopsy shows Russell bodies and Miculus cell. Spelling, beta. Biopsy shows Russell bodies and Miculus cell. Russell bodies and Miculus cell, beta. Russell bodies and Miculus cells. Russell bodies and Miculus cells, beta. RB and Miculus cell. Russell body RB. Don't forget the Russell body. Don't forget this question, beta. Russell bodies, and this is one question of ENT pathology which is coming in your exam, beta. You should know Russell body and Miculus cell are 2 characteristic features of the rhinoscleroma. Write down RB. Write down RB. Russell body are solid blue cells, beta. Like plasma cells, beta. Russell bodies are solid blue cells, beta. Russell bodies are solid blue cells. Russell bodies, solid blue cell. Miculus cell are large vacuolated cell. Miculus cell are large vacuolated cell, beta. Russell bodies are solid blue cells, and Miculus cells are large vacuolated cell, beta. Large vacuolated cell, beta. Just I'm telling you detail, it's not required, but you should know because this is one question of ENT pathology which is asked in MCI exam also, beta. Guys, do remember NEET PG, INICET preparation is 30-35% or 40% above this level, beta. So, you know, when you prepare for PLAB, you appear in the PLAB. You can't appear in the PLAB and you prepare for USMLE. You understand? And vice versa also. When you prepare for PLAB, you can't appear in the USMLE, but every exam has a different focus areas, different detail requirement, different kind of diseases which are favorite for that particular exam. So, NEET PG would be like for all subjects for you guys, or for next examination for the PG exam later on. The same thing will be acting as a base. On the base, pizza base, there will be more toppings needed here and there, beta. Topping in the form of more detail of the topics, then more number of topics added, recent advances, and then more, you know, more diagnostic approaches and different things at a higher level of question, beta. But doable. That's also doable. It's not like, but yet right now we're focusing on our first level milestone, this exam. But after that, when you are done with this, the same information of different subjects would be acting as a baseline platform for you to jump up to the next level, beta. So Russell bodies are solid blue cell. Can you see, beta, solid blue cell, beta? These are Russell body, beta. Solid blue cell are Russell bodies, and Miculus cells are large vacuolated cell, beta. Okay, fine. Okay. Now, drug of choice. Drug of choice is tetracycline plus streptomycin. Drug of choice is tetracycline plus streptomycin. Tetracycline plus streptomycin, beta. Tetracycline plus streptomycin. In histopathologies, biopsy shows Russell bodies and Miculus cells. Miculus cell, Russell bodies and Miculus cell, beta. Okay, let us do this further, beta. Okay, look at screen, beta. Let us revise the topic. First of all, rhinoscleroma, also called as woody nose. It is caused by a bacteria Klebsiella rhinoscleromatis, also called as fish bacillus, and this disease is more common in North India. Now think about this disease as a doctor. The first stage of disease is just like atrophic rhinitis, and that's called atrophic stage. But then comes the granulomatous stage, in which multiple granulomas form on the nose, and that's why it is called woody nose. The third stage of fibrosis. The biopsy shows Russell bodies and Mikulicz cell, and the drug of choice is tetracycline and streptomycin. Please do not forget these two questions. Beta. Why to forget the question which have already been asked? Beta? Okay, Russell body, Mikulicz cell, tetracycline and streptomycin. Beta. Okay, bache. Now, next one is rhinosporidiosis. Rhinosporidiosis. Beta. Next third disease. Beta. Rhinosporidiosis is infection of nose by Rhinosporidium seabrai. Mind you, beta. Rhinoscleroma. Rhinoscleroma, bacterial problem, woody nose, and now rhinosporidiosis is infection of nose by Rhinosporidium seabrai. It looks like a fungus, but rhinosporidium, sporidium and a fungus. No, it's not a fungus, it's an aquatic protozoa found in the pond's water, beta. Aquatic na, water na, aquatic protozoa, beta. It's not a fungus, it is aquatic protozoa found in the pond's water, beta. So villages where you use ponds for your daily use, if you jump in the pond to take a bath, if the water of the pond has got this organism, your mucosa will come in contact with this organism. Wherever this organism will touch your mucosa, it can form the lesion over there. So infection is acquired by bathing in the ponds. It is more common in South India, beta, particularly Tamil Nadu. So the typical question of ENT, beta, Tamil Nadu resident. No other answer possible, beta. You know, all these things sometimes they play. Sometimes you are not sure about answer, but oh, resident of Tamil Nadu. Why Tamil Nadu? But why particularly Tamil Nadu? Such things are a solid clue in the exam, beta. Okay, please see, wherever some particular state or region has got a disease and the question also has the same word used over there, even if the other things are not clear to you, you know what is the diagnosis over there. So, resident of Tamil Nadu, beta. Okay, coastal part of Tamil Nadu. So, wherever the infected water touches the human mucosa, the lesion form. So, what are the sites involved? Of course, number one, nose. Look at me, beta. You jump into the pond water to take a bath, the water will enter your nose, your mouth, touch your eyes and your genital area mucosa also. Of course, nose is the most common site, that's why we call it rhinosporidiosis. Okay, oral cavity, conjunctiva and genital mucosa. Nose, oral cavity, conjunctiva, genital mucosa means wherever the infected water touches the human mucosa, beta. Okay, fine. Now please look at screen, beta. This is the classical picture. Very favorite topic, very favorite question, beta. Please, this kind of irregular mass, beta. This disease forms like a mass kind of thing in the nose, beta. Now this is called, write down, strawberry-like or mulberry-like, beta. Guys, mulberry word is coming second time, beta. This is strawberry-like or mulberry-like nasal mass, beta. Nasal mass. It's not a nasal mucosa. It's nasal mass. Can you see extra mass, beta? Strawberry-like or mulberry-like nasal mass with epistaxis, beta. Means irregular surface mass, beta. Irregular. Just look at this mass carefully, beta. Please see. Can you see this mass has got irregular, bossylated kind of appearance, beta, like a mulberry or strawberry kind of this thing. You know, mulberry, strawberry got this kind of depression and cuts and black points and all that. Same kind of bossylated appearance, and this as like contours are there like that. Okay, mulberry-like or strawberry-like nasal mass with epistaxis. I am reminded here, beta. Mulberry word came earlier also. Mulberry word came in the chapter of DNS. Mulberry-like nasal mucosa. If you remember, we said that. Let me show you. Don't do that. I'll show you, beta. I'll show you so that you are able to recall, beta. Oh. Can you remember the mulberry appearance of nasal mucosa? This is mulberry, not mass, beta. It's not extra mass. Only turbinates start looking like mulberry. It's okay. No extra mass there. Mulberry appearance of nasal mucosa is seen in ITH. What is ITH? Inferior turbinate hypertrophy, beta. Okay. What is this page number, beta? This page number is 24, beta. Everybody go over there, and this is what is called active revision when you revise, and just right here, page 24, beta. Another mulberry. There are two mulberries in ENT nose, beta. One is mulberry-like nasal mass rhinosporidiosis. Mulberry-like nasal mucosa is inferior turbinate hypertrophy. In ITH, there is no extra mass, beta. Only your own turbinates start looking like a mulberry. Here, there is extra mass formation over here. Mulberry-like nasal mass with epistaxis or strawberry-like nasal mass with epistaxis, beta. Treatment is surgery. Surgery, beta. Surgery. Excision of mass with cautery or base, beta. What is electrocautery, beta? Electrocautery means burn the base, beta. Burn. Electrocautery, look at me, beta. You remove the mass, you burn the base, beta. When you burn the base with current is electrocautery. In the operation theatre where machine got electrocautery, you burn it with the base with the electrocautery followed by Depson. Don't worry, beta. This is Depson is drug of choice, beta. This is given after surgery to prevent recurrence. Followed by Depson to prevent recurrence, beta. Okay, fine. Don't confuse rhinoscleroma. The previous topic, rhinoscleroma, it was tetracycline and streptomycin, beta. Rhinosporidiosis, is dapsone beta. Okay, fine. Guys, rhinoscleroma. Is there any rhinoscleroma has any D beta? No D na. Rhinoscleroma has no D na. Okay, no D na. No dapsone here beta. But rhinosporidiosis, D is there na. D is there. D will be of dapsone beta. Such kind of thing help you in the exam to take a very quick sure call because time is 1 minute beta. So rhinoscleroma or rhinosporidiosis confusion, which is dapsone? Rhinosporidiosis D for dapsone beta. Oh, dapsone comes on the rhinosporidiosis side. This question will never go wrong beta. Rhinoscleroma, rhinosporidiosis. D only comes in the rhinosporidiosis. So dapsone is towards this side beta. Let's quickly see the main point of this topic. First of all, rhinosporidiosis will be seen in Tamil Nadu beta. Basically there is a history of taking bath in the pond's water. The pond water contain aquatic protozoa called Rhinosporidium sebri that touches the human mucosa and makes lesion in nose, oral cavity, conjunctiva and genital mucosa, but mostly nose. The classical question is resident of Tamil Nadu with strawberry-like nasal mass or mulberry-like nasal mass with epistaxis. Treatment is surgery first of all. Remove this mass with electrocautery of the base beta. Burn the base with current. Okay, followed by dapsone. Dapsone is given after surgery to prevent recurrence beta. Dapsone is drug of choice here. Rhinoscleroma, drug of choice was streptomycin plus tetracycline. Okay, here dapsone is there. Now let's do the fourth topic beta. CSF rhinorrhea. CSF rhinorrhea is leakage of CSF from nose. Okay, CSF rhinorrhea is leakage of CSF from nose beta. CSF rhinorrhea is leakage of CSF from nose beta. Okay, this word came earlier also that from your nose CSF is leaking beta. Leakage of CSF from nose is CSF rhinorrhea. This is CSF rhinorrhea beta. Okay, now couple of things about it. Write down. Just see your notes beta. See your notes. Very important topic. CSF rhinorrhea. Very important topic. Okay. Now most common site of leak is cribriform plate. Most common site is cribriform plate. I know cribriform plate are ready-made hole in the roof of the nose beta. Most common site is cribriform plate. Cribriform plate beta. What are the causes? Number one, surgery, FES. FES beta. Surgery, FES. What is full form of FES beta? FES functional, F functional endoscopic sinus surgery. Functional endoscopic sinus surgery beta. Okay. Then number two, head injury. I hope you remember head injury. In that head injury only you saw this picture that CSF is leaking beta because of the fracture of the skull. Head injury, and this type of leak is called which leak? Traumatic CSF leak beta. Head injury will cause traumatic CSF leak, and please understand traumatic CSF leak is a blood mixed CSF beta. Put an arrow. It is blood mixed CSF. It is blood mixed CSF beta. The CSF is mixed with the blood. It is blood mixed CSF beta. Okay. Therefore, on filter paper, it gives a very important question: target sign or hello sign beta. On filter paper, it gives target sign or hello sign. On filter paper, it gives target sign or hello sign beta. Mind you, target sign or hello sign is only seen in traumatic CSF leak. Why? It is blood mixed CSF beta. Look at me beta. The drop by drop one blood CSF is coming, but that CSF contains blood. Now I keep a filter paper below the nose and I let one drop of CSF mixed with blood fall on the filter paper. I dry it and I see it across the light. I see a hello, central light point around that a hello actually. This is target sign or hello sign. Visual question. It's a seen in not a CSF rhinorrhea in general. Only traumatic CSF rhinorrhea or traumatic CSF leak beta. Yaad rakha bache. This is an important topic. This you have to remember. Traumatic CSF leak shows which sign on filter paper? Target sign or hello sign beta. Now, guys, look at me beta. Look at me. Now, please see. Drop by drop by drop CSF is falling. Can you see this lady? The drop by drop by drop CSF drops are falling beta. Now, I have a doubt. Is it CSF? Is it CSF? Or is it simple nasal secretions beta? Maybe he has cold or she has cold. Only the secretion of the nose are coming out from the nose beta. Now, most confirmatory test is collected in a bottle and send it to the lab for a protein. That protein is called beta-2 transferrin. That protein is found in the CSF, but it is not found in the nasal secretions beta. So it's a 100% confirmatory test is, look at the next line, most confirmatory test for CSF leak is, write down, beta-2 transferrin estimation. This protein is only found in the CSF. Beta-2 transferrin estimation, this protein is only found in the CSF but not in the nasal secretions beta. My doubt is it CSF or is it nasal secretions beta? So if this protein is positive in the sample you collected and sent to the lab, it means it's 100% CSF is there. Okay, fine. Now, other tests or points to differentiate CSF from nasal discharge. This is a costly test, beta. Okay, we don't do in every patient, but can there be simple things? Yes. Number one, CSF is non-sticky. Like what? Sorry. CSF is non-sticky like water, beta. CSF is like water, bache. CSF is non-sticky like water. Look at me, beta. CSF is non-sticky like water. Look at me, everyone. This nasal secretion is coming. You know, they are sticky. They are sticky. But CSF is like water. You know, can you see water? Is water sticky? When you take water on your hand, is it sticky, beta? Look at me, beta. When you take water on your hand, is it sticky? No. You can't make string out of this, na? But nasal secretion are sticky, beta. Sticky, na? So take it on a, of course, you can't take it on your hand, beta. You are not that great a doctor. Don't be like a god. Don't be like a god, beta. Don't be like a dog also, by the way. But don't be like a god also. Ki apna finger, you don't keep your finger below somebody else's nose and look like this, beta. That's not the medical professional should be doing. Take a handkerchief, not your handkerchief, but patient handkerchief, by the way. And just let the few drops fall on that and see on the cloth, is it sticky or not. That's all. Okay. Number two, very important point. Patient cannot sniff back CSF, beta. Patient cannot sniff back CSF, beta. You know sniff back? You know sniff back CSF? Patient cannot sniff back. It's not sticky, na? It's not sticky. So patient cannot sniff back CSF, beta. Sniff back. And I think you know, you can sniff back nasal secretion, beta. You can sniff back, like, you know, drop, falling cold, very bad cold. Sometimes you have a very bad cold and it's a Valentine day and you're sitting in Costa Coffee or Cafe Coffee day and across the table is sitting your girlfriend and you had a very bad cold on that day. It's like dropping like that and you're using tissues and all that. But you know, when you're talking, sometimes what happens is, there is a drop is about to fall on the table. And at that critical moment, you do like this, and you know, you just pull it back, you sniff it back, and you save yourself from such a bad embarrassment in front of your girlfriend. Okay? So patient cannot sniff back CSF, but patient can sniff back the nasal secretion, beta. Doctor, this I cannot sniff it back. If it is falling, it has to fall. However I may try, I cannot pull it back actually. Okay? And number three, biochemical analysis. Biochemical analysis, beta. Biochemical analysis, beta. Why? CSF has got CSF has got its own values of sugar and protein. You know, CSF value of sugar, protein, meningitis story. CSF has got its own value of sugar and protein. Somehow, you can get that crude. There's a crude test, beta. Crude test. But the best test is beta-2 transferrin estimation, beta. But these are the simpler tests, which may give you some idea. Like patient CSF is non-sticky, patient cannot sniff back CSF, and biochemical analysis. But the most reliable test is beta-2 transferrin estimation. This is the question also, beta, for exam. Okay. Now the next thing is test to find the site of leak. This is to confirm, is it CSF? Now, from where the CSF is leaking, beta, because nose, when you are leaking, but nose has got a big area from where it can leak. So what are the various tests to find the site of leak? Number one, nasal endoscopy. And put an endoscope and see from where it is leaking. Now, please see, what is the color of CSF? Transparent, no color. Now, if you put an endoscope, can you see the CSF leaking? Look at like a practical thing, beta. You don't get to see from where it is leaking, beta. Okay. So, can we give some color to CSF? Because CSF has no color. It's very difficult to see the CSF coming from somewhere. So think like a doctor, think like a smart doctor. You do a lumbar puncture, and inject what? Inject some dye over there. Which dye? Fluorescent dye. Which dye? Fluorescent dye, intrathecal injection. This will give green color to CSF. Which color? Green color. Nasal endoscopy with what? With this one, beta. Plain endoscopy might not give you any idea much, beta. Plain endoscopy might not give you much idea, but if you inject fluorescent dye, beta. Intrathecal means what? Lumbar puncture. If you do lumbar puncture, inject fluorescent dye. This fluorescent dye will give green color and the same CSF comes over here. And now when you do endoscopy, you don't see transparent thing. You see green color fluid coming from there and you know, oh, it is coming from there, beta. Then there are other tests like CT, cysternography, radiology test. CT, cysternography. Then MRI, T2 images. MRI, you know, T1, T2 images. T2 for CSF. And best radiological investigation to find the site of leak is HRCT, skull base. HRCT skull base, beta. HRCT skull base. HRCT skull base, beta. HRCT skull base. Okay. What is HR? Anybody? What is HR? What is HR? High resolution. High resolution, beta. HR is high resolution, beta. Okay. Finally, the treatment, beta. Now, please see, when I say CSF is leaking from your nose, you get so worried. Oh, CSF is leaking from your nose, beta. And you want to do urgent surgical closure. The choice will be, what's the treatment of CSF anuria? You will mark urgent because you think CSF is a very precious fluid of the body. Because physiology people teach us like that. They teach CSF in such a way that it is the most pious fluid of the body. But CSF is nothing, beta. CSF is nothing more than limca, beta. You know limca? Nimbu pani? You know, limca, lime water, limbu. What is CSF? Limca hi to hai, limca. You know, less water, salt, sugar, that's all. And it is being continuously manufactured also. So don't worry about it. Give the body time, because there is a fracture of the base of skull and lot of fracture heal on their own, beta. So don't put surgery as a primary treatment. It's a neurosurgery, beta. So neurosurgery has got its own complication. So treatment is not urgent surgery. Treatment is conservative treatment for 7 to 10 days with bed rest and antibiotic. Yes, I am concerned about infection, beta. I don't want meningitis to happen, because brain is connected to nose now. I don't want patient to develop meningitis for this case. So I will give antibiotic bus. But treatment is not urgent surgery. It's conservative treatment for 7 to 10 days with bed rest and antibiotics, beta. With bed rest and antibiotics. Okay, let us revise this topic, beta. You can see it's a full of question topic, beta. CSF rhinorrhea, most common site is cribriform plate. Then you should not forget, traumatic CSF leak gives halo sign or target sign, because it is blood mixed CSF. Most confirmed test is beta-2 transferrin estimation. Patient cannot sniff back CSF. Test to find, this is important, beta. How to find the site of leak? Endoscopy with which dye? Fluorescent dye, intrathecal injection. CT cystoscopy. MRI Tesla 2, T2 images. But the best radiological investigation is high resolution CT of skull base. Treatment is not urgent surgery, beta. Treatment is conservative treatment. Don't worry. Conservative treatment with bed rest and antibiotic for 7 to 10 days. In these 7 to 10 days, lot of fracture will heal and leak will stop. And if they don't stop after 10 days, then you think of surgery. But treatment, primary treatment is not surgery. Conservative treatment with bed rest and antibiotic for 7 to 10 days, beta. Okay? So these, look back, beta. These are 4 topics, beta. Look back, beta. Everybody just go through pages, beta. Atrophy rhinitis, rhinoscleroma, rhinosporidiosis, and now CSF rhinorrhea. Ultra important topic, beta. Okay? Chalo. Now we come to the last topic of the nose, blood supply of the nose and epistaxis, beta. Epistaxis. Okay, bache? Now, everybody, blood supply of nose. Blood supply of nose, beta. On the side, write down here. 80% from ECA, 20% from ICA. 80% from ECA, 20% from ICA, beta. Okay. Now, up to milliturbinate is ECA. Above milliturbinate, write down the word ICA, beta. ICA. ICA word is missing, beta. Up to milliturbinate is ECA. Above milliturbinate is ICA, beta. ICA, internal carotid artery. Internal carotid artery is towards the brain side, beta. Internal carotid is brain side here. Brain side, na? So, up to milliturbinate is ECA. Above milliturbinate is ICA, beta. Okay. Now, can we draw a line here, beta, so that we don't get confused? This is the ECA territory. From ECA comes 2 branches. Maxillary artery, facial artery. Maxillary artery and facial artery. Okay. From maxillary artery comes 2 branches further. Sphenopalatine artery, greater palatine artery. From facial comes superior labial artery, beta. Facial, outside facial, superior labial, upper lip. Superior labial, upper lip, beta. Palatine, palatine, labial. Sphenopalatine, greater palatine, and the superior labial artery, beta. Superior labial artery. Okay. From ICA comes which artery? Ophthalmic artery. And from ophthalmic, 2 arteries. Anterior ethmoidal, posterior ethmoidal artery. Anterior ethmoidal and posterior ethmoidal artery, beta. Anterior ethmoidal and posterior ethmoidal artery. Ethmoidal artery. Okay, bache. Mind you, the 80% is this circulation and only 20% is this circulation. 80%, 20%, beta. 80%, 20%, beta. 80%, 20%. Okay, Ajo. Now please understand, when you talk about these arteries, beta, these arteries are to be conceptualized, beta. Don't cram them without understanding it. Now when you look at somebody's face, beta, now please see, this is the common carotid artery here, and from there 2 branches come: external carotid, internal carotid. Okay. Now what are the 3 branches of external carotid artery? Just look at the screen, beta. Look at the screen. Sphenopalatine. Sphenopalatine, greater palatine, and superior labial. Now when I say sphenopalatine, palate, greater palatine, palate, superior labial is upper lip, beta. Now what is lying below the nose? Palate, lip, upper lip. Upper lip is what? Superior labial. It goes to the nose from here, beta. Then 2 palatine, greater palatine, sphenopalatine. So can you see 3 arteries are going from below upward like this, beta. 3 arteries like this. 3 arteries going from below upward. Superior labial, sphenopalatine, and greater palatine are going like this. But 2 arteries are coming from above, brain. This is brain side, from brain downward. Okay. Can you tell me, if the 2 arteries coming from above downward too, can you tell me which bone lies between 2 orbit? Which bone is between 2 orbits? Which bone is here, beta? Ethmoid bone. What is the name of the artery? Anterior ethmoidal artery, posterior ethmoidal artery. From below 3 artery, beta. Sphenopalatine, greater palatine, superior labial, and from above two arteries, anterior ethmoidal, posterior ethmoidal artery. But what is the demarcation is middle turbinate beta. Middle turbinate, below up to middle turbinate is ECA territory. 80% of the circulation is under ECA. Only remaining small percent, 20% above the middle turbinate is through the ethmoidal arteries beta. Okay, why ethmoidal word is coming? Because from brain two artery coming down, and which bone is between two orbit is the ethmoid bone beta. That's the ethmoidal artery beta. Okay, thank you. So if you delve into it now, you can find, or from where name coming? Oh, below the nose is what beta? Palate, lip. Palate, lip. Sphenopalatine, greater palatine, superior labial, and these three arteries going from below upward. Two arteries coming from above downward beta, above downward, from brain side, ICA territory, brain side, and anterior ethmoidal, posterior ethmoidal. Why? Between the two orbits is which bone? Ethmoid bone beta. But please mind you, up to middle turbinate is the ECA territory, above the middle turbinate is ICA territory beta. Okay, so 80% of circulation is coming from external carotid artery, only 20% is coming from the internal carotid artery. This is only very minimal, only very small area above middle turbinate. This is a very not major supply beta. This is the not the major supply. Actually, the major supply is this side beta. But still, if the bleeding is from above the middle turbinate, you must look at these arteries beta. Okay, what is the artery of epistaxis? The artery of epistaxis is sphenopalatine artery. The artery of epistaxis is sphenopalatine artery beta. Sphenopalatine artery. The artery of epistaxis is sphenopalatine artery beta. SPA. Now comes the epistaxis beta. Epistaxis. Okay. First of all, most common area is little area beta. Most common area of epistaxis is little area beta. This area is on antero-inferior part of septum. On the septum beta. On the septum, right in the front of your nose beta. Look at me beta. Look at what is the name? Antero-inferior. सोचो जरा, सोचो, think about it. Antero-inferior. It's too much anterior, too much inferior. बहुत आगे भी है, बहुत नीचे भी है. Look at me बेटा. इसलिए तुम्हारी fingers के लिए available भी है बेटा. When you rotate your finger in the nose, this is your little area beta. This is when you're touching the septum over here, from the front of the nose, there lies the little area beta. Unfortunately, this area has got a vascular plexus, and that is called Kiesel-Back plexus. This area has Kiesel-Back plexus of four arteries. MCQ beta. This area has Kiesel-Back plexus of four arteries beta. Kiesel-Back plexus of four arteries. This area has Kiesel-Back plexus of four arteries beta. What are four arteries? Total how many arteries are there beta? Five na? Total 5 arteries. You know 5 arteries: sphenopalatine, greater palatine, superior labial, then anterior ethmoidal, posterior ethmoidal. Out 1, 2, 3, 4, 5 beta. 5 artery total beta. Now which artery shall I remove beta? Of course these 3 will be there. Which artery shall I remove beta? Of course posterior ethmoidal artery would not be part of this beta. Okay. So the plexus is made of SP plus GP plus SL plus AE. Now this is the MCQ beta. Which artery is not a part of the plexus is posterior ethmoidal artery is not a part of Kiesel-Back plexus. There are out of 5 arteries, 4 arteries make the plexus. Number 1 sphenopalatine, number 2 greater palatine, number 3 superior labial, number 4 anterior ethmoidal, but posterior ethmoidal artery is not a part of the Kiesel-Back plexus. Is a very commonly asked question beta. Am I clear beta? Fine. Now what are the causes of epistaxis beta? Causes. What are the causes of epistaxis? The most common cause of epistaxis is fingernail trauma. Most common cause is fingernail trauma or nose picking habit beta. MCQ beta. Most common cause is fingernail trauma or nose picking habit beta. Look at me beta. Epistaxis seen in which group of patient most commonly? Children. Remember school days beta. Remember school days. Most commonly epistaxis is problem of children beta. Remember school time, summer problem, summer, a lot of people used to bleed from nose. Why? In school, children are having good time beta. Look at me beta. Teacher is teaching. That's none of my business beta. Some kids are busy. They are rotating and thinking about something else. When the school will be breaking, when when the teacher will die and all. So they are having, when they are rotating finger in the nose, they are having good time. Which area they are touching? This area is little area, and it contains a vascular plexus called Kiesel-Back plexus. One fine day when they are rubbing, the mucosa will tear apart from the little area, and below the mucosa there is a plexus of 4 artery branches. One of the branches of this arteries start bleeding beta. That's why it is such a common problem in children beta. Most common cause is fingernail trauma. Okay. Number 2, hypertension. In blood pressure people, hypertension causes posterior epistaxis beta. MCQ. Doctor, blood is falling in my throat. Doctor, blood is falling in my throat beta. My dear friends, mostly in epistaxis, bleeding is from the front beta. If you see epistaxis, bleeding is mostly from the front of the nose. Na? It's not that you don't see the bleeding from the back side of the nose. Na? Most of the time, this is the bleeding beta. Hai na? This is the bleeding. Okay. Okay. This anterior epistaxis. This anterior. 99.999%, whatever you have seen now, most of the bleeding is from the front of the nose, beta. But hypertension patient says, doctor, blood is falling in my throat. It is posterior epistaxis, beta. Okay? And I'm sure you know that hypertension as a cause will be seen in elderly patient, beta. Elderly patients. Hypertension would be seen as a cause, put an arrow, elderly patient, beta. Think like a doctor. It will not be a young chap mostly, hypertensive disease, elderly patient, but it causes posterior bleed, beta. Then accidental trauma in younger patient, beta. In your age, you are not wearing helmet, you fell down from motorcycle, you hit the nose from on the ground, bleeding started. Somebody punches your nose on and your bleeding started, beta. Then bleeding disorders. You know, hemophilia, must have heard the name, hemophilia, very common problem, hemophilia. No, hemophilia patient can come bleeding from the nose also, beta. Then anticoagulant drug, think like a doctor, not cramming, beta. A lot of people nowadays are on anticoagulant drug like aspirin, warfarin, heparin, hai na? So people are on anticoagulant drugs can also have bleeding from nose, beta. And then who can forget in India, hemorrhagic fever like dengue, beta. You know dengue, hemorrhagic fever, thrombocytopenia. So all these things can present as epistaxis, beta. Number 7, one tumor, beta. Angiofibroma, beta. I hope you remember angiofibroma is a highly vascular tumor. Angiofibroma, it's made of blood vessel, beta. You know, young boy with epistaxis, angiofibroma. Highly vascular tumor, beta. And number 8, the most important one, number 8, beta. Number 8 is most important, etc. Etc. beta, etc. Matlab, there are n number of causes, beta. N number of causes. It's just a clinically important ones, beta. There are 100 causes or more than that, beta. A lot of causes are there. But keep in mind, it can be an elderly patient with hypertension. It can be a younger patient with accident history. It can be a child with, fingernail trauma. It can be a hemophilia patient. It can be elderly person on aspirin or warfarin. It can be patient of dengue hemorrhagic fever. It can be a chap of angiofibroma, or it can be n number of things which can lead to epistaxis, beta. Okay. Now, treatment. How to treat it? Treatment is pinch the nose for 2 to 3 minutes. First of all, look at me, beta. First of all, you pinch the nose for 2 to 3 minutes, beta. The basic thing which you use in the school also, beta. Now, if that fails, then chemical cauterization of little area with silver nitrate, beta. AgNO3. MCQ, beta. Which agent we are using to chemical cauterize the little area? Answer is silver nitrate, beta. Chemical cauterization of little area with silver nitrate. Silver nitrate, beta. Chemical cauterization of little area with silver nitrate, beta. You know, we get ready-made sticks, beta, like this, available. This is a bleeding, beta. Can you see which area is this area, beta? Which area is this area? This area is which area? Yes, tell me, what area? Little area, beta. Can you see? Little area is in the anterior-inferior part of septum. So you can burn this area with a stick coated with which agent? Silver nitrate, beta. Can you see? You are applying silver nitrate on the little area, beta, to burn it, beta. What material used over here is silver nitrate, beta. Practical thing, okay? Silver nitrate, beta. Next one, beta. Anterior nasal packing. If the cautery fails, then we do anterior nasal packing in the bracket on both sides, beta. On both sides, beta. You put the pack in the nose, beta. Pack. To give a pressure on the septum, you give anterior nasal packing on both sides, beta. Anterior nasal packing on both sides, beta. Look at screen, beta. Look at screen, everyone. Can you see? The doctor has taken a gauze piece and he is using the gauze piece. He has applied what? He has applied the soframycin, or any liquid paraffin to make it moist, and you layer by layer he's packing in the nose. Why? He wants to give pressure on the septum, beta. On this side also, on that side also, so that from both sides pressure comes. By the pressure, breathing. What is this packing, beta? Anterior nasal packing. Can you see, beta? When the doctor is doing anterior packing like this, this cannot reach coana. Anybody, what is coana? Socho zara batao. What is coana, beta? What is coana? Coana is posterior opening of nasal cavity. What is coana? Posterior opening of nasal cavity. This pack does not go up to coana, beta, because you cannot go up to that area. So if the bleeding is occurring from the posterior most end of the nose, this pack will be useless, beta. Okay. So anterior packing. Now if this also fails, then I have to do posterior packing, beta. Posterior packing. Okay. Open your notes, beta. Posterior packing. Posterior packing, beta. Anterior packing, posterior packing, beta. Okay, posterior packing. Now, this is the posterior nasal pack, beta. Put an arrow. This is the posterior nasal pack. This is the pack look like, beta. Now, can you see this is the pack over here? This is the posterior nasal pack, and it has got 2 threads on one side, 1 thread on the other side. First of all, what is the name of this look of the pack is posterior nasal pack. Now, this pack has got 2 threads on one side, 1 thread on the other side, beta. Now, what happens is, why there are 2 threads on one side? 2 threads on one side are tied at nostril. 2 threads on one side are tied at nostril, beta. They are tied at nostril. Idhar bandh dete hain, so that pack doesn't fall in the throat. And 1 thread hangs in the throat. The single thread, beta. Single thread. 1 thread hangs in the throat. It helps for pack removal, beta. There are 3 threads, 2 thread on one side, 1 on the other side. Beta. Read your notes, beta. Look at screen, beta. Read your notes. These 2 threads on one side are tied at the nostril, and the third single thread hangs in the throat and helps to remove the pack. Mind you, this patient is under anesthesia in the ICU, very badly bleeding patient, very sick patient, very serious patient, and posterior pack is not a simple thing, beta. You have to put it under anesthesia. Anterior pack I can put in front of you right now over here. Over here, beta. Interior packing is not a problem. But posterior pack you have to do under anesthesia, beta. Let me show you. Not for your exam, but for clinical life, beta. Because at the end of the day, we are aspiring to become good doctor of the future, beta. Okay? This is a posterior pack, beta. Now, how we do it? Can you see posterior pack here, beta? Can you see it has got 2 threads on one side, 1 thread on the other side, beta. Can you see the posterior pack, beta? Can you see? This is a posterior pack. This one, 2 thread on one side, 1 thread on the other side, beta. Patient is bleeding a lot. Lot of bleeding is coming under anesthesia. Sick patient, very risky patient, might die because of hemorrhage. So you are trying to save the patient. What you do is posterior packing now. How we do it? First of all, we pass a catheter from the nose and pull the other end of catheter to the mouth. We pass a catheter from the nose and we pull the other end of the catheter to the mouth, beta. Then you tie the 2 ends of the thread, 2 threads to one end of the catheter, beta. Okay? Okay? Now you do what? Now you pull the catheter, beta. Now you pull the catheter like this, and the pack is tied to the other end of catheter, will automatically start going in the mouth with the finger. With the finger, you just take it behind the nose into the choana area, beta. Choana, what is choana? Posterior opening of the catheter. With your finger, you direct it in that area. Keep pulling the catheter, and you see the 2 threads will come out of the nose, beta. Okay? 2 threads will come out of the nose. Again, you tighten it, and now you see, beta. Did you see the one thing? 2 threads, can you see, beta, over here? 2 threads came out from here, 1 thread is in the mouth, beta. Now these 2 threads you tie over here, beta. You tie over here properly, okay? And 1 thread you keep in the mouth. The patient is under anesthesia in the ICU now, after surgery also. Now why you tie 2 thread over here, beta? So that the pack is stable. If you don't tie the thread over here, the pack may fall in the throat and patient may swallow the pack, beta. Swallow the pack, beta. You know, तुमने pack डाला, तुम next day आए, pack है ही नहीं. तुम pack ढूंढ रहे, pack कहाँ चला गया? Patient pack खा गया. Patient ate the pack last night, beta, because you never tied the 2 edges of thread properly. So if the pack will fall down the throat, patient might swallow the pack, और तुम्हारा pack ढूंढे नहीं. So you tie it over there. After 2 days, bleeding stopped. Patient saved. You want to remove the pack? No problem. No need to go to the operation theater again. You open up these knots, beta. Open up the nostril knots. Pack is loose. Now hold the 3rd thread in the mouth. This one, from here. Pull the pack from the mouth and throw in the dustbin, beta. This 3rd thread is for pack removal, beta. Okay? Now read your notes again, beta. Now read your notes again, everybody. Read your notes again. The 2 thread on one side are tied at nostril. 1 thread hangs in the throat and helps for pack removal, beta. Number 1, number 2, beta. Okay? Number 1, number 2. 2 thread on one side and 1 thread on the other side. It hangs in the throat for pack removal, beta. Now problem is if these 2 packs also fail, beta. If posterior anterior pack fails to control bleeding, then we do ESPAL, beta. This is a possible question in your paper, ESPAL. What is ESPAL? ESPAL is endoscopic sphenopalatine artery ligation. It is a standard procedure nowadays, beta. Endoscopic sphenopalatine artery ligation, beta. Anybody, which artery is artery of epistaxis? Go back to your note, beta. Everybody, please see your note, beta. Which artery is artery of epistaxis, beta? First page of epistaxis, beta. Artery of epistaxis, which artery? Sphenopalatine artery. So in majority of the cases, this artery is the culprit artery, beta. So first of all, when the bleeding cannot be controlled with packing, first artery to be ligated is sphenopalatine artery. This is called ESPAL, beta. ESPAL. Endoscopic sphenopalatine artery ligation. ESPAL. Now can you tell me, sphenopalatine artery is a branch of which artery, beta? Maxillary artery. Maxillary artery is a branch of which artery? External carotid artery, beta. External carotid artery, beta. Can you see? So we jump like this, beta. If this doesn't control, then we tie this one. If this doesn't control, then we tie this one, beta. Am I clear, beta? Fine. Now come back to your notes, beta. Sphenopalatine artery ligation, if fails, then maxillary artery ligation. And if also fails, then external carotid artery ligation. Do we really do it or is it a theoretical thing? We really do it. Really do it, beta. Now ECA ligation will be done where, beta? Kahan hai ECA, beta? Idhar? ECA kahan hai? Where is ECA? Touch your ECA. Yes, it is neck. I know you know it. The neck mein. In the neck. All of you, beta. Draw, beta. It is in the neck, beta. ECA ligation will be done in the neck. You'll have to, one team of surgeons will open the neck quickly to save the patient. Your patient is bleeding like a lot. Trauma patient. Accident case, beta. Bleeding a lot. You want to save the patient? You have to tie the ECA now, beta. Okay? Neck. Now when you open the neck, you see which artery? Common carotid. And then 2 branches out of that. Internal carotid, external carotid, beta. Now is a very tricky question. And this question, when I joined PG in the first year in Lady Harding Medical College, my consultant asked me. In the emergency, he was doing this case. Patient was bleeding like hell. He opened the neck quickly, and then there was a common carotid artery here, 2 branches from here, and he looked at me. He said, "New PG." I said, "Yes." He said, which one is ECA and which one is ICA? You know, what did I feel? I said, patient marne wala hai, to usko bacha le pehle. You know, in my heart I felt the patient, I was seeing so much of blood in the OT first time actually. I was internally thinking that patient is about to die. Please don't ask question. Please save the patient. But the reality was, I did not know the answer even. I did not know the answer that which one is ECA and which one is ICA. You know, anatomy will tell you. Antero, medial, posterior, lateral. ऐसा कुछ नहीं होता. There is nothing like this, believe me. When neck is open, everything is anterior. No medial, no lateral. It's like this, beta. Both arteries are like moving like this. And you really want at that moment to pray to the God, at least you should have labeled it. You know what? By chance you tie, by mistake, you tie internal carotid artery. Can you understand? Brain will get paralyzed. Brain will get stroke immediately and you will go to the jail. You kill the patient. If you tie ICA, by mistake, you kill the patient. So he asked me, nahi aata, you don't know it? I did not know it. And he told a very good trick, which is an MCA question of anatomy also. Very, very important trick is, ECA has got 8 branches in the neck. ICA has got no branch in neck. Wow. Anatomy knowledge, beta. ICA has got no branch in the neck, beta. ICA has got no branch in the neck, beta. ICA has got no branch in the neck. No branch in the neck. This is a question for anatomy, beta. NEET PG also. Which of the following is branch of ICA in the neck? In the neck. Answer is none of the above. None of the above. ICA name is internal carotid artery. Internal carotid artery means meant for the brain and eye. It's not meant for the outside structures, beta. So it doesn't give any branch in the neck. It is just going to the brain straight away. Okay. So how to identify ECA from ICA? By following a simple anatomical, trick that ECA has got 8 branches. ICA has got no branch in the neck, beta. Okay. Fine. So you identify that and then you do what? You apply the stitch over there, beta. Now problem is if ECA ligation also fails, beta, and that's the MCQ. You might say, if ECA ligation also fails, let him die. You know what? Let him die. No, we keep fighting. You know what? If ECA ligation also fails, then look at the screen, beta. Look at the screen. Still 20% is coming from ICA, beta. ICA. Of course, you cannot tie ICA. You cannot tie ophthalmic, but you can always tie ethmoidal artery, beta. You can always ligate ethmoidal arteries, beta. Ethmoidal artery ligation. If ECA ligation fails, it means this whole area has been controlled. Still the bleeding continues, then something is happening over here. I cannot tie ICA. I cannot tie ophthalmic artery, but I can always tie the ethmoidal arteries, beta. So the answer is ethmoidal artery ligation, beta. Ethmoidal artery ligation. Answer is ethmoidal artery ligation. MCQ, beta. Logical question, ethmoidal artery ligation. If ECA ligation also fails, then we do ethmoidal artery ligation. Ethmoidal artery ligation. Okay, bache, fine. Let's quickly go through the management, beta. First is basic things. Pinch the nose, chemical cauterization with silver nitrate, then anterior packing, then posterior packing. But if posterior packing also fails, then we do this ESPAL. Nobody should miss this word, beta. ESPAL. Endoscopic sphenopattern artery ligation. This is a practical question, beta. If bleeding could not be controlled with the packings, which is the first artery to be ligated? Sphenopalatine artery ligation, also called ESPAL. Endoscopic sphenopalatine artery ligation, beta. If this fails, then maxillary artery. If this fails, then extracarotid artery, ECA ligation. But question is, if ECA ligation also fails, then we have to tie ethmoidal arteries, beta. Ethmoidal arteries. This is the basic protocol of the epistaxis management also, beta. Okay, fine. Now, before we conclude, let us see some questions, beta. Now, can you tell me, let me start from beginning, beta. Whatever questions are left, beta. Yeah, we've done a couple of them. We've done, yeah. All are true about rhinoscleroma except, be careful. Rhinoscleroma, all are true except, beta. Except. Okay. Woody nose, scleroma, woody nose, yes. Russell body Mikulicz cell, correct. Remember? Rhinoscleroma 2 markers, Russell body Mikulicz cell biopsy finding. Dapsone is highly useful drug. Dapsone, D. That was not rhinoscleroma. That was what? Rhinosporidiosis. Rhinosporidiosis, D for Dapsone. This is not a useful drug. This is the answer, beta. C is the answer. For this, the drug is streptomycin plus tetracycline, beta. Streptomycin plus tetracycline. And what is the causative organism? Frisch bacillus, beta. Dapsone is used for rhinosporidiosis. I remember D for Dapsone, beta. Okay. So one trick solved the whole question, beta. Oh, I am 100% sure. Oh, Dapsone is not for scleroma. Dapsone is for rhinosporidiosis. Dapsone D. Okay. Chalo. Which is true about rhinosporidiosis, beta. True. Okay. Caused by Klebsiella? No. Rhinosporidiosis is Rhinosporidium sebrae. Mulberry-like nasal polyp or mulberry-like nasal mucosa. First of all, whenever two choices are so close, the answer is one of them, beta. Always remember, if there is an unknown question, totally unknown question, and in that unknown question even, there are two choices which are very close, a little different from each other, it means the answer has to be out of these two, beta. So you will be at least having 50% chance of being correct in an unknown question even. Okay, so rhinosporidosis, whenever you see two choices very close, na, pick your, put your energy over there. Mulberry-like nasal polyp or mulberry-like nasal mucosa? Answer is mulberry-like nasal polyp, beta, polyp, beta. Remember, mulberry-like nasal mucosa is a feature of inferior turbinate hypertrophy, ITH, beta. Inferior turbinate hypertrophy, beta. Okay, now, wide roomy cavity with thick crust formation, bad odor is seen in. Can you answer, beta? Wide roomy cavity, crust formation, bad smell from nose. Of course, atrophic rhinitis. Atrophic rhinitis, roomy cavity, crust formation, bad odor, beta. Typical question of atrophic rhinitis. Okay. All are true about CSO rhinorrhea except. All are true about CSO rhinorrhea except the cribriform plate is the commonest site of leak. Correct? Correct. Immediate surgery should be done. Wrong. The treatment is conservative treatment. I told you CSF leak is conservative treatment for 7 to 10 days, beta. Not immediate treatment. The answer is B. HRCT skull base is best radiological investigation, yes, and beta 2 transferrin is used to confirm the diagnosis, correct, beta. The answer to this question is B, beta, but is not true. It is not, we do not operate the CSF rhinorrhea immediately, beta. Okay? The treatment is wait and watch. All statements are true about Ringet's tumor. Now, I hope you remember, Ringet tumor is other name of inverted papilloma of nose. Correct? It's more common in males, correct? It's inverted, therefore locally invasive, correct? Arise from nasal septum, wrong. Arise from lateral wall of nose. Don't worry. At least you should have heard this word. I'm not expecting you to know the answer. I'm not saying that you should know the answer. I'm saying you should know, okay, this topic is there in the notes, beta. Oh, Ringet's tumor, inverted papilloma of nose. Now when you open that, you will say, oh, site of origin is important. Ringet's tumor is arising from lateral wall of nose, not from the septum. Okay, that's a significant solving question on your own also, beta. Okay, now, Kieselbeck plexus. Which artery is not a part of Kieselbeck plexus? I hope everybody knows posterior ethmoidal artery. Posterior ethmoidal artery is not a part of this plexus, beta. Am I clear, beta? Fine. Now, am I clear, beta? Okay, Kieselbeck plexus, anterior, superior sphenopalatine, greater palatine, superior labial, anterior ethmoidal artery. But posterior ethmoidal artery is not a part of this plexus, beta. Okay. Now, okay, which of the following is not correct statement, beta? Not correct. Not correct. Sphenoid sinus drain into SCR, correct. Drainage point, beta. DCR surgery, the sac opening is made in the inferior meatus, wrong. DCR surgery, the hole is made in the middle meatus. Middle meatus, beta. Remember, middle meatus. DCR surgery is the dacryocystocytostomy surgery, the hole is made in the middle meatus, beta. Okay? Okay, this is incorrect, beta. Anterior ethmoidal cell drain into middle meatus, correct. And posterior ethmoidal cell drain into superior meatus, beta. Okay? Yeah, now please see. This is the question we discussed just now. In a patient of resistant epistaxis from left nasal cavity, the bleeding could not be controlled with ECL ligation, beta. ECL ligation failed, beta. We just did now that ECL ligation, if fails, then what is the next artery to be ligated? So, Chodra, ECL ligation failed to control bleeding. What is the possible source of bleeding in this patient? ECL ligation done. Then please understand, then it has to be ethmoidal artery. You know why? It comes from ICA. Maxillary artery, ECA. Sphenopalatine, ECA. Facial, ECA, beta. ECA has been ligated. So, the source of bleeding is ethmoidal artery, which is coming from ICA, beta. ICA. Okay? Fine, beta. And this you've done already. Fine. Larynx over there, and I think larynx must be the page number of larynx would be 57, beta. 57. Everybody, open up larynx and open up the page number 57. Everyone, okay? So, workbook is I would say, is sort of, I can say, my baby. It's like, I thought that, okay, let's do something new this time, and Dr. Vineet was really kind enough to sort of do it for other subjects as well. And the idea of workbook is, number one, to make sure that you don't keep writing only, you invest time to understand the subject. Number two, you have got the images side by side, better, because when I was always feeling that if I'm a student, when I want to revise the subject, I must have those images with me which teacher showed us while explaining the topic to us, because that would make me more confident about my revision also, better. So that's why from there only this concept of workbook came, and I discussed with Dr. Vineet about it, that how we can do it, and Dr. Vineet was very kind enough to accommodate the idea. So that let us see how this concept evolves, better. Okay. Now I hope everybody workbook is open, and the page number is 57, better. 57 larynx, better. Okay. Now let us understand larynx, better, everyone. Now what is your larynx, better? Please see larynx. Now, when you have to write down, I'll say, okay, now write down. Otherwise, you understand. Okay, we'll keep reading the notes also. Now, please see larynx, beta. Now, this is your which bone? Hired bone, beta. Which bone? Hired bone. Am I clear, beta? Hired bone. This is hired bone. Okay, and this is your trachea, beta. Now, trachea is separate. Hired bone is separate. Hired bone is not a part of larynx, beta. In between the two, this is the trachea, beta. In between the two, this is the trachea, beta. This is the larynx, beta. This is larynx, beta. Okay, larynx is there, beta. Okay, so between the hired bone above and the trachea below, the in between part is the larynx, beta. Now, everyone, please look at the screen. Now, touch your larynx, everyone. Touch your larynx, everyone. This is your larynx. Touch your larynx, everyone. Now, can you see larynx is made of cartilages, beta? It's made of cartilages. This is cartilage, 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 beta. Okay, it's made of cartilages. Now, if you allow me to go forward, larynx is made of 6 cartilages. Larynx is made of 6 cartilages. Total how many cartilages? 6 cartilages. Now, out of 6, 3 are unpaired and 3 are paired, beta. 3 are unpaired and 3 are paired. Everybody open up your workbook and keep reading with me. Let us do the reading also together. Larynx is made of 6 cartilages. How many cartilages? 6 cartilages. 3 are unpaired and 3 are paired, beta. 3 are unpaired and 3 are paired, beta. Now, the thyroid cartilage, beta. First of all, let us discuss the unpaired cartilages. Unpaired cartilages. Number 1, thyroid. Number 2, cricoid. Number 3, epiglottis. Everybody speak with me. When I say speak with me, each one of you is going to speak with me, beta. Let us make sure that we revise the topic one time in the class only, beta. Okay? Everybody speak with me. What are 3 unpaired cartilages? Number 1, thyroid. Number 2, cricoid. Number 3, epiglottis. Once again, beta, bolo bache. What are 3 unpaired cartilages? Thyroid, cricoid, epiglottis, beta. Okay? Now, let us write the shape of the cartilages, beta. Everybody write down shape of the cartilages. Thyroid, put an line. Thyroid is open book-like cartilage. Open book-like cartilage. What is it, beta? This is shape of cartilage, beta. Shape of cartilage, open book-like cartilage. All of you draw a diagram like this. Open book, beta. Thyroid is open book, and this book is open behind toward the back side, beta. Okay, open book. Cricoid is a ring-like cartilage. Ring-like cartilage. Cricoid is a ring-like cartilage. The cricoid is a ring-like cartilage. Epiglottis is a leaf-like cartilage. Very good. Leaf-like cartilage, beta. Leaf-like. Draw the shape, beta. Leaf-like cartilage. It's a leaf-like cartilage, beta. Leaf-like cartilage. Okay. एक बार फिर से करते हैं. Okay, let's do one more time. What are 3 unpaired cartilages? Number 1, thyroid. बोलो बेटा, बोलो. Number 1, thyroid. Number 2, cricoid. Number 3, epiglottis. What is shape of thyroid cartilage? Open book. What is shape of cricoid? Ring-like. And what is shape of epiglottis? Leaf-like cartilage, beta. Okay. Now, this is your MCQ, beta. Cricoid is the MCQ, beta. Already question that came. Write the Q. Q means question, beta. A lot of places have already drawn MCQ. Can you see the red box over there, MCQ? It means this question has already come or can come in the future exam, beta. Okay. Now, let us do the understanding of this, beta. Now, where is your thyroid cartilage, beta? Look at screen, everyone. Now, please see. This is your thyroid cartilage area. This is your thyroid cartilage. This is your cricoid cartilage, beta. Okay, this area thyroid and cricoid. Okay, you say, Raji, where it is thyroid, where is cricoid, beta? Everybody look at screen, everyone. Now, please see on the screen. This is your outer larynx, beta. Okay, everybody, can you speak with me, beta? Can you speak with me, everyone? Can you tell me what is this bone, beta? What is this bone? This bone is hired bone. Very good. H, hired bone. Hired bone, beta. Okay. Now, what is this cartilage? Thyroid cartilage. Thyroid cartilage. What is this cartilage? Cricoid cartilage. What is, beta? Trachea. Am I clear, beta? Trachea. Thyroid is what type of cartilage? Open book-like cartilage. Look at my hand, beta. It is like open book-like cartilage. And cricoid is a ring-like cartilage. Everybody, can you tell me what is the trachea made of? Trachea is made of what? Trachea is made of what, beta? Trachea is made of rings, beta. Like, look at it. Trachea is made of rings, hai na? Okay, rings. Can you imagine the ring of the cricoid is fitting over the ring of the trachea, beta? Look at my hand, beta. The ring of the cricoid is fitting over the ring of the trachea. Okay, so thyroid is an open book-like cartilage. It is open from behind. A cricoid is a ring-like cartilage, and cricoid is fitting over the rings of the trachea. Imagine, we have to create a very absolute perfect understanding of the subject, beta. Not basic, beta. We have to go to the higher clinical level. So a question comes twisted, I can handle that, beta. Okay. Now everybody, there is a sidebar. When I say sidebar means this part of your notes, beta. Can you see this sidebar, beta? Everybody, can you see this sidebar, beta? All of you, can you see this sidebar? This one, beta. Sidebar. This sidebar has to be used for you to make extra points in your notes, beta. We have kept just a sidebar for you. So you write whatever you understand in a simple way, beta. Knowledge has no language, beta. Knowledge is a concept. You can write that in whatever language you are comfortable. English, Telugu, Tamil, whatever, Gujarati, Punjabi, Hindi, whatever. You should write over there. But in this sidebar, we'll write extra points. Make this note workbook into your own notes, beta. How to convert a workbook to your notes? Underline it in a systematic manner. Don't make it too dirty. Don't make it too clumsy. Underline in a systematic manner. And write extra point on the sidebar, beta. Now write down extra point on the sidebar. Write down thyroid and cricoid. Thyroid and cricoid are palpable from outside. Thyroid and cricoid are palpable from outside, beta. Yes, I can palpate my thyroid and my cricoid from outside. Thyroid and cricoid are palpable from outside, beta. They are palpable from outside. Yes, I can touch my thyroid, I can touch my cricoid also, beta. Okay, thyroid and cricoid are palpable from outside, beta. Am I clear? Palpable from outside. Thyroid and cricoid are palpable from outside. Everybody look at screen, beta. Look at screen, everyone. Now, where is thyroid and where is cricoid, beta? Look at screen, everyone. Let me show you. Now look at your neck, beta, over here. Can you see? This is again the same picture. Now, what is this cartilage? Everybody, can you speak with me, beta? What is this cartilage? This cartilage is thyroid cartilage. What is this cartilage? Cricoid cartilage. Okay, fine, beta. Now, if you allow me, can you see this picture of your neck, beta? Now, which is this bone? Hyoid bone. Is hyoid bone a part of larynx? No, hyoid bone is not a part of larynx, beta. Thyroid cartilage, open bone. Cricoid is part of the larynx, beta. But after that, what is there? Trachea. Trachea, beta. Trachea is here, beta. Trachea is here. So, cricoid ring is fitting over the rings of trachea. Okay. Now, let's discuss about the epiglottis, beta. Epiglottis, beta. Okay. Now, allow me to show you a picture of epiglottis first of all. Just 1 second. Now, can you see this pink cartilage, beta? This one. This is a leaf-like cartilage. This pink cartilage is epiglottis, beta. Epiglottis. Okay. Now, what is this cartilage? Thyroid cartilage. You are looking into larynx from here, beta. Here. Okay. Fine, like this. Larynx is in the well. It's in the well. Can you see neck is a well? Larynx is in the well. So, you always look like this, beta. Okay. So, thyroid cartilage is open from behind. Can you see it is open from behind, beta? Can you see this cartilage open from behind? This green thing. Can you see that, beta? And epiglottis is a leaf-like cartilage. Now, read your notes, beta. Read your notes. Open the workbook. Now, epiglottis, points about epiglottis. It is attached to midpoint of thyroid cartilage. It is attached to midpoint of thyroid cartilage, beta. Okay. Now, one line please add over here. Just one line add over here, beta. Write down. To the same midpoint, two vocal cord are also attached. To same midpoint, two vocal cord are also attached, beta. At the same midpoint, two vocal cords are also attached. Am I clear, beta? At the same midpoint, two vocal cords are also attached, beta. Am I clear? Fine. At the same midpoint, two vocal cord are also attached. Have you written this line, beta? Epiglottis is a leaf-like cartilage. Yes, it is attached to all these points about epiglottis, beta. Epiglottis is a leaf-like cartilage. Okay. It is attached to midpoint of thyroid cartilage. Okay. To the same midpoint, two vocal cord are also attached, beta. Okay. Am I clear? Now, what is the function of epiglottis? All these points are about epiglottis, beta. E mane epiglottis. Okay. You can write a bracket. Epiglottis. We are talking about EP mane epiglottis, beta. What is the role of epiglottis? What is the role of epiglottis? It covers vocal cords, beta. It covers what? Vocal cord. Vocal cord is equal to glottis. Okay, now the question, what is glottis? Whenever MCQ says glottic cancer, glottic problem, glottic word means vocal cord problem, beta. Okay, because vocal cord is equal to glottis, beta. Okay, now look at me, beta. What is the word of, what is the name of cartilage? Epiglottis. Now look at me, beta. This is your vocal cord and epiglottis covers it, beta. Epiglottis covers. Epi mane cover, glottis mane vocal cord. It's the cover of the vocal cord, beta. It's a cover of the vocal cord. Am I clear, beta? What is the role of epiglottis, beta? Epiglottis cover the vocal cord, not fully, beta. Don't think it covers it fully. It cannot cover it fully. Otherwise, how will you breathe, beta? It covers it partially, but epiglottis is a cover of the vocal cord. Why epiglottis word came, beta? Because epi means cover, glottis means vocal cord. It covers vocal cord. That's why it's called epiglottis. Am I clear? Now, third point. It's elastic cartilage. It does not ossify with age. Last time MCI question, beta. It is elastic cartilage. It does not ossify with age is MCI question already, beta. Which cartilage of larynx does not ossify with age is epiglottis, beta. It is elastic cartilage, soft, beta. Look at my hand, beta. A leaf has to be soft. A leaf has to move. Look at my hand, beta. It has to be soft. It has to move. It is elastic cartilage. It does not ossify with age, beta. Am I clear, beta? Fine. Can we revise, beta, up to this much? Epiglottis. What is the shape of epiglottis, beta? It's a leaf-like cartilage. Before we do this, can we see this video, beta, about the epiglottis, beta? Everybody, look at screen, beta. Look at screen, everyone. Now, please see on the screen, beta. Please see on the screen. Yes, can you see? This is what, beta? This is what? This is the thyroid cartilage. Okay. Now, let us see. What is this, beta? This is what? Epiglottis. This is what, beta? Epiglottis, beta. Am I clear? This is what? Epiglottis, beta. Epiglottis. Thyroid cartilage, epiglottis, beta. Can you see, beta? Epiglottis. Can you see epiglottis is moving, beta? It's moving. Okay. It's moving. 1 second. ये इस पे चल रहा है Chalo. Okay guys, let us see this video now. This is your thyroid cartilage. This is leaf-like cartilage is epiglottis, beta. Epiglottis, can you see it cover the vocal cord? What are these two white lines? Vocal cord. Let me rotate it for you and let us see into the larynx, beta. Into the larynx, beta. Can you see epiglottis? What are these two white lines, beta? These two white lines are the vocal cord, beta. Am I clear, beta? Fine. This is leaf-like cartilage and it attached to the midpoint of thyroid. This is your, can you see, beta? This is your thyroid cartilage. It is open book-like cartilage. It is open from behind. This leaf-like cartilage attached to the midpoint of thyroid cartilage inside larynx. At the same midpoint, two vocal cord are also attached, beta. Can you see two vocal cord? The white line represent the vocal cord, beta. Okay, bache, fine. Can you see? Can you see, beta? This is okay, fine. So this is your thing I'm saying. Can you see, beta? Epiglottis is attached to midpoint of thyroid cartilage. To the same midpoint, two vocal are also attached. What is the role of epiglottis? It covers the vocal cords, and that is why called epiglottis, because vocal cord means glottis, beta. An important thing is epiglottis is elastic cartilage. It does not ossify with age, beta. Okay, am I clear? Wonderful. Let us go further, beta. Let us go further, everybody. Now let us talk about thyroid angle, beta. Now thyroid angle, next topic. Thyroid angle. Everybody reach over here, beta. Everybody reach over here. Thyroid angle. This is the end of the epiglottis, beta. Okay. Now, one more simple concept. On the sidebar, write down beta, sidebar, or just write on the sidebar, beta. Epiglottis represents anterior part of body. When you are confused in a diagram, is epiglottis, what is interior part of the picture, posterior part of the picture? Wherever the epiglottis is, it's anterior, beta. Wherever the epiglottis is, it is anterior. Am I clear, beta? Anterior. Epiglottis represent the anterior part of the body, beta. Okay. So when you see a clinical diagram or an anatomical diagram, wherever the epiglottis is, that's the anterior part of the picture, beta. Am I clear? Fine. Chalo. Now let me show you a couple of more things before we go further. Now everybody, can you see over here? Can you see over here, beta? This is the larynx view from inside, beta. When you see it from inside like that, okay, that was animation, beta. The real picture is this one, beta. Okay. Now this is what, beta? This is E. What is E, beta? What is E? E mane epiglottis. This is the epiglottis, beta. This is epiglottis. Can you see, beta? The epiglottis, beta. Okay. What is this, beta? This is vocal cord. Yes, vocal cord, beta. Vocal cord. Now can you tell me in this clinical diagram which is interior? Is this interior or this interior, beta? Yes, I know now from my understanding. Wherever the epiglottis is, that is the anterior part of picture. Of course, this is posterior part of picture. Is it clear to all? Okay. Can you understand the real epiglottis look like this? Leaf-like and vocal cord. Don't you think so? They're attached to the same midpoint of the thyroid cartilage inside larynx, beta. You cannot touch your epiglottis from outside. You cannot touch your vocal cord from outside, beta. You can touch only two cartilages. But are two cartilages which are palpable from outside. Number one, thyroid. Number two, cricoid. Are you speaking with me? I really want each one of you to write something in the chat box right after the first break, beta. In the first break, you have to do this and you have to make sure you are telling what is going in your mind, but I need to connect with you through this medium in whatever ways possible, beta. And I need to hear from you guys that how you are living this experience, beta. Are you speaking with me? Are you feeling that I am with you in the room only where you are sitting? You are sitting on the chair, I am sitting on the bed and teaching you. You know what? Like that kind of thing. If you are able to imagine, then my purpose is served. Then I love online medium also, beta, that way. If you are able to feel that I am there with you, that purpose is served. Are you revising with me or not? You know, tell me one more time, which two cartilage are outsidely palpable, beta? Number one, thyroid, speak about it. Number one, thyroid. Number two, cricoid. But epiglottis is inside the larynx, beta. Okay. Now, let us understand thyroid angle, beta. Everybody, can you tell me, what is the shape of thyroid cartilage? What is the shape of thyroid cartilage? It is a open book-like cartilage, beta. Open book, beta. It is open from behind or front? Of course, behind, beta. This is thyroid cartilage, is open book, is like this, beta. Now, look at me, beta. Now, look at me, everyone. This is a thyroid, is open book-like cartilage. Can you see, beta? Can you see this look of the thyroid cartilage? This is the thyroid cartilage from side, beta. And you know, it has got two lamina. Can you see it has got two lamina? One lamina, second lamina. When you open the book like this, we have got two flaps of the book. One this flap, one this flap. The flaps are called laminae, beta. And the angle between two laminae, this angle, beta, look at screen, beta. This angle between two laminae is called thyroid angle, beta. Look at screen, beta. From the side angle, I can show you. The thyroid angle is the angle between two lamina of the thyroid cartilage. Okay, read your notes, beta. The thyroid angle is the angle between two lamina of the thyroid cartilage, beta. Okay, very good. I'm clear. Okay. Now, in males it is 90 degree, female 120 degree. But MCQ, in males it is 90, female 120 degree, beta. 120 degree. Why? Why so? Look at me, everyone. Look at me, everyone. Why it is so? See, the thyroid cartilage is flat in females. Female flat, beta. It's flat in female, beta. Flat in female, but in males it comes forward. And you look at me, beta. Look at me. It's very prominent. You can see over here, beta. This is my thyroid cartilage. It is very prominent, beta. Prominent. Now, can you understand? In female it is flat. In female it is flat, beta. Flat. Now, in males it is prominent, beta. In female it is flat, in males it is prominent, beta. Now please see beta over here. Okay, can you see beta? In female, it is flat beta, flat. In male, it comes forward to become more prominent. Can you see on the screen beta? Look at my hand beta, look at my hand. In female, angle will be more. In male, angle will be less beta. Why? It is becoming more prominent. In male, it is becoming prominent beta. It is becoming prominent, so angle will be less. But in female, it is flat, angle will be more beta. Flat means more angle. Prominent means sharp. Sharp means less angle beta. You know? Okay, prominent means sharp. Sharp means less angle beta. Okay. So prominence of thyroid cartilage in males is called. Everybody look at your note beta. Prominence of thyroid cartilage in males is called Adam's apple beta. ADAM. Adam's apple. Very good. Adam's apple beta. Prominence of thyroid cartilage is called Adam's apple beta. ADAM, Adam's apple. Spelling ADAM, Adam's apple beta. Prominence of thyroid cartilage in males is called Adam's apple beta. Adam apple. ये जो मेरे में है ना, this in males it called Adam's apple. Females, hear me beta. Females don't have any prominence like this beta. So there is nothing like Eve's apple beta. You would have never heard in literature ever. Eve never had an apple beta. Only Adam had an apple. There is nothing like Eve's apple in the book. Eve's apple तो कभी आया नहीं आज तक. No Eve's apple. Only Adam had an apple. Eve never had an apple actually. Okay. So prominence of thyroid cartilage in male is called Adam's apple beta. So please remember. Can you revise with me? What is thyroid angle in males? 90. Females 120. Why angle is less in male? Because thyroid cartilage is more prominent in males, and this prominence is called which apple? Adam's apple beta. This picture is there with you to revise beta. Now, all of you go to the next part beta. 3 paired cartilages beta. Paired. 3 unpaired. 3 paired beta. Can you speak with me? 3 unpaired beta. सब लोग बोलेंगे. Everyone, whichever city you are right now, you're going to revise the thing with me. When I say revise means, don't think कौन क्या सोच रहा है. Who is sitting in the room or that's none of your business beta. You say with me beta. Say what I want is you must revise important point of the notes right in the class itself. Understand the notes, concepts, clinical concepts, and some revision of the important points also beta. Speak with me beta. What are 3 unpaired cartilage? Number 1 thyroid, number 2 cricoid, number 3 epiglottis. Beta. Now let us discuss about the 3 paired cartilages beta. Paired. 3 unpaired, 3 paired. Total 6 cartilages beta. Total 6 cartilages. 3 unpaired we finish. We study 3 paired now. The paired are number 1 corniculate. Bolo beta. Number 1 corniculate. Number 2 cuneiform. Number 3 arytenoid beta. Once again speak beta. What are 3 paired cartilages? Number 1 corniculate. Number 2 cuneiform. Number 3 arytenoid beta. याद रहेगा corniculate, cuneiform, arytenoid. Now please see, corniculate and cuneiform are rudimentary cartilages. Means they do not have any functional value beta. They are rudimentary corniculate and cuneiform are rudimentary cartilages. They do not have any functional value beta. Okay. Now write down in the bracket. Put a bracket. They are like, put a bracket beta. Put a bracket. They are like rice grain like cartilages. Rice grain like cartilage beta. They are like rice grain like cartilage. Rice grain, write down. They are like rice grain like cartilage beta. They are like rice grain like cartilage. Rice grain. You know चावल के दाने? Rice grain. Small rice grain like cartilage beta. Rice grain like cartilages. Okay. They are like rice grain like cartilages beta. Rice grain like cartilages. And what is the shape of arytenoid? Write down the third one. Arytenoid is a pebble like cartilage. Pebble. P-E-B-B-L-E. Arytenoid is a pebble like cartilage beta. Arytenoid is a pebble like cartilage beta. Arytenoid is a pebble like cartilage. Arytenoid is a pebble like cartilage. Pebble means small stone beta. Arytenoid is a pebble like cartilage. Pebble like cartilage beta. 1 second guys, 1 second. Corniculate and cuneiform are rice grain like cartilages. Arytenoid is a pebble like cartilage. Pebble on a small stone. And let us revise the shape of the cartilages beta. Shape of the cartilages. Speak with me beta. Thyroid cartilage is open book like cartilage. Cricoid is a ring like cartilage. Epiglottis is a leaf like cartilage. Arytenoid is a pebble like cartilage. But corniculate and cuneiform are rice grain like cartilage. Rice grain beta. Very small. Rice grain. Chota sa cartilage. Small cartilage. That's why useless. Useless matlab rudimentary cartilage. Rudimentary cartilage beta. Practically speaking, we have got 4 cartilages. Thyroid, cricoid, epiglottis, and from here only 1 arytenoid, because these 2 are only namesake cartilages. They do not have any functional value beta. Okay. Now let us understand arytenoid beta. Now arytenoid make posterior 1/3 of vocal cord beta. Arytenoid make posterior 1/3 of vocal cord. Arytenoid make posterior 1/3 of vocal cord. What does it mean beta? Now everybody, can you see over here? Arytenoid make posterior 1/3 of vocal cord beta. Okay. Okay. Yeah. Now see this picture beta. See this picture. Can you tell me what is this cartilage beta? Everybody, can you tell me what is this cartilage? Epiglottis beta. Epiglottis. Okay. Epiglottis. Leaf like cartilage. Epiglottis beta. Okay. Everybody, if you remember, epiglottis is attached to midpoint of thyroid cartilage inside larynx beta. What are these 2 lines are indicating? What are these 2? These are what? Vocal cord. If this is epiglottis, This is vocal cord. Can you see posterior 1/3 of vocal cord has got some pebble-like cartilage, beta. Can you see pebble-like cartilage? So these two are arytenoid cartilage, beta. What are they, beta? They are what, beta? Arytenoid cartilage. This is arytenoid, beta. This is arytenoid, beta. Now look at screen, beta. Now please see. This is what, beta? E mane epiglottis, beta. Okay, what is it, beta? Vocal cord. Vocal cord, beta. These two are vocal cord, beta. So a lot of things are clear, beta. Epiglottis is attached to midpoint of thyroid cartilage inside larynx. Epiglottis covers the vocal cord, and arytenoid make posterior 1/3 of vocal cord, beta. Now you can very easily write down the side, beta. Arytenoid represent posterior part of the picture, beta. I hope you remember. Epiglottis represent the anterior part of picture. Arytenoid represent the posterior part of picture, beta. Now write down. Arytenoid represent posterior part of picture, beta. I hope you remember. You wrote epiglottis represents anterior part of picture. Now let us write down the arytenoid represents posterior part of picture, posterior part of body, beta. Oh, my concept is getting more clear. Oh, epiglottis is the anterior part of the body, and arytenoid is posterior part of the body. So I know for any diagram now, whenever I see some diagram, wherever the epiglottis is, I will see it's anterior, beta. When I say arytenoid, I'll see it's the posterior part of the body, beta. So epiglottis represent the anterior part of the anatomy, and arytenoid represent the posterior part of anatomy, beta. Am I clear, beta? So epiglottis covers the vocal cord, and arytenoid represent posterior part of the vocal. Arytenoid represent what? Arytenoid makes what? Posterior 1/3 of vocal cord. Once again, epiglottis covers the vocal cord, and arytenoid makes posterior 1/3 of vocal cord. You tell me, how many vocal cord you have? One or two? How many vocal cord you have? Are you speaking? One or two? Two. Two, beta. Two vocal cords. Two vocal cord. Two vocal cord means two arytenoid. That's why arytenoid is a paired cartilage, beta. It's a paired cartilage, beta. Am I clear, beta? Fine. That's perfect, beta. How many of you are sitting on the bed right now with two pillow behind? How is sitting like this, beta? How is sitting like this, beta? How many of you are sitting with a two pillow and just on the bed, just little bit study and all that? How many are doing that actually? You know what? How many of you are excited, beta? How many are sitting on the chair? On the chair with the sports shoes on, beta. With the sports shoes on means that your brain is active. If you are slogging, with the back is slanting and the tab is here, the phone is here, you know what? You feel little lazy, sleepy. You know? Why not sit on the chair? The chair is in front of you. Just look around in the room. Is there any chair? There must be a chair. You know what? In between, you can sit on the bed also. In between, just keep walking, learning, and keep sitting on the chair in between, but stay active. Please wear sports shoes when you attend the classes. Online classes, always wear sports shoes so that you know when you wear sports shoes means that you have to be sporty. Sporty means active. Active, hai na? Okay, fine. Chalo. Now, next concept. Let's go to the next concept. Voice in adults. Voice in adults. Voice in adults. Males have low pitch voice. Males have got low pitch voice. Matlab dull voice. Males have got low pitch voice means dull voice. Dull voice. Dull voice is a very dull kind of voice. Look at my voice, a croaky voice, not a hoarse voice, beta. Hoarse means a disease, symptom. My voice is a little dull voice, a croaky voice, but females have got a high pitch voice. It's a normal difference, beta. This is normal. This is what, beta? Normal, beta. Write down. It's a normal thing, beta. Normal thing. This is normal. Males have got low pitch voice, female have got high pitch voice. This is a normal phenomenon, beta. Okay? Males have got low pitch voice, female have got high pitch voice, beta. Low pitch voice, dull voice. This is a normal difference between male and female. I hope you remember school days, beta. When you were in school in 4th, 5th class, male, female had a similar kind of voice. And then came the puberty. And the whole body was hijacked by the hormones. You know that. Everything changed in us actually at that time. You know, at puberty. And one of the changes in us was voice also. In males, the voice cracks up. The voice changes. You know what? The voice becomes dull, more husky, more a deep kind of voice. Okay? More dull, boring kind of voice. And female have got a very fine voice, a sharp voice. And I sincerely believe females represent the fine part of creation. Fine part of creation. And male represent the dull part of creation. You know, I think nature only made females. Whatever was left, nature made into males and threw into the planet actually like that. So male, nobody looks at us, you know what. Males are got like we are like dull part of creation. And female are the sharp or the fine part of creation. This is a natural difference. But God forbid, agar ulta ho jaye, if reverse happens, beta, if Narendra Modi starts speaking like Mamata Banerjee, or Mamata Banerjee starts speaking like Narendra Modi, it will be disaster, beta. It will be disaster. It will be really disaster, beta. Can you understand, beta? If everybody has to speak the way you are, which gender you're coming from, beta. Okay? Now let me show you some scary thing, beta. Some scary thing. And 1 second, beta. See this question, beta. Puberphonia, guts maneuver, thyroplasty type 3, androphonia, typhothyroid. All these things may be looking alien to you completely, I know. But after 5 minutes, you'll know each one of them. Let us challenge ourselves. This is looking scary to you. Let us make it simple and everything will be understandable. Number 1, puberphonia. Puberphonia. First of all, it's a disease. Puberphonia, first write down, it's a disease of voice. Disease of voice, beta. It's a disease of voice, beta. Puberphonia is a disease of voice, beta. Okay. What is the disease, beta? It is high pitch voice in male. Feminine voice, beta. You tell me, beta, what is the normal pitch of voice in male? Look at the screen, beta. Look at the screen. What is the normal pitch of voice in male is? Low pitch, dull voice. But if a female kind of voice is produced by a male, it's called puberphonia. High pitch voice in male is feminine voice. It means Narendra Modi speaks like Mamta Banerjee. That's a disease of voice called puberphonia. Okay. Write down in the bracket side, on the sidebar, write down patient. What is the patient? Young college going boy. College going shy boy, beta. Shy boy. Shy boy, beta. Very shy boy. Young college going shy boy. Imagine, it's like 20 year or 18 year. It's a college going boy, beta. Young college going shy boy, beta. Shy boy. Okay, fine. Now, how to treat it? The treatment is speech therapy, beta. The treatment is speech therapy. Have you heard the word physiotherapy, beta? Physiotherapy. What is physiotherapy? Exercises. You know, orthopedic department, physiotherapy, exercises, beta. Speech therapy is vocal exercises, beta. Vocal means voice exercises. What is the name of that exercise? Speech therapy means exercises, beta. Like physiotherapy exercises, speech therapy means voice exercises. What is the name of that exercise? Write down, beta. The name of that exercise is Gutsman maneuver, beta. Gutzman's Gutsman's maneuver. Gutsman's maneuver, beta. Maneuver. Gutzmann is MCQ, beta. Gutsman maneuver. Gutzmann. What is the name of the speech therapy? Speech therapy, put an arrow, beta. Put an arrow. What is the name of the exercise in the speech therapy? Gutsman's maneuver, beta. Gutsman maneuver. Gutzmann. Gutsman maneuver. Oh man, have guts, speak like a man. Don't we say that in a fight, beta? When we fight, you know, जब दो लड़कों की लड़ाई हो जाती है, when two guys fight, sometimes there's a dialogue, very famous. Oh man, have guts, speak like a man. You know what? Speak like a man. Gutsman story. Where here a man is speaking like a woman. When we fight, in the fight we say, oh man, have guts, speak like a man. From the story I remember the word guts man. Oh man, have guts, speak like a man. Oh man, have guts, speak like a man. Puberphonia. This maneuver is used for what? Puberphonia. Because in puberphonia, a man is speaking like a woman. Okay? What we do in Gutsman maneuver? Please look at the screen. Pull thyroid cartilage downwards, push it backward and speak for 6 months. For 6 months you have to speak like this. Pull thyroid cartilage downward and main thing is push it backward. The main thing is push the thyroid cartilage backward. Look at me, look at me everyone. Everybody look at me. Vocal cord are attached to midpoint of which cartilage? Thyroid cartilage. Vocal cord attached to midpoint of which cartilage? Thyroid cartilage. Am I clear, beta? Thyroid cartilage. Now if you push the thyroid cartilage backward, you are pushing the vocal cord backward. You are pushing the vocal cord backward, beta. Please understand, the vocal cord are attached to midpoint of which cartilage? The thyroid cartilage, beta. Am I clear, beta? Vocal cord are attached to midpoint of which cartilage? Thyroid cartilage, beta. Can you see it? Okay. Can you see over here? Now, if I push the green thing backward, like this, beta, green thing backward, don't you think so? These wires will become loose, beta. When you push the thyroid cartilage backward, it will become loose, and loose things produce low pitch voice, beta. Have you ever seen guitar wire, beta? If the guitar wire is tight wire, and the tight wire produces high pitch, very sharp sound, beta. But if you make that wire loose, and that loose wire will produce low pitch sound, beta. I want low pitch. So for 6 months you speak like this, beta. For 6 months you speak like this, and doing practice at home, doing practice in the hospital with the OPD people also, and within 6 months your voice will get back to normal male voice because your vocal cord will become permanently loose, beta. By pressing it again and again and again, you'll make them loose, beta. But maybe out of 100, one case will not recover with this therapy, beta. Then look at your notes, beta. Then look at your notes. Then the treatment is surgery. Beta. If it fails, then we do, everybody write down SX. SX means surgical treatment, beta. Then we do what? Surgical. SX means surgical treatment, beta. For next 3 months of your life. For next 3 months of your life, beta. Please understand. For next 3 months of your life, there is no E between S and X, beta. There is no E, beta. No E. No E over there, beta. You will not think about anything else apart from your exam, beta. Apart from studies. Nothing, no hanky-panky stuff, nothing. I know this is a very natural desire. Everybody has that. But, you know, at this moment, life is demanding from us mental celibacy. Mental celibacy means let us decrease the number of stimuli. Let us decrease the number of reasons why we waste time. Let us decrease the number of, stimulation we get from other things. Let us focus our whole energy on studies only, beta. But on 4th June evening, get back to your normal self. I'm not going to change you. I don't want to change you. May God bless you the way you are. Is absolutely great. You are a great creation of nature. But at this moment, life is demanding from you a different version of yourself. A more dedicated version towards study. But on 4th June evening, the moment you come out of the hall, bounce back to your normal, original self, which you should be proud of. I'm proud to be imperfect. I'm not okay to be imperfect. I'm proud to be imperfect. But at this moment, life is demanding from me the perfect dedication, discipline, and full focus on study. So I can do that. I can change my version for some time and get back to the original version of mine on 4th of June evening, beta. Okay, so no E between S and X for next 3 months at least, beta. Okay, so SX means surgical treatment. Surgical treatment. What is the name of surgery, beta? The name of surgery is type 3 thyroplasty. Wow. Type 3, 3 means Roman 3, beta. Type 3 thyroplasty. The name of surgery is type 3 thyroplasty. Type 3 thyroplasty. Beta. The name of surgery is type 3 thyroplasty. Type 3 thyroplasty. The name of surgery is type 3 thyroplasty, beta. Okay. What is type 3 thyroplasty? It is surgical shortening or loosening of vocal cord, beta. It is surgical shortening or loosening of vocal cord, beta. Type 3 thyroplasty, it is surgical shortening or loosening of vocal cord, beta. It is surgical shortening or loosening of vocal cord. Okay. So what is the name of surgery? Bolo beta mein type 3 thyroplasty. It is surgical shortening or loosening of vocal cord. Mind you, the loosening is the correct word, beta. Loosening. Shortening is not the correct word. Let me tell you before you ask me, you know, why Rajiv, why you are cutting it short? I'm not cutting it short, beta. That shortening is the wrong historical word linked to it. The correct word is loosening, beta. Okay. Surgical shortening or loosening of vocal cord, beta. Okay, am I clear, beta? Fine. Now can we go for androphonia, beta? Can we go for androphonia? Androphonia. Next topic, androphonia. Again, it's a disease, beta. Again, a disease of voice, beta. Let us make notes as clinical as possible, beta. As clinical as possible. No ratta without understanding. We have to remember, but after understanding, beta. Without understanding, don't really just cram up, beta. Let's conceptualize, beta. Again, a disease of voice. What is definition? It is low pitch voice in female. Oh, masculine voice. किसी female में मर्दाना दमदार आवाज. किसी female में मर्दाना दमदार आवाज, बेटा. मतलब means Mamata Banerjee speaking like Narendra Modi. Mamata Banerjee speaking like Narendra Modi, beta. Disaster. Disaster. Remember that singer, Usha Uthup? If you remember Usha Uthup, that is very famous singer. And she used to sing a song, Hari Om Hari, Hari Om Hari. She had actually a very masculine voice, actually. That is, she is alive. She has a very masculine voice. And that is a low pitch voice in a female is a disease called androphonia. What's the treatment? The treatment is type 4 thyroplasty. Again, SX, beta. What is SX? Not that what you used to think. Surgical treatment, beta. Oh. Treatment is surgical treatment. What is the name of surgery? Type 4 thyroplasty. Very good. Type 3 thyroplasty. This is type 4 thyroplasty, my dear friends. Type 4 thyroplasty. Okay, bache, type 3 thyroplasty. This is type 4 thyroplasty. Type 4 thyroplasty. Okay. Now you tell me what is type 3. Look at your notes, beta. What is type 3? The type 3 was shortening or loosening of vocal cord. Surgical shortening or loosening of vocal cord. What should be type 4? Reverse of that, beta. Reverse. Type 3 was shortening, loosening. This will be, of course, surgical lengthening or tightening of vocal cord, my dear friends. Surgical lengthening or tightening of the vocal cord. Am I clear, beta? Type 3 was shortening, loosening. Type 4 is lengthening, tightening of vocal cord. Wonderful. I hope you are learning it. I hope you are enjoying the process of learning. I hope it's a bright, sunny morning for you. I hope you are active. I hope you are eager to learn further. That's what here I am for. Okay, fine. Use me fully. Use me fully. Exploit me fully to understand it. Okay. Now, everyone, look at those 5 scary MCQs one more time, beta. Can you see, beta, this puberphonia, guts and maneuver? Oh, puberphonia. I know now. Puberphonia matlab high pitch voice in a male. Correct. Name of maneuver for speech therapy for puberphonia is Gutsman maneuver is a maneuver used for puberphonia treatment. The surgery name for puberphonia is type 3 thyroplasty. And type 3 thyroplasty is what? Surgical shortening or loosening of vocal cord. Shortening or loosening of vocal cord. And androphonia is a female speaking like a male, means low pitch voice in a female, and the name of surgery is type 4 thyroplasty, and the type 4 thyroplasty is surgical lengthening or tightening of vocal cord. Okay, beta? Surgical lengthening or tightening of vocal cord. Okay. Now, everybody, samajh aa gaya? Could you understand? Yes. Could you make notes? Yes. But could you memorize it? No. No. In this class, none of you would try to memorize anything better. In this class of whole ENT of 3 days, you will only understand the concepts, make the workbook complete, and just do some simple things revision with me in the class. But none of you have a pressure to memorize anything in the class. I'm not going to ask the questions anyway. But you are online. In the offline also, I never ask a question, by the way. In the offline also, I never ask any question. Tum batao, tum batao, tum batao. In offline, never do that. I hate those teachers who ask questions. Now, membranes of larynx. Next topic, everyone. Membranes of larynx. I'm lucky to have coffee. For you, coffee will be in 30 minutes maybe from now. Okay? I wish I could offer you. Now, everybody answer me this question, beta. Everyone, what is this cartilage? T. What is T? What is T? Thyroid cartilage. What is this C, beta? What is this C? Cricoid cartilage. Okay, what is this bone, beta? H. Hyoid bone. Hyoid bone. Can you see membrane, beta? Look at screen, beta. There are 2 membranes over here, beta. One membrane, second membrane, beta. Oh, and the name is very easy, beta. The membrane name starts from below, goes to upward, beta. This membrane is called thyroid membrane, between thyroid and hyoid, thyroid membrane. This is what? Thyroid membrane. Now, can you tell me what is the name of this membrane, beta? Then cricothyroid. This is cricoid, na? This membrane is cricothyroid. Number 2, thyroid membrane. Am I clear, beta? So, membrane name is very clear. You can label in your diagram also. Thyroid membrane, cricothyroid membrane. Beta. Everybody label it. This membrane is called thyroid membrane. This membrane is called cricothyroid membrane. Cricothyroid membrane. Thyroid membrane and cricothyroid membrane. Beta. Okay, fine. Okay, now some important point about the membranes. First of all, thyroid membrane. Next page number 59, everybody come here. Thyroid membrane, it is pierced by, something pierces through it. It is pierced by, number 1, internal branch of SLN. What is SLN? Superior laryngeal nerve. Internal branch of, something has to go inside, beta. Internal branch of SLN, the internal branch has to go inside. It has to pierce the larynx. Which membrane? Thyroid membrane, beta. Number 2, superior laryngeal vessels. And number 3, a disease called laryngocele, beta. Laryngocele, it's a disease, beta. We'll discuss later on laryngocele, but it also pierces this membrane, beta. Laryngocele is a disease. Laryngocele is a disease, beta. Okay. Can you revise with me, beta? Thyroid membrane is pierced by, number 1. Everybody speak with me. Number 1, internal branch of superior laryngeal nerve, SLN. Everybody from now onward, SLN is which nerve? Superior laryngeal nerve. So, internal branch of SLN pierces the membrane to go in the larynx. Now, superior laryngeal nerve, superior laryngeal vessels. Number 3, laryngocele is a disease, beta. Then comes the cricothyroid membrane, beta. Cricothyroid membrane, it is site of cricothyroidotomy. It is site of cricothyroidotomy. Cricothyroidotomy. What is otomy? What is otomy? Cricothyroidotomy. What is otomy, beta? Otomy means open. Cricothyroidotomy. It is site of cricothyroidotomy. It's an airway surgery which is done in acute airway obstruction. It is airway surgery done in acute airway obstruction, beta. Acute airway obstruction. Everybody, acute airway obstruction, my dear friends. Now, let me show you a picture of the cricothyroidotomy. Can you see cricothyroidotomy, beta? Can you see what is spelling, beta? Cricothyroidotomy. Cricothyroid membrane, otomy means open. And what you do that? You open it up, you put a tube through that, beta. Can you see? You put a tube and then you give oxygen to that. It is done in, read your note, beta. It is done in acute airway obstruction, beta. It is an airway surgery, beta. Can you tell me any other way procedure, airway procedures, beta? If a patient has got airway, matlab, some person has got breathing difficulty. Other airway procedure, which is very common, beta. Other airway procedure. This is cricothyroidotomy is very uncommon. This surgery is very uncommon, beta. This is just for your knowledge that okay, there is no. But other popular airway procedures, beta. Can you tell me? Yeah, write down the side one. Side bar. When I say side bar, nahi hai, beta. Not that bar. That bar will come after 4th June, beta. Side bar. Side bar. Sidebar, beta. No, nothing in the right now. Let's focus on study, beta. Okay, fine. We'll enjoy. We'll have good time. Remember that you remember that Sholay का dialogue, beta. Sholay में एक dialogue था ना, Sholay movie, very popular movie. होली कब है? होली कब है बेटा? होली कब है? 4th June evening. हमारी होली, दिवाली, ईद, everything will be 4th June evening, beta. 4th June evening. Nothing before that, beta. Okay? Study. Let us do our best to make our life better, beta. We don't want to sulk further. We don't want to wait for other exam, beta. We want to give best to this exam only, beta. So no, nothing, beta. No festivals, nothing, beta. If any cousin is getting married in your house, beta. If your close cousin is getting married, don't even give too much importance to that, beta. Believe me, that doesn't, you would not enjoy over there, beta. Even if you're eating best biryani on the planet, beta. In your heart, you're feeling, I should have been studying, why to waste your time over there, beta? Don't worry. Next year, another marriage will come, beta. Of not that cousin, some other cousin. Sorry, for not that cousin, but other cousin, beta. But can you imagine? I passed FMG exam. Now I'm a doctor in India, and then you go to another marriage. How good you'll feel, beta. How good you feel. And every biryani rice will be so yummy, you know what. And on that marriage, you'll be looking for your matrimonial alliances also. So let's look for the good times. But right now, it's a time to study. Okay, fine. Now, other airway on the sidebar, write down. Other airway options. Other airway option. Number 1, intubation. Think like a doctor. Yes, intubation can save the patient. Intubation. Yes. Number 2, very popular word, tracheostomy. Oh, yes. Yes, Rajiv, we have heard this word. Yes. Intubation and tracheostomy are more popular things, beta. Intubation and tracheostomy are more popular things. So, cricothyroidotomy is a rare airway option, beta. Okay? Okay, fine. Other airway options. Other airway options. Okay, intubation and tracheostomy. Am I clear, beta? Fine. Chalo. Let's go further. Now, come back to the notes, beta. So, this is the membrane of the larynx, beta. Can we go further, beta? Everybody. The next topic is mucosa of larynx, beta. Everybody open up this topic now, beta. Mucosa of larynx, beta. Now what is this, everyone? Everybody, can you tell me what is this? What is this white thing? Vocal cord. Yes, Rajiv, it is vocal cord, beta. Now vocal cord. Now everybody, I'll be very happy if you answer this question. This is a cartilage here, beta. One on this side, one. This is A. What is A, beta? Can you tell me, beta? What is A? A for? A for. Not for A for, not apple, beta. If life has changed, it's not A for apple always, beta. A for which cartilage? Arytenoid cartilage. Oh yes, arytenoid. Yes. We discussed that. Arytenoid represent posterior 1/3 of vocal cord. Can you see, beta? Anterior 2/3 of vocal cord is white in color. Hai na? This is different bulky color, beta. Bulky kind of appearance over there, and that's arytenoid cartilage. Am I clear, beta? Everybody? Can you see? There are two different. This is anterior 2/3 is membranous. This is, can you see this bulky thing over there? This is arytenoid cartilage. This one on this side, one on this side. So my concept is getting clear, beta. Now arytenoid make posterior 1/3 of vocal cord. Now can you tell me which is anterior and which is posterior of the picture, beta? Anybody? What is this? Anterior or posterior, beta? Anterior. Why? Because arytenoid are posterior of the picture. What is lying over there is epiglottis. Is this side, beta? Oh yes. A lot to learn from one picture, beta. Okay. Now everyone, look at screen, beta. Can you see this picture of larynx? The whole larynx is pink in color. Whole larynx is pink in color, beta. But vocal cord are white in color. The whole larynx is pink in color, but vocal cord are white in color, beta. Different color means different epithelium. Larynx has got two different type of epithelium, beta. Now read the next line, beta. Larynx is lined by ciliated columnar epithelium except vocal cords, which are white. If I would have in your shoes, I would have written that. Okay. Rajiv told us this is white, beta. I can see. Oh, white matlab different color. Larynx is different color, pink color. But vocal cord are white in color. Larynx is lined by ciliated columnar epithelium. Vocal cord are white. Which are lined by? What type of epithelium will line it, beta? Look at screen, beta. Can you see, beta, over here? Can you see over here? What is white? My palm is white, beta. Can you see my palm is white? Okay. Now what is epithelium here? Stratified squamous epithelium. Same here, beta. Stratified squamous epithelium, beta. Write down. Vocal cord are lined by stratified squamous epithelium. Oh, white. White color means stratified squamous epithelium. Oh yes, I got it. Yes. Larynx is pink in color, but vocal are white in color. There are two different epithelium. Larynx is lined by ciliated columnar epithelium, except vocal cords, which are lined by stratified squamous epithelium. And I hope you know, stratified means multiple layer. Multiple layer means upper layer shed off, lower layer come up. Skin. Skin, upper layer shed off, lower layer come up. This keep happening, beta. But now understand, everybody. What happens is, in some smokers, this rate of shedding of vocal cord epithelium becomes faster. In some smokers, this rate of shedding of vocal cord epithelium becomes faster, and that leads to a disease called keratosis larynx, beta. Next topic, keratosis larynx, beta. Keratosis larynx, can you see over here, beta? On one of the vocal cord, there is a keratinaceous debris, beta. On one of the vocal cord, there is keratinaceous debris over there, beta. Am I clear, beta? Can you see keratinaceous debris over there? Okay. This is what, beta? Keratin. What is the color of keratin? White. Rate of shedding of vocal cord epithelium has become faster, beta. Okay. So, okay, fine, beta, fine. This is called keratosis larynx, beta. Okay, now read the notes with me. In next page, beta. Next page, everybody open up the next page. In some smoker, vocal cord epithelium starts shedding faster. This leads to a disease called, underline the word, keratosis larynx. Keratosis larynx. Oh, keratosis larynx seen in smokers, beta. Okay, smokers. Highlight the word smokers. Smokers get the disease, beta. Now the dangerous thing is, it is a pre-malignant disease. Oh, this can convert to cancer, beta. It's a pre-malignant disease, beta. It's a pre-malignant disease, beta. It's a pre-malignant disease, beta. This can convert to cancer. It's a pre-malignant disease, my dear friends. Smoker can develop it, and later on the disease can convert to cancer also. It's a pre-malignant disease, beta. Now write down, beta, C/C, beta. What is C/C? Chief complaint, beta. Hoarse voice. Chief complaint is hoarse voice. Hoarse voice. Chief complaint is hoarse voice, beta. HOARSE, hoarse voice. Chief complaint is hoarse voice, my dear friends. Hoarse voice. Simple logic, beta. Vocal cord problem is voice problem. Voice problem is called hoarse voice, beta. Very simple logic. Every vocal cord problem will have one symptom: hoarse voice. Hoarse. Vocal cord kharab means voice kharab, beta. Okay, bad voice called hoarse voice, beta. Treatment is surgery. The surgery is called stripping of vocal cord mucosa. Stripping of vocal cord mucosa. The surgery is called stripping of vocal cord mucosa. The surgery is called stripping of vocal cord mucosa. Okay, also called as decortication. Is equal to money, also called as decortication. Stripping of vocal mucosa. Stripping money, remove it. Stripping. Stripping to make it naked, beta. Stripping of vocal mucosa to make it naked, beta. Okay, let me show you stripping, beta. Can you see stripping, beta? Can you see? The mucosa is being removed. Have you seen the potato, beta? Potato. Potato skin is peeled off. You peel off the potato skin and you similarly peel off the mucosa of the vocal cord. Beta. Peel off. Look at me, beta. Peel off. Peeling matlab nikal dena means stripping of vocal mucosa. You'll ask me, Rajiv, what happens later? After few weeks, it gets regenerated. You know, regeneration, and the new mucosa will come, will be healthy mucosa. Okay, so stripping means remove the mucosa, but it's also called decortication. Okay, now one more thing, beta. One more thing is plus quit smoking also. Of course, beta, quit smoking also. Beta, quit smoking also, na? Cigarette भी छोड़ना पड़ेगा ना, है ना? Pre-malignant है, cigarette छोड़ना पड़ेगा. Don't change the brand from Gold Flake to Marlboro Light. Don't change the brand from Gold Flake to Marlboro Light, बेटा, है ना? ऐसा नहीं है. Marlboro Light is not safe, बेटा, equally harmful, है ना? तो ये nature ने एक warning दे दिया. One warning given by nature, this is pre-malignant condition, and अगर नहीं छोड़ा तो कैंसर हो जाएगा, बेटा, है ना? तो इसलिए अगर ये हो गया तो सिगरेट छोड़ देना चाहिए. Okay, fine. Now, on the sidebar write down. On the sidebar write down other treatment. Other treatment is CO2 laser chordectomy, carbon dioxide laser chordectomy. Some people say, let us not take a single chance, let us remove that much part of vocal cord with laser. Which laser? Carbon dioxide laser chordectomy mane, let us remove that much part of vocal cord. If you think voice will go bad after surgery, yes, voice will go bad. Yes, but you have to not, if you don't want to take a chance, we can remove that much part of vocal cord also. CO2 laser chordectomy. Am I clear, beta? Fine. I hope you are enjoying the process of learning. That's very important for me. I should not make your day dull. You and me together should make the day brighter. Bright for you, bright for me as well. Okay? CO2 laser chordectomy. Okay. Everybody, you might ask me that, Rajiv, this is theory, but if we see the questions, how do the questions come, beta? Everybody read this question with me. A chronic smoker presents with history of hoarseness. Okay. On examination, the patient is found to have what disease? Keratosis larynx, beta. Oh, keratosis larynx. Smoker, keratosis larynx, beta. All of the following are possible treatment modalities except, beta. He's saying except. Now, number one, he says laser. Yes, I just read laser, CO2 laser. Yes. Elimination of chronic laryngeal irritant, मतलब smoking. Smoking को बंद करना है. Yes. Stripping of vocal cord. Yes. But I will not do laryngectomy, beta. Answer is B, beta. B. Can you understand, beta? B. Except all of the following treatment are for keratosis larynx. Except I will not do laryngectomy, beta. Laryngectomy. It's a pre-cancerous condition. It's not cancer. It's pre-cancerous. It's pre-malignant. It can develop cancer. But today you don't have cancer, beta. You can't be so, so, I would say, finicky. Larynx निकाल देते हैं. Let's remove the larynx. कहीं कैंसर ना हो जाए. कहीं कैंसर हो, ऐसा नहीं. ऐसे मूवी है ना, कहीं प्यार ना हो जाए. Not like that ना, दिल निकाल दो कहीं प्यार ना हो जाए. No यार. ले देखते क्या होता है ना. अभी हुआ तो नहीं है ना. As of now, no cancer ना. It's pre-malignant. It's not malignant. So, ऐसे ही कहीं प्यार ना हो जाए तो दिल निकाल दो. है ना, larynx में कैंसर ना हो जाए, larynx निकाल दो. No, not like that. So laryngectomy should not be done for this, beta. Am I clear? This is what the question. They say difficult question, clinical question. But I have a common sense. I trust FMGs. They have common sense, lot of common sense. You have to play the game well on that day. Don't get too, jittery with seeing little bit deviated thing here and there. I can handle it, beta. I can handle it. Okay, I have firm faith in FMGs, beta. FMGs have got a brilliant mind. Only that's the reason they could survive in a foreign country. Otherwise, they would have come back. First 6 months was horrible in the university. When you reached over there, the language was not understandable. The food was beyond comprehension. People were all aliens, beta. We were missing our moms and dads and relatives and cousins and friends and whatnot. Weather was also extreme, beta. People from South India never exposed to the extreme cold, and temperature was pretty low over there. We managed it somehow. We learned to fight over there. Yes, we felt weaker in the beginning, but then we made it happen. We never came back. We never wasted the parents' money. Some of the people might have come back in that, phase. They took a call, no, let's go. But we did not do that. We just persisted over there. We kept fighting over there. And within 1 year, we settled over there. We started liking the place. 2 years passed. 3rd year, we had local girlfriends also. I know it, beta. I know, you develop local people friendships also. In between also, we started making a world over there. You are street smart people. Trust your common sense. You have got much more common sense than IMGs actually. You have got much more street smartness than IMGs actually. Because IMG, we people are pampered people. We live in our own country and study. But you guys go out and study. It's not easy to do that. So respect yourself. Trust yourself more than, yes, there is a tough exam in front of us. वो हम कर लेंगे. अभी नहीं हुआ, अब कर लेंगे. इस बार कर लेंगे. But after that, we are at par with anybody. There's no difference between IMG and FMG. In fact, FMG have got much more street smartness, IQ, common sense than the IMGs actually. I deal with both the groups. I can tell you a lot of surety over there. Trust yourself. When a question sounds difficult to you, don't get too anxious. When a question sounds little unknown to you, don't get too confused. पढ़ते हैं. Elimination of chronic laryngeal irritant means smoking. Smoking. इतना पता लगा लेंगे भाई. इतना समझ है. इतना common sense है. Use करेंगे. We'll use in the exam day the same common sense, beta. Okay? चलो. I don't flatter people. I'm telling you your own worth. I need not flatter anyone. Let me tell you very humbly, honestly, I need not flatter anyone. I need not say good words to anyone, but I mean what I say, and I say what I mean. This is what I am actually. I only say what I mean, and if I say, I really have that ingrained within me, because I have been dealing with FMGs for the last 12 years, staying in the hostels with them, right from whichever country, Kyrgyzstan, now Ukraine, Russia, China, Philippines, etc., etc. I have learned that FMG got immense power. Only thing is that, okay, they need a little bit hand holding in the beginning. After that, they can make things much, much better. Let us trust ourselves better, okay? Now, next one. 3 division of larynx, better. Next topic, 3 division of larynx. Anybody can tell me, what is glottis? What is glottis? Vocal cord. Okay, glottis is vocal cord. So glottis is vocal cord. Above that, supraglottis. Below that, subglottis. Beta. Very easy. Beta. Look at me. Beta. Above the vocal cord, supraglottis. Below the vocal cord, subglottis. And vocal cord is glottis. Beta. Glottis, supraglottis, subglottis. Am I clear? Let us start it one by one. Let us discuss supraglottis first. Beta. From above downward. Beta. Supraglottis first of all. Supraglottis has got 5 parts. Beta. 5 parts. Okay, let us do better. What are 5 parts? Number 1, epiglottis. Oh, yes. Epiglottis has to be part of supraglottis, beta. Look at my hand, beta. You will say, Rajiv, your hand has coffee. No, no, not this hand, beta. You see this hand, beta. Look at me, beta. I wish you were here, you know. I'm missing you guys. Now, please see. This is vocal cord. This is the epiglottis. Epiglottis. Epiglottis, you know. It has to be supraglottis. Above the vocal cord is supraglottis. Yes, epiglottis. Yes, yes, yes. Very good. Epiglottis. Number 2, scary word. Airy epiglottic fold. What the hell is this one now? Airy matlab arytenoid. Airy matlab arytenoid. Arytenoid to epiglottis, there are 2 folds, beta. Airy epiglottic fold, beta. Yes, Rajiv, show us. Let me show you. That's what I'm here for. Okay. Clinical understanding. Anatomical clarity. Okay. Now, beta, look at screen, beta. What is this, beta? What is this, everybody? What is this? Epiglottis. Very good. Epiglottis. Beta. Can I write down, beta? E mane epiglottis, 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 epiglottis. So, this is anterior of the picture, beta. Posterior of the picture, beta. Okay, bache? Fine. Now, vocal cord. What is it? A, beta. What is A? A for arytenoid. Yes, arytenoid is the posterior 1/3 of vocal cord, beta. Okay. Can you see a fold here, beta? Everybody. 1 fold on this side. 1 fold on this side, beta. Now, this fold will be called AEF. AEF. What AEF? Airy epiglottic fold. Oh, yes. This fold is going from arytenoid to epiglottis, beta. Arytenoid to epiglottis, beta. That's why airy epiglottic fold, beta. Now, let me remove the marking and you see yourself, beta. Can you see airy epiglottic fold? 1 on this side, 1 on this side, beta. Is it visible to all of you, beta? Oh, yes, yes, yes. Rajiv, you're right. Arytenoid se epiglottis tak ek fold ja raha hai, and that fold, this fold is called airy epiglottic fold. 1 on this side and 1 on this side, beta. 1 on this side also. Okay, yes. Make sense? Okay. Now, can you see the white one, beta? This white one. This is what, beta? This is called true vocal cord, the real vocal cord. The vocal cord, beta. The real. When we say vocal cord, we mean the white vocal cord, beta. Okay. But on top of that, if you see, there's another vocal cord here. And that is called false vocal cord, pink color vocal cord. Can you see? Above the true vocal cord, there is another vocal cord here. It's not a vocal cord, a stupid fold kind of thing. False vocal cord, you know, useless, false vocal cord. Can you see it over there? This is false vocal cord. Beta. Let me label the picture for you. What I'm trying to say, is the white vocal cord are the true vocal cord, the real vocal cord, but these pink one are not just a fold called a false vocal cord. Beta. In between the two, there is some space going, that's called ventricle. Beta. You can't see ventricle? Ventricle is going between the false vocal cord and true vocal cord. Look at me, beta. False vocal cord, true vocal cord. Between the two, there is something going. It's called the ventricle. Beta. You can't see ventricle. It's going between the two. Ventricle. Okay. Now read your notes, beta. Read your notes, everyone. Open up your notes. Airy epiglottic fold. Then you have got false vocal cord. False vocal cord is equal to ventricular bands, beta. Is equal to ventricular bands. They are rudimentary, beta. Rudimentary means of no practical value. They are rudimentary means of no practical value. Rudimentary means useless. Pink fold, useless fold. Then ventricle. Ventricle is space between false vocal cord and true vocal cord, beta. Ventricle is the space between false vocal cord and true vocal cord. Okay. Now, look at this diagram, beta. Look at this diagram. What is FVC? What is FVC? False vocal cord. It's a cut section, beta. It's a cut section. False vocal. What is TVC? The true vocal cord, the real vocal cord, the vocal cord. When I say vocal cord, I mean the true vocal cord. This is useless, beta. It's just a fold. What is ventricle? It is a space between false vocal cord and true vocal cord, beta. Okay. Can you see, guys? From ventricle, there is some mucosal outpouching going like this, and that is called saccule. Saccule number 5, beta. Point number 5. Everybody read your note number 5. Saccule. Saccule is outpouching from ventricle. Outpouching from ventricle. Full stop. Full stop, beta. Full stop. Full stop, beta. It is rich in mucosal glands, so called as oil can of larynx. Oh. So oil, also called as oil can of larynx. It produces a moisturizer for the larynx, but oil can. It has got a very rich mucosal gland, therefore it is also called oil can of larynx beta. Oil can of larynx. Am I clear beta? It is also called as oil can of larynx beta. Am I clear beta? Oil can of larynx. Okay beta, fine. Okay. Just write on the sidebar beta. Write on the sidebar. Ventricle and saccule are hidden areas beta. Ventricle and saccule are hidden areas. You cannot see them, my dear friends. Ventricle, saccule are hidden areas. You can't see ventricle. Could you see the ventricle? No. Could you see the saccule? No. So they can't see the ventricle, saccule. They're hidden areas. They're within the, you can see them on CT scan maybe, but not on the endoscopy. They're hidden areas beta. Am I clear beta? Let us revise beta. Supraglottis, everybody. I've written ventricle, saccule are hidden areas beta. Let us revise beta. Supraglottis, how many parts? Everybody, are you with me beta? Are you imagining that you and me are sitting in the same room together? It's not a virtual class. It's a physical in-person class where you and me are sitting in the same room, studying together, learning together. I'm not a faculty. I'm just a friend of yours, an elder brother of yours who is trying to share his knowledge with you so that you are able to score maximum question out of ENT. That's my heartfelt wish. Okay. That's why it's a 5-part. Number 1, epiglottis. Yes. Number 2, which fold beta? Airy epiglottic folds. Number 3, which vocal cord? False vocal cord, which are also called as the ventricular bands. They are rudimentary beta. What speak about false cord, also called rudimentary. But number 4, bolo beta, number 4, ventricle. What is ventricle? It is space between false vocal cord and true vocal cord. Space between false vocal cord and true vocal cord beta. And number 5, saccule. Saccule is out pouching from ventricle. It has rich mucosal glands. Therefore, it is also called as oil can of larynx. My dear friends, ventricle and saccule are hidden areas beta. You can't see them. And one more point. What is the other name of false vocal cord? Ventricular bands. What is the role of false vocal cord? Nami false beta. False means useless. Useless beta. Hai? So we do not speak with true false vocal cord. We speak with true vocal cord. But if someone starts speaking from false vocal cord, it's a disease beta. Go to the next page, everyone. Go to the next page. Next page beta. Disease beta. Dysphonia plica ventricularis. If a patient produces sound from false vocal cord beta. MCQ beta. False vocal cord. Then it's a disease called dysphonia plica ventricularis. If a patient produces sound from false vocal cord, mind you, I repeat, we produce sound from true vocal cord. False vocal cord are useless vocal cords. Okay, fine. If a patient produces sound from false vocal cord, it's a disease called dysphonia plica ventricularis. Dysphonia plica ventricularis. Dysphonia plica ventricularis. If a patient produces sound from false vocal cord, it's a disease called dysphonia plica ventricularis. Oh, Rajiv, ये तो मिसाइल का नाम लग रहा है. अभी जो मिसाइलें चल रही हैं, it look like a missile name beta. Let's make it simple. You tell me, what is the other name of false vocal cord? Look at your note beta. Look at your notes. What is the other name of false vocal cord? Bolo beta, bolo. Ventricular bands. Very good, ventricular band. Can you see beta over here? Plica means band. Ventricular band means false vocal cord. Producing wrong kind of voice means dysphonia. Oh, नाम ही बता रहा है. Dysphonia, wrong kind of voice. Plica ventricularis means other name of false vocal cord. Ventricular band, band माने plica. Very simple question. If a patient produces sound from false vocal cord, it's a disease called dysphonia plica ventricularis. Dysphonia plica ventricularis beta. Dysphonia plica ventricularis beta. You say, Rajiv, this is the notes, but how the exam can ask us the clinical scenario based question? Then I'll say, let us see in between some question also beta, that how the question can be twisted, and you have to just be thinking about the thing in a right way so that we are able to answer that beta. Chalo, let's read this question beta. A 42-year-old patient singer by profession has been vigorously practicing for an important concert of his life. He has subsequently developed hoarse voice. On laryngoscopy, he is found to have adduction of false vocal cord while phonating. Phonating means while speaking. False vocal cord adduction beta. Look at this, adduction of false vocal cord while phonating. False vocal cord are being used to phonate mane to produce sound. What is the name of this disease or clinical condition called? Dysphonia plica ventricularis. Never get scared of 3-liner, 4-liner, 5-liner question beta. They have got some important key point. Just go there, focus on that and answer that question. Do not over dissect the question beta. When you over dissect the question, you go to the rare answers and then you change the answer, and when you change the answer too much, they are generally wrong beta. Wrong. Get to the common sense, get to the commoner answers, get to the commoner clinical things. Don't think of too rare things. If the language is a little bit changing here and there, I'm a FMG. I'm proud to be FMG beta. I want one day, this feeling should be within every FMG, that I'm proud to be an FMG beta. And believe me, may nature bless us. I'm seeing that happening with the next coming up beta. National exit test coming up. Once next comes up, this IMG, FMG differentiation would come to an end beta. Because an FMG can proudly say at that time, if you have passed next, I've also passed the same exam called next beta. then there's nothing like you pass MCI and I pass NEET PG. Not like that, brother. No, everybody will be same, brother. And I'm really looking forward to that era when this differentiation of FMG IMG has to end, brother. And national exit test is going to do a huge favor to FMGs. It's not going to be tougher exam, brother. People are saying it's tougher. We'll handle it. Don't worry. We'll handle it. For we have to handhold all the junior batches of the FMG also, and to bring them to the next level. And we will make it happen. Believe me. And it's a beautiful exam, and everyone will come at par. No FMG IMG differentiation now. Everybody will say, FMG will say, if you cleared next, I also cleared next. So we are same, brother. And then this feeling, this I have a dream actually there. The dream is that every FMG should stand like this at the Indian airport when he reaches. I'm proud to be FMG. So this is what I am looking 5 years down the line. This feeling has to percolate down, and this may God bless us. May God bless us. May God bless us. May we contribute to make it happen. So can you see that, brother? Adduction of false vocal cord by phonating. Oh, I can see it's dysphonia plica ventricularis, brother. Okay. Now next one, brother. Next one. One more topic. We are 5 minutes away from the break. The best line of the class is this one, I know. The best line is, oh, I'm 5 minutes away from the break actually. Laryngocele, beta. Laryngocele. What is laryngocele? It's a disease more common in people who play trumpets, beta. Trumpets. Who play trumpets. That's a clue in the exam. Who play. This is a topic important for FMG. Very important topic. Trumpets mean, in the bracket, wind instruments. You know trumpet? Trumpet, Chennai, bagpiper, saxophones, any instrument in which you have to blow a lot of air. What will happen? Due to pressure of the air, your saccule may start becoming bigger in size. Okay? Now what it is abnormally dilated saccule. It's abnormally dilated saccule. It's abnormally dilated saccule. Abnormally dilated saccule. Everybody draw a diagram with me. False vocal cord. A big laryngocele. Let us label it. FVC, TVC, ventricle. Saccule became big in size. This is laryngocele. Oh, saccule is a normal structure. We all have saccule. But if saccule mein hawa bhar jaye, if saccule becomes too big in size, it is laryngocele. Beta. What does it contain? Air. It is air-filled swelling. Beta. Because trumpet blower, wind instrument blower will put a lot of pressure in the larynx, and due to the pressure of the air, the saccule may become a balloon-like thing. It's actually filled with too much of air, and saccule become bigger in size. That abnormally dilated saccule is a disease called laryngocele. Laryngocele. Am I clear? Laryngocele. Now, let's go to the, have you drawn it? Sidebar, beta, sidebar, bar, sidebar, sidebar. Okay, fine. Can we go further? Now, let's go forward. Open the notes, beta. It pierces which membrane to come out? Thyroid membrane to come out, beta, and appears as air-filled neck swelling. Now, wait here, beta, wait here. Is your brain telling you that this word came earlier also? Laryngocele, thyroid membrane. Aaya tha? When we revise, we are going to go back. Everybody go back with me, beta. Everybody go back. And this is the way you will revise for every subject, beta. Oh, I'll go back. Oh, yes, page number 59, beta. Oh, page number 59, and this word came over. Oh, it pierces thyroid membrane, beta. Look at beta. This word came here also. It pierces which membrane? Thyroid membrane to appear in the neck, beta. Okay. Then you come back over here, beta. Then you come back to the same page again, and write over here, page 59, beta. Page 59. The same story was there at page 59 also. Try to create, interlocking of the memory, beta. Interlocking of the memory. Please create interlocking, beta. Revision. Why revision is not effective? Why we are not having too much advantage with the revision, beta? Why? Because we are doing a very passive revision. How do we revise? We sit on the bed. We put 2 pillows behind the back as if we are 7 months pregnant. Sorry for that. That's why we are sitting, sitting on the bed mostly with the 2 pillows at the back and relax, and the book is, the notes are there in front of you. Mostly you are taking a bed sheet or a blanket or rajai or quilt like this, and your hands are also inside the blanket. I don't know where they are. You also know. You only know. In between, when the one page finishes, you bring your hand out and you just do the next page over there. And then in this time, what happens? A thought comes. Today you sleep. Tomorrow you become a better person. You are just 6 inches away from the sleep, beta. What you do is you have to pull the blanket on your head and just sleep with this hope that tomorrow you become a better person, beta. That will not come. Exam will come. Why I am telling you all these things with so much clarity? Because I have done the same mistakes. I've done the same mistakes. Multiple number of days and weeks and months I wasted like this. And then I realized, no, You have to play the game well. You have to wear the sports shoes, sit down on the chair, and then roam around in the room and study and keep flipping the pages this way, that. Oh, ye yahan bhi aaya tha, udhar dekha, idhar underline kiya. Keep the brain active, engaged, and active engagement with the notes, faster revision even, will create a deeper impact in your brain, beta. So let us convert a passive revision into active revision, beta. Within the notes, some overlap. Go to the bad part. Subject overlap, surgery reading, pathology notes there. Pathology notes kahan padhe? Wahan pe Almira mein. You are almost 2 meters away. रजाई में किसका मन करता है भाई? Who wants to leave the blanket and go to pathology notes and bring that and see over there? Oh, seminoma here. Oh, yes, both the things are correlating. You have to correlate. For that, you have to wear the sports shoes. Let us start a new culture in FMG exam, beta. Sports shoe culture, beta. Sports shoe culture. This really helped me, beta. Sports shoe culture means I am active. I'm active. Brain gets a command. Brain is a wild monkey. You want to convert it to a pet dog? Be strict with it. Be disciplined with it. And wearing sports shoes gives a signal to the brain. This is a time to be active, not to be sleepy. Pick up seminoma pathology notes, pick up surgery, compare. Oh, underline over here, beta. Pathology page number this. This is what is going to create a deep impact in your brain, and exam will easy for you to recall, beta. All these things are coming from within my own experience of my own failures, beta. That's why maybe most of you would be able to really say, yes, we also do the same thing. But everyone does the same thing, beta. But we have to evolve. We have to improve, and we can improve. Okay? So it places which membrane? Thyroid membrane. I see that in the page number 59 also. Examination shows Bryce's sign, my dear friends. BRYCE. Very important question, Bryce's sign. Not the Broca's sign or the Boca's sign of the, which Dr. Vineet must have told you about. Another one, disease, pharyngeal pouch, Zenkel diverticulum, gurgling sound, not that one. It's Bryce's, BRYCE, Bryce's sign. What is Bryce's sign, beta? Bryce's sign, BRYCE, beta. Bryce's sign. What is Bryce's sign, beta? Look at screen, everyone. Bryce's sign means, what is it, beta? It is air-filled neck swelling, beta. Can you see air-filled neck swelling here? It is air-filled neck swelling, beta. Air-filled neck swelling. Air-filled neck swelling, beta. Okay? Now look at me, beta. Look at me, everyone. When you press it, when you press the swelling from outside, there's a sound of air leakage, beta. Can you see, beta? This is the air-filled neck swelling. When you press it, the sound will come as if the tire got punctured, beta. The sound of air leak can be heard when you press the laryngosele, and this is called Bryce's sign, my dear friends. Bryce's sign. Now, beta. Bryce's sign, beta. BRYCE, Bryce's sign. Come back to the note, beta. Oh, the sound of air leak heard when laryngosele is pressed, beta, because it's air-filled neck swelling. Okay. Investigation. X-ray soft tissue neck with Valsalva. Very important. Underline the word with Valsalva. Underline the word with Valsalva. What is Valsalva, beta? What Valsalva? Valsalva is when you press the nose and try to exhale. This is Valsalva, beta. This is Valsalva. Everybody, Valsalva. Look, ऐसे. Naak band karo. Close the nose, close the mouth, and exhale. This will make it more prominent. This Valsalva is close the nose, close the mouth, and do like this. This will make it air-filled, more prominent, beta. And when you do X-ray like this, you'll see a very prominent swelling, beta. And where is the swelling, beta? This is the, beta. This is the swelling. It contains what, beta? Air, na? Air will look black, na? Can you see, beta? This is the laryngosele, beta. This is laryngosele, beta. Air-filled. Air looks black on the X-ray. Air-filled. X-ray neck with Valsalva is a clue for your answer, beta. There is no other question with X-ray neck with Valsalva, beta. X-ray neck with Valsalva means more air will be filling in that swelling. It will be more prominent, beta. Am I clear, beta? Okay, fine. Treatment is surgical excision, beta. Treatment is surgical excision, my dear friends. Surgical excision. You do surgery, you open it up and remove it, beta. Surgical excision, beta. Let's revise this topic. What is the name of disease, beta? Laryngosele. Now, if I'm a student, if I'm this thing, then I would very, clearly write down, oh, this is he, what he's doing is Valsalva. This is Valsalva, beta. I will label my notes like this, oh, to make it more useful for other things also. Well, I know what is Valsalva. Okay? Please feel free to label the way you want to. Your knowledge is your knowledge. The way you want to really keep it in your memory is your own business. Whatever language is comfortable, no problem, beta. Laryngosele is a disease more common in people who play trumpets or wind-based instruments. So first question will be a trumpet blower. I know the answer already. What's the definition of it? It's abnormally dilated saccule. I know we all have saccule, but if saccule becomes very big in size, it's called the laryngosele. Okay. Now it pierces which membrane? Thyroid membrane to appear in the neck as air-filled neck swelling. As air-filled neck swelling. Now when you press it, the sound of air leak is heard. This is called Bryce's sign. X-ray neck is done with Valsalva. And you see air-filled neck swelling, and the treatment is surgical excision, beta. Surgical excision. This is supraglottis, beta. This is supraglottis. Everything is supraglottis. Okay? We'll take a break here. It's a 15 minutes break. Let's not really take too long breaks. Let's be, structured in the class as much as possible. Sometimes I may be late. I'm sorry for that. But we'll start in 15 minutes from now, and you can take a break, and then we start again, beta. Okay? So this is a break for you for 15 minutes, beta. Next one is subglottis, beta. Supraglottis, now subglottis. Now what is subglottis? Everybody, what is subglottis now? Now subglottis, it's an empty space in the cricoid ring. Everybody look at me, beta. Everybody, can you tell me which cartilage is a ring-like cartilage? Which cartilage? The ring-like cartilage. Look at me, beta. This is cricoid, beta. You remember cricoid? Cricoid, the ring-like cartilage. If cricoid is a ring, then subglottis is the empty space in that ring, beta. Please once again see which cartilage is a ring-like cartilage. Cricoid, cricoid, and cricoid is a ring-like cartilage. Whatever is the empty space in that is called subglottis. Now look at this. Subglottis is the empty space in the cricoid ring. Now what does it contain, beta? Write down. It contains air. It only contains air, beta. There is no structure in subglottis. Only air, air, and air, beta. It only contains air, beta. It's an air-filled column. It only contains air, beta. Am I clear? It only contains air. Am I clear? Fine. Now please understand that subglottis has got nothing. It only contains air, beta. Air. Okay. Now subglottis finishes. What start? Trachea starts, beta. Trachea start. I hope you remember the concept that the cricoid ring is fitting over the tracheal ring, beta. Cricoid ring is fitting over the tracheal ring. Okay. So subglottis is the empty space in the cricoid ring. It only contains air, and I remember from anatomy discussion that cricoid is a ring-like cartilage and it is fitting over the tracheal ring, beta. So when cricoid ends, the larynx also ends. When larynx ends, what starts is trachea. Okay, this is the only thing you need to know about subglottis, beta. Now come the real champion, beta. Real champion is glottis. Glottis, beta. Glottis is equal to true vocal cord. Is equal to vocal cord, beta. When I say vocal cord, I mean glottis. Vocal cord. We will call it VC. When I say VC, means vocal cord, beta. Glottis is true vocal cord or vocal cord. When I say vocal cord, I mean the true vocal cord, the real vocal cord, beta. Okay, and we'll call it VC, beta. Now underline the word length of vocal cord. Length of vocal cord, males is 18 to 23 millimeter, and female is 16 to 17 millimeter, beta. Male 18 to 23 millimeter, female 16 to 17 millimeter. 23, 16, 17 millimeter. Guys, please understand. Male is, speak up with me, beta. What is the length of male vocal cord? 18 to 23 millimeter. Female is 16 to 17 millimeter, beta. Mind you, it's millimeter, not centimeter, beta. Centimeter, 50. Can you imagine 15 centimeter? 15 centimeter में तो neck पार हो जाएगा, बेटा. 15 centimeter में तो गर्दन भी पार हो जाएगी, बेटा, है ना? So it's not centimeter, it's millimeter. 15 centimeter में तो neck will cross, बच्चे. Centimeter, 15 centimeter, ना? It's millimeter, बेटा. Okay? Anybody? What is thyroid angle in males? Thyroid angle in males is 90. Female, बोलो जरा, बोलो. Male 90, female 120 degree. Okay, male 90, female 120 degree, beta. Now this is your diagram, beta. Everybody look at this diagram. Now can you tell me what is the anterior of the picture, beta? Anterior of the picture. Epiglottis is the anterior of the picture. Everybody write down A mane anterior, P mane posterior, beta. Posterior, beta. Anterior, posterior. Am I clear? Now everybody, epiglottis represent anterior. Okay, write down T, beta. Thyroid. Why thyroid, beta? Can you tell me? Vocal cord are attached to midpoint of which cartilage? Thyroid cartilage. Try to recall, beta. At the midpoint of thyroid cartilage, two things attach. One is epiglottis, other is vocal cord, beta. Okay, vocal cord. Am I clear, beta? Vocal cord. Okay. And what is this A? Everybody, what is A? A for arytenoid. Can we label it, beta? A is what, beta? A for arytenoid, beta. I know now. I'm getting the concepts now clear. A mane arytenoid, beta. Oh, arytenoid make posterior 1/3 of the vocal cord. Okay, beta. A for arytenoid. Now, can you see between the two arytenoids there is a muscle called interarytenoid muscle, beta. Can you see? Interarytenoid muscle, IA muscle. This is unpaired muscle, beta. Of course, it's a single muscle, beta. Unpaired muscle is single muscle. It's a single muscle. Unpaired muscle means single muscle, beta. Okay. Of course, it's a midline muscle. It has to be single muscle. It's a midline muscle, single muscle. Okay. It has to be unpaired muscle, na? In the midline, between two arytenoids is a midline, na? So interarytenoid muscle, IA muscle is an unpaired muscle, beta. Okay. Now everybody, can you just see between the inside the vocal cord, there is another muscle, beta. Everybody, look at screen. Inside the vocal cord, there is another muscle. Now just see on the screen, beta. Vocal cord are this one, beta. This is A, beta. This muscle is called IA muscle. What is IA muscle? Interarytenoid muscle. Now vocal cord start from midpoint of which cartilage? Thyroid cartilage. What is the name of this muscle, beta? Within the vocal cord is called thyroarytenoid muscle. TA muscle, beta. Look at your diagram, beta, in the notes. Thyroarytenoid. Now how to remember thyroarytenoid? Vocal cord start from midpoint of which cartilage? Thyroid cartilage. They end at which cartilage? Arytenoid cartilage. And what is the muscle name will be? Thyroarytenoid. Because vocal cord extends from the thyroid cartilage to the arytenoid cartilage. So muscle within the vocal cord will be called thyroarytenoid. Beta. Thyroarytenoid. Am I clear, beta? Thyroarytenoid. Okay, fine. Now, again see, beta. See, he says that anterior commissure and posterior commissure, beta. Look at screen, beta. Can you see anterior commissure, posterior commissure? Anterior commissure means the anterior junction of vocal cord, and posterior commissure means posterior junction of the vocal cord. Anterior commissure or posterior commissure. Commissure means junction. Commissure means junction. Beta. Now all of you again see at the picture. Now you have to tell me what is this commissure, beta. What is this commissure? Which commissure? Can you guess it, beta? Can you guess what is commissure, beta? What is the anterior or posterior commissure? Now apply your knowledge. Epiglottis is what? Anterior. Interior, beta. This is anterior commissure. What is beta? Posterior commissure, beta. What is beta? E, beta? E means epiglottis, and epiglottis is the anterior of the picture, beta. Okay? Epiglottis side is anterior. Anterior commissure, posterior commissure, beta. Can you tell me what is this A? A for arytenoid. Okay? What is this muscle, beta? Interarytenoid muscle. Okay? Anybody, what is this muscle, beta? This muscle is what? TA muscle. What is TA full form? Thyroarytenoid muscle. Okay? What is this muscle, beta? IA muscle? Interarytenoid muscle, beta. Okay? Fine. Is it clear to all? This not a too difficult thing, beta. Okay? Now, arytenoid is a hard part of vocal cord, beta. Okay? Now, allow me to show you the one video to support this thing further, beta. Can you see arytenoid? Sorry. Can you see the arytenoid, beta? Can you see this one, everybody? Now, this is arytenoid, this is epiglottis. Epiglottis is anterior, arytenoid posterior, beta. Let me rotate the specimen towards you, and you see this is the arytenoid, and cornugate cuneiform are rudimentary cartilages, useless cartilages. Let us look within the larynx, beta, from above, beta. Okay? What is the anterior? What is the beta? Epiglottis. Okay? Can you see what is this cartilage? Arytenoid cartilage. Can you see when arytenoid move, vocal cord open or close, beta? Can you see? Can you see? They close. Adduction. When they move like this, beta, abduction, beta. Can you see they are moving, beta? Abduction, adduction, beta. When arytenoid move, vocal cord move, beta. Because muscle are attached on the arytenoid, beta. Arytenoid. Can you see, beta? Movement of the vocal cord. Adduction, abduction. Adduction, abduction. Because muscle are attached where? Arytenoid, beta. Thyroarytenoid, interarytenoid. So all these movements are going to happen over arytenoid, beta. Can you tell me one? Try it, beta. What is this yellow ring-like cartilage? What is yellow ring-like cartilage? Which cartilage ring-like, beta? Arytenoid. Which cartilage ring-like, beta? Ring-like, cricoid cartilage, beta. What is this yellow ring-like cartilage? Is this yellow ring is like, what is this yellow ring-like cartilage? Cricoid, beta. What is this cartilage, beta? Arytenoid cartilage, paired cartilage. What is the pink cartilage? Leaf-like is epiglottis, beta. Am I clear, beta? Fine. Is it? So I'm getting the idea. Oh, muscle are attaching on the arytenoid. When arytenoid move, vocal cord move, beta. Once again, please create a visual in your mind. Arytenoid move, vocal cord move, beta. Muscle are attached on the arytenoid, beta. Adduction, abduction. Adduction, abduction, beta. Okay. This is the, you can say the animation. But in the reality, if you see, reality, beta. See on the screen, beta. Reality. Please see. This is endoscopy. We are putting an endoscope through the nose, beta. Nose. You are going down into the pharynx, beta, now. And from the top, the endoscope is flexible endoscope, beta. And it takes a turn. From the nose, you are going back of the nose and entering the, can you see epiglottis there, beta? Can you see epiglottis, beta? Everybody, can you see epiglottis? This is your epiglottis. You are seeing from above like this, beta. Above like this, because larynx is inside the well. This is epiglottis, beta. This is epiglottis, beta. Okay. Now, this is vocal cord. Okay. This is epiglottis and vocal cord, beta. Now, please see on the screen. Now, everybody, can you see vocal cord, beta, over there? Epiglottis is what? Anterior part of the picture. Arytenoid is posterior part of the picture, beta. What is arytenoid, beta? What is arytenoid making? Arytenoid make posterior 1/3 of vocal cord. Can you tell me where is arytenoid right now? Can you tell me where is the arytenoid right now, beta? This is epiglottis. This is vocal cord. Then this should be arytenoid, beta. This should be arytenoid, na? Anterior, posterior. Anterior, epiglottis, posterior, arytenoid cartilage, beta. Okay, fine. Now, everybody, please see on the screen, beta. He will label it for you, beta. Can you see he's labeling arytenoid, beta? He is labeling arytenoid, beta. है ना? Arytenoid is labeling. It means that मैं कहानी नहीं बना रहा. I'm not creating a fiction. I am telling a science over here, beta. ऐसा नहीं कि मैं कुछ भी पढ़ा के चला गया, है ना? Arytenoid उसने भी label किया है. Can you see true vocal cord, white vocal cord, false vocal cord, pink vocal cord, है ना? Everything is there in front of you. This is endoscopy picture. You are seeing from above like this, beta. Okay? So epiglottis is this side, beta. This is epiglottis side. This is arytenoid side, beta. Am I clear, beta? Fine. Now let me show you abduction, adduction, beta. Please see, beta. This is what, beta? Vocal cord. This is, beta, what? Abduction. ABD. Abduction means open. This is adduction. Abduction, adduction. Abduction, adduction. Abduction, adduction. Am I clear, beta? Open, abduction. Close, adduction. ADD. Abduction, adduction. Am I clear? Fine. For this, you have to understand muscles are required. So thyroarytenoid and interarytenoid are adductor muscle, beta. Please look at the screen, beta. They close the vocal cord. Adductor means this movement, beta. But by chance, if these two muscles turn weak, what will happen? The vocal cord will not be able to close fully. There will be some gap left between the vocal cord. and this is a disease called phonesthenia. First understand it, then see the notes. Have you heard the word myasthenia? What is myasthenia? Muscular weakness. Phonesthenia means muscular weakness of vocal cord. Phonesthenia. There will be some gap left between vocal cord, and this gap looks like what? Look at screen, beta. This gap looks like what? Keyhole. This gap looks like what, beta? Keyhole, beta. This gap. Can you see? This gap looks, this much gap will be left between the vocal cord forever. Howsoever you may try, your cords cannot completely close because thyroretinoid and interretinoid are weak muscles, beta. They are weak in this patient. TA and IA, now look at your notes, beta. Everybody look at your workbook. TA and IA are adductor muscles. Adductor means close karte hain. If they are weak, look at your workbook. If they are weak, it's a disease called phonesthenia. Phonesthenia. How I remember it? Myasthenia gravis. Myasthenia, phonesthenia. Now, in this, adduction will be incomplete. Adduction will be incomplete. So, there will be a gap between the vocal cord, and the gap looks like what? Look at the shape of the gap, beta. Can you see the shape of the gap is keyhole, beta. Keyhole. So, my question is ready. Keyhole glottis is seen in which disease? Phonesthenia. Keyhole glottis is seen in which disease? Phonesthenia, beta. Okay? Chal. Now, everybody, please see on the screen, beta. Please see on the screen. Let's now do the notes again, beta. Open up the workbook. Open up the workbook. Now, both TA and IA are adductor muscles, beta. If they are weak, it's a disease called phonesthenia. Oh, phonesthenia. Examination shows, fill in the blank, beta. Examination shows keyhole glottis. Examination shows keyhole glottis. Examination shows keyhole glottis, beta. Examination shows keyhole glottis. Keyhole glottis, beta. Okay. Keyhole glottis is due to gap between the vocal cords, beta. Okay, fine. Yaad rakha, beta. Phonesthenia, keyhole glottis, MCQ. Everywhere I have drawn red box like this, beta. MCQ means this question has come or can come. Okay. Now, vocal cords, one thing, do not have two things, beta. Vocal cords do not have lymphatics is a very important question. Vocal cord do not have lymphatics. Vocal cords do not have mucosal glands also, beta. Vocal cord do not have lymphatic is an important thing to remember. Vocal cord में lymphatics नहीं होते. Vocal cord do not have lymphatics, बेटा. Vocal cord do not have lymphatics. Okay, बच्चे, fine. चलो. Now, okay, fine, बच्चे, fine. Now, let's go further, beta. Let's go further. Now, next topic is Rinke space, beta. Rinke space. First of all, Rinke space. Just open up Rinke space. It is the subepithelial loose connective tissue in vocal cord. Rinke space is subepithelial loose connective tissue in the vocal cord, beta. Subepithelial loose connective tissue in the vocal cord. Subepithelial loose connective tissue in the vocal cord, beta. Okay, subepithelial loose connective tissue in the vocal cord. Now, all of you draw a diagram, beta. Mucosa. This is what a vocal, VC means vocal cord, na? Mucosa. Mucosa of the vocal cord. And below that, please draw the loose tissue, beta. This loose tissue is called the Rinke space. Draw an arrow, Rinke space. Below the mucosa of the vocal cord, below the epithelium of vocal cord, there is a subepithelial loose connective tissue, and that subepithelial loose connective tissue is called Rinke space, beta. Rinke space. Rinke space. Okay. Fine. Anybody? What is the mucosa of the vocal cord? Can you tell me, beta? Mucosa. Look at my palm. Yaad hai, beta? Palm se yaad hai? What is the color of vocal cord? What is the color of vocal cord? White. White, beta. And what is the color of the vocal cord? White. Palm color? White. What is the nature of the epithelium of the mucosa of the vocal cord? Is stratified squamous epithelium. Below that stratified squamous epithelium, there is a loose tissue, and that is called Rinke space, beta. Rinke space. Am I clear, beta? Now, edema of the space is called Rinke's edema. Very good. First line is normal anatomy, beta. Edema of the space is called Rinke's edema. Edema of the space is called Rinke's edema, beta. Okay, beta. Edema of the space is called Rinke's edema. Rinke's edema, beta. Edema of the space is called Rinke's edema, beta. Guys, can you see on the screen, beta? Can you see? the vocal cord are swollen. Can you see? There's a swollen vocal cord. Can you see? Vocal cord में fluid भर गया है. Vocal cord में there is a lot of fluid in the vocal cord. Can you see? Vocal cord full of fluid, beta. Full of fluid. This is called Rinck's edema, beta. Can you see? Rinck's edema. The vocal cord full of fluid actually. Now think about it. Is it unilateral, bilateral? Oh, bilateral. It's involving both the vocal cord. Bilateral. Okay. Is it pinpoint or diffuse? Oh, it is diffuse, beta. I know. It's not pinpoint. It's bilateral diffuse swelling of vocal cord. Look at your notes, beta. Look at the notes, beta. It is bilateral diffuse swelling of vocal cord. Bilateral diffuse swelling of vocal cord. Am I clear, beta? Now create a question in your mind. Why will it happen, beta? Cause. Look at your notes, beta. Cause. Smoking is the most common cause. Smoking is the most common cause, beta. Smoking is the most common cause. Okay. Fine. Everybody look at your notes, beta. Smoking is the most common cause, beta. And put an arrow. Therefore, it is also called as AKA mane also called as smoker's polyp of larynx. Smoker's polyp. Some books call it smoker's polyp also because smoking is the most common cause, beta. Smoking is most common cause, beta. Smoking is most common cause. Smoker's polyp of larynx. Smoker's polyp of larynx, beta. Okay. They're also called as smoker's polyp of larynx, beta. Okay, बच्चे, fine. Number 2, vocal abuse. Vocal abuse मतलब फालतू बोलना, फालतू. You know, just unnecessary talking like I am doing. You know, I am doing too much of talking, too loud talking, too much, you know, unnecessary use of voice. You know, vocal abuse, beta. Abuse. You know, to shout at people. People shouting also. Too much shouting and too much excessive speaking. That is abuse, beta. Okay. Now, chief complaint, beta. On the sidebar, write down chief complaint. Chief complaint, logical, beta. Logical, common sense, hoarse voice. I am a doctor. Think like a doctor. You are not a medical student anymore. You are a doctor of future now. We are just few months away from becoming intern or post-intern as well. So start behaving like a doctor in your mind, beta. Vocal cord problem means voice problem. So treatment is hoarse voice, beta. Treatment is surgery. The surgery is called stripping of vocal cord mucosa. The treatment is surgery. The surgery is called stripping of vocal cord mucosa. The surgery, stripping of vocal cord mucosa. The surgery is called stripping of vocal cord mucosa. The surgery is called stripping of vocal cord mucosa. Okay, fine. Okay, fine. The surgery is called stripping of vocal cord mucosa. Stripping. Okay. Now, people who will be having active revision, who are wearing sports shoes and revising tonight, their brain will say, oh, stripping word came earlier also. Right now, if you're sitting in the class and your brain is telling you, oh, stripping word came earlier also, but you are unable to recall where this word came earlier. It means that your brain is perfectly normal brain. Let me again say, if when you heard this word stripping just now, if your brain said that, oh, this word came earlier also, but you are unable to recall where this word came earlier, which topic it came earlier, it means that your brain is perfectly normal brain. At this moment, what you're supposed to do, go back and search. No passive revision, but active revision. Okay, go back and find out where this word came. Well, just go back. And you say, oh, this word came where? Oh, yes, this word came in the topic called keratosis larynx. This word came in the topic of keratosis larynx. Keratosis. This word came in the topic of keratosis larynx. This word came, just look at your note. This word came in the topic of keratosis larynx. Keratosis larynx. Okay, can you see that? Keratosis larynx. Okay, keratosis larynx. This word came in the topic of keratosis larynx. And if you revise it this way, your brain will say, oh, stripping word surgery is coming at two places. One is in the topic of keratosis larynx, other is in the topic of the Rinck's edema, beta. Rinck's edema. Okay, give me 1 second. Okay, this is called active revision, beta. Active revision matlab don't read passively. Stripping. Search for the other word. Stripping, it came earlier also where? Oh, stripping word came in the topic of earlier topic of keratosis larynx also. And if your brain is fully alert and if you are not sleepy, your brain will tell you, oh, look at your note, beta. Stripping word came into topic keratosis larynx and Rinck's edema, and both of the diseases the cause is smoking, beta. Just look at this one, beta. Even keratosis larynx, the cause is smoking, beta. Smoker. Look at Rinck's edema, beta. Rinck's edema. You will say Rinck's edema, the most common cause is smoking, beta. Smoking. Okay? Now, how to really correlate this? Active revision. Let us develop a sports shoe culture, beta, in FMG. Sports shoe culture means, you know, active revision, not passive. वरना revision के बाद भी याद कुछ नहीं आता, बेटा. है ना? देखा ना? Revision कर लिया, लेकिन फिर भी याद नहीं आ रहा क्यों? Let us get engaged into active revision बेटा. Let us try to correlate one part of notes with other part of notes. Let us try to correlate surgery with pathology, medicine with pharmacology, or maybe any like physiology with medicine, or maybe anatomy with orthopedics. This is what has to be done better. Believe me, this will create major bridges in your memory areas, interlocking of the memory, and this will make the recall easier in the exam also. Okay, chalo. This is what page number beta? This is page number is 60 na. So when I go over there, I will write over here beta. अगर मैं student होता तो मैं ये करता, मैं लिखता page number 60, means this word came at 60 number page also. Let us develop this culture beta. Why the workbooks have been introduced beta? So that you give more time to understanding and revising rather than just writing. Okay, fine. Chalo. चलेंगे बेटा, fine. Let us revise this topic. What is Rinke space? Rinke space is subepithelial loose connective tissue layer in the vocal cord. Edema of this space is called Rinke's edema. Can you see Rinke edema beta? Edema of this space is called Rinke's edema. Look at it, is bilateral, diffuse swelling of vocal cord. Most common cause is smoking. Second common cause is vocal abuse, and the chief complaint is hoarse voice, and treatment is surgery called stripping of vocal cord mucosa. Okay, there must be some smokers in this batch. Every batch has it, who are listening to me, and they will get really scared. You know what, smoking causes this, or smoking causes that, smoking causes cancer and all that. They already know that. After ENT class, they might decide, nahi bhai, chhod dete hain cigarette, hai na? But tonight they will say, nahi yaar, let us leave cigarette smoking. I will say, don't do this to yourself. As of now, you won't be able to really, survive through if you leave everything, beta. I can't expect you to become a saint suddenly. Changes do not happen drastically like that. Ekdam se you can't become a saint from coming, like a normal human. You know what? We are all normal human. I'm not encouraging smoking here. I'm not saying people who are not smoking start smoking, but I'm saying people are dependent on smoking. They should not take this challenge right now of leaving cigarette right at this moment. We will think about it after 4th June. After 4th June. Till that time, if you're dependent on this, don't challenge your physiology too much. Better. Whatever you're doing, do it in a minimal way, whatever can keep you safe and all that. But don't really think of, because I got email like that, okay, Rajiv, I heard your lecture of Larynx and I want to quit smoking, how to do that. I said, hang on, buddy. 4th June, let it pass, and after that we'll talk about it. Don't give too many challenges to the body that body says, no way, I'm not going to really do anything. बहुत ज़्यादा भी करेंगे ना, तो body freak out कर जाएगी. Body will create a revolt within itself. We don't want to. Let us oblige by the physical. But other things like alcohol, weed, or anything you're taking, please leave it. Please abstain from it, because that makes you dull. You know it. But smoking has got a physiological dependence at a cellular level actually. So I don't want to play with the physiology too much. If you want to quit smoking, you're most welcome. After 4th June, connect me with me. I'll let you know how to do it. Okay, I'm not encouraging it. I'm just being practical over here. But I know only one thing. What works? What works actually? I'm not sure about the motivation and all that. What is this? I don't know what is motivation. Honestly, I don't know. I can tell you the real practical thing which works actually. That's the only thing I have to share with you. Okay, apart from ENT. Now the next topic, very popular topic, bhai. Vocal nodule is a super duper topic and is a very favorite topic of the MCI paper, beta. Vocal nodules also called as singer's nodule, beta. Also called as singer's nodules. Also called as singer's nodule, beta. Okay. Also called as screamer nodule or teacher's nodule. Teacher, faltu bolte rehna, vocal abuse, singer's nodule, screamer nodule or teacher's nodules, beta. Okay. Now, can you see two laddus, beta? Two small laddus, beta. Can you see two laddus? One laddu, chota laddu, beta. Small laddu here, small laddu here, beta. Okay. Now, let's see. Cause vocal abuse, beta. Vocal abuse is the cause. Of course, faltu bolna, jada bolna, meri tarah, unnecessary talking or loud talking. It's bilateral disease. There are two laddus, beta. Two laddu na, bilateral disease. What is the site of nodule? Write down, beta. Site of nodule is junction of anterior 1/3 and posterior 2/3 of vocal cord. Junction of anterior 1/3 and posterior 2/3 of vocal cord. Site of nodule is junction of anterior 1/3 and posterior 2/3 of vocal cord. Junction of anterior 1/3 and posterior 2/3 of vocal cord. Okay, beta. Chief complaint, hoarse voice. Hoarse voice. Vocal problem is voice problem. Treatment. Voice rest. Voice rest, beta. No surgery, beta. No surgery. No surgery. Just keep your mouth shut. अपना मुंह बंद रखो, उतना ही बहुत है. Just keep your mouth shut. Don't speak too much. Don't speak too loud. Voice rest. Voice rest. Just keep your mouth shut. No surgery. Or speech therapy. We can give you a training to speak properly. voice rest or speech therapy beta, voice rest or speech therapy, age old question of MCI beta. Please 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 do not write surgery beta. ये गलती मत करना, don't write surgery, vocal nodule, no surgery, just keep your mouth shut. कम बोलो, speak less, that's sufficient. Voice rest or speech therapy beta. Okay, fine. Voice rest or speech therapy. Chalo. Let us revise the topic beta. Everybody, what is the name of the disease? Vocal nodules, also called as, speak up with me, also called as singer's nodule, screamer's nodule or teacher's nodules. Okay, are they, what is the cause of this? Is vocal abuse, singer, screamer, teacher is vocal abuse, unilateral, bilateral? Of course they are bilateral beta, bilateral. What is the site of nodule beta? Look at screen beta. What is the site of nodule? Junction of anterior 1/3 and posterior 2/3 beta. This is the nodule beta. Junction of anterior 1/3 and posterior 2/3. This is the nodule beta. Okay. Now, what is the chief complaint? Vocal cord problem means voice problem, hoarse voice. Treatment, never write surgery. Voice rest or speech therapy is the answer beta. Just keep your mouth shut. Speak slowly. Speak less. That's good. Okay. Let's discuss the next laddu beta. This was big, small laddu. Let's discuss the big laddu beta. Big laddu is vocal polyp. Oh. Vocal polyp beta. Can you see on the screen beta? Vocal polyp. Oh, it's a big laddu. It's a big laddu beta. Big laddu. This is what a polyp. Of course, look is called polyp beta. Vocal polyp. Now, vocal polyp, its cause. Look at your notes beta. Look at your notes. Cause, site, chief complaint are same as a nodule. Cause, site, chief complaint are same as nodule, but it is unilateral beta. It is unilateral. Can you see? It is single-sided beta. It is unilateral. Okay. Cause, site, chief complaint are same as nodule, but it is unilateral beta. Just correct it beta. Cause, site, chief complaint, just same as, yeah, same as vocal nodule beta. Same as vocal nodule, but it is unilateral. Put a circle, but it is unilateral. Just separate these two things beta. Same as vocal nodule, but unilateral beta. Okay. Treatment. Now please understand. Can this big laddu disappear on its own? तुम्हें लगता है? Can this big laddu just disappear with voice rest? No. Small laddus, nodule can go away. This big laddu will have to be removed beta. The treatment is surgery. Look at your note beta. Surgery called MLS beta. Surgery called MLS. The full form is microlaryngeal surgery beta. Surgery called MLS, microlaryngeal surgery. Okay. This is surgery of vocal cord under microscope. Look at your note beta. MLS. Bolo beta, what is MLS? Microlaryngeal surgery. This is surgery of vocal cord under microscope beta. Can you see beta? MLS beta. Microlaryngeal surgery is the surgery of vocal cord under microscope. Can you see? The surgery is being done under microscope beta. Like this beta. Now why MLS beta? Why MLS beta? Why under microscope? Now you tell me. What is length of male vocal cord? Bolo. Are you imagining that we are together in the room or no? You have to write in the break also. Are you able to imagine that we are together in one room? We are discussing the topics together. It's not virtual. It's actually, let's imagine that we are together in one room. Even I am imagining the same thing as you are sitting in front of me. Okay. So can you tell me what is the length of male vocal cord? Speak up. Male vocal cord 18 to 23 millimeter. Female 16 to 17 millimeter. Millimeter. Fingertip. Can you see beta? What is 25 millimeter? This fingertip is 25. This much. This is vocal cord or a fingertip. All of you look at your fingertip. This much is a vocal cord. Imagine you are doing this surgery without microscope. Without microscope. Imagine you are doing this surgery without microscope. Okay. You put the laryngoscope. You see inside. There is a small vocal cord. The small polyp. You hold the polyp with the forceps, and you hold the forceps like the polyp with the forceps, and then you remove it and you pull it out and you say, oh, the whole vocal cord also came out. The vocal cord also came out, beta. Vocal cord also came out. Big problem, big complication. Do you want to do this? No. Better see under microscope, beta. Because when you see the patient vocal cord under microscope, they look like not millimeter, they look like kilometer, beta. Kilometer, big vocal. Let me show you how do they look like, beta. How do they look like? Let me show you. They look like really big. They look like really big. Look at screen, beta. Look at screen, everyone. Let me show you. Can you see, beta? Yeah. Oh, beautiful laddu, beta. Acha laga? Can you see vocal cord, big, beautiful laddu over here. This is polyp. Oh, polyp beta. Okay. Now how we do the surgery? Okay. Now I'm operating under microscope. It looks so big. I'll take a forceps inside. I will hold it, the polyp with the forceps. Okay. Then I'll take a scissor inside. I'll just cut it from here. I will holding it. I'll just cut it over here, and I will just remove it, beta. Okay. I'm going to cut it over here and remove it, beta. Once again, please see. Okay. One second. Now please see on the screen, beta. If it shows this time, you hold it with the forceps like this. Hold it. It's a MLS, micro-laryngeal surgery. Then you take a scissor over here and you just chop the base of the polyp with the scissor and remove it, and that's all about surgery. Can you see such a beautiful surgery, beta? Polyp गायब हो गया, beta. Polyp गायब हो गया, है ना? Polyp गायब हो गया. But if you keep on shouting, the polyp will come back, beta. मैं वापस रख दूँगा polyp वहीं पे. Polyp will come back. Again surgery. Okay, again I'll remove it. But if you keep on shouting, the polyp will come back, beta. फिर वापस आ जाएगा polyp. Okay? So behave, speak less also, beta. Okay? The surgery is called MLS, beta. MLS. Am I clear, beta? Please understand, MLS is a general word. Under MLS, you can do anything. Any surgery of vocal cord is MLS, beta. Like laparoscopy. Laparoscopy, you can do appendectomy, hysterectomy, you can do cholecystectomy or any other surgery also, beta. है ना? Same, MLS is a general word, microlaryngeal surgery. Under MLS, you can do multiple different type of surgeries of vocal cord, beta. Okay? Chal. Let us go further, beta. One MCQ of microscopy, beta. Look at your notes, everyone. Okay? Now, focal length of ENT microscope, beta. Focal length of ENT microscope for, you know, ENT microscope is different from eye microscope, beta. Eye में एक ही part होता है. Eye has only one part. Eye and eye. एक ही तो eye तो है. ENT में 3 parts हैं. Ear, nose, throat. And can you see there are different depth? Ear is less depth, beta. So you need less focal length, 200 millimeter. Nose is little more depth, 300 millimeter. Larynx, throat. Larynx is inside the well. कुएं के अंदर है. Larynx is inside the well. So you look like this. It's too much deep. Well is too much deep, na? So you need more focal length. So ENT 200, ear 200, nose 300, larynx 400. Beta. How to remember it? ENT 2, 3, 4. Ear 2, nose 3, larynx 4. ENT 2, 3, 4. याद रहेगा बेटा? So focal length of the microscope is different for the different part of the ENT. For ear surgery we use 200 millimeter. For nose surgery we use 300 millimeter. And for larynx we use 400 millimeter. Beta. ENT 2, 3, 4. Beta. याद रहेगा बच्चे? 2, 3, 4. Now the next topic, beta. Intubation granuloma. Intubation granuloma, beta. Look at the समझना है. Whenever you read a topic, first understand the name. Intubation granuloma means something related to intubation, maybe a complication of intubation, beta. Yes. What is the cause of it? Look at your note, beta. Cause is faulty intubation. Faulty intubation. For example, after surgery under general anesthesia, beta. General anesthesia. General anesthesia, put an arrow, needs intubation, beta. General anesthesia needs intubation, beta. General anesthesia needs intubation. General anesthesia. You know, general anesthesia cannot be given without intubation, beta. General anesthesia needs intubation, beta. After surgery under general anesthesia, and general anesthesia needs intubation, beta. So there will be some history of anesthesia given or surgery done or some surgery under anesthesia. Some story will be there. But basically, look at me, beta. When you put the endotracheal tube, your tube is passing through the vocal cord. Through the vocal cord, tube is passing like this. The endotracheal tube might cause injury to the vocal cord. On the vocal cord, you see some granuloma formation, and that is called intubation granuloma, beta. Intubation granuloma. This is intubation granuloma, beta. Again, it's bilateral. Both sides. Can you see 2 laddu, beta? Big laddu, beta. One on this side, one on this side. 2 laddu, beta. Actually, intubation tube, when passed through it, it injured the vocal cord, this side, that side, and it is causing granuloma formation, and that is called intubation granuloma. Site, beta. What is site of it? Fill in the blank, beta. Site. Site is junction of anterior 2/3 and posterior 1/3 of vocal cord. Junction of anterior 2/3 and posterior 1/3 of vocal cord, beta. Is your brain telling you something? Junction of anterior 2/3 and posterior 1/3 of vocal cord. Is your brain telling you something, beta? Where was the nodule, beta? Look at your notes, beta. Where was the nodule? Vocal nodule was where? Bolo, beta, bolo. Vocal nodule was where? Junction of anterior 1/3 and posterior 2/3, beta. Junction of anterior 1/3 and posterior 2/3 of vocal cord, beta. Am I clear, beta? Fine, fine. Treatment is MLS, beta. Microlaryngeal surgery. Okay, MLS is a general term. In MLS, you can remove the polyp, you can remove the granuloma, and maybe 100 more surgery of vocal cord, beta. Okay, every surgery of vocal cord is under microscope, and that's called MLS. What is full form of MLS, beta? What is full form of MLS? Microlaryngeal surgery, beta. Microlaryngeal surgery. Am I clear, beta? Can we revise this topic, beta? Intubation granuloma. Okay, beta? Intubation granuloma. Everybody, what is the cause of it? Faulty intubation. For example, after surgery under general anesthesia, because general anesthesia needs intubation. You tell me, beta. Unilateral, bilateral? It's bilateral. What is site of granuloma? Bolo, beta, site of granuloma. Junction of anterior 2/3 and posterior 1/3. To revise, where was the vocal nodule? Vocal nodule was junction of anterior 1/3 and posterior 2/3, beta. Okay? Anybody, what is chief complaint? Same, hoarse voice, beta. If you want to write, just write on the side, beta. Chief complaint is hoarse voice, beta. If you think you still want to write chief complaint, hoarse voice. It's very simple, beta. Vocal cord problem means voice problem, beta. Hoarse voice. Hoarse voice, beta. Okay, fine, very good, horse voice, perfect. Now, treatment is MLS, beta. MLS. Beta. Now, look at me, beta. Look at me. How the question comes. Look at me, beta. How the question comes now. Of intubation granuloma. 43-year-old lady underwent appendectomy under general anesthesia. After 3 days, she is complaining of hoarseness of voice. What is the cause of hoarseness of voice? Now, appendectomy has been done. Look at me, beta. Appendix is here. Larynx is here. Tum kaha, main kaha. It's 1 kilometer away. 1 kilometer away. You cannot damage the vocal cord while operating the appendix, beta. Okay? ऐसे थोड़ी कि तुम ऐसे जाओगे. You won't do like this. ऐसे जाके thorax को फोड़ा, neck को फोड़ा, और फिर larynx को फोड़ा. ऐसे थोड़ी करोगे. Is it a surgery or a butchery? You are doing surgery or butchery, beta. So while appendectomy, you cannot injure your vocal cord, beta. Surgeon cannot damage vocal cord. Of course. The problem is general anesthesia. Look at the question. A 43-year-old lady underwent appendectomy under general anesthesia. So question, the clue, the appendectomy is a surgery, no relation with the vocal cord. But general anesthesia is a real problem because to give general anesthesia, you need intubation tube, and this is a complication of intubation called intubation granuloma. So what is the cause of hoarseness of voice in this patient is intubation granuloma. Appendectomy word is given to just confuse you, beta. Am I clear? Perfect. Now let's go further, beta. Next is juvenile papilloma of larynx, beta. Next is juvenile papilloma of larynx. JPL, beta. JPL. Juvenile papilloma of larynx. Now, each word is important, beta. Juvenile means young children, 4 to 6 years. Juvenile means young children, 4 to 6 years, beta. Okay. P means HPV 6 and 11. HPV 6 and 11. It is caused by human papillomavirus 6 and 11. I hope you know HPV causes warts, genital warts. So mother was suffering from genital warts and the baby got the infection at birth. So the infection is coming from mother at birth. From mother at birth. Okay. It's a disease of young children. It is caused by HPV 6 and 11. Human papillomavirus. How does the baby got it? Baby got it from mother because mother was suffering from genital warts, and you know genital warts are caused by HPV, and the same HPV got transmitted to the baby during birth, beta. And within 4 to 6 years, the disease presented, beta. What is L? Larynx, beta. JPL. Viral warts in the larynx, beta. Viral warts. Can you see over here in the picture? Can you see there are warts, beta, over there? Viral warts. This is vocal cord. This is vocal cord. These are viral warts, beta. You can label it also, beta, if you want to. You can say these are the viral warts, beta. These are viral warts. Okay, these are viral warts. Am I clear? They are the viral warts. Okay. Now, unfortunately, these viral warts can spread to trachea also. If the immunity is not good, they can grow down into trachea also. Okay, fine. Am I clear? Now, look at the next line. Look at the next line. They can spread to trachea also. Can you see that? They can spread to trachea also. Okay. Now, next point. Next point is clinical presentation. Now this is the, I will again and again use the word C/P. How to imagine the clinical question, beta. Clinical presentation C/P. What is C/C, beta? Chief complaint, symptom. Clinical picture, beta, patient total picture for the MCQ, beta. 4 to 6 year child. Okay. With chronic hoarseness of voice. Why chronic, beta? Because the problem started at birth and gradually it presenting at 4 to 6 years of age. So history is dating back to birth, beta. Chronic hoarseness of voice plus minus respiratory difficulty. Oh. Why respiratory difficulty, beta? Look at screen, beta. Why respiratory difficulty? Can you imagine, beta? The papilloma grew too much and they fill the whole larynx, beta. Oh. If papilloma grows so much and they completely fill the larynx, how will you breathe, beta? How will the baby breathe, beta? Plus minus respiratory. Plus minus means symptom may be there, symptom may not be there. Okay. Plus minus respiratory difficulty, beta. Okay. Treatment, my dear friend. Treatment is surgery. Surgery. What is the name of surgery, beta? MLS. Everybody speak about it. What is MLS? Bolo, beta. What is MLS? Are you imagining me with you or not? Beta? At least I have started imagining you with me now. I have started imagining you with me now. I hope you are imagining. Please write in the chat box. Are you imagining me and you together in one room, beta? Let us increase the power of online. You know, let's try to do that, beta, because it's effective medium in a way that we can connect with so many people just sitting all across the country. That's really huge can say way to connect to so many people at one point. But are you able to imagine that we are together in this room? Please share your feeling in the chat box right now. Okay. Now, what is MLS? What is MLS? Microlaryngeal surgery. I told you MLS is a general word, and we can do multiple surgery with that. But we use a laser to burn this, beta. MLS with, write down, MLS with CO2 laser. Which laser, beta? Carbon dioxide laser. Oh, CO2 laser, beta. CO2 laser. Recurrence is very common. Oh, they come back, beta. They come back. Even if you burn them, they come back. One more point about it. On the side, write down. On the sidebar, write down. Sidebar. It's a pre-malignant disease. Please use sidebar, beta. Don't make the notes very, clumsy. Just use that. It's a pre-malignant disease, beta. This can lead to cancer in the child, beta. It's a pre-malignant disease, beta. This juvenile papilloma is pre-malignant disease. People who are thinking now, they will feel, oh, HPV causes cancer cervix also. Human papillomavirus is a carcinogenic virus. Na? HPV, remember, cancer cervix also. This can also lead to laryngeal cancer in the child, beta. It's a pre-malignant disease, beta. Okay, fine, beta, fine. One more thing, beta. Which laser is used for it is CO2 laser. One general question. Put a box like that, beta. Put a box. It's a general question, beta. CO2 laser is the most commonly used laser in laryngeal surgery. CO2 is the most commonly used laser in laryngeal surgery. Its wavelength is 10,600 nanometer, beta. Its wavelength is 10,600 nanometer, beta. 10,600 nanometer, beta. Okay. Keep writing the question in the chat box. Whatever question you have, I'll be happy to reply to them too. Okay. Okay. Let's revise this topic, beta. Juvenile papilloma of larynx, beta. Before that, let me show you how the laser works, beta. Everybody, let me show you how the laser works. Everyone see the screen, beta. Now, please see on the screen. Where are you? This is the laser. This is the vocal cord. This is the vocal cord. This is the all the papilloma, beta, viral warts. Okay. You are seeing under a microscope, and your foot has a laser button, beta. Foot has a laser button, and then you start doing the surgery, beta. Then does surgery. Can you see this is a laser beam over a red beam? And please see, the all are papilloma or the viral warts. Papilloma is the viral warts, beta. Please see, this is a laser shoot button, and there is laser pointer. My foot operates the laser, and can you see this laser is burning all the papilloma, beta? Laser is burning all the papilloma one by one by one by one. So MLS with which laser? Carbon dioxide laser. CO2 laser is the most commonly used laser in laryngeal surgery, and its wavelength is 10,600 nanometer, beta. 10,600 nanometer. 10,600 nanometer. Okay, fine. Now, is it clear to all? Let us revise this topic, beta. Let us revise this topic. What is the name of the disease, beta? Juvenile papilloma of larynx. What is the name of the disease? Juvenile papilloma of larynx. Beta. Everybody, juvenile papilloma of larynx. Everyone, can you revise? Juvenile means what? It's a disease of which age? Young children. What is the age? 4 to 6-year-old child. P mane papilloma. Which virus? HPV. Bolo beta. Which virus? HPV 6 and 11. Human papilloma virus 6 and 11. Beta. HPV 6 and 11. And L mane viral warts in the larynx. Okay, these warts can also spread downward to the trachea also. Okay, now what is the clinical picture of the patient? 4 to 6-year-old child with chronic hoarseness of voice plus minus respiratory difficulty. Why plus minus? Because these papilloma might just fully fill it. How will you breathe properly then? Okay, treatment is MLS with which laser? Carbon dioxide laser, CO2 laser, and the recurrence is very common, and one extra point is it's a pre-malignant disease, beta. And CO2 laser is the most commonly used laser for laryngeal surgery. What is the wavelength, beta? Bolo bache, every bolo beta. And what is the wavelength? 10,600 nanometer, beta. Again, I request you to write in the chat box, are you imagine that we are together in the room or not? That's what my purpose is, okay? That you should really use this online as we are sitting together. Are you? Share this thing, beta. Now, Ananya has asked one question, that how would we differentiate between rhynchedema and keratosis larynx, because both have got the same kind of picture. Guys, smoker, both. Hoarse voice, both. What is the differentiating point is examination. Every patient with hoarseness of voice is subjected to endoscopy in the ENT clinic. Endoscopy, beta. One symptom of headache can have 100 diagnoses on the CT scan or MRI of the brain. Similarly, one symptom of hoarse voice can have 100 diagnoses of vocal cord disorders after endoscopy has been done, beta. So, in this particular patient, you are right, Ananya, that patient is smoker both sides, yes. Both patients got hoarseness of voice. Every smoker with hoarseness of voice will be subjected to endoscopy in the clinic, and that will show you the clear picture. Is it keratosis larynx or is it the rhynchedema? So, basic thing is how to differentiate is examination. So, patient is always, in the file also, history and examination. First, we take the history. Same history can have 10 more diagnoses. Examination will tell you, oh, this is a diagnosis. Am I clear, beta, Ananya? Ananya, is the question answered, beta? Thank you very much, Anupreet, Gayatri, Danya. Thank you very much, Vijay. Aditya, a lot of people are there. Thank you. Okay. Thank you very much. Thank you. Great, great. I'm glad that you're enjoying the session, because that's what I don't want you to fatigue at the end of the day. At the end of the day, I want you to be supercharged to study more, beta. That's what my aim is. When the day ends, you should feel, oh, we can study more now. Not just ENT, 2-hour ENT, then microbiology or physiology or biochemistry. Tomorrow, 12-hour. T for Tuesday, T for 12-hour, beta. write it on the wall, paste a lot of things on it. Is a reminder. When we get distracted, these paper things really remind us what we should be doing better. So it's better. All these hacks work better. All these. My mind is a wild monkey better. My mind jumps from one thing to another to another. I'm a very distractible person. I'm a very ill-organized person. I'm very imperfect in a lot of things actually, but I have to develop my own hacks to keep me as organized as possible. Not totally, but sometimes I have to be organized, you know what. So all these are a reminder for me. I have to make 100 MCQs for the new batch. I have to make some new notes. I have to make new images, etc. I keep reminding, oh no, I have to, for 2 hours, I have to work. You know what? Okay, fine. Ananya, is your question answered? Okay. Chalo. Now, let's see this question better. Everybody see this question. 6-year-old child presented to ENT OPD with the chief complaint of hoarseness of voice for last 6 months. 6-year-old child presented to ENT OPD with chief complaint of hoarseness of voice for last 6 months. Beta. First of all, it is a 6-year-old child. Beta. Hoarseness of voice for last 6 months, chronic hoarseness of voice. Okay. There is no history of vocal abuse. Beta. No history of vocal abuse. What a diagnosis? It cannot be vocal nodule because vocal nodule is due to vocal abuse. Rhynchedema, smoking, or vocal abuse. Smoking is not there, vocal abuse is not there. Vocal polyp, again vocal abuse. The answer is juvenile papilloma of larynx. Better. Why 6-year-old child? Juvenile. This is how the question will be. Better. Are you able to interpret this question? Why it is not vocal nodule? Because there is no hoarseness of voice. And 6-year-old child, there is no smoking over there, so it cannot be rhynchedema. It cannot be vocal polyp because there is no hoarseness of voice, there is no vocal abuse over there. So 6-year-old means juvenile. Juvenile. That's how the question. They are not that difficult. Clinical scenario in surgery, medicine, etc. are not that difficult as they look like. At least 50% of them are doable. Doable because they have got the key pointers over there. Key pointers. They may look like 1 kilometer long, but they are simple. Like I give you an example. A small young child is crying with abdominal pain, and a lot of story written here and there, and gone to the hospital and all that, and passing red currant jelly stools. Oh, red currant jelly stool is intersusception. Oh, yes. Red currant jelly stool is intersusception. Yes. There may be such a big question over there, but I know child, red currant jelly stool, see the intersusception also. Beta. That's the answer. In a long statement based question, always look at the last line. Like in this question, what is the diagnosis asking? Read 4 choices, then go to the main body of the question. In all subjects, but whatever general things I'm talking of, everything is applicable to other subjects better, more in fact, okay. So in any long question, always look at the last line first of all, maybe sometimes ask investigation, drug of choice or diagnosis, then read the 4 choices, you have fair idea what my boundaries are, these 4 choices are your boundaries, you have to think within these 4 boundaries. Now you go to the main body of question, now read, oh, juvenile papilloma already there means that you already know that maybe juvenile papilloma, 6-year-old child, hoarseness of voice, 6 months chronic, no vocal abuse means nodule is gone, rhynchedema gone, no smoking, rhynchedema gone, no polyp gone, juvenile papilloma larynx. Try using these tricks in medicine, surgery also better. No one of you should really go to the exam without doing medicine. That will be a bigger mistake. Better. Please understand, this will be a bigger mistake if you do this, that you leave medicine and go to the exam. Next is difference between pediatric and adult larynx. Open up your notes, beta. Difference between pediatric and adult larynx. Beta. Position C2, C3 in children. Adult it is C3, C6. Beta. Write down. In children it is high. Write down beta high. Larynx high in the children. Adult it is low. Low. As we grow in the age, larynx comes down the neck. A doctor, think like a doctor. What is the learning over here? As you grow in the age, larynx comes down the neck. Beta. Okay, fine. Now, narrowest part is subglottis. This is the MCI question. Beta. Narrowest part is subglottis. Narrowest part is subglottis. Beta. Narrowest part is subglottis. Beta. Narrowest part is subglottis. Narrowest part is subglottis. Beta. Subglottis. Okay. Adult it is glottis. Adult it is glottis. Beta. Adult it is glottis. Am I clear? Beta? Okay. Can we revise? Beta? What is the position of larynx in children? C2, C3. Here. Adult C3 to C6. Okay. Narrowest part is children is this subglottis, adult it is glottis. Beta. This is MCQ. Beta. Narrowest part of pediatric larynx is subglottis. Beta. Let us go to the next page now. Method of laryngeal examination. Method of laryngeal examination. Beta. Okay. What is the method? Number 1 is IL. Beta. What is IL? Indirect laryngoscopy. Indirect laryngoscopy. Indirect laryngoscopy, it is OPD procedure. What is OPD? Outpatient department procedure. It is OPD procedure, matlab outpatient department procedure. OPD matlab outpatient department procedure. Beta. Okay. Now look at the mirror. Beta. Look at the mirror. Indirect laryngoscopy mirror is a straight mirror. Beta. Indirect laryngoscopy mirror is a straight mirror. It's a straight mirror and the mirror surface is warmed before using. mirror surface is warmed before using beta. Before you use this mirror, you must warm the mirror beta. You must warm the mirror. Mirror surface is warmed before using beta. Mirror surface is warmed before using beta. Okay. Mirror surface is warmed before using. Warmed before using beta. Okay. Now. Okay. Mirror surface is warmed before using beta. Now, everybody, look at me beta. Look at me, everyone. In my hand, there is an indirect laryngoscopy mirror beta. In my hand, there is an indirect laryngoscopy mirror beta. Now, it's a straight mirror. It's a straight mirror beta. Can you see over there beta? This is a straight mirror beta. It's a straight mirror. It's a straight mirror. This is a straight mirror beta. Straight mirror. Now, let me make some other background for you. Maybe that would be better. In which you see, yeah, idhar aao. It's a, can you see this? It's a straight mirror beta. Straight mirror. Idhar aao. Now, क्या नाम है तुम्हारा?
Arjun.
Arjun is with us. He keeps the whole thing clean, है ना? So Arjun, he is my patient here. Okay, he's my patient here. Now this is which mirror? Indirect laryngo. Can you see this is straight mirror, beta? It's a straight mirror. Okay, straight mirror. Now, if I don't warm the mirror, if I put the mirror like this, open mouth like this, there will be fogging of the mirror, beta. Fogging. You know fogging? There will be misty fogging over the mirror. I can't see anything. So what I do is I warm the mirror on the flame, and then check it also, beta. ऐसा नहीं कि बहुत गर्म कर देना. Don't put गर्मा गर्म mirror in patient mouth. You will burn the palate बेटा. Palate जल जाएगा उसका, है ना? गर्मा गर्म नहीं डाल देना. ऐसा नहीं बहुत गर्म करके मुंह में डाल दिया mirror उसके, है ना? Don't make it too hot, warm, hot नहीं. Don't make it too hot and put in the mouth of the patient. The palate will burn and the patient will slap you. Not like that. So just check it, just warm it, and then you check it on the back of your hand. Then you hold the patient's tongue like this and just open the mouth, and then you put the mirror in the patient mouth like that. Okay? Can you see beta? This is a straight mirror, beta. Straight mirror. Okay? Let me take it close to the. You see it, beta. This is a straight mirror. Can you see, beta? Can you see it's a straight mirror? Okay. This is a straight mirror, beta. This is a straight. Can you see straight mirror? Okay. Fine. Okay. This is the look of the mirror, beta. This is an indirect laryngoscopy mirror. Is a straight mirror, beta. Okay. Thank you. Thank you. Yeah. Now look at screen, everyone. Look at screen, everyone. Now please see. This is the way we do it, beta. This is the way we do it. Okay. This is the mirror. You know what? You hold the patient like this. Okay. Fine. And then you put the mirror in patient mouth, and then you see the larynx over there, beta. Larynx over there. Can you see beta epiglottis over there? Can you see epiglottis over there, beta? दिख रहा है? Can you see epiglottis over there? सच में होता है बेटा. Epiglottis दिख रहा है बेटा? Can you see epiglottis? It is really there. सच में होता है. मैं कहानी नहीं बना रहा. I'm not making stories over here, बेटा. है ना? सच में होता है epiglottis, है ना? You can see that. But are you seeing the larynx or are you seeing the image of the larynx, beta? Tell me. Are you seeing the larynx or image of the larynx, beta? Image of the larynx. Indirect. You're seeing the image of the larynx, not the larynx, beta. Larynx is inside the well. Well के अंदर है. It's not that you put your head into patient mouth like this and you're looking down and the larynx like that. That is not possible. You can't put your head into patient mouth and look at like this. That's not possible. Hai? So you are actually seeing the image of larynx. If you've seen that movie Padmavat, na? That movie, when he says, I want to see the queen, he doesn't show him the queen actually. He just shows the image of the queen in the mirror only. In the mirror only, and that's indirect. Indirect, na? Indirect laryngoscopy. Okay, fine. That's very good. Indirect laryngoscopy. So this is the mirror. Let's come back to the notes, beta. Let everybody come back to the notes. Indirect laryngoscopy mirror. It is done with the help of the mirror. Okay. The mirror surface is warmed before using. IL does not show. This is MCQ, beta. Anterior commissure of vocal cord. ये याद रखना बेटा. Laryngeal surface, epiglottis or under surface. Ventricle, saccule were already hidden areas. If you remember, you can't see them. They are hidden areas. Okay. Number 5. Under surface of vocal cord. 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 Okay. Number 6. Subglottis. Subglottis, beta. Below the vocal cord. How can you see below the vocal cord? Subglottis. And number 7, apex of piriform sinus. Apex of piriform sinus. P-Y-R-E, piriform sinus. Apex of piriform sinus, beta. Piriform sinus. Apex of piriform sinus, beta. Okay, beta. We'll discuss about piriform sinus later on, but in the pharynx topic, beta, is part of pharynx. Now look at me, why anterior commissure is not visible, beta. Look at me, beta. This is anterior commissure. This is anterior commissure, beta. Now please see on the screen. This is anterior commissure, beta. You know, anterior commissure, it is covered by what? Epiglottis, beta. Epiglottis. It called epiglottis, beta. Okay. Now where is the mirror right now? Mirror is on the roof. Look at the roof. Mirror is on the roof right now. You are larynx, beta. Your larynx. Can you see? The vocal cord anterior part is covered by the epiglottis. I told you epiglottis doesn't cover it fully. It covers the anterior part because epiglottis is the anterior part of the larynx, beta. Okay. So anterior commissure is hidden below the epiglottis. Number 2, epiglottis, beta. Can you see the upper surface of vocal epiglottis? Yes. This will make an image in the mirror. Mirror is on the roof right now. Okay. But can the under surface, this one, under surface can make an image? No, not at all. This will not make an image. Okay. Fine. Now the third is under surface vocal cord. How can you see the under surface vocal cord? Mirror is where? Mirror is on the roof, beta. Okay, fine. And ventricle, saccular, anyway hidden areas, beta. Let us revise the list of these structures not seen on indirect laryngoscopy. All of you read with me. Number 1, anterior commissure of vocal cord cannot be seen. Then other things are under surface of epiglottis, also called as laryngeal surface of epiglottis, beta. Okay. Then you cannot see ventricle, you cannot see saccule. Then you cannot see the under surface vocal cord, subglottic area which is below the vocal cord, and one extra thing from pharynx is apex of piriform sinus. All these things are not visible on indirect laryngoscopy, beta. Indirect laryngoscopy. Okay, fine. Yeah. Okay, guys. Let me take few questions in the meantime. That's from the chat box. Srinivas, yeah, we'll be sharing the Telegram. I'll share the Telegram link also with you of my channel, of my group actually, of the FMG channel, and we'll be discussing whatever question you have, can post over there. I'll share at the end of the class today only. Srinivas, we are very anxious. Srinivas, okay, Karthik, okay, thank you very much, guys. That's good. I'm glad that you're learning it, beta. That's very good. We'll discuss a lot of things, but don't worry. somebody wrote that he's already in the shop to buy the sports shoes. Sham ko evening mein khareed lena, abhi pad lete hain. Very good, very good. Okay, thank you very much, beta. Thank you very much. Let me take any other question which I'm missing. At the end, I'll take all the question also. You can, if I miss, Telegram ID I'll share definitely, beta. We are together, beta. We are together not just for these 3 days. We are together till the time you go on the other side of 150, beta. My purpose is not just ENT. My purpose is you have to go on the side of 150, beta. Please understand. So we are together in this journey till the time you really stand on the other side. ENT tak bahana hai, beta. मुझे तुम्हें पास करवाना है. ENT एक excuse है. ENT is just an excuse for me to come in connection with you. I have to make sure that you stand on the other side of 150, beta, and start your life in a proper way. Okay. Okay, beta. Is any no question as of now? We'll connect on Telegram for sure. Don't worry, beta. Don't worry. Thank you very much. Chalo, I think there is no other question. Yeah, perfect. At the end, I'll just screen and I'll take every question. You can keep putting your question or you can save it for Telegram also. I'll apply there also. Now let's go further, beta. Let's go further. Everybody, let's go further. What is direct laryngoscopy, beta? Direct laryngoscopy is an OT procedure, beta. Direct laryngoscopy is an operation theatre procedure, beta. It's an OT procedure, and I'm sure you would have seen sometime direct laryngoscopy being done because, you know, a lot of people, when they are intubating, they're doing direct laryngoscopy. Let me show you. Don't you think so? This is direct laryngoscopy, beta. This one. Can you see, beta? The doctor is seeing with the laryngoscope directly with his own eyes. What is IL? IL is indirect laryngoscopy, means mirror image. This is direct, beta. Direct, because patient is being intubated or patient is being examined, you put the laryngoscope directly and you see the vocal cord with your own eye. This is direct. Image through mirror is indirect, beta. Are you clear about IL and DL term, beta? IL, DL. What is IL full form? Indirect laryngoscopy. What is it, beta? DL. What is DL? Direct laryngoscopy, beta. Okay, fine. Chalo. Let's go further, beta. Now, stridor, beta. Stridor is noisy breathing, beta. Stridor is noisy breathing. Noisy breathing. Its cause is airway obstruction, beta. Its cause is airway obstruction. What is stridor? Stridor is noisy breathing. Its cause is airway obstruction, beta. Airway obstruction. Guys, what is the principle which will explain this, beta? First of all, you hear the stridor with me, beta. Everybody hear the stridor, beta. All of you hear the stridor sound. Did you hear this sound, beta? This sound is stridor, beta. Stridor. Now this is a clinical concept beta. Guys, stridor is noisy breathing and it causes airway obstruction beta. Now what do you mean by it when I say airway obstruction? That you know what I'm trying to say, that physics says that whenever air passes through a narrow chamber, it produces sound beta. Whenever air passes through a narrow chamber, it produces sound beta. Whenever air passes through a narrow area, it has to generate some sound. Otherwise, your breathing is a quiet process beta. It's a silent process. It's a silent process beta. Silent. Nobody should know that you're breathing beta. Nobody should know that you're breathing. Nobody should know that you're breathing. Your neighbor should not know that you're breathing beta. Breathing is a private affair. Breathing is a private affair. Even you don't know that you're breathing. But forget about others beta. But can you hear your heart sound? No. Can you hear your neighbor's heart sound and sitting in the same room? No. I'm not talking about the songs, but Hindi film songs, Dhadkan, Dil Ki Dhadkan and all that. I'm not talking about those songs. I'm talking about real life actually. Can you hear other person's breathing or beating heart? No. But if you can hear that somebody is breathing, the science says that there is some blockage in the pathway of the passage of the sound. Like if your roommate is snoring, you feel like throwing him out of the window. Don't you think so? What is snoring? Again, there is problem in the passage of the air. There is some blockage in the flow of the air. Here we call it snoring. Snoring. And if the problem is in the bronchioles, lower level, here, we call it wheezing, asthma. You remember wheezing? Again, sound is there, na? Here snoring sound, here wheezing sound, in between stridor sound, stridor sound. Understand? Sound is a sound, different type of sound from different type of areas. Basic purpose is same. Whenever the passage of the air is through a narrow area, that generates sound, and that sound in this part is called stridor. Okay? So again, read your beta. Stridor means noisy breathing, and the stridor is due to blockage in the passage of the air. It causes airway obstruction beta. Okay, there are three types of stridor depending on the level of obstruction beta. Number one, inspiratory stridor. The inspiratory stridor is due to blockage in the pharynx and supraglottis. MCQ supraglottis beta. Supraglottis beta. If there is problem in the supraglottis, it's going to cause inspiratory stridor. Biphasic, glottis, subglottis and cervical trachea. Under subglottis beta. Subglottis causes biphasic stridor. Subglottic blockage causes biphasic stridor. And expiratory is thoracic trachea and bronchi beta. Thoracic trachea and bronchi. Depending on the level of obstruction, we have got three types of stridor beta. Inspiratory stridor, biphasic stridor, expiratory stridor. Higher, look at me beta. Over this area blockage, inspiratory stridor. Over this area blockage, expiratory stridor. Middle blockage, biphasic stridor. Let's revise it once again beta. I know as a doctor that this sound should be known to everyone. This sound is called stridor. Nobody should forget this sound. You are a doctor of future beta. Nobody should forget this sound. This sound is called stridor, and stridor means that there is some blockage in the airway beta. Okay, this is a very common sound in pediatric emergency. You should know as a doctor. Okay, depending on the level of obstruction, there are three types of stridor beta. Okay, one is inspiratory stridor, biphasic stridor, expiratory stridor. If the problem is in the upper part, pharynx and supraglottis, inspiratory stridor. If the problem is in the middle part, glottis, subglottis and cervical trachea up to this level, is biphasic stridor. But if the problem is the thoracic trachea or the bronchi, it's expiratory stridor beta. Okay, two questions never forget. Never forget, supraglottic problem causes inspiratory stridor. ये कोई नहीं भूलेगा बेटा. Nobody will forget this one. Supraglottic problem causes inspiratory stridor and subglottic problem causes biphasic stridor. Okay, chale? Chalo. This is stridor beta. Now everyone, let's go further. Let's do the function of larynx beta. Function of larynx. Primary function of larynx is not speaking. When we say larynx, oh, it's speaking. No. Primary function of larynx is protection of lower airway, means lungs beta. Everybody, primary function of larynx is protection of lower airway or lungs beta. What do you mean by this beta? Lower airway or lungs. Protection of lower airway or lungs beta. Idhar dekho. This is your lung. This is the entry gate of lungs. Larynx is the entry door of or entry gate of the lungs beta. If vocal cord will not open, even air cannot go inside. If vocal cord will not open, even air cannot go inside beta. Can you understand that beta? If vocal cord will not open, even air cannot go inside beta. Forget about other things. Okay? If vocal cord will open, only then air can go inside the lungs beta. So larynx decides what will enter the lungs, what will not enter the lungs. So basic function of larynx, primary function of larynx is protection of lower airway or lungs beta. The second function is phonation. Phonation beta. Write down phonation. Phonation is equal to sound production beta. Everybody, phonation is equal to sound production. Okay? Sound production is from true vocal cords in adduction, in expiration beta. Okay, we produce sound from, anybody, tell me, you tell me, we speak from true vocal cord or false vocal cord? We speak from true vocal cord. False cord are rudimentary. Okay, so sound production is from true vocal cord in adduction. Everybody, adduction mean what? Open or closed beta? Adduction mean closed beta. Right, as simple as possible beta. Adduction mean closed vocal. We speak with closed vocal cord in expiration beta. In expiration. in expiration. Okay, 3 point number 1, number 2 and number 3. 3 point to remember how humans produce sound. We produce sound from true vocal cord in adduction, in expiration. Beta. What do you mean by in expiration? Iska kya matlab? In expiration. Now look at screen, everyone. Look at the screen, everyone. Please see beta. Now, when you speak, beta, when you speak, your vocal cord have to close first of all. Close. What is it, beta? Abduction. When you breathe, cords are open. When you speak, cords are closed. Adduction, abduction, adduction, adduction. This is adduction, beta. This is adduction. Okay. When you speak, vocal cord are closed, beta. This is what, beta? True vocal cord, the white vocal cord, the real vocal cord, and they are closed mean adducted vocal cord. Adducted vocal cord, beta. Now please understand what is this expiration, beta. Now look at the vocal cord, beta. Look at the vocal cord. Don't you think so? They are actually like a membrane, beta. Like a tabla has a membrane. You know tabla has a membrane. How tabla produces sound, beta? Usse yaad aa jayega. When your hand play on the tabla membrane, hand is a force, beta. When your hand play on the tabla membrane vibrates in the air. Micro vibration which you cannot see. Whenever any membrane vibrates, produces sound, beta. Whenever any membrane vibrate, it produces sound, beta. Sound. It's a rule. Whenever any membrane vibrate, it produces sound, beta. Tabla membrane. Same here, beta. Same here. Vocal cord membrane. Where is the force? Force is the lungs, beta. Lung has the force, beta. Look at me, beta. Lung has the force. Now vocal cord are closed right now. This is lungs, beta, over here. When the expiratory air is coming out of the lung and vocal cord are closed, this expiratory air hits the vocal cord from below and vocal cord vibrate in the air like this, beta. They vibrate in the air like this. When they vibrate, any membrane when it vibrates produces sound, beta. Any membrane when it vibrates, it produces sound, beta. Am I clear, beta? Fine. Now look at the screen, beta. Let me show you how does it vibrate, beta. So when you breathe, when you speak, they close, beta. Please see, when you breathe, your vocal cord are open. When you speak, they have to close, beta. Now let me show you slow motion, beta. Slow motion. Now everybody see. Can you see your vocal cord, beta? All of you see patient is right now speaking, saying E like that, beta. Please see. And look at how the cord are vibrating. Just see on the screen. E. Can you see? Can you see vocal cord are vibrating in the air? Can you see micro vibration of vocal cord, beta? Please see on the screen, beta, once again. When I say E, how to do? E. Can you see the cord are dancing in the air? Cord are vibrating in the air, beta. Did you notice that, beta? Did you notice one thing? The cord are vibrating in the air. Okay. Now once again see, beta. We speak from true vocal cord in the adducted position in expiratory phase of respiration. The expiratory air is vibrating this vocal cord. Vibration of any membrane will produce sound, beta. As simple as that. Is it clear, beta? Now write down golden rule. You have a space there. Write down golden. Add the golden rule, beta. Everybody write here. You have got the space here. Write the golden rule. Put a box. Write down. Golden rule is we breathe with open vocal cord. We speak with closed vocal cord. We breathe with open vocal cord. We speak with closed vocal cord. We breathe with open vocal cord. We speak with closed vocal cord. Write the box and write down. We breathe with open vocal cord and we speak with closed vocal cord. We breathe with open vocal cord and we speak with closed vocal cord, beta. This is your golden rule to remember, beta. Okay, bache, fine. Am I clear? Okay, fine. Itna samajh aa gaya, beta. We breathe with open vocal cord, we speak with closed vocal cord. Open matlab abduction and closed matlab adduction, beta. Adduction. Done? This much is okay? Okay. Now, this is exactly 1:45 nearly from at my watch. Now, everyone, because next topic will be very interesting topic, muscles of larynx and vocal cord paralysis and all that. I want each one of you to have a lunch break now and relax for some time, and then we are going to have very important session. It's a 45-minute lunch break for everyone. 45-minute lunch break for everyone, beta. Now, and at 2:30 we start again, beta. Hello friends, welcome back after the lunch break, and I hope you could relax for some time. And now let us discuss the next part, and the next part will be about muscles of the larynx. The last thing we did was the golden rule. The golden rule was that we breathe with open vocal cord and we speak with the closed vocal cord. So there are two movements of vocal cord. If you can really see, the vocal cord will have two movements very clearly, and one movement will be abduction and other will be abduction. Now please see, This is adduction. This is adduction, beta. And this is abduction. Can you see, beta? Abduction, adduction, abduction, adduction. For this, you need, of course, muscles, beta. Muscle of larynx. So next topic will be, of course, muscles of the larynx, beta. Next topic, muscles of the larynx. The muscle of larynx. Next topic. Everybody come to the page number 67, and let us start a discussion of muscles of larynx, beta. Now there are three group of muscles: abductor, adductor, and tensor. Abductor open, adductor close, tensor stretch. Okay. Abductor is only one. The only one abductor of the vocal cord is posterior cricoarytenoid, beta. A very, very famous question, star question of the paper is, the only abductor muscle of the vocal cord is the posterior cricoarytenoid is the only abductor of vocal cord, beta. Adductor muscle. If you remember, adductor are four actually. Two you have already done, TA and IA, beta. Remember TA and IA, thyroarytenoid and interarytenoid. This discussion came already in the vocal cord muscles. TA and IA are adductor muscle. What is TA? Thyroarytenoid. What is IA? Interarytenoid muscle, beta. Okay. If you remember this one, I'm sure you would see your notes when you revise. We are not doing passive revision anymore. We're going to do the active revision, beta. I hope you remember this diagram, beta. The thyroarytenoid is within the vocal cord and interarytenoid is in the between the two arytenoid. And in your note, it is written that both TA and IA are adductor muscle, beta. Adductor. So look at your notes now. The two adductor muscles are TA and IA. What is TA? Thyroarytenoid. What is IA? Interarytenoid muscle. Interarytenoid. Am I clear, beta? Now, the third adductor is lateral cricoarytenoid. Lateral cricoarytenoid is the third adductor, beta. Okay, and fourth one is cricothyroid, beta. Cricothyroid. Once again, speak with me, beta. Which is the only abductor of vocal cord? Posterior cricoarytenoid is the only abductor of the vocal cord. And what are the four adductors? TA. What is TA? Thyroarytenoid. What is IA? Interarytenoid. What is the third one? Lateral cricoarytenoid. And number 4, cricothyroid, beta. Now there are two tensors, beta. One abductor, 4 adductor, and 2 tensor, beta. 2 tensors. Tensor are 2. You know, cricothyroid is the main tensor is another question, beta. Cricothyroid is the main tensor of vocal cord. Look at the screen, beta. Tensor are 2. Cricothyroid is the main tensor, and number 2, vocalis muscle, beta. Vocalis muscle. So there are 2 tensor, but out of the 2, the main one is cricothyroid, beta. Now what is the role of tensor muscle, everybody? Tensor give us quality of voice, beta. Tensor give us quality of voice. Tensors give us quality of voice, beta. Tensor give us quality of voice, beta. Everybody, tensor give us quality of voice. Okay. Okay. Now what is quality of voice, beta? Now please understand this. Abductor is clear, beta. Abductor is what? Open. Adductor is closed, beta. Clear? Now what is this tensor muscle thing, beta? Now please understand, tensor means the stretch the vocal cord, and tensor give us what? Quality of voice, beta. Now everybody understand what is the quality of voice, beta. Now please understand here, when I say quality of voice, beta, some people have got good quality of voice, somebody got bad quality of voice, average quality of voice. What do you mean by quality of voice, beta? Quality of voice means you should change the frequency intermittently. You should not speak with the same frequency, beta. You should not speak with the same frequency, you know? You should not really have a static frequency like that. Now, please understand, when somebody speaks in a single tone, beta, then that in English we call it monotonous voice. That person is very monotonous voice. Monotone means single frequency, beta. Monotone means single frequency. Monotonous voice. That voice is a boring voice. And the classical example of this will be our previous Prime Minister, very learned economist, Sardar Manmohan Singh ji. Manmohan Singh, very learned fellow, but when he speaks, when he gives a speech, you must have noticed he has got a single pitch actually, single frequency sound, beta. He doesn't make it up and down. He speaks in a single way, and that makes a speech very boring, beta. I have attended few, convocation in AIMS, Delhi, where he used to be there, and when he speaks, the speech is very, boring in a way that you don't feel like sitting in the hall, but you can't leave the hall and go out, na? The country's PM is speaking, how can you leave the hall and go out, na? But that interest is not there, because you know what, the real live humans, beta, the live humans do not speak that way. You know what, we normal humans have got, a lot of moods, like sometimes anger, sometimes gussa, gila, shikwa, pyar, mohabbat. We want to show anger, we want to show love, we want to show frustration. How do we show that? From our face, from our hands movement, and from voice also. Sometimes the way you change the thing, say the thing, changes the whole meaning of the thing, beta. Sometimes the way you say the thing will change the meaning of the thing also, beta. Like, if I ask you, "Tum kal aayi nahi, main wait karta raha." "Tum kal aayi nahi, main wait karta raha" is a happy question. But if I say like this, "Tum kal aayi nahi, main wait karta raha," is an angry question. English, if I ask you, "Where were you yesterday? I was waiting for you." "Where were you yesterday? I was waiting for you" is a happy question. But if I say like this, same thing, "Where were you yesterday? I was waiting for you," is an angry question, beta. This is the quality of voice. You can change the pitch of the sound little bit intermittently, and that will change the quality of the voice, beta. So tensors give you quality of voice. When they're tense, pitch is little bit high. When they're little loose, pitch is a little bit low. So this playing of the pitch is the quality of the voice, and tensor give you quality of the voice, beta. Okay, let's once again revise, beta. There is one abductor of vocal cord. Read your note, beta. One abductor is posterior cricoarytenoid is the only abductor of the vocal cord. There are 4 adductors, beta. Number 1, TA. What is TA? Thyroarytenoid. What is IA? Interarytenoid. Number 3, read your note, beta. Number 3, lateral cricoarytenoid. And number 4, cricothyroid, beta. Okay, there are 2 tensors. The main tensor is cricothyroid, and number 2, vocalis, beta. Vocalis. And tensors give us quality of voice, beta. Am I clear, beta? Tensors give us quality of voice. Okay, very good. Now everybody get back to the table again, beta. Everybody see this table again, beta. See this table. Now can you tell me which one muscle is working for 2 functions, beta? Out of all these muscles, which muscle has got 2 functions, beta? Can you see that, beta? Can you tell me which muscle has got 2 functions, beta? Can you see? Oh, cricothyroid is adductor and tensor also, beta. Cricothyroid has 2 functions. It is adductor and tensor also. Now let's make a story. Cricothyroid gets angry, beta. Why? Because all muscles are having one function. Cricothyroid feels that I am being treated differently. I am being made to do 2 functions, adduction and tension also. So in this anger, in this frustration of doing 2 works, when other muscles are doing only 1 work, in this anger, in this frustration, cricothyroid sits outside the main house in protest. In protest, beta. Okay, just to make a story to remember it. So look at the line, next line. All muscles lie inside larynx except cricothyroid. MCQ. All muscles lie inside larynx except cricothyroid. How will I memorize it, beta? In a story form. In a story form, that cricothyroid is the only muscle which is being made to do 2 functions. And in this anger, in this frustration, because it is the only muscle which is made to do 2 functions, in this protest, it sits outside the main house. And that's why MCQ of anatomy, all muscles lie inside larynx except cricothyroid, beta. Now one more story to memorize the next thing, beta. Cricothyroid says, I am angry with you guys because you are making me do 2 functions, whereas other muscles are doing only 1 function. And in this protest, it sits outside the main house. And there it says that if you want me to do 2 functions, then give me an exclusive nerve supply. I want a separate nerve supply which I will not share with any other muscle. I demand an extra special nerve supply. So look at the next orange box, beta. All muscles of larynx, read up, beta. All muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Once again, beta, all muscles are lying inside the larynx except cricothyroid. So therefore, all muscles are supplied by single nerve called recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Am I clear, beta? Fine. Okay. So will you remember it, beta? Will you remember it? Okay. Why external branch, anybody? Why external branch? Because this muscle is outside the larynx, beta. See, if you try to develop stories now, you will be sure about it. Cricothyroid does 2 functions. In the protest, it sits outside the main house. It sits outside the main house and it says that if I have to do 2 functions, I demand an extra nerve supply, special nerve supply, exclusive nerve supply, which I will not share with any other muscle. That's the next box. All muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Am I clear? Fine. External branch of superior laryngeal nerve. Now, let's go the sensory nerve supply of larynx. The 3 part: supraglottis, glottis, subglottis. Write down the bracket. Above vocal cord, in the bracket write down supraglottis. Internal branch of SLN. SLN, beta. SLN. Not SCN, SLN. Internal branch of SLN. Below vocal cord is subglottis, beta. RLN. And vocal cord, both these nerves, beta. Vocal cord, both these nerves. Okay. Vocal cord is glottis, beta. Glottis. Supraglottis, subglottis, and glottis. I hope you remember there are 3 divisions of larynx: supraglottis, glottis, and subglottis. Supraglottis is by internal branch of SLN. The subglottis is by RLN. Vocal cord is in between the 2, so that's why both these nerves, beta. And for your information, these 2 are branches of which nerve? Vagus nerve, beta. Sorry, vagus nerve, beta. Sorry. Vagus give RLN and SLN, and SLN got 2 branches: internal branch, external branch. This is the complete nerve supply of the larynx, beta. Larynx has only got 2 nerves, RLN and SLN. What is RLN, beta? What is RLN, beta? RLN, recurrent laryngeal nerve. What is SLN? Superior laryngeal nerve. And for your kind of information, there is no 3rd nerve in larynx, beta. Don't even think about the third nerve. There are only two nerves, and RLN, SLN, and they are coming from vagus nerve, beta. SLN got two branches. Internal branch is sensory, external branch supplies the cricothyroid, beta. And if vagus is cut, larynx is dead. Please understand, if vagus is cut, larynx is dead, beta. If vagus is cut, larynx will be dead. Are getting my point? If you by chance vagus is damaged, vagus is cut, then larynx is also damaged, beta. Larynx is neurologically dead. Vagus cut means larynx is dead. Okay? Is it clear to all, beta? Muscles clear, nerves clear. Larynx only a two nerve, RLN, SLN, beta. All muscles are supplied by RLN except cricothyroid, which is supplied by external branch of SLN, beta. Okay. Now the next topic should be vocal cord palsy, beta. Vocal cord palsy. Okay. First of all, vocal cord palsy is almost similar to RLN palsy. Sometimes the question uses the word recurrent laryngeal palsy is same as vocal cord palsy, beta. I know from my understanding that majority, all the muscles of larynx supplied by single nerve, RLN, except only one muscle, beta. So sometimes they use the word overlapping term. RLN palsy is same as vocal cord palsy. RLN is responsible for the major nerve supply of the larynx, beta. First of all, incidence wise, write down incidence. Incidence wise, left is to right is 4:1. Means left cord palsy is 4 times more common than the right side. Incidence wise, left cord palsy is 4 times more common than the right side, beta. Okay. Just look at screen, everyone. Look at screen. This is your mouth. This is your tongue. This is your tooth. Last tooth over there. Okay. Uvula. Okay. Can you see? Just this is the end of the tongue over here. Right there you see what? Epiglottis. Can you see epiglottis? Epiglottis सच में होता है बेटा, कहानी नहीं है. This is really there. Oh, this is epiglottis, and this anterior is anterior. Okay, and then at the back we have got the vocal cord. Vocal cord. Now compare the movement of the left. This is right. Left is the right, beta. Left side is paralyzed, beta. Can you see? Left is not moving at all. Can you see that, beta? Left is not moving at all. Only right is moving, beta. Could you see that, beta? Left is not moving at all, beta. If you see, can you see, beta, over there? Again, see, beta. Right cord is moving normally. Left is not moving, beta. Can you see? Right is moving. This right is moving. Again, see. Once again, see, beta. Let us see the left cord palsy, beta. This is left side. Left side is this side. This is the right side. The right side is moving normally. Can you see? It's moving normally. Oh, yes. But left side is not moving at all, beta. Okay, fine. Left side is not moving at all. Okay, fine. Correct. Okay. Now, let us discuss for the topic further, beta. What I'm saying is the left side cord palsy is 4 times more common than the right side. Now, why it is so? This is because of longer course of left RLN. This is because of longer course of left RLN, beta. Recurrent laryngeal nerve, left side has got a longer course. This is because of the longer course of left RLN. Now, please see anatomy, beta. I'm sure you'll do it in anatomy also, but just I'm touching it one time. Please see. Guys, can you tell me, RLN is a branch of which nerve? Everybody, speak up with me. RLN is a branch of which nerve? Vagus nerve, beta. All of you touch your vagus nerve. Everybody touch your vagus nerve. This is your vagus nerve, beta. This is your vagus nerve here, okay? And from vagus, which nerve comes? The RLN, beta. Now, please see. This is your larynx. This is your vagus nerve. First, right side, beta. Now, RLN is a stupid nerve, beta. Bevkoof nerve, RLN. Why? It takes origin from vagus nerve, RLN. It should have gone to the larynx like this. It doesn't go like this. It goes down first, down, 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 right side. It enters the thorax. Suddenly it recalls, oh, I have to go back. I have to go back. Okay? There's an artery here called subclavian artery, beta. Subclavian artery. It takes a turn around subclavian artery and then comes up in the neck, and then there is a gland here. Which gland here? Thyroid gland, beta. It touches the thyroid gland and then it enters the larynx, beta. Can you see, beta, over here? Can you see? Can you see? The right side is taking a turn around the subclavian artery and coming up and touching which gland? Thyroid gland, and then going to the larynx, beta. Okay? Now, please see on the screen, beta. Please see on the screen. If right is stupid, left is maha stupid. If right, अगर right बेवकूफ है, left maha बेवकूफ है. कैसे? Right is taking turn from here, left side. It goes down, 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 down. It enters thorax. Still, it has no problem. It goes down to thorax. It travels half thorax down. It comes over here. Suddenly it realizes, oh, I'm at the wrong place. ये तो गलती हो गई. I'm wrong place. It takes a turn around arch of aorta, and then it comes up, 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 and then again enters the neck and touches which gland? Thyroid gland, and then it supplies the larynx, beta. Because it recurs its course, it's called recurrent. Both sides, right, left, both sides, they recur their course. That's why recurrent word is there, because they make a loop and come back. But left side makes a loop little lower down around arch of aorta. Over here. Guys, you will agree with me. Longer the course, more the relations, beta. More the relation, and just like life, beta. More relations means more complications. Would you not agree with me, beta? More relation means more complications also. What is not over here, beta? There are so many things in the thorax, mediastinum. Bronchus is there, yes. Lung is there? Yes. Esophagus is there? Yes. Heart is there? Yes. Then lymph nodes of the mediastinum are there? Yes. Anything goes wrong with any of these structure is going to press the left recurrent laryngeal nerve also, and that is going to cause the left chord palsy also. This is why left chord palsy is 4 times more common than the right side, beta. Now read your notes, beta. This is because of the longer course of left RLN. Beta. This is an anatomy topic we'll discuss. I'll just touch that just to make a background over there. Okay. Now everybody, please see. Can you see this picture, beta? This will be very helpful for your general surgery, beta. Okay. See over there. See over here, beta. This is RLN, beta. Okay. Clear? Now, RLN. Recurrent laryngeal nerve is lying close to lower pole of thyroid gland. SLN is lying close to upper pole of thyroid gland. Superior laryngeal nerve is lying close to upper pole and RLN lying close to lower pole. Okay. So, in my thyroid surgery, I should remember, I should be very careful as a surgeon, because at the lower pole, when I am operating, I might damage the RLN nerve. At the upper pole, I might damage the SLN nerve. Superior laryngeal nerve will be upper pole only, na beta. You can write down upper pole, lower pole, beta. This is upper pole. This is which pole? Lower pole, beta. So now I know from today that thyroid surgery can damage 2 nerves. At the upper pole, surgeon may damage the SLN. At the lower pole, the surgeon may damage the RLN nerve, beta. Okay, beta. Clear? Okay. The surgery is called thyroidectomy. Thyroidectomy. Okay. Chalo. Ye clear? Okay, beta. This is important. Okay. Now everyone, please come over here. Most common cause of unilateral vocal cord palsy or vocal cord palsy is idiopathic or carcinoma bronchus, means malignancy. Idiopathic is the best answer. This is symbol means second best answer. If idiopathic is not in the choice, then you mark carcinoma bronchus or malignancy. But write down, this is number 1, beta. Number 2 is bilateral vocal cord palsy, beta. Bilateral, you tell me, beta, which surgery has the chance of damaging both side RLN, beta? Look at screen, beta. You are doing total thyroidectomy. Don't you think so? In that, this can be injured, beta. But you are doing total thyroidectomy. So, most common cause of bilateral RLN palsy or bilateral cord palsy will be, of course, thyroid surgery. Because thyroid is one gland which is coming in contact with both RLN. So, if the surgeon is operating total thyroidectomy, the surgeon may damage the both RLN, beta. Am I clear, beta? Fine. Chal. Okay, bache? Fine. Now, third question, beta. Ortner syndrome, O-R-T-N-E-R. Ortner syndrome, O-R-T-N-E-R, Ortner syndrome is left atriomegaly causing left vocal cord palsy, beta. Left atriomegaly causing left vocal cord palsy, beta. Left atriomegaly causing left vocal cord palsy. I told you, beta, the heart is very close to the left RLN. Okay, if heart problem causing vocal cord problem, it's called Ortner syndrome, beta. Ortner syndrome also called as cardio-vocal syndrome, beta. Cardio-vocal syndrome. Ortner syndrome also called as cardio-vocal syndrome, beta. Ortner syndrome also called as cardio-vocal syndrome, beta. Cardio-vocal syndrome. Ortner syndrome also called as cardio-vocal syndrome, beta. Ortner syndrome also called as cardio-vocal syndrome. Okay, bache. Heart problem causing vocal cord problem is Ortner syndrome or cardio-vocal syndrome, because I know now left RLN goes very close to arch of aorta. Arch of aorta is close to the left atrium also. So, left atriomegaly causing left cord palsy is called Ortner syndrome, beta. Okay, bache. Fine. Now, next one, beta. Next topic. Let us discuss on the side right down here. On the side right down, there are 2 types of bilateral vocal cord palsies. 2 types of bilateral vocal cord palsies, beta. A bilateral abductor, B bilateral adductor, beta. A and B. A is bilateral abductor, B is bilateral adductor. Let us discuss about bilateral abductor palsy. Everybody get focused now. Abductor palsy, abduction palsy, abductor palsy. Everybody, let's simplify it, beta. Abductor means abduction. Palsy means absent. Abduction absent, beta. Everybody, simple meaning is bilateral abduction absent, beta. Bilateral abduction absent. Now you tell me, beta. You tell me, everybody. Everybody get attentive. Abduction is absent. Abduction is absent. The cord are in which position? Closed position or open position? Everybody you have to think about it. If abduction is absent, then cord are in which position? Open position or closed position? closed position. Abduction absent मतलब लिखो vocal cord in permanently closed position. Vocal cord in permanently closed position beta. Let us simplify it first of all. Let's not get scared of this topic. Abductor palsy. Abductor palsy माने abduction absent. Abduction absent माने vocal cord are in permanently closed position beta. Am I clear beta? What is the look of this first of all? Let us see that beta. What is the look of this palsy beta? Everybody look at screen beta. After the paralysis, this is the look beta. Both vocal cord are in closed position permanently. This is the final position of vocal cord and they cannot move beyond it this way or that way. Now when does it happen? Look at your notes beta. Look at your notes beta. Everybody look at your notes once and now understand with me beta. Everybody understand with me. Everybody. Now think about a practical problem beta. Everybody think about a practical problem. Bilateral RLN injury in thyroid surgery beta. Bilateral RLN injury in thyroid surgery. Everybody look at me. Now leave your notes beta. Leave your note. Focus on me to understand the clinical question. Imagine you and me are doing thyroid surgery together. The name of surgery is total thyroidectomy. Okay, you cut the right RLN, I cut the left RLN. The score is equal. 1-1 से match बराबर चल रहा है. You cut the right RLN, I cut the left RLN. Both RLN got injured, damaged. Now you tell me, everybody, you tell me, if both recurrent are damaged, which one muscle is still working? Try to think about it. If both RLN got damaged, which one muscle is still working? Yes, cricothyroid. Why? Because all muscles of larynx are supplied by RLN except cricothyroid, which is supplied by external branch of SLN beta. Okay. Now everybody think with me. What is the role of cricothyroid? Cricothyroid is adductor. Cricothyroid is adductor beta. Now very scary situation. Very scary situation beta. Only one muscle is left, cricothyroid. And unfortunately, that's an adductor muscle beta. Adductor muscle. What will happen is, it will bring both the vocal cord in the midline position beta. Final position will be the midline position. Why? Only one muscle left is cricothyroid and that is also adductor beta. Oh, adductor. So both cord will come in the midline. After that, they cannot move beta. Okay. This is called median or paramedian position or closed position. Now you tell me, if this is the final position of the vocal cord, can you breathe like this? This is a final position of vocal, permanently closed position. You tell me, what is the golden rule? We breathe with open vocal cord, we speak with closed vocal cord. Thyroid surgery got over, patient is still in the operation theatre, anesthesia over, patient coming out of anesthesia. This is the final position of vocal cord. You tell me, can you breathe like this? Can you breathe like this? Yes or no? No. Saans aayega? No. Can you breathe like this? No. But can you speak like this? Yes. Yes. Why? The golden rule is, we speak with closed vocal cord, we breathe with open vocal cord, but these are permanently closed vocal cord. So you cannot breathe, but you can speak. So patient before dying, because patient is having difficulty breathing, patient before dying will tell your name and my name also that these two guys have killed me. You remember? ऊपर जाने से पहले तुम्हारा और मेरा नाम बता के जाएगा. Don't worry, we'll not let the patient die. We'll save the patient because we will be doing immediate tracheostomy. Immediately on the operation theatre table, thyroidectomy done, patient got this problem. Immediately, what is airway surgery? Tracheostomy. We open up the trachea, we put a tube, we save the patient. Now let's go back to your notes, everybody. If you understood this, then notes will be a cakewalk for you. Everybody look at screen. What is the cause of this? Bilateral RLN injury in thyroid surgery. What is the cause of it? Bilateral RLN injury in thyroid surgery. Bilateral RLN injury in thyroid surgery. Okay. Now which muscle is still working? Only cricothyroid left. Only cricothyroid left, which is adductor. Oh yes. Only one muscle is left and that is adductor. Only cricothyroid is left and that is adductor. Adductor. Okay. Now vocal cord come in which position? Median or paramedian position or closed position beta. Vocal cord come in which position? Median or paramedian position or closed position beta. Closed position. Am I clear beta? Okay, closed position. Because only one muscle left is adductor, therefore put an arrow beta. Put an arrow ऐसे डालो. Therefore vocal cord come in median or paramedian position or closed position. Now, so put an arrow. Patient can't breathe properly but can speak normally. Oh, the golden rule says that we breathe with open vocal cord, we speak with closed vocal cord, but they are permanently closed vocal cord beta. So patient can't breathe with closed vocal cord but can speak normally with closed vocal cord. So symptom is what? Symptom is respiratory difficulty with normal voice beta. Respiratory difficulty with normal voice beta. Am I clear? Respiratory difficulty with normal voice. Okay. This is a star question beta. If both R, L, N get injured, what will be the post-operative symptom of the patient after thyroid surgery? Respiratory difficulty with normal voice beta. Immediate treatment is tracheostomy. Tracheostomy beta. Tracheostomy. Okay. Fine. After that, definite treatment is definitive treatment. Definitive treatment is treatment of the problem. Tracheostomy is a life-saving procedure beta. Definitive treatment is type 2 thyroplasty. Type 2 thoroplasty beta. Type 2 thoroplasty. Type 2 thoroplasty, definite treatment. Definite treatment is done when? After 6 months beta. We wait for 6 months for the any chance of recovery. So we, in any vocal cord problem, we must wait for 6 months for any chance of recovery, because some nerve injuries can recover also beta. What is the name of surgery? Type 2 thoroplasty. Right, beta? Surgical treatment. This is surgery beta. SX. Surgery beta. What is the name of surgery? Type 2 thoroplasty. Now what is type 2 thoroplasty? Is equal to lateralization of vocal cord. Matlab, we bring one vocal cord outside. Lateralization means both cord have gone inside. Let us pass a suture around vocal cord and look at my hand and pull it outward beta. Bring it laterally. This is called lateralization of vocal cord. Lateralization of vocal cord beta. Okay, lateralization of vocal cord. If you see, this is the picture of the type 2 thoroplasty beta. This is beta. Can you see beta over here? This is lateralization beta. This is lateralization beta. Lateralization. Can you see beta over here? Both cord were in midline. I passed a suture around vocal cord and pulled it outward beta. Can you see this vocal cord? I passed a suture and I pulled it outward. This is called the lateralization of vocal cord. You know what will happen? The air will start going into the lungs beta. At least you open it up. Okay, bacha, air will start going. If you are thinking, sir, voice will go bad, Raji, voice will go bad. Yes, voice will go bad. It's okay, no problem. That's acceptable side effect of this surgery beta. You know, you want to be alive or you want to speak and die. If I give you two options, you want to be alive and speak little less normally, or you want to speak full normally and die. Of course, you say, you know, let me breathe, I can speak little less normally. So the voice will go bad after surgery, but it's okay. Okay. Other treatment. Look at your note. Other treatment is CO2 laser cordectomy. Other treatment is CO2 laser cordectomy. CO2 laser cordectomy. Some people say remove one vocal cord only. They say let us remove one vocal cord only so that some space for the air is there to breathe. CO2 laser cordectomy. But that's other treatment. Let's revise this topic beta. Important topic. Bilateral abductor palsy beta. Everybody keep this picture in mind beta. Bilateral abductor palsy. Abductor palsy. Bilateral abductor palsy. This is bilateral abductor palsy. Okay. Now, everybody start from the beginning. Abductor palsy matlab abduction absent. If abduction is absent, vocal cord are in permanently closed position like this. When will this happen in the real clinical world? When we are doing total thyroidectomy and both RLN got damaged. Now which muscle is still working? If both RLN got damaged, read your note, only cricothyroid muscle is working. And that is an adductor muscle. Both vocal cord will come in the median or paramedian position, which is called closed position permanently and are paralyzed after that. I know you breathe with open vocal cord, you speak with closed vocal cord. These are permanently closed vocal cord. Therefore, the symptom is very clear. MCQ beta. The chief complaint of this palsy will be respiratory difficulty but normal voice. Okay. Immediate treatment will be tracheostomy. Tracheostomy. After 6 months, you do definitive treatment, and that is called type 2 thoroplasty or lateralization of vocal cord. Lateralization, you pass a suture on vocal cord and pull it outward so that the air space can be there to let the air go into the lungs beta. Am I clear? Other treatment is CO2 laser cordectomy. Okay. Let's do the reverse of this beta. The second one, B. Bilateral adductor palsy beta. If you understood this one, the second one will be easy beta. This is the reverse of this beta. Bilateral adductor palsy beta. B. That was A. Bilateral cord palsy of two type, abductor palsy beta. Now this one is B. Bilateral adductor palsy cause. First of all, let's simplify it beta. Adductor means adduction. Adduction. Palsy means absent. Adduction absent. Adduction absent. Everybody, this is exactly opposite of the first one. Therefore, vocal cord are permanently open. Vocal cord are permanently open. Open. Vocal cord are permanently open. Permanently open. My dear friends, is the reverse of the first one. In that, vocal cord permanently closed. Look at my hand. Adduction absent. Adduction absent. Adduction absent means cord will be permanently open. Permanent cord are permanently open. Let us make it scientifically simple. Scientifically simple. Vocal cord in permanently open position. Okay. Can you see? I think you will agree. This is what the position of the vocal cord. Permanently open position. Bilateral adductor palsy. ध्यान से समझ के सोच के attempt करना. Adduction absent means adduction absent means the vocal cord are permanently in open position. Now when does this happen? Now leave your notes beta. इधर देखो. Leave your notes beta. Now when does this happen beta? When bilateral vagal palsy is there. I told you when vagus is dead, larynx is dead beta. When both vagal got damaged, no muscle is working. At that moment, what happens is vocal cord come in cadaveric position. Cadaver means death position. That's called intermediate position, and this is open position. Cadaveric position is open position. When we'll die one day, beta. We'll die one day, for sure. Everybody has to die one day. At that moment, the cord will be open. Cord will be open, beta. When somebody dies, the cord becomes open. Here, vagus gone this side, vagus gone this side. Vagus dead means larynx dead, beta. So cord come in cadaveric position, also called as intermediate position, also called as open position. Now you tell me, can you breathe like this? You tell me, beta. Can you breathe like this? Tell me, yes or no? सांस आएगा? Yes. Can you breathe like this? Yes. सांस आएगा? भर भर के आएगा? सांस खूब आएगा? Breathing is not a problem, but there is one other problem. क्या? Can you speak like this? No. Can you speak like this? No. We speak with which cord? We speak with closed vocal cord, and they are what? Permanently open vocal cord. Permanently open vocal cord. How can you speak like this? So you can't speak like this, but can you breathe like this? Yes. So breathing is not a problem. Speaking is a problem. You know what? Air will leak, beta. Air will leak now. Okay. So voice will not be like this. और क्या हाल है? कहाँ जा रहे हो? The voice will be like this, beta. और क्या हाल है? कहाँ जा रहे हो? You did not come yesterday. What is happening right now is air leak, beta. When we speak, air should not leak. But in this case, when you try to speak, air will leak and the voice will be gone like. So chief complaint will be aphonia. Don't write. Written. We'll, later on we discuss the notes. First understand. Aphonia. But another problem. What? Aspiration. I hope you remember. Primary function of larynx is protection of lungs, beta. Now the gate is permanently open. कोई भी आए, कोई भी जाए, कोई फर्क नहीं पड़ता. No problem. Anybody can come in, anybody can go out anytime. No problem. Aspiration is a big problem now again. You know why? You know what is happening? You know you are eating dosa. You are eating dosa, beta. है ना? You are eating dosa and the sambar is here, beta. This is your food channel. Huh? Sambar is here, beta. This is sambar. This is a food channel here. Okay? Fine. When you eat dosa, the sambar is passing very close to the area here and here, beta. Don't you think so? The sambar will outflow into the lungs, beta. Sambar will outflow. When you are eating dosa, this sambar is passing from here and sambar will go into the lungs also and you will get sambar pneumonia. Sambar pneumonia. Not sambar pneumonia, but pneumonia. You can understand, beta. When you eat, you will aspirate, beta. Hai na? Some food particle will go into your lungs, some saliva will go to your lungs and you will get pneumonia also, beta. Okay? Now read your notes, beta. Now read your notes. I hope all of you are feeling, active. I hope that sleep, 30 minutes of sleep is over now, everybody. After lunch, everybody feels sleepy. I know that. But I hope everybody please get up and, jump on, feet for some time. You can see, can you see I'm standing? I'm standing actually, So you can also stand in between, you can just take your gadget and just roam around in the room if you're sleepy. If you're feeling sleepy at this moment, leave the chair now. Leave the chair now, get up and just roam around with the gadget in your hand, beta. Okay? Now read with me, beta. What is the cause of this? The cause of this is bilateral vagal palsy, beta. Bilateral vagus palsy means RLN plus SLN is equal to complete palsy. Complete palsy, beta. Complete palsy. It's a complete palsy, beta. Nothing is left. Okay? Complete palsy. Okay? Okay. Put an arrow here. Put an arrow. No muscle working. Unfortunately, no muscle working, beta. No muscle working, beta. When it's a complete palsy, vagus palsy is RLN plus SLN palsy. No muscle working. Okay? Dead. Death. Dead. Vocal cord lie in cadaveric position, open position. Everybody draw a diagram like this, open position, like this. Vocal cord lie in cadaveric position or open position, also called as intermediate position. Okay, compare it on the other side. That was median or paramedian position or closed position. This is open position, also called as cadaveric position or intermediate position. Now, what is the chief complaint? Very good. Aphonia and aspiration. Aphonia means loss of voice and aspiration will cause sambar pneumonia or pneumonia, not sambar pneumonia. Okay. Now, treatment is surgery. What is the name of surgery, beta? Type 1 thyroplasty. People who are feeling sleepy, please stand, leave the chair, leave the bed, stand and walk in the room, beta. Walk in the room. Feeling sleepy after lunch is a common physiological phenomenon. But you have to really, control your physiology. Do some extra things to really change the whole brain waves right now. Okay? At night also same thing. When you feel sleepy, when the first thought comes, leave the bed immediately, beta. Go and make a cup of tea or coffee. When the first thought of sleep comes at night, when you have not finished your target, it's not a time for you to sleep as per your own schedule. Leave the bed, leave the chair, go and make the tea or coffee for you. Or if you are staying in a hostel, can't make it, just maybe warm a cup of water in the kettle and pour something and take a green tea or something like that. Change the brain waves at that point in time. It's a 5 minutes critical zone, beta. If you are living that moment again and again, I want to sleep, I have to sleep, I'm tired, tomorrow I have class, I should sleep, tomorrow I'll become a better person, tomorrow I'll do extra work and all that, but today I should sleep. This is going on and on and on. If you give 5 minutes to your brain to let it continue this thought process. After 5 minutes, you are in the bed with the sheet on your face and you're sleeping. But if you leave the bed immediately with the first thought, leave it, wear the sports shoes, and go in the kitchen or warm the kettle water, take it, put a green tea into that, drink that, just roam around for a while, hear some song and come back. You never know, you can get 90 minutes of extra study, beta. You never know. Before sleeping, you read 90 minutes extra, beta. Okay, fine. Type 1 tharoplasty is medialization of vocal cord. Very good. Medialization, beta. What is type 2? Lateralization. Look at my hand, beta. Type 2 was to pull it outward. Type 1 will be push it inward, beta. Because both cords are open. Both cords are open. So I push one vocal cord towards the midline, beta. Please, can you see beta over there? I must do one. I have to push this vocal cord towards the midline, beta. Like this. I have to push it from here to push it towards the midline, beta. Okay, fine. Other treatment is, look at your notes, beta. Other treatment is Teflon injection in vocal cord. Teflon or fat or collagen injection in vocal cord. Teflon or fat or collagen injection in the vocal cord. Teflon or fat or collagen injection in the vocal cord. Okay. What this collagen injection will do? Please see on the screen, beta. Again the same thing. When you inject Teflon or fat or collagen, this will cause permanent swelling of the vocal cord. Okay. Can you see? This is the what you're injecting: Teflon, Teflon, fat, collagen. You have got 3 options. You can inject either of these things: Teflon or fat or collagen injection into vocal cord. This will cause permanent swelling of vocal cord. Look at it, beta. Swelling means it will come towards the midline, beta. Swelling means it will come towards the midline. Am I clear, beta? Teflon, fat or collagen injection in the vocal cord. Am I clear? Fine. Okay, great, wonderful. So this is this thing. Now you tell me, beta. You tell me. Will you do this procedure on one side or both sides? On one side or both sides, beta? This Teflon injection or medialization, would you do on one side or both side? Only one side. Never do 2 side, beta. Please see. Permanent swelling of vocal cord. If you inject both side, beta, both vocal cord will come in the midline, beta. Both cord will come in the midline. तो क्या होगा? आवाज तो आएगी, पर वो अंतिम आवाज होगी. If you do it both side, there will be voice, good voice, but that's the last voice. Patient won't be able to survive. So all these cord procedures, whatever you study in cord palsy, are done only on one side, beta. One side. Okay, fine, very good. Very good. Perfect. Let's revise this, beta. What is the name of the palsy? Bilateral adductor palsy. Everybody, let's revise the topic, beta. Bilateral adductor palsy, matlab adduction absent. Adduction absent, beta. Adduction absent, beta. Okay. Matlab vocal cord are in permanently open position. Adduction absent means vocal cord are permanently in open position. What is the cause of this? Bilateral vagal paralysis. Vagus means RLN plus SLN palsy. Look at your note, beta. Or complete palsy means no muscle is working. Vocal cord come in cadaveric position. Cadaver means death position, and this is fortunately open position. And also called intermediate position. Okay. Now, look at me, beta, look at me. Can you breathe like this? Yes, no problem. But can you speak like this? No. Aphonia, number 1. Number 2, aspiration, and that leads to pneumonia. Definitive treatment is type 1 tharoplasty or medialization of vocal cord. Okay. You bring one vocal cord to the midline, beta. Okay. Or the other treatment is Teflon or fat or collagen injection in the vocal cord. Am I clear, beta? Fine. Now, go to your notes, beta. That's the next part, beta. Please see on the screen. Now let's do the third, same topic but third thing. Write down if SLN is injured in thyroid surgery. Now please see, if SLN is injured in thyroid surgery, beta. If SLN is injured in thyroid surgery, now cricothyroid is injured, beta. Injured, which is the main tensor, beta. If SLN is injured in thyroid surgery, cricothyroid is injured, which is the main tensor. Why? Everybody, speak with me, beta. All of you speak with me. All muscles of larynx are supplied by RLN, except cricothyroid, which is supplied by external branch of SLN. Now, if SLN is injured in thyroid surgery, last time you and me did thyroid surgery together. You cut the right RLN, I cut the left RLN, and we were in a big trouble. This time you said me, Rajiv, let us be very careful this time. We will not cut the RLN this time, beta. Okay? But at the upper pole of the thyroid, which nerve is there? SLN. This time, by mistake, we cut the SLN nerve. Now, which muscle is supplied by SLN? Is cricothyroid, beta. Cricothyroid muscle is supplied by external branch of SLN. And if you know, cricothyroid is the main tensor of vocal cord. And what is the role of tensor muscle? Tell me. What is the role of tensor muscle? Quality of voice. So, chief complaint will be poor quality of voice, beta. So, chief complaint will be poor quality of voice, beta. Write down C/C. Chief complaint is poor quality of voice, beta. Poor quality of voice, beta. Okay. Everybody write down cricothyroid muscle, beta. Muscle. Not injured, beta. Cricothyroid muscle Paralyzed. Paralyzed. Muscle is paralyzed, beta. Cricoid muscle is paralyzed. It will lead to poor quality of voice. Examination shows what? Bowed down vocal cord. Bowed down vocal cords. Bowed down vocal cord. Bowed down. B-O-W-E-D. Bowed down vocal cord. Beta. Bowed down. Something when it's not tense, it will be bowed down. Beta. Bowed down vocal cord. Beta. Bowed down vocal cord. Example will be bowed down. Bow down. Look at my hand. Beta. The cord will bow down. Tensor gone, cord will be bow down, beta. Latak jayenge. Lax means bow down. Lax means, look at my hand, beta. Lax means bow down, beta. Look at my hand, beta. Bow down like this. Okay? Bow down vocal cord, beta. 2 question. Cheek will be poor quality of voice because tensor give us quality of voice, and example will be bowed down vocal cord. Both are MCQs, beta. Both are MCQs. Bowed down vocal cord, both are MCQ, beta. Am I clear, beta? Fine. Bowed down vocal cords. Very good. Okay? Now everybody use the sidebar and write one important thing over here. Write down, in the sidebar, write down everybody one thing. Write down diphtheria can lead to unilateral vocal cord palsy. Not bilateral. Highlight is unilateral. But diphtheria will lead to unilateral vocal cord palsy. Treatment is conservative treatment. Conservative treatment. Important question for your upcoming exam, beta. If the problem is bilateral cord palsy, you have to treat it very aggressively. But if the problem is unilateral cord palsy, abductor or adductor or whatever, we don't really put our foot into it. Nature takes care of it. Treatment is conservative, beta. Don't forget this question. Diphtheria can lead to one side cord palsy, but if the cord palsy is one side, you should not bother too much. You should just treat it conservatively, beta. Am I clear, beta? This is a possible question. Nobody will forget. Extra question, beta. Extra question, beta. Okay. Okay, beta. Fine. Anybody who is right now, walking in the room, can you share your story, beta? Anybody who was awake but who was sleepy but now feeling better? Anybody who can tell in the, are you okay? Everybody, are you okay? Are you studying? Write in the chat box. Are you all learning? Are you learning these concepts of vocal palsy? Let me know in the chat box. Everybody okay? Now everybody, please see on the screen. Now please see on the screen, beta. Now can you tell me this question, answer this question, beta. Which of the following surgical procedure is indicated in adductor palsy of vocal cord? Everybody, look at your notes, beta. Adductor palsy. Which of the following surgical procedure is done in adductor palsy of the vocal cord, beta? Adductor palsy of the vocal cord. Okay, anybody? Type 1 thoroplasty, medialization. Okay, is it clear, beta? Everybody look at your note. Adductor palsy need what? Type 1 thoroplasty, and that is medialization of vocal cord. Okay, fine. Chalo. Now everybody, can you tell me this question, beta? Everybody look at screen, beta. Chalo. Everybody read this question with me. 52-year-old female patient underwent total thyroidectomy. While surgery, both RLN got damaged accidentally. While surgery, both RLN got damaged accidentally, beta. Both RLN got damaged accidentally. Now you tell me, what are the expected post-operative symptom of this patient, beta? Now everybody try to think about it. Now both side RLN got damaged. What type of palsy it will be? Bilateral abductor palsy, beta. All of you write in the chat box, beta. Try to be aggressively using the chat box. Write down the answer. I want to check that how many could you answer this one. Bilateral abductor palsy, beta. Bilateral abductor palsy. And this leads to what? Anybody, what is the answer, beta? I'm waiting for you in the chat box. Please give the answer over there. Everyone, pick up the chat box. It's not difficult. I know you have to switch here and there, but it's okay, beta. Okay, fine. Use that chat box, beta. Okay, what is the answer, beta? Respiratory distress with the normal voice. Okay, fine, beta. Respiratory distress with normal voice. Everyone, okay, fine. Very good. Okay. Is it clear? Bilateral abductor palsy will lead to respiratory distress with normal voice, beta. Is it clear to all? Everyone, try to answer the question, beta. So you're confident. Oh, both side RLN got damaged. This is the same story as I said that you and me were doing third surgery together. You cut the right RLN, I cut the left RLN. Both RLN got damaged. What was the symptom of the patient? Patient cannot breathe but can speak better. Respiratory distress with normal voice because both vocal cord come in midline position. Bilateral abductor palsy better. Bilateral abductor palsy. Okay, fine. Because you said that vocal cord, when we breathe, cord are open. We breathe with open vocal cord, we speak with closed vocal cord. These are permanently closed vocal cord, beta. Okay, so respiratory distress with normal voice, beta. Am I clear, beta? Fine. Very good, very good. All of you get participate, beta, and that's why I'm making you practice the question also in the class, so you get confident about your, concepts also, beta. Anybody? Which of the following is the abductor of the vocal cord? Anyone? Use the chat box, beta. Which of the following is the abductor of the vocal cord? Only abductor of vocal cord. Only abductor of vocal cord, single abductor, beta, is posterior cricoarytenoid, beta. Posterior cricoarytenoid is the only abductor of the vocal cord, beta. Very good, very good, very good. Okay, perfect. Now, everybody now answer it carefully, beta. You can do it. First of all, you can do it. Don't get scared of long question. You can do it. 6-year-old child with emergency, with stridor, respiratory distress for last 6 hours. On laryngoscopy, vocal cord are found to be lying in median position and are immobile. Wait here. Cord are in median position and are immobile, beta. Which palsy it is? Immobile or palsy? Cord are in median position. Which palsy? Abductor palsy or adductor palsy? You tell me. It's a case of which palsy, beta? This is a case of which palsy? Bilateral abductor palsy. Bilateral abductor palsy. What would be the part of management of this patient, beta? Bilateral abductor palsy, you will have to go for type 2 thoroplasty, also called as lateralization. Lateralization, beta. Answer is D, beta. D. Lateralization, beta. This is vocal cord are in median position and are paralyzed and are immobile. It's a case of median position. Median position, it's a case of bilateral abductor palsy. So, what type of thoroplasty we do is type 2 thoroplasty or lateralization of vocal cord, beta. Lateralization of vocal cord. Very good, beta. Type 2 thoroplasty. A lot of people are answering very correctly. That's amazing. This is the way I want the class to be. Very good, very good. Perfect. That's amazing, really. Yeah. Very nice, very nice. Amazing. That's really great. I know we have understood it. I know we have made notes, but we are yet to memorize it, beta. Don't worry. In this class of ENT, please do not take a tension of memorizing anything, beta. Conceptualizing, yes. Making notes, yes. But don't take a burden of remembering right now. Live the clinical experience with me, and then when you go home, it will not take more than 2 hours to revise everything. I assure you on that. You just take 2 hours of focus study, and really the notes are over, beta. Okay? Very nice, beta. Type 2 thoroplasty. Very good. Very good. Amazing. A lot of people have answered in all the batches correctly. Other people, please participate, beta. Please participate. It will give, even if you make mistakes, I don't have any problem. I'm not judging you. I'm not evaluating you, beta. I'm assisting you. Who the hell I am to evaluate you, beta? If I had to evaluate you, I would have passed you way back, beta. I would have given you MCA pass certificate and you would have started your internship if it would have been me. I'm not here to evaluate you. I don't judge people. I don't evaluate anyone. I am here to assist you in the process of learning so that you stand on the other side of 150. That's only my dream I have, actually. That's the only thing I have. So, if I ask you, what is, please speak up, beta. Please speak. If I ask you, what is this bone? Even if you say tibia, I don't mind, beta. I don't mind. I'll tell you, no, beta. It is hyoid bone. Let's learn from now. I ask you this, what is this bone? I want you to speak up at least. Oh, sir, tibia. It's okay. Wrong. No, beta, it's hyoid bone. But from this moment, you know it's hyoid bone. And I want you to really understand it further, remember it, and go to the exam and pass the exam, beta. This is what I really want to know. So please participate. Maybe you answer wrong thing, no problem. I want you to, tease your knowledge. Okay, what type of question are coming? That's why we're doing question in the class only. So you know already, oh, I can handle it. Oh, median position, immobile means palsy, median means abductor palsy, and I would know the treatment will be lateralization or type 2 thoroplasty, beta. Perfect, beta. Somebody saying that somebody saying that Dr. Dhawan is mimicry artist. I think I'll become one day. Okay, beta. Chalo. Now let's go to the next topic, beta. Laryngomalacia. And please do not forget, beta, unilateral cord palsy. Treatment is conservative. Don't forget this one. Diphtheria can lead to unilateral cord palsy and treatment is conservative, beta. Let's discuss laryngomalacia, beta. Laryngomalacia. Laryngomalacia is the most common congenital anomaly of larynx. Now this is star topic. First of all, it's a star topic, beta. Laryngomalacia is the most common congenital anomaly of larynx, beta. Okay, fine. Now, it is also called as congenital laryngeal stridor. It is the most common cause of, write down, beta, it is the most common cause of neonatal stridor. It is the most common cause of neonatal stridor. All three liner. This is star topic. MCQ coming very rampant of the topic, beta. Okay, fine. Beta. It is the most common cause of neonatal stridor, beta. Very good response in the chat box. I'm really truly happy, and I'll encourage other people also to respond, beta. Nobody is judging you. You say wrong thing, but let us get totally in sync with the class, beta. Wonderful response. Thank you very much for that. Now, now, beta, it is a weakness of supraglottis. Malaysia mean weakness. It's the weakness of supraglottis. Everybody, are you awake? Are you awake after the lunch break? Are you awake totally in your senses? It's the weakness of supraglottis, beta. Look at me, beta. How excited I am to be with you. You should be also equally excited. Look at me, how excited I am. It's not on my face. Can you not see that? How excited I am to be with you guys. And I want you also to be equally excited. It's a love affair. It has to be mutual, It has to be mutual. You understand? Love affair. It has to be mutual, like that. It's a weakness of supraglottis, beta. Weakness. Malaysia mane weakness. Laryngomalacia mane weakness of larynx. But which part of larynx, beta? It will be supraglottis larynx. Now you tell me, beta. Supraglottic problem causes which type of stridor? Yes, inspiratory stridor, beta. Very good. Inspiratory stridor, beta. Inspiratory stridor. Yes, very good, beta. Remember, supraglottic obstruction causes inspiratory stridor. Somebody asked in the break in the chat box that, sir, bronchial problem causes bronchi wheezing. That is something else, beta. Bronchial problem, bronchi wheezing. Okay. Up to bronchi is stridor, beta. Bronchi is the major one, na? Okay. So any supraglottic problem causes inspiratory stridor. Inspiratory stridor, beta. Okay. The baby will be getting, very sick sound, beta. This sound will be continuously coming. Mother will say, doctor, I'm very concerned. My baby produces this kind of sound 24 hours a day, beta. This sound is coming every day. And you will ask the question, ma'am, when did this sound start in your baby? She will say, doctor, stridor started in first week of life. Stridor started first week of life. This is a sound which is coming continuously from the child day in and day out. Okay, fine. Now, stridor starts in first week of life. Because it's a congenital problem. Mother will say, doctor, right after birth I noticed it. It's a congenital anomaly of larynx, beta. Then you'll ask any other thing you want to say. She says it increases on crying and less in prone position, beta. Just mark 3 arrow like that, beta. It is inspiratory stridor. Yes, stridor starts in first week of life. It increases on crying and it is decreasing in the prone position. In the prone position, beta. Decreasing in the prone position, beta. Okay, bache. Fine. Okay. Now, please see next point. Very important point. Very important point. Cry sound is normal because vocal cord are normal. The vocal cord have got no fault over here. Look at the screen, beta. Look at the screen. It's a weakness of supraglottis, not of glottis, beta. Okay, supraglottis is weak. But vocal cord are normal, so cry sound is normal. Beta, cry sound, it comes from the vocal cord, beta. Cry sound comes from the vocal cord. No, you must have heard this sound, beta. This is the cry sound of the baby. This sound comes from the vocal cord, beta. This is a clear sound. It means that vocal cord are having no problem. Okay, you understand that? Every sound comes from the vocal cord. Okay, so I asked the mother, is the cry sound okay? She said, he cries absolutely normal, no problem. Why cry sound is normal? Because vocal cords are normal. Vocal cords are normal. Okay, very important question of MCI. Okay, examination shows omega shaped epiglottis. Omega shaped epiglottis. Examination shows omega shaped epiglottis. Omega shaped epiglottis. Omega shaped epiglottis, beta. Write down the symbol, beta, omega. Remember physics symbol, beta, omega. Omega shaped epiglottis. Okay, why? Because epiglottis is folded. What is the normal shape of epiglottis? Leaf-like. When the leaf is folded, it becomes omega. I hope you remember the physics symbol omega, beta. Omega shaped epiglottis. Omega shaped epiglottis, beta. Omega shaped epiglottis. Okay, fine. Fine. Now, write down. Treatment is conservative treatment, beta. Conservative treatment. No active treatment required. The baby is fine, beta. Reassure mother, this sound will go away. Tell the mother, your baby is getting proper oxygen. There is no damage to the lungs. There is no damage to the heart. Everything is perfectly all right. The baby's oxygen level is absolutely normal. Yes, he is making sound when he breathes in, but do not worry. This sound will disappear automatically within 1.5 years, beta. Reassure mother that it is self-limiting condition. Reassure mother that it is self-limiting condition, beta. Self-limiting condition means within a year or 1.5 years, the sound will disappear. Tell the mother that your baby is getting proper oxygen, so do not worry about anything. Okay, fine. Okay. Now let me show you that what do you mean by omega shaped epiglottis, beta. Look at screen, everyone. What do you mean by omega shaped epiglottis? Actually, what happens is the larynx gets squeezed up, beta. Squeezed up. And when larynx gets squeezed up, the epiglottis get folded, and that's why there is a sound in the baby, beta. Okay. Now please see on the screen. This is laryngomalacia, beta. Can you see? Just compare it, beta. Larynx squeeze out. Whenever larynx gets squeezed out, there is sound, beta. Can you see omega shaped epiglottis, beta? Can you see omega shaped epiglottis? Okay, this is why the sound is coming. But sound doesn't mean that child will die out of this problem. Sound doesn't mean that he has a hypoxia. There is some sound coming, but reassure mother, it's self-limiting condition, beta. Let's revise this topic of laryngomalacia. Once again, beta, read out, beta, with me. Laryngomalacia, everybody. Laryngomalacia, it is the most common congenital anomaly of larynx. First of all, it's also called as, bolo beta, bolo bache, padke bolo. It's also called as congenital laryngeal stridor. It's also called as congenital laryngeal stridor, beta. Congenital laryngeal stridor. It is also called as congenital laryngeal stridor, beta. Okay. Now, it is the most common cause of neonatal stridor. This is MCQ. Okay. Paida hote hi, after birth, baby gets stridor sound, beta. The most common cause is laryngomalacia. Very common, very common problem. Now, chief complaint is inspiratory stridor. Why? It's a weakness of supraglottis, beta. Okay. Supraglottic problem causes inspiratory stridor. Now, the stridor, 3 points. It appears in first week of life. Number 2, it increases on crying. And number 3, it decreases in prone position. It decreases in prone position, beta. But the cry sound of the baby is normal because vocal cord are normal. Cry sound of baby is normal because vocal cord are normal. Example shows, look at the screen, what is this, beta? What type of epiglottis? What type of epiglottis, beta? What type of epiglottis? Squeezing up, beta. What is that, beta? Omega shaped epiglottis. Omega shaped. Can you see, beta? Omega shaped epiglottis. Okay. Now, the treatment is, do not worry, no treatment required. Conservative treatment, but reassure mother, it is self-limiting condition. Very important topic, beta. Okay. Now, let us write one more extra point in the sidebar, beta. Right, beta? Everybody, on the sidebar, write one extra point, beta. You have a space here, na? You can write over here. Everybody, just write, just draw a line. This topic is over. Add one more disease over here, beta. Okay. Write down congenital laryngeal web. Congenital laryngeal web, beta. Congenital laryngeal web. Most common site is glottic web, beta. Most common site is glottic web. Glottic web means vocal cord, beta. Vocal cord. All of you draw, beta, like this. This is the vocal cord web, beta. Most common site is glottic web, beta. Glottic. Can you see between the vocal cord there is a web over there? Okay. Most common site is glottic web, beta. Okay. Chief complaint. Chief complaint, beta. C/C, chief complaint. Chief complaint, beta. First of all, can you see glottic web, beta? Can you see this glottic web? Between the two vocal cord, this is the web, beta. This, what is it, beta? What is it, beta? This is vocal cord. Vocal cord, this is the web area, beta. This is the web. Am I clear? Web. Now, chief complaint will be hoarse cry, beta. In this case, you tell me, cry will be normal? Not at all. Cry will be abnormal. Hoarse cry. Why? Vocal cord problem means voice problem. Child doesn't have any sound, beta. Child only can cry. Cry. Hai? Cry is the sound coming from the vocal cord. Because vocal cord have a web, therefore there is a hoarse cry. Treatment. CO2 laser surgery. Treatment is CO2 laser surgery, beta. CO2 laser surgery. CO2 laser surgery, but treatment is CO2 laser surgery. CO2 laser surgery, beta. Treatment is CO2 laser surgery. I'm going to CO2 carbon dioxide laser. With the laser, you cut this, beta. Okay? Glottic web. Glottic web, beta. Before we go further, beta, somebody asked me, sir, can you tell quickly about various thyroplasty, beta? I'll post this image in a Telegram group also. Guys, there are 2 Telegram group of mine. One is FMG group, other is NEET PG INICET group. Please join FMG group, beta. FMG group, because they two have a different kind of, target areas for the question and all that. So I generally refine the question on one side is better. I'll share the link with you, but join Rajiv Dhawan FMG ENT. You'll find it in Telegram. So I'll put this slide in the Telegram group also. But let us see this, beta. Let us revise it. Type 1 is medialization. Done for which palsy? Adductor palsy. Type 2 is lateralization. Done for abductor palsy. Type 3 was shortening, loosening, done for puberphonia. Remember puberphonia? Narendra Modi speaking like Mamata Banerjee. Type 4 is lengthening or tightening, done for androphonia. Remember androphonia? Mamata Banerjee speaking like Narendra Modi. If you remember clearly, just see clearly, type 1 and type 2 are opposite of each other. And type 3 and type 4 are opposite of each other, beta. Type 1 and type 2 are opposite of each other. Procedure also, indication also, beta. Adductor, abductor. Puberphonia, androphonia. Okay. Now what is type 1? What is type 1? M. Medialization, beta. Can I write M here? Yes. What is type 2? L. What is lateralization? L. Can I write L, beta? Okay. Type 3. Type 3 is what? Shortening, loosening. Can I write S, beta? S. Okay. And type 4 is reverse of that, lengthening, tightening. I hope you remember what is MLS, beta. What is MLS, beta? What is MLS, anybody? What is MLS? Micro laryngeal surgery. But for us, MLS will become a mnemonic of thyroplasty also. Why not really, make it really like this? MLS is mnemonic of thyroplasty also. Type 1 M, medialization. Type 2 L, lateralization. Type 3 S, shortening, loosening. And type 4 is reverse of that, lengthening, tightening, beta. Okay, so I'll post this image in the Telegram also. You can take it from there. Okay, try to save these images in one folder. Whatever images you're doing, radiology, derma, this thing, I'll say make specific folder for pathology, radiology, general, for one subject, but for radio, separate folder, patho, separate folder, surgery, separate folder, derma, separate folder, and for other, for ophthalmology also one folder, for fundus picture and all that. But for other things, you can make one general folder, bit. So that you have got important, whatever you find in a Telegram and other gram or this gram or that gram, you transfer it over there, beta. None of you, let me take 1 minute, beta. None of you would be using, sorry to say that, Instagram beyond today. If you really think that I am a well-wisher, if you really think that, I'm not a faculty, I'm just like an elder brother to you guys, and if I can suggest you that what to do which can make my success more possible, decrease the number of stimuli in your life. At this moment, do you think Instagram is more important? Or Tinder is more important? Or Facebook is more important? Or your books are more important? So let's do the right thing at the right time. 4th June evening, I'll put a message in the groups. Please reinstall Instagram at the earlier. Please, I'll tell you, on 4th June evening, I'll remind you, have you installed Instagram or not? Reinstall Instagram. Temporary deactivation is possible. I know I'm asking for a kidney from you. I know that. I'm asking for a kidney donation from you. I know that. It's a very painful thing. But, I have a very clear concept about it. I want to make sure that you do every right thing, that you stand on the other side of 150. So I'm asking for a small sacrifice from all of you today. Please uninstall all the unnecessary apps like makemytrip.com. Where are you going, by the way? Never. Why the app is there? I don't know. Why Facebook is there? Why Instagram is there? Why Tinder is there? Other things, like just look around the extra apps over there. Let us replace all those apps with just maybe one app, Telegram or WhatsApp. It's more than sufficient, beta. For that's also for academic value things, beta. Do not keep on checking WhatsApp every hour. For academic notices, yes, you have to check it 1 or 2 times. But for general things, for connecting with your family, friends, or etc., you may keep a time after dinner. After dinner, you feel anyway sleepy. At that time, keep a call, make a call at home, or if you have got any friend or girlfriend or boyfriend or whatever. But that time only, check WhatsApp, and after that, don't keep on answering every WhatsApp coming within 10 seconds of that. Beta. That habit we have to put in hold for at least 3 months now. We'll bounce back to life on 4th of June evening. Don't worry about that. I'm not a boring person. I don't really dictate anything. I don't really preach anything. But I'm suggesting you do the right thing at the right time now, because all of these things drain you. If you see one of your friend's picture in Instagram, do you feel good about it? No, we feel jealous about it. People don't want to accept it, but that's a fact. That's the fact, beta. You know it. That's a fact actually. You have an engineering friend, and then he got the job very early. You are still in MBBS, the 4-year course, the 5.5-year course, now the MCA exam and all that. But he's progressing his life. He reached Bangalore. From there he went to New York, and now he's posting a picture in the New York with the Statue of Liberty in the background. The moment you look at his picture on Instagram, you feel really so low about your own life. Beta. I know it's comparison. People say don't compare, but we do compare. We are humans. We are not gods here. We are not gods. One friend of yours getting engaged. She was a non-medico. Bloody hell, you feel what the hell I'm doing. Meri bari ka bhai. All these things are stimuli which will take you away from the books. But doctors are doctors. We cannot really afford to do all these things, At this moment, not for sure. But 4th June onward, we'll again become the wild monkeys. Don't behave like a pet dog all through your life. Pet dogs are boring people. We are blessed to become wild monkeys. We will be wild monkey all through our life, actually. I'm not here to change you. I'm not here to really, I don't profess change. Nobody need to change. You are what you are. But yes, you can behave. You can become disciplined at certain point of time in your life. And this is the time when you are expected to do really different things, actually. So let's make today, after the class over, don't do it because I said it. Don't do it because I said it. Evaluate. Does it really add value to your life when you're using Instagram or Facebook or anything else? If your heart says no, it's eating away my time. It's eating away my energy. It fills me with negative comparative emotions. Better delete those stimuli from your phones. But on 4th June evening, we'll reinstall them. Let's keep kicking, beta. Let's keep kicking. But as of now, these all things should be in your folders right now. Let's replace the app with the folders, different folder in our images gallery beta. Okay, so type 1 is medialization, type 2 is lateralization, type 3 is shortening, and type 4 is lengthening, tightening, and I developed a way to memorize it. Oh, MLS is a mnemonic of thyroplasties beta. Okay, very good, very good. Okay, chalo. Let's go next beta. Next topic beta, pediatric laryngeal infections beta. Pediatric laryngeal infections beta. Pediatric laryngeal infection beta. First of all, write down. Put an arrow. They cause edema of larynx. They cause edema of the larynx. And therefore, they lead to airway emergency. They lead to airway emergency beta. Airway emergency. They lead to airway emergency beta. Pediatric laryngeal infection are not like, you know, simple infection. They can kill the babies beta. Pediatric laryngeal infection are very important for your pediatric question also beta. For your pediatric question also. These children will not come to the OPD. These children will be landing in the emergency beta. They will be landing in the emergency in a very serious situation, something like this beta. This is the look of the baby beta. Pediatric laryngeal infections are asked in MCI also, ENT also, are asked in MCI pediatric also beta. So double possibility of question beta. Now under this category, we have got two topics beta. The first one is acute epiglottitis. The first one is acute epiglottitis. Look at the definition beta. It is infection of supraglottis beta. It is infection of supraglottis. Now it is caused by step pneumoniae followed by HIB beta. HIB, Haemophilus influenzae B bacteria. It's a bacterial infection. It's a bacterial infection caused by the most common causative organism. I know there's a lot of debate going on this particular organism, bacteria, which is the commonest organism to cause acute epiglottitis. Whenever the question is asked from you in any exam, in NEET, PG, INICET or MCI, FMG, they always ask for the global scenario beta, global scenario. They never ask you, if they ask you India, they'll write in India beta. If they ask you developing country, they'll write developing country. But the question which came last time was, what are the most common causative organism of this condition? When they ask like this in any exam, in any subject, we mean global statistics beta. And global statistics say that due to HIB immunization in the planet, due to HIB immunization in a lot of countries, the HIB has come down as a causative organism of this infection. The streptovirus pneumonia has become number 1. I'm very well aware that there's a debate going on in multiple, you know, YouTube things and all that, but accept it that this is the answer which you have to mark in the upcoming exam also if the question comes like this beta. So it is caused by strep pneumonia also, or second common is HIB. This symbol means second common beta. Answer. Age is 2 to 7 years. Imagine the baby beta. Age 2 to 7 years. Now clinical picture beta. Clinical picture is, first of all, very sick baby beta. All of you imagine the patient as a doctor. Very sick baby. It's a very sick baby beta. It's a very sick baby who can die within few hours also. It's a very sick baby bache. It's a very sick baby. Okay. Now, chief complaint, respiratory difficulty. Which stridor beta? Everybody. Which stridor? Everybody. Which stridor? You can tell me which stridor? Why inspiratory stridor? It is infection of supraglottis once again. Supraglottic problem causes inspiratory stridor. I know that. Supraglottic problem causes inspiratory stridor beta. Inspiratory stridor. Inspiratory stridor beta. Inspiratory stridor. Number 3, high fever. Oh, high fever also beta. High fever. This patient got high bacterial infection, gives high fever beta. High fever. Drooling of saliva. Why drooling of saliva beta? Why drooling of saliva? Everybody look at me beta. All of you do this with me. All of you keep a hand on thyroid cartilage. Do this beta. Keep a hand on thyroid cartilage and swallow your saliva. Swallow your saliva beta. Did you notice that your larynx goes up when you swallow? Larynx does upward movement when you swallow. Yes. Now in this patient, larynx has got infection. There is a pain in the larynx. So child does not want to swallow, because whenever he swallow, there is upward movement of larynx and child gets a lot of pain in the throat. He doesn't want to do this movement. He doesn't even swallow his saliva. He let the saliva flow out from his mouth beta. Okay, drooling of saliva. Even swallowing saliva is also painful. Drooling of saliva. The mouth is full of saliva. In the throat, also saliva is filled up. Because he doesn't swallow saliva because of pain, he doesn't want to swallow it even. Because even swallowing of the saliva is also a painful thing. Okay, drooling of saliva and write down, and hot potato voice. Add one word beta, hot potato voice. Oh, there's a special kind of voice because mouth is full of saliva. Saliva beta, saliva nahi. It's not saliva, it's saliva. Hot potato voice beta. Hot potato voice. Hot potato voice beta. Okay, fine. What is hot potato voice? Hot potato, garam aloo beta, garam aloo. Hot potato voice. Look at me beta. Hot potato voice. What do you mean by hot potato voice beta? What kind of voice it is? Look at me beta. Sometimes you're very hungry. बहुत भूख लगी हुई है. You go to the kitchen. You go to the kitchen without thinking, बिना सोचे हुए. There is something in the plate, right, lying over there. You pick that some vada, pakoda, something like that, samosa, or something like that, and you just pick that vada and put in the mouth, and now you realize it is so damn hot. You put by chance you put a hot object in your mouth, and now you can't swallow it. You can't really throw it out. Now ये निगला जा रहा है, ना ये उगला जा रहा है, और फिर भी you try to speak like that hot potato voice, beta. Because the child has collected a lot of saliva in the mouth, beta. Hot potato voice. This child sits bending forward, beta. This is called tripod sign. Very good. Tripod sign. Tripod sign. The child sits bending forward. This is called tripod sign, beta. Tripod sign. The child sits bending forward. This is called tripod sign, beta. Tripod sign. Tripod sign. Look at me, beta. What is tripod, beta? Look at me, beta. Look at me, tripod. Look at me, beta. Look at me. Like this tripod. Why? What is the name of disease, beta? Epiglottitis. Epiglottis is swollen due to edema. I told you, edema, na? Now, epiglottis is swollen. Now, please understand, if you make the baby lie down on the back, epiglottis will cover the vocal cord too much because it is bulky. It is epiglottis edema. It will cover the vocal too much. Patient will not be breathe. He will sit up. He's a 2-year-old child can sit up. 2-year-old, 2 to 7 year, na? 2-year-old child can sit up. Very smartly, he will keep his hand on the bed like this in the emergency. By doing this, what he's doing is, he's letting his epiglottis fall away from the vocal cord, so that vocal cord is not blocked or covered by the epiglottis, so that there is some space for the child to breathe. By doing this, he's letting his epiglottis fall away from the vocal cord. This, can you look at the position? This is actually a tripod. Can you see from my shoulder down, the tripod, tripod position, like this. He keeps his hand on the bed actually, and bends like this. This is called tripod position. Tripod sign. X-ray. Which X-ray, beta? X-ray lower limb? X-ray hip joint? No. X-ray neck. Which view? Lateral view. X-ray neck, lateral view, beta. Which view? Lateral view. X-ray neck, lateral view will show thumb sign, beta. Very popular question. X-ray neck, lateral view will show thumb sign, beta. X-ray neck, lateral view will show thumb sign, beta. Thumb sign. X-ray neck, lateral view will show thumb sign, beta. Thumb sign. X-ray neck, lateral view will show thumb sign. Thumb means swollen epiglottis. Thumb means swollen epiglottis. Where's the thumb, beta? Can you see this X-ray, beta? Everybody, can you see this X-ray? Can you see X-ray neck, beta? Can you see, beta, vertebra? Can you see vertebra? It's a neck X-ray. Vertebra. Can you see lateral view, beta? Lateral view. Look at this point, beta. This is the epiglottis which is swollen, beta. This is the epiglottis which is swollen, and that is called thumb sign. The swollen epiglottis looks like a thumb. Can you tell me what is the normal shape of the epiglottis? Leaf-like. When the leaf is swollen, it looks like a thumb actually. Can you see it like a thumb? Can you see thumb sign? Very good. Thumb sign, beta. Very good. Now, first treatment is, of course, beta, no antibiotic, no steroid. It's an airway emergency. First treatment is airway management, beta. Airway management by intubation. Oh, airway management by intubation, beta. Airway management by intubation. Intubation. Save the baby first, beta. It's a very sick baby. I told you, it's a very sick baby. Airway management by intubation. Don't lose this baby, beta. Look at screen, beta. Look at screen. Immediately, you are emergency doctor. You should do one thing. Put a laryngoscope. What he's doing is intubation, beta. Can you see intubation going on? So put a laryngoscope and do the intubation, beta. This will save the baby. Put the patient on ventilator after that. What not to do? Add one MCQ pediatric question. Do not do. Write on the sidebar, beta. Sidebar, write down. Do not do repeated laryngoscopy because it will increase edema. Do not do repeated laryngoscopy because it will increase edema. Do not do repeated laryngoscopy because it will increase the edema. This is another question of pediatric. What to do is intubation, but what not to do is avoid repeated laryngoscopy because it will increase the edema. Okay, fine. Now, next one. Number 2, steroids. Number 3, antibiotic. Steroid. Number 3, antibiotic. Why the hell steroid, beta? Steroid for what? Edema. Think like a doctor. My dear friends, you are not medical student anymore. You are soon to be medical professionals. Okay, start thinking like a doctor. Okay, steroid for edema, antibiotic, infection, bacterial infection. Okay, can we revise this topic, beta? Everybody, let's start this topic. Pediatric laryngeal infection, first of all, they cause edema of the larynx, therefore airway obstruction, airway emergencies, beta. Okay, now there are 2 conditions in that. Acute epiglottitis, it's infection of supraglottis. Now think like oh, epiglottitis. When you today, one promise I have to take from you. I'm sorry, I'm asking. I'm a too demanding person as far as you guys are concerned, beta. One promise I'm going to take from you. You may or may not wear the sports shoes, beta. That's your wish. That's okay. That's just an idea I shared with you because I like that idea. But this other one, which is definitely mandatory, is what? Now look at me, everyone. When you revise, the mobile phone will be switched off. Can we do that? When you revise your notes, better notes mean notes, only notes. You're not accessing the videos, not accessing the telegram, anything. कर लिया, हो गया, अब notes पढ़ना है. When we revise, our mobile phone will be switched off mode, not silent mode, beta. Can we make this commitment to each other today? Why? Because if you are revising stupid thing like, vocal cord palsy, and side by side, YouTube is there, Instagram is there, Facebook is there. Do you think type 1 thyroplasty, type 2 thyroplasty can compete with Instagram? Do you think so? It's unfair competition, beta. This is unnatural thing for the brain. Thyroplasty, 1, 2, 3, 4. Natural thing is what? Brain wants to make babies, you know what? Brain wants to make babies, you know what? That's what the very natural thing. You'll be automatically getting more focus, more energy will tilt toward that side, beta. Okay? So, let us not really expect ourselves to remember when we revise if your mobile phone is switched on. That's not really the right thing to do. Brain would not get too much of impact till the time it's fully available. To be fully available, you have to do things differently. You think it's difficult to switch off the mobile phone? Are we really that important? Is Modi going to call you up to decide, shall I support Russia or Ukraine at this moment? Do you think we are that important? Really? Do I switch off my mobile when I do something constructive? Yes, I do. My mobile is continuously, people, so many students are connected on Telegram or so many grams and all that, that, I have to reply sometimes. But when I have to do some constructive work, like making MCQs or making something like for you guys, something, I have to switch off my mobile and really focus full energy on that. That's how, otherwise my mind is so distractible. I'm a very easy to distract person. I get very easily distracted to the things outside. Better. If I'm doing something, making MCQs, in the meantime, some students send me an email, I reply that also on the phone, my whole thought is broken. Now I start doing the emails only. After that, I forget about this work. So what I learned from a mistake was, I have to switch off, disconnect from the rest of the world to focus on the work I'm doing. And for you, what is more important right now as far as your life milestone is concerned? Right now, your life milestone is this exam. This exam is the most important thing in your life. Nothing is more important than this. If we pass, everybody stand by his side. You know it. When we fail, only few are there. You know it, beta. When we pass, everybody is happy with us, partying with us, like having good time with us. But when we fail, nobody is with us, beta, except for a few family members, a few friends and all that. That's all. They will always be there, beta. You chat with them, you don't chat with them, you be with Instagram or not with them, it's okay. They're part of your life, they'll remain to be part of your life. Rest all is extra accessories in your life, beta. However you want to increase that, that's okay. It's very source of pleasure for us, fine. But that's not the substance of the life, actually. That's not the real essence of life. Right now, we cannot afford to do that. After 4th June, you do whatever you want to. I don't want to change you guys at all. You be what you are, absolutely be crazy. It's okay, no problem. But right now, I'm expecting you to focus your energy this way, because when you use Instagram or some other thing and all that, your brain really gets consumed by that. And you get a little bit negative feeling of comparing your life with other life. And you don't get to the books very easily. Better. And even if you go and your phone is on now, you get suddenly, you're revising, physiology. And out of that, for example, a topic comes metabolic alkalosis, respiratory acidosis, which is a hell lot of a topic. And now brain doesn't want to do this. Brain wants to do something interesting. Suddenly your phone is on and you go to the YouTube and you switch on something interesting, which is a new song. Beta. Oh, new song. Like, you know what? You know that song? You know what? So oh yeah, that's the like. But that changed the whole thing, beta. That you were doing something, you're trying to know something and suddenly you change to something else. So let us decrease the stimuli, beta. Let's keep the mobile phone switched off and keep it 2 meters away from us. Sit down with the notes, invest your energy, heart and soul into it. Try to do active revision. Go this way, go that way. Just change, say the pages, underline there, underline here, write the page number, this one here, so that you're able to correlate. Oh, what is written over here? This is going to interlock the memory, and now the impact will be deeper in your brain, beta. There's a high chance second revision will make it even more deeper, third revision will make it even more deeper, and fourth one, the last look, will make it final layering, beta. You ask yourself, if you read this way without getting distracted by mobile phone or other things in life, if you focus way, brain is totally focused on notes, and you read the notes like this, beta, 4 times, don't you think so we'll be able to recall in the exam, beta? You tell me, beta. Tell me honestly, it's a subjective paper? No, it's objective paper. Objective paper means what? The choices are written in front of you, beta. They do not ask which maneuver is used for the treatment of puberphonia. They give you out of these 4 maneuver, which maneuver is used for the treatment of puberphonia. Then you recall the story, guts man, oh man, have guts, speak like a man, guts man, guts man, guts man. 1 class, guts man. Then we revise the class, guts man. Then you 3 revision, you guts man, guts man, guts man. 1 week before the exam, guts man. If you have done all these things with focus, do you think we are not going to recall it in the exam? When the screen will show all the 4 choices to you, beta. It's not a subjective paper, beta. Fortunately, it's not a subjective paper. अगर subjective essay writing paper होता ना, तो मैं तो कभी पास ना हो पाता. मेरे gutsman के spelling गलत होते मेरे तो. I would have, मेरे को spelling आते नहीं बहुत सी चीजों के. I don't know the spellings of a lot of things, beta. I would have failed in the exam. Fortunately, objective paper है बेटा. शुक्र है spelling नहीं check हो रहे भाई. Spelling check हो रहे तो मैं तो पक्का fail हो जाता. मैं तो कभी पास ही नहीं हो पाता किसी चीज में. Objective paper has got a beauty that in front of you 4 choices written, you have to mark it. But if we are revising it, appropriately with focus, with mobile phone off, mobile phone at a distance of 2 meters from your body, full alert on the books, on the notes, and wearing sports shoes, sitting on the chair. All these things will make our revision more active, more impactful also. Okay, fine. I hope either of these ideas you are able to incorporate in your life. I'll be very happy to really hear from your side. Did anyone do this or not? Okay. Now, let's revise, beta. It's infection of supraglottis. It is caused by which bacteria? Step 2 is pyogenes. Second common is HIB. I'm very well aware there's a controversy on this topic, and I'm saying that the question is always about the world statistics. So world statistics is step 2 pneumonia, beta. The age is 2 to 7 years, and the clinical picture, imagine the patient as a very sick baby. The child has got respiratory distress. What type of stridor? Inspiratory stridor, because supraglottic problem causes inspiratory stridor. Bacterial infection will cause high fever. Child has pain in the throat, so drooling of saliva, hot potato voice. Child very smartly sits bending forward. This is called tripod sign. X-ray neck will show which sign? Thumb sign. Thumb sign, beta. X-ray neck will show thumb sign. And the treatment, the first treatment is airway management by intubation, beta. Intubation. But do not do repeated laryngoscopy because that will increase the edema. Then you give steroids and antibiotics, beta. Okay, beta. Now let's go further, beta. Let's go further. Second topic is number 2. Beta, this was A, beta. This was A. Acute, I put A, na? A likha na, A. Write down here B. B. Croup. Acute laryngotracheobronchitis. Croup. C-R-O-U-P, croup. Acute laryngotracheobronchitis. A-L-T-B. Laryngotracheobronchitis. Acute laryngotracheobronchitis. It's infection of complete airway. Look at the name, laryngotracheobronchitis. It's infection of complete airway, but subglottis is most affected part. But is most affected part? Subglottis. Full in the blank, subglottis is most affected part. It's infection of complete airway, laryngotracheobronchitis also. Chest is also infected. But what is the most affected part? Subglottis. Subglottis is most affected part. Subglottis is most affected part. It is caused by para-influenza virus. Oh, I'll compare it with the other one, beta. Okay, that was bacterial. This is viral. Which virus? Para-influenza virus. Age. Age is 3 months to 3 years, beta. Age is 3 months to 3 years. What was the age in the first one? Compare. Active revision, beta. 2 to 7 years. 3 months to 3 years, beta. Okay, 3 months to 3. Active revision. Compare. 2 to 7 years. 3 months to 3 years, beta. Clinical presentation. It's a less sick baby, beta. It is not that sick baby, beta. It's a less sick baby. Epiglottitis is a bigger emergency. That's a very sick baby. This is not that sick. Viral, na? Less sick baby. Respiratory distress, respiratory difficulty. Biphasic stridor. Why biphasic? Subglottic problem. It is infection of complete airway, but what is most affected part is subglottis, beta. Okay? So, subglottis problem causes biphasic stridor. Low fever, beta. Low fever, not high fever. Compare it on the other side. Low fever here. Low fever. Why, beta? Low fever. Viral infection generally cause low fever, beta. COVID-19. Fever was not high grade. It was low fever. 100, 101, 99.5 and all that. That kind of fever was there, beta. Low fever. And barking cough, beta. The chest has got a problem. A-L-T-B, beta. What is B? Bronchitis, beta. Bronchitis. Highlight the word B. Laryngotracheobronchitis. Bronchitis means bronchospasm is there, beta. The cough is there. Okay. Cough is the distinguishing feature here. Okay. Fine. Okay. Now, next one. X-ray will show. X-ray, which X-ray? X-ray neck, AP view. Which view? AP view. X-ray neck will show, X-ray neck, AP view. Anterior-posterior view will show steeple sign. S-T-E-E-P-L-E. Steeple sign, S-T-E-E-P-L-E. Anybody, what was the name of X-ray sign in epiglottitis baby? Thumb sign. Thumb, swollen epiglottis, thumb. Steeple means narrowing of subglottis. Narrowing of subglottis. Anybody can tell me. Now, everybody look at me, beta. Which is the narrowest part of pediatric larynx? Aap batao mujhe. What is the narrowest part of pediatric larynx is? Subglottis. What is the most affected part in laryngotracheobronchitis? Subglottis. And that is very narrow, beta. Narrow. Too narrow. Steepling, beta. Too narrow, beta. Steeple word has come from the church, beta. Church. You know, church has got steeples like this. What is steeple? Steeple is a minar, beta. You know, outer face of church has got minar. Minar, beta, the tubular minar from base, and the apex gets conical, beta. Conical apex, beta. I'm sure you would have seen, you know, this kind of, you know, steeples, beta. This is what, beta, trachea, which is normal. This is subglottis. Subglottis, beta. Trachea, subglottis, beta. Steeples of the church. Steeple of the church. Okay, steeple sign. Okay. Fine, beta. Steeple of the church, beta. Okay, fine. Now, let me show you how does the real look like, beta. Look at screen, everyone. Let me show you, beta, over here. Just see on the X-ray, beta, over here. Abhi kuch nahi nazar aa raha. Everything is same. Let me show you, beta, where it is. Focus on screen, beta. This is your trachea. Trachea, beta. Okay. This is your subglottis. Can you see? This is trachea. Subglottis. Trachea, subglottis. Can you see what a trachea, subglottis? Fine. Can you see steeple there? Now let me remove the marking over there, beta. Let me remove the marking. Now can you see the steeple here, beta? This black shadow, air. Trachea is normal. This is the steeple, beta. Can you see over there? Now, everybody, do an experiment with me, beta. Now, everybody, again, see now say the same picture, beta. Did you notice one thing? Now your eyes are able to locate this steeple with a lot of ease, beta. Oh, सीधा ही आंखें वहीं जा रही हैं, beta. Direct eyes are going there only, beta. Why? Because you practiced it one time before. Now, when you practice 3 times, 4 times, in the exam, it will become very easy for you because eyes will search it for somehow. Oh, this is steeple, beta. Am I clear, beta? So, don't think that, okay, first time everybody is a champion, beta. First time everybody is a learner. Second time, everybody has to revise, and then your eyes become very, very, sure, but okay, oh, this is revision, beta. That's the main thing. Let me tell you. The real one thing I understood in last 12 years in FMG segment, that revision is the key to success, beta. One time nobody can remember. One time nobody can remember, beta. I can tell you. 2 times also nobody. 3rd time also. 4th time the real change starts coming, beta. So don't judge yourself right now. Judge yourself after 4th June, beta. Not even 4th June. अपना काम करते जाएंगे, beta. Let's keep on working hard. जब डर लगे, whenever you feel scared, what if I fail this time? What if I fail this time again? What if I do not pass the exam this time? What my family will think? What my girlfriend will think? What my boyfriend will think? What might happen to my life and all that? जब ये डर लगे, whenever you feel scared, बस एक ही चीज़ करना, बेटा. Fold your hand and look above and tell him that I am doing my part. You please do your part. Tell it to him that मैं अपना काम कर रहा हूँ, बाकी तू संभाल ले भाई. मैं अपना काम कर रहा हूँ, पढ़ाई कर रहा हूँ, मेहनत कर रहा हूँ, बाकी तू संभाल लेना. ऊपर वाले पे छोड़ देना. Leave it to him to decide. May God bless your hard work, beta. May God bless your hard work. You, me are very small, minuscule part of the whole creation story, beta. Very small parts. We cannot predict what is going to happen in the future. How 4 June will be, nobody can predict. You have 2 options. Either to keep getting scared of the bad outcome and keep wasting time, or to have firm faith in yourself and him. I will do my hard work and I'll leave the rest to him. Always when you feel fear, fold your hand and tell him, I know result is in your hands. मैं अपना काम पूरा कर रहा हूँ, अपना काम पूरा करना है. You will do complete hard work. Only hard work is blessed, beta. I never say, may God bless you, beta. May God bless your hard work. You have to do hard work first of all. जब डर लगे ना बेटा, ऊपर देखना है, बोलना है कि भाई मैं अपना पूरा कर रहा हूँ, बाकी तू जाने, तेरा काम जाने भाई. Please do your job, beta. ऊपर वाले को बोलना है कि please choose to bless my hard work. That's the only thing you can do, beta. Beyond this, nobody can really, do anything. It's he who decides. We are too minuscule, beta. Too minuscule. How 4 June exam will be? Can I really comment today what type of ENT question are coming? Let me be, okay, I may be, doing a good job in the past. People might say, okay, Rajiv, your really questions are coming in the exam like that. But can I predict 4 June? Tell me. No, when I teach today, I always pray before coming to every class, beta. I always pray. This is my routine actually. Before coming to any class till date, I pray that whatever I may teach today, may the student understand and may a question come out of that. But it is you who decides what actually happens. I can't really predict that. Same is applicable for you also. You can't predict the result. You can't really, sort of do anything about the exam, how a paper will be. What you can do is your hard work. And when you do revision, the things start looking very visible to you. Oh, steeple sign. Now treatment. Treatment is, number 1, airway. Of course, airway. Number 2, bronchodilator. Why bronchodilator, beta? Why bronchodilator? ALTB. B matlab bronchitis. ALTB. Bronchitis. For bronchitis, you need bronchodilator. Steroids. Edema, beta, for edema. And then antibiotics, beta. Antibiotic to prevent. You say, Rajiv, why antibiotic, beta? You say, Rajiv, it's a viral infection. Parainfluenza virus, the virus, beta. Why are you giving antibiotic? I have a question from all of you. When the whole world was eating azithromycin for COVID-19, you never asked this question. When the whole world was going crazy after azithromycin, nobody was getting azithromycin in the market even. You never asked this question. COVID-19 is also a viral infection. Why the bloody hell everybody was eating azithromycin then? Role of antibiotic is to prevent secondary infection, beta. Secondary infection, okay? So, to prevent which infection? Secondary infection, beta. Secondary bacterial infection. Every viral infection can lead to secondary bacterial infection, beta. Okay, fine. Now, let's revise this topic, beta. The name of topic is croup or acute laryngotracheobronchitis. Everybody speak with me, beta. What is the other name of croup? ALTB, full form, acute laryngotracheobronchitis. It's infection of complete airway, but subglottis is the most affected part. Okay, it's caused by which virus? Para-influenza virus, beta. Okay, the epiglottis was bacterial infection, strep pneumoniae or HIB. What is the age in epiglottis? Was 2 to 7 years. Age here is 3 months to 3 years, beta. Okay, now clinical presentation. It's a very sick baby or less sick baby. This one is a less sick baby, beta. Okay, now chief complaint is respiratory difficulty. Okay, biphasic stridor, low fever and cough. Cough is the main distinguishing feature. Okay, now if you do X-ray neck AP view, you will see steeple sign. Steeple is a narrowing of subglottis. The treatment is again airway management, bronchodilator, steroids, and antibiotic to prevent secondary infection. Beta. Okay, everybody come to the next one. Beta. TB larynx. 2 signs to remember, beta. Only 2 signs to remember. Don't even 2 signs, beta. What are 2 signs? Number 1, mouse nibbled up in the vocal cord and turban epiglottis, beta. 2 question, old historical question, no more coming nowadays for last 5-6 years. This is TB larynx is almost gone out of the picture at all, totally gone. We don't see TB larynx at all now. More or less, TB larynx, 2 things to remember: mouse nibbled up in the vocal cord, and number 2, turban epiglottis. Beta. Turban epiglottis. Turban epiglottis, beta. Am I clear, beta? Fine. Mouse nibbled up in the vocal cord and turban epiglottis, beta. Okay, bache? Fine. Turban, how to remember it? Turban TB, turban TB, turban TB. Anybody? Omega epiglottis is seen in laryngomalacia. Omega epiglottis is seen in laryngomalacia, beta. Guys, may I suggest you one more thing? You have got 18 subjects, 19 subjects with you, 19 subjects, and take one more copy, extra copy with you, beta. Keep one extra copy with you of 1 copy for all the subjects. Divide that into segments like, ENT 5 pages, Optha 5 pages, medicine 20 pages, surgery 20 pages, PSM 20 pages, OBGY 15 pages, psychiatry 5 pages, like that. You divide, you make it like division. Into that, any selected point you find interesting in your notes, worth memorizing your notes, and you'll forget it if you don't revise in the last 1 or 2 days before exam, write in that copy in the appropriate section of ophthalmology or ENT or derma or psychiatry, wherever you find it. In the last 1 week before exam, we'll read this copy 2-3 times. This will suddenly give a boost to you, as far as your, recall is concerned, beta. Because a lot of important points which you found as important, you are stored in 2 places. Where? In the folders of the images or somewhere, or in this copy, beta. This is called 20th copy concept, which I really introduced in way back in 2012. I brought it for PG actually. And this actually was, which I use in my PG preparation days also. Now this 20th copy concept is something like, you will find it really useful if you write very selective things. Don't write the whole. ऐसा नहीं पूरे notes इधर चेप दिए पकड़ के. ऐसा नहीं करना. Main turban epiglottis, TB larynx, omega epiglottis is the laryngomalacia, beta. Okay. Any type 1 thoroplasty, type 1, 2, 3 thoroplasty, middleization, lateralization, shortening, loosening, and all that. You write the other side also like that. So this kind of 5 pages of ENT which you devise on your own, or ophthalmology, or orthopedics, or pediatrics, when you read those catchy points on maybe 1st of June or 2nd of June also, you revise it again. 2 times you read this whole copy. Can you imagine how many points will suddenly start, getting shining in your brain, and recall of those points in the exam will be short recall, beta. Okay? All these hacks work in the exam, beta. Because this exam is very different, beta. This exam is not like standard exam where we get 1 year to prepare for NEET PG. 4 months, exam is done, beta. This 3 months now left, beta. So this paper will have everything. Sam, Dam, Dand, Bed. Everything, sab kuch chalega bhai us din. Sam, Dam, Dand, Bed. Everything will work on that day. So try to develop your strategy for the last 1 week right from now. ये नहीं कि ये पढ़ लिया वो वहाँ चला गया, वो पढ़ लिया वो वहाँ पढ़ा हुआ है, कभी बाद में पढ़ा ही नहीं, फिर फायदा क्या होगा? What you studied on 28th of February, if you don't recall, revise, re-revise, and last look 1 week before exam. Do you think this 28th February will add volume or number to your exam? No, you'll forget. These all things you'll forget. Okay, so please understand this game right now, because tomorrow is 1st of March. So we are entering into very critical zone now. Let us be super dedicated and structured. Not just hard work, but smart hard work, beta. Not just hard work, smart hard work. How will I get this information useful for me for the exam day? That's what the approach should be, beta. Okay, chalo. Now one MCQ, beta. Clinical scenario, beta. MCQ, please see. A person while having lunch suddenly gets choking and aphonia. A person while having lunch suddenly gets choking and aphonia. Aphonia also, beta. Aphonia also. A person while having lunch suddenly gets choking and aphonia. What happened, beta? What happened? Please look at screen, beta. What happened? The food particle is stuck as laryngeal foreign body. The immediate treatment is, write down, Heimlich maneuver. Heimlich. Heimlich maneuver. Spelling, beta. Immediate treatment is Heimlich maneuver. H-E-I-M, beta. Heimlich. H-E-I-I. This is I, beta. I. Heimlich. H-E-I-M-L-I-C-H. Heimlich maneuver. Heimlich maneuver, beta. Heimlich maneuver. Heimlich maneuver, how we do it? Pressure is given on the epigastrium in upward and backward direction. Pressure is given on the epigastrium in upward and backward direction. Pressure is given on the epigastrium in upward and backward direction, beta. Okay, fine. Now, look at screen, everyone. Look at screen, everyone. Please see what happened. Just look at this one, beta. Please see. Now, please see. Please see, brother. We have a guinea pig with us. This is, I hope you don't know, this is Hariom, our main techie guy, Now please see this patient, beta. Now this patient is having, यहाँ पे. This patient is having, you know, popcorns, and what he does, he actually swallows the. One second. One second, guys. Okay, shall I play it now? स्क्रीन कभी अड़ जाती है इसमें. One second. यहाँ से उठाते हैं दोबारा. हाँ, अब करना, रुको. हाँ, ठीक है. कुछ वीडियो चलते हैं, कुछ नहीं चलते. One second. Anyway, just look at this picture, that how we do the Heimlich maneuver. Let me show you. देखना बेटा अभी. चलो कोई बात नहीं, it's okay. We'll show it from here. एक मिनट रुकना. Now what happened to this child? This patient is, yeah. दोबारा कर रहे. करूँ? Mirroring. Done. Yeah. अब आ रहा है? ये चल रहा है. आई थिंक इसी में प्रॉब्लम आ रहा है. एनीवे कोई बात नहीं, दैट्स ओके. एनीवे, now please see, now this child, this is MCQ actually which has been asked in such a way that the patient was having food or lunch or dinner, whatever. They make a story like that, and then the patient suddenly gets choking and aphonia. Imagine you're eating biryani, you know, and suddenly you feel choked up and you're unable to breathe and you're unable to speak also. What happened? A piece of mutton or chicken got stuck between your vocal cords. So read your notes better. This is due to food particles stuck as laryngeal foreign body. And for this we have to do a maneuver to push the foreign body out, and that maneuver is called the Heimlich maneuver. This is Heimlich maneuver. That's a Heimlich maneuver. Come here. What we do is, for example, if this patient, and this patient is not like this, this patient is like about to die because it's choked up like. So what we do is we stand behind the patient and we just keep our hand over this, like you can keep like this also, or you can just do like this also and keep the edge of the hand over here on the epigastrium, and push it backward and upward. Don't press the chest, you push this epigastric area and you just push it back and up like this, back and up. What you're trying to do, you are pushing the diaphragm upward. This is diaphragm goes upward and thoracic pressure rises and the foreign body is pushed out. Basically, you want to push the diaphragm upward so that the thoracic pressure rises and the foreign body is pushed out, and the patient is saved. But if it fails, you do it how many times? 4 times. 1, 2, 3, 4 times. And if it doesn't work, then read the next line. Then we do what? Cricothyroidotomy. Then we do what? Cricothyroidotomy. Have you read your notes? Can you see this visual question? What is the name of maneuver? The hands are on the epigastrium and the direction of pressure is upward and backward. So that the thoracic pressure rises and the foreign body is expelled out. Am I clear? Fine. So this is the Heimlich maneuver. Don't forget this diagram. This can be a visual question for your exam also. What is the name of maneuver being shown in the picture? Okay, and read your notes also. If this fails, then we do cricothyroidotomy. Cricothyroidotomy. Anybody who remembers cricothyroidotomy? Remember cricothyroidotomy? Cricothyroidotomy is what? When you open it from here, you put a tube and give oxygen to that. You do that, and after some time you do a laryngoscopy and pull the foreign body out. But to save the patient, if Heimlich maneuver fails, then you do cricothyroidotomy. If you remember, this was an emergency airway procedure which can be done by opening the cricothyroid membrane over here. Okay, fine. Cha. This is about a general question, about a scenario-based question. Okay, fine. Heimlich maneuver. Yeah. So mugophonia is speech problem in public appearance only. How to remember it? M for mugophonia, M for mic. M for mugophonia, M for mic. Mic. So it's a psychological problem. You get too conscious of other people and you get confused on the stage. When you hold the mic, doctor, I'm otherwise absolutely normal, but when I am standing on the stage in front of strangers, I get so confused that I stammer on the stage. It's not a laryngeal problem, it's a psychological problem. But because it's phonia, I wanted you to understand. Mogiophonia means speech problem in public appearance only, beta. Okay, fine. So how to remember? M for mogiophonia, M for mic, beta. It happens on the mic. Okay, it happens on the mic, beta. Now, next one. Rhinolalia aperta or hypernasality, beta. So this was the voice disorder. Put a number 1, mogiophonia. Number 1 is mogiophonia and number 2 is rhinolalia aperta. We are doing the topic of voice disorder, beta, voice disorders. Rhinolalia aperta is hypernasality of voice. Hypernasality of voice, beta. Nasal element is too much, beta. Nasal element is too much, everyone. Hypernasality. Look at me, beta. Look at me. Hypernasality means nasal element is too much. If you remember, there was a Bollywood singer. Nowadays, he's a judge actually. Most of the time, he's judge. You know, in various shows. His name is Himesh Reshammiya. Himesh Reshammiya, remember? Himesh Reshammiya. He has got a very nasal sound, hypernasal sound. And that's, if you want to understand rhinolalia aperta, think about Himesh Reshammiya actually. He's a hypernasality of voice, beta. Now, all of you say Baba. Say Baba. 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 Now say Mama. Look at my lip movement, beta. Baba. Look at my lip movement. Everybody look at my lip movement. Baba, Baba, Mama. Baba, Mama. And both of them have got the same kind of lip movement. Baba, Mama. No difference, beta. No difference. How can the same lip movement produce two different types of sound? If nose contributes, the nose air contributes, the sound produces Mama. Mama is nasal contribution. If nose does not contribute to the sound, it is Baba. Baba, Mama. Baba, Mama. Okay? So what decides, will the nose contribute or will the nose not contribute? Palate, beta. Look at your palate, beta. Palate divides the nose from mouth. Would you agree? Palate divides the nose from the mouth, beta. If your palate is defective, your nose will mix with the mouth. If your palate separates the nose from mouth, if your palate is defective, it will create, you know, mixture of the nose air with the mouth here, beta. So, any problem of palate will cause a rhinolalia aperta. What are the causes? Everything palate, 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 palate. Cleft palate, submucous cleft palate, palatal palsy, palatal perforation, palatal weakness, also called velopharyngeal insufficiency. Palatal weakness, also called velopharyngeal insufficiency. Velo matlab velum. Palate is a curtain. Look at me, beta. Palate is a curtain. Soft palate is a curtain. Velum mane curtain. Velopharyngeal insufficiency mane weakness, beta. So any problem of palate will cause aperta. Everybody, how to remember it? Write down aperta. A-P-E-R-T. P for palate, beta. P for palate. P for palate, beta. P for palate. Okay, bache? Aperta. Aperta. P for palate. Okay, P for palate. So any problem of palate will cause aperta. Let us revise once again, beta. The causes of rhinolalia aperta, everything palate, palate, palate. Number 1, cleft palate. Number 2, submucous cleft palate. Number 3, palatal paralysis. Number 4, palatal perforation. And number 5, palatal weakness, also called as velopharyngeal insufficiency. My basic rule to remember is aperta has a P, P for palate. Any problem of palate will cause a rhinolalia aperta. Any problem of palate will mix the nose with the mouth hair. So it will be hypernasality of the voice. Means the nose will become more dominant, beta. Look at me. If you ever see a cleft palate child in your practice, cleft palate child in a practice, beta, then what will happen? When cleft palate is there, look at me, beta. When cleft palate is there, nose is mixing with the mouth. Nose air is mixing with the mouth hair, beta. Now this poor chap, this poor child with cleft palate will say Baba. He says Baba. The sound produces Bama. He says Baba. The sound produces Bama, like that. He said Baba, but the sound produces Bama because nose contributed. Nose got more dominant in the voice. Hypernasality. Baba becomes Bama, like that. Rhinolalia aperta or hypernasality of the voice, beta. Okay, fine. Chalo, beta. Okay, can we go further? Now, the third one is rhinolalia clausa. Clausa means close, close, beta. Just close nose, beta. Clausa, close nose. Clausa, close nose. Okay, nose is closed, beta. Nose is blocked, beta. Clausa means nose is closed. Nasal polyp. If your nose is full of polyp or a tumor, or nose is full of some other mass, there's no air. If there's no air, what will contribute? Nothing. Hyponasality means nasal component is less. Nasal polyp, adenoid hypertrophy. We'll discuss the next topic. Adenoid is behind the nose, beta. Adenoid hypertrophy. Adenoid is behind the nose. It grows like a big mass. You tell me, beta. If nose has blocked from behind, closed from behind, how the nose air will go in the mouth then? And a tumor, angiofibroma. Any mass like lesion which closes the nose, which blocks the nose, that causes rhinolalia clausa, hyponasality of voice, beta. Once again, let us read, beta. Let us see. Rhinolalia clausa. Clausa is closed nose. 3 causes to remember. Nasal polyp will close the nose, adenoid hypertrophy close the nose, and angiofibroma tumor will close the nose, beta. All these things which close the nose, which block the nose will cause a rhinolalia clausa or hyponasality of voice, beta. Now number 4 is functional aphonia or hysterical aphonia, beta. Functional aphonia or hysterical aphonia. Functional aphonia or hysterical aphonia, beta. Functional aphonia or hysterical aphonia, beta. among later functional aphonia or hysterical aphonia. Guys, please, it's a psychological problem, first of all. It's a functional matlab psychological problem. Functional matlab drama. Just right outside, patient is doing drama. Just to make it simple, drama. Patient is doing drama over there, beta. Patient is doing a drama over there. Drama. Patient has no problem, but patient is trying to create a scene, a drama over there. Hysteria means create a scene. Patient is pretending the symptom of loss of voice. Pretending means acting. In a simple language, acting, beta. Patient is pretending the symptom of loss of voice. Actually, there is no problem. Actually, the voice is normal, beta. Actually, the voice is normal. Actually, the voice is normal, beta. Patient is pretending the symptom of voice. Actually, the voice is normal. So, patient is doing drama. There is no problem, beta. Functional patient. You say functional patient. It's a very common diagnosis. Oh, no, it's a functional patient, beta. Please understand, beta. Please understand. We all are functional sometime in our life, beta. Remember school time? So, what school time? Today, you have a maths test. And you are not prepared. You had a cousin marriage, you were busy in that, you did not attend, you did not really, revise anything of the maths test, and maths teacher is cruel teacher. He's going to really give you a real good one. Now you are scared. You're scared today is a test. Now you, in the morning, 5:30 a.m. when your mom wakes you up, you go to your mother and you tell her, I have a bad stomach pain. I have a bad stomach pain. She's a kind lady, mothers are generally kind, creatures. She will say, okay, take leave today, no problem, take rest. You know what, then you go and you sleep in the same bed again at 8:30 a.m. in the morning. You go to the street and you start playing. You know what, I'm sure some of you would have done it for sure. That is also functional. You're doing acting of the stomach pain. Huh? Same here. This lady, this patient wants to attract the attention of everyone to herself, and that's why she's pretending the symptom of loss of voice. Actually, the voice is normal. Okay? More common in young female, beta. More common in young females. Sorry, ma'am. Sorry, ma'am. Sorry, ladies. But more common in young female in the bracket, especially 20-year-old. 20-year-old, beta. More common in young females, particularly 20-year-old, beta. 20-year-old. Okay? So typical question of MCI, beta. Very common question. 20-year-old female presenting with sudden loss of voice. 20-year-old female presenting with sudden loss of voice. What is the possible cause? Functional aphonia, beta. Just be careful, but just be careful. Okay? Imagine you are the emergency medical doctor in the hospital after your internship is over, and some family come, 4 or 5 members of family come with their daughter. When they say our daughter has lost her voice suddenly, and you ask what is the name, you say Anushka. They say Anushka. What is the age? You say 20 year. You recall this lecture, or ENT lecture. 20-year-old female, loss of voice, sudden, get lost. Chalo baar, kuch nahi hai. Don't do like this. As we get lost, chalo, baar chalo. Nothing like that. You are the patient has to find. It's not. It doesn't mean that every 20-year-old female with sudden loss of voice has functional aphonia, beta. It doesn't mean that. There may be some other genuine cause. There may be some other genuine cause over there, beta. So first prove the diagnosis. How to prove the diagnosis, beta? This is a very important question. MCQ. How to prove diagnosis? Very simple. Cough sound is normal. Cough sound is normal, and this proves diagnosis. Cough sound is normal, and this proves the diagnosis, beta. Cough sound is normal, and this proves the diagnosis. MCI question, beta. 20-year-old female with sudden loss of voice and cough sound normal. What is the possible diagnosis? Functional aphonia, beta. This is the cough sound. Cough is also sound, by the way. Cough sound comes from the vocal cord. Cough sound comes from the vocal cord, na? Cough is a sound, actually. Cough is a sound, and that comes from the vocal cord, beta. Guys, but do not do stupid mistake. You want to elicit cough sound? You want to elicit cough sound, beta? Don't. This lady is super intelligent. This 20-year-old female, college-going female, is super intelligent female. Let me tell you. She has convinced 5-6 family members of her family, very elder family members, and all of them are convinced that their daughter has got a genuine problem and she has lost her voice. And now the next target is you, beta. Now next target is you. And if you don't act smart, she will confuse you. Now she's looking at you. She wants to make sure that you are also trapped, actually. The doctor is also trapped. So now if the patient is intelligent, we are also intelligent. Don't you think so? If patient is smart, we are also super smart. Now, don't go to her and tell her that, ma'am, cough, please. Now, if you, sorry, ma'am, it's sir, actually, no? Ma'am, cough. If you tell this girl that, ma'am, cough, please. Now, she's an intelligent lady. She will say, why she's asking me to cough? And now she get an idea that cough is important for you to make some diagnosis. Now, she will never cough. अब उसको खांसी आएगी तो भी नहीं करेगी. Even if she wants to cough, she will never cough. You have given an idea to her now. If she is smart, you are also smart. Put a stethoscope, stand behind her and auscultate like this. Auscultate like this from back, and while auscultating, if she is acting, you are also acting with her. While auscultating, ask her to cough. Now she has seen in some Hindi movies, some Telugu movies, that every time doctor puts the stethoscope in the chest, generally doctor say, "Khansi karke dikhaiye, please cough, please." And the moment you say, "Ma'am, cough, please," and say, the once she coughs, the diagnosis is ready, better. Okay, so cough has to be elicited. Thank you very much. Cough has to be elicited, but not patient should not know that cough is important for you. Are you getting my point? Okay, so because she is intelligent, you are also some intelligent, So vocal cord movements are normal. vocal cord movements are normal यार, वो तो कुछ भी नहीं है ना. It's an acting treatment. Psychotherapy, not speech therapy बेटा. Psychotherapy because it's psychological problem ना. Psychotherapy, not speech therapy. Speech therapy क्यों देना है? गला ठीक है, दिमाग खराब है. गला ठीक है, दिमाग खराब है. Larynx is okay, mind is not okay, brain is not okay. Psychotherapy or psychiatrist consultation बेटा. Psychotherapy or psychiatrist consultation. Okay, psychotherapy or psychiatrist consultation बेटा. This is the topic which has been asked multiple number of times. Let's revise this topic. What is the name of topic? Functional aphonia or hysterical aphonia. It's a drama created by the patient. Beta. Patient is pretending the symptom of loss of voice, but actually voice is absolutely normal. This patient is acting over there. Now, this is seen in young female. Beta. Every time the question will come like that, 20-year-old female presenting to emergency with sudden loss of voice, functional aphonia. How to prove diagnosis? Important second question. Cough sound is normal and this proves the diagnosis. The one who can cough can speak also. The sound na. अगर आप खा सकते हो तो आप बोल भी सकते हो. This sound. The one who can cough can speak also. Okay. Vocal cord movement on examination are found to be normal. Treatment is psychotherapy. Don't write speech therapy. It's a psychotherapy, mind problem. Okay. Okay. Fine. Next topic, beta. Cancer larynx, beta. Cancer larynx. Somebody asked this question. Srinath. No, Srijit. Srijit has asked question. Common nerve injured in thyroid surgery, beta. Me and Dr. Vineet have put a common video on Miss channel, YouTube channel. You can see that video about the nerve injuries in thyroid surgery. You can just search, just see the YouTube channel of Miss. There is a common video between me and Dr. Vineet. We will discuss what are the nerves to be injured in what order, beta. Okay, that's a surgery topic. And Vikram has asked, any aspiration in omega-shaped epiglottis in laryngomalacia? No. Laryngomalacia baby does not aspirate, guys. Aspiration is not prevented just by epiglottis. Epiglottis is only 1/3 of the story, beta. Epiglottis is not going to create full protection. Epiglottis doesn't cover epiglottis is not the only factor to prevent aspiration, beta. There are other mechanisms also, like sensory nerve supply of the larynx and all that. Okay, fine. Okay, very good. Okay. Now, if you have any question, you can always, put in the group also, beta. That's not a problem, huh? Okay. Can you start cancer larynx, beta? Cancer larynx, first of all, it's more common in males, beta. It's more common in males in 40 to 60 years of age. Okay, cancer larynx is more common in males in 40 to 60 years of age. Females do not get this cancer. Mostly males are getting this cancer, beta. Now, risk factor is smoking. Everybody smoking is known. Number 2, alcohol also. You may not be knowing alcohol as a risk factor for this cancer, but yes, that is the case. Cancer larynx, the risk factor is smoking plus alcohol also. This cancer has 3 types, beta. Everybody, the cancer has 3 types, beta. Guys, can you tell me what are 3 divisions of larynx? Bolo, beta. 3 divisions of larynx, beta. Can you speak, beta? Number 1, glottis, supraglottis, subglottis. Same 3 cancer. Glottis cancer, supraglottis cancer, subglottis cancer, beta. Number 1, glottis cancer, beta. Anybody, what is glottis? Bolo dara. What is cancer? What is glottis? Vocal cord. What is vocal cord? True vocal cord. Yes, it is cancer of true vocal cord, beta. It is cancer of true vocal cord, and it's the most common site of laryngeal cancer. Most commonly, the cancer start from the vocal cord, beta. Okay, most commonly start from the vocal cord. Okay, bache. Now, everybody, look at screen. First of all, let me show you this one, beta. The vocal cord cancer, how do you look like? Just see over here. Can you see glottic cancer, beta? Glottic cancer is a cancer of true vocal cord. Where are we right now, beta? This is your normal vocal cord. This is your other vocal cord, and there is a cancer with the yellow arrow, beta. Can you see vocal cord, and this is the vocal cord cancer, glottic cancer. Now, can you tell me what will be the chief complaint of this patient, beta? All of you try this. What is the chief complaint of this patient? Chief complaint of this patient will be what? Hoarse voice. Very good. Hoarse voice, beta. है ना? Vocal cord problem is voice problem, beta. Okay? Chief complaint is hoarse voice. Next page, beta. Chief complaint is hoarse voice, beta. MCQ. Chief complaint is hoarse voice, beta. H-O-A-R-S-E. Hoarse voice. MCQ, beta. What is symptom of glottic cancer, beta? Hoarse voice, beta. Simple logic, beta. Larynx में there are only 2 symptoms mainly. What are 2 symptoms? या तो आवाज नहीं आ रही या सांस नहीं आ रहा. You know what? If the problem is vocal cord, voice is the problem. If some edema is there, some cancer is there, some other things are there, then breathing may be a difficulty. Vocal cord palsy is there, breathing may be a difficulty. Okay? So larynx has got major 2 symptoms: voice problem, breathing problem. Voice problem, breathing problem. Okay? Fine. So vocal cord problem, voice, hoarse voice. There are no neck node metastasis. Anybody? Why? Write in the chat box, beta. Write in the chat box. I want you to answer this question in the chat box. I'm waiting for 10 seconds. There are no neck node metastasis in glottic cancer. There are no neck node metastasis in glottic cancer, beta. There are no neck node metastasis in glottic cancer. Why so? Can you write in the chat box, beta? Can you write in the chat box? Why so? Because what? Because vocal cord have no lymphatics. Very good. Everybody, did you answer this question? Vocal cord have no lymphatics, beta. Vocal cord have no lymphatics, beta. Vocal cord have no lymphatics, beta. Vocal cord have no lymphatics. Okay, okay, very good. Yes. Very good, beta. Datti Vikram rightly said that. Vocal cord have no lymphatics, beta. Very good. Wasim, a lot of people are answering this question. Wonderful. There are no lymphatic drainage, beta. There's no lymphatic drainage, beta. Very good. Wonderful. Very nice. Great, beta. Very good. Thank you, Akshay. Very good. Pushpendra. Gaurav Mane. No lymphatic. Yes. Vocal cord have no lymphatics. Therefore, no nectar metastasis. Therefore, put an symbol. Therefore, good prognosis. Very good. Vocal cord have no lymphatics. So, there are no nectar metastasis. So, therefore, vocal cord cancer or glottic cancer has got a good prognosis, beta. Number 2. Supraglottic cancer, beta. Supraglottic cancer. Very good, beta. Very good, Akshay. Very nice. Yeah, lymphatics are absent, beta. Very nice. Perfect. I'm glad that you are in sync with the class, beta. Supraglottis cancer, beta. Supraglottic cancer above the vocal cord. Most common site is epiglottis, beta. Epiglottis. Most common site is epiglottis. Epiglottis, beta. Remember, vocal cord upper covered by, partially covered by epiglottis. Supraglottis. Above the vocal cord is epiglottis. Most common site is epiglottis, beta. Clinical features. Clinical feature. Number 1, throat pain referred to ear, beta. Throat pain referred to ear. Throat pain referred to ear, beta. Very good, beta. I'm glad that you're participating in all this. Do participate, beta. Participating in all these questions on the chat would really make this class more interactive. I know it's a virtual medium, but we can always feel that, okay, we are together. And then nobody is judging you, beta. Nobody is judging you. It's not, nobody is evaluating you that, okay, you are the real champion. I don't want champions. I want everyone to pass the exam. I want you to understand, make mistakes here. You are allowed, you are welcome to make mistakes here, so that later on in the exam day, when you play the World Cup, you don't do the mistakes, same mistakes, beta. Okay, this is a gully match, beta. It's a gully match. It's not even a district match, beta. It's a gully match. Gully cricket is being played. The day you play the World Cup on the 4th of June, what I want is you do all the mistakes now, so that you know what mistakes I do, and you don't do those mistakes on that day. That's how we save you from those mistakes, beta. So we are not judging you, we are not evaluating you, we are just assisting you, beta. Feeling of lump in throat. Feeling of lump in throat. There is a mass in the throat, feeling of lump in the throat, beta. Okay, lump in the throat. Some of you, beta, may be having this feeling of foreign body sensation in the throat. Mera gala saaf nahi hai. There is something stuck in my throat always. My throat is not clear, but that is not feeling of lump in throat, beta. Don't tonight, when you revise the topic, you say, your brain will say, I think you have got feeling of lump in throat. I think you are smoking. I think you have developed cancer. I think you're not going to survive. Then why should you study? Beta. Brain bolega कि भाई गले में कुछ हो रहा है, किचकिच होती है ना, तुम्हें शायद सिगरेट पीते हो. ब्रेन बोलेगा हाँ कैंसर हो गया, हाँ बचना तो है नहीं, हाँ तो पढ़ने का फायदा क्या, सो जाओ ना भाई, सो जाओ. Brain will tell you 10 reasons not to study every night. Kill that thought. कोई कैंसर वैंसर नहीं है. This feeling of foreign body in throat is very common otherwise also. Do you have dysphagia? No. भर भर के खाते हैं छोले भटूरे कुलचे डोसा सांबर, dysphagia है नहीं ना. Other symptom are also there ना. Throat pain referred to ear, feeling of lump in throat, dysphagia, and number 4, my favorite, hot potato voice. Hot potato voice, beta. Hot potato voice, beta. If you are now, look at me, everyone. Hot potato voice. If you are hearing, when you hear this word, and your brain is saying that this word came earlier also somewhere, but you are not able to recall where this word came, it means that your brain is perfectly normal brain. It means your brain is perfectly normal brain. This is the way brain works. Then when you revise this tonight, when you go back, oh, epiglottitis also had same kind of voice. That is epiglottitis. This is epiglottic cancer. Oh, some mass there, some mass here, beta. ऐसे याद हो, ऐसे अभी नहीं याद आएगा, अभी तो सिर्फ तुम्हें इतना लगा. This one you should feel, oh, this word has come earlier today in the class. Where it came, I'm not able to recall it. It means your brain is perfectly normal brain. Okay, don't over criticize yourself. Try to love yourself the way you are. You are a unique creation of nature. Love yourself. Whatever you are for others, it's their business. But whatever for you, you should love yourself. You should like yourself. You should really, it's okay. It's just the way you are, beta. We are overcritical about ourselves. Our schooling system makes us overcritical about ourselves. They assess us in a wrong way. You know what? Some of the other things. And then we start feeling that we are mediocre. We are not. We are okay. We are not brilliant. I don't want to be brilliant. I don't want to be brilliant, honestly. Being brilliant is really a load to carry, a very huge burden to carry. I don't want to become that. I'm just an average, common human man. Human, I want to be like this only. But yes, I'm not really, I don't want you to be overcritical about yourself. Let's follow a scheme of preparation and let's follow the right path of preparation. After third revision, we'll be able to recall a lot of things better. Okay? Hot potato voice better. Okay? Now, subglottic cancer. Anybody what is subglottis better? Remember, subglottis is the empty space in the cricoid ring better. You draw it. I hope remember subglottis is the empty space in the cricoid ring better. Okay? This is a rare cancer. Now, if in this area, there is a cancerous growth beta, what it will cause is stridor beta. Stridor, chief complaint is stridor beta. You know why? Subglottis is only air and air beta. Subglottis has got no structure. If you remember, if cricoid is a ring, subglottis is the empty space in that ring. If that ring has got air space, if that ring develops a cancer inside that, the airway is obstructed. Whenever airway is obstructed, you have got a stridor. Beta. Okay? Now. Perfect. Now let us do tumor staging of laryngeal cancer. Beta. T1, T2, T3, T4. T1, T2, T3, T4. Beta. Let us do that. T1, T2, T3, T4. T1. T1 is only one structure involved. Only one structure involved. Only one structure involved. Beta. T2, more than one structure involved. T1 is one structure involved. Okay. T2 is more than one structure involved. More than one structure involved. Okay. For example, look at me, beta. If tumor involves epiglottis only, T1. If tumor involves epiglottis and vocal cord, T2. T3, vocal cord is fixed or immobile, beta. This is the question possible in your exam. It has never come in MCI till date, but if the question comes, it will be of T3, beta. T3 is very classical thing. T3 matlab vocal cord fixed. Vocal cord fixed matlab vocal cord immobile due to cancer, and that's T3, beta. T4 is invasion of thyroid cartilage. T4 is invasion of thyroid cartilage, beta. T4 is invasion of thyroid cartilage. Okay, invasion of thyroid cartilage. Thyroid cartilage got invaded, beta. Let us revise this, beta. It has never come in your paper, but still, higher level questions. T1, bolo beta, bolo. T1, everybody speak up with me. Are you with me are you with me? Are you imagining that we are together? T1 means what? Only one structure involved. T2 means more than one structure involved. Okay, when I say tumor involving epiglottis, only T1. When I say tumor involving epiglottis and epiglottic fold, two things, T2. But T3, the classical thing, T3 means vocal cord is fixed or immobile. Beta. Immobile or fixed vocal cord, 100% T3. And if thyroid cartilage is invaded, T4. Beta. Now treatment. T1, T2 is radiotherapy. T1, T2 is radiotherapy. Beta. T1, T2 radiotherapy. T1, T2 radiotherapy. Beta. Radiotherapy. Okay. T3, T4 is total laryngectomy followed by radiotherapy. Total laryngectomy plus minus one more surgery, beta. Plus minus radical neck dissection surgery, beta. Radical neck dissection surgery. R&D surgery, beta. Plus minus. Okay, if there is no neck node, every tumor, there may be neck node metastasis, there may not be neck node metastasis. If there is neck node metastasis, then you do R&D surgery also. What is R&D full form? Radical neck dissection surgery, beta. Radical neck dissection surgery. Okay, followed by radiotherapy. Beta. Okay, followed by radiotherapy. Treatment of choice for T1, N0, M0 glottic cancer nowadays. This is the latest thing, beta. Nowadays, treatment of choice for T1, N0, M0 glottic cancer means glottic cancer. Highlight the word vocal cord cancer, beta. For T1 glottic cancer, beta. T1 glottic cancer. Niche likh lo jaye. Laser is a better answer than radiotherapy nowadays. This is a new thing. For T1 glottic cancer, laser is a better answer than radiotherapy. If particularly the MCQ is about T1 glottic cancer, I will look for the answer choices. If laser word is written over there, I'll mark laser as a right answer. I'll mark laser as a right answer. Okay, bache, fine. And one line after that. After total laryngectomy, patient has got permanent tracheostomy. Permanent. When you do laryngectomy, patient has got permanent tracheostomy. After total laryngectomy, patient has got permanent tracheostomy. Everybody speak with me, beta. Let's revise this topic. T1. Everybody T1. T1 is what? One structure involved. T2, bolo beta. T2, more than one structure involved. T3, vocal cord is fixed or immobile. Important question T3. T4, thyroid cord is invaded. Treatment for T1, T2, radiotherapy. T3, T4, total laryngectomy. Big tumor, big surgery. Total laryngectomy plus minus R&D surgery. What is R&D? Radical neck dissection surgery. If there is a neck node present, metastasis present, then you do R&D surgery. Plus minus R&D surgery followed by radiotherapy. But nowadays, treatment of T1 glottic cancer has changed. If question particularly is T1 glottic cancer, treatment will be laser is better answer than radiotherapy. Beta. Laser is a better answer than radiotherapy. Beta. Beta. Laser is a better answer than radiotherapy. Okay, fine. Beta. Fine, very good. After total laryngectomy, patient has got permanent tracheostomy. Permanent tracheostomy. Okay, now let me show you. Now please see, this is the incision. This is total laryngectomy surgery, beta. You elevate the flap, beta. Okay, fine. Now this is what beta, which cartilage? Thyroid cartilage. This is cricoid cartilage, trachea beta. Thyroid cartilage, cricoid cartilage, trachea. You separate from this side, then separate from above also beta, over here. Because this is, you have to separate. This is laryngectomy. You have to remove this much part. Laryngectomy, you have to remove this much part beta. Okay, fine. You separate it from sides, you separate it from above, and then you separate it from below also beta, from the trachea also. Did you notice? Okay, did you notice that beta? We just separate from the trachea also beta. Okay, then now you are saying goodbye to larynx beta. Okay, please hear. The larynx has been removed. Total laryngectomy has been done beta. Okay, now what to do with the trachea? Now trachea is left only over here now beta. Please understand, the specimen went out, only trachea is left. Now what to do with the trachea beta? Please understand, it's a very tricky situation. Now only trachea is left over here, just up to the sternum beta. Either up to clavicle is at this level. After that nothing is over here beta. How to fill this gap now? ऐसा तो है नहीं that you can pull the trachea like a bamboo and like fix it or stitch it behind the nose so air goes there. That's not possible. It's not a spring beta. It's not a spring na, that you can pull the trachea and stitch it back to the nose. That's not possible. Now what to do beta? Because larynx is gone. There's nothing over here. How to maintain the continuity of the air now? So the air goes into the lungs actually. Now the only option left is you have to stitch the edges of the trachea to the edges of the skin beta. Permanently suturing the edges of the trachea to the edges of the skin of the neck. Okay. Look at skin beta. When the surgery is about to end, you make a hole or make a cut in the skin of the neck beta. Did you notice that beta? Now please see. I am stitching the edges of the skin with the edges of the trachea beta. This is skin, and after 7 days beta. This is the, please see, the edges of the skin have been sutured to the edges of the trachea. Now there is no connection upstairs beta. Larynx is gone. The air has to go from here into lungs and come out of here only beta. This, after 7 days you remove the suture. Now this hole will be permanently visible in the neck of the patient like this forever beta. It's a permanent hole in the neck of the patient. Now this hole will not be closed beta. Now there is no connection over here beta. There is no connection upstairs my dear friends. There is nothing over here beta. Nothing over here. This is the end. The trachea is here beta. You suture the edges of trachea to the skin. Now air go from here, air comes out from here beta. Okay, fine. This is trachea, then the bronchi beta. Okay, so the air is going from here like that. There's no connection upstairs. You are not breathing from nose. You're breathing from the neck now. This is the direct entry into the lungs for the air. You not breathe from here, you breathe from the neck hole actually. Am I clear beta? Fine. Now, can this patient speak beta? Laryngectomy has been done. Can the patient speak? Technically no, na, but science can help him. We can train the person to speak still with special things like, next topic beta. Next topic is the voice production after laryngectomy beta. Next topic everybody. Voice production after laryngectomy. Just draw a line beta, beta. This small thing. 3 methods beta. There are 3 methods. Number 1, esophageal voice is a poor method. The basic method is you can train the person to speak using esophagus with speech therapy training, but it's a very bad method beta, poor method. It's impractical, it's useless, only namesake. The second one, very commonly used is this one beta, electrolarynx or artificial larynx. This is very, very common, electrolarynx or artificial larynx. It is, what is, it is battery operated. It is battery operated external vibrator. It is battery operated external vibrator beta. There is a charger with it. There is a battery inside this device. You have to keep it in the pocket of yours. And when you want to speak, you have to use it beta. It's a battery operated external vibrator. It's an external instrument beta. It's called electrolarynx or artificial larynx beta. Electrolarynx or artificial larynx. Look at screen beta. How you use it? Like this beta. You charge it and then you touch it like this beta. Over there beta. Can you see this is approximately this is the length of the device of this much device. You know, you just charge it, keep it in your hand, and when you want to touch, when you want to speak, this is the vibrating surface. You touch it like this. You touch it like this, and then you can speak. It costs around 6,000-7,000 rupees. Very affordable. Very, very successful. There's an electrical sound, but you can understand it. Doctors can understand it. Our ears are tuned. Families start understanding within a week time, and people can communicate very easily beta. Very easily. It looks difficult, but you know, after a few months, people adapt to it. Families adapt to it. They start communicating with the patient very effectively. But it's external vibrator. It's dependent on a battery beta. I saw a patient in one of the OPDs. The patient came after 3 months of surgery. He has started using the vibrator, this electrolarynx or artificial larynx, and he came with his wife. In the OPD, he and his wife started fighting on some point, on some issue. They had a fight in the OPD only. Now the wife was speaking from here, and this guy was replying from here. The fight was going on pretty well. The match was going equal. She was saying something from here, and he was replying like this. And full force fight was going on, but suddenly the battery got drained. The battery got drained, and this poor chap lost the match. Beta. Can you fit something in the body which can make you speak without need of any battery beta? In the body, inside the body. Right? And what is that? Number 3. Number 3 is tracheoesophageal puncture device beta. Number 3 is tracheoesophageal puncture device. TP device, tracheoesophageal puncture device. Example is Blom Singer prosthesis. Blom Singer prosthesis. Its internal device, it is a unidirectional valve. Blom Singer prosthesis, it's an internal device. Electrolysis, artificial device, external device, this internal device. This valve you fit between trachea and esophagus. What is the name of the device? Tracheoesophageal puncture device, beta. TEP device. Tracheoesophageal, TEP device. Tracheoesophageal puncture device, it is internal device. You fit in the body, okay? And in the bracket, go, it's a unidirectional valve, beta. Can you see the valve-like thing, beta? And when you fit in the body, it looks like this, beta. This you put it surgically, beta. Okay, this is way. Can you see TP device, beta? This is the tracheostomy hole, beta. Tracheostomy hole, and this is the posterior wall of trachea, and through that you can see a valve-like device over there. This is the TEP device, beta. Tracheoesophageal puncture device, beta. TEP device. Am I clear, beta? Let us devise once again, beta. Voice production after laryngectomy. Number 1, esophageal voice. Poor method. But number 2, this one is electrolarynx or artificial larynx. It is a battery-operated external vibrator. Like this. But the best one is the third one. The third one is tracheoesophageal puncture device. What is the example of that is? Bolo beta. What is the example is? Blom Singer prosthesis. It is a unidirectional valve. It's an internal device you put in the body like this, and this helps you speak without the need of any battery actually. Okay, fine. TP device, beta. But my dear friends, the hole will be there always in your neck, beta. This hole, beta, will be there, beta. If you are thinking, Rajiv, this can cause infection. Yes, it can cause infection, beta. It direct entry into lungs. You have to, keep it covered with something. If you think flies can go inside, yes, they can go inside, they can roam around, and they can come out also. Can you jump in the swimming pool with it? No, you will die in an instant, beta. The moment you jump in the swimming pool, the water will directly fill into your lungs and you will just die. Can you take a shower? That will be antim shower, beta. That will be your last shower. The moment you switch on the shower, the water will go into your lungs, aspirate, and you die. You know what? Hana? But people learn to live with it. People learn within 2, 3, 6 months. They learn to live with it. They keep it covered with some cloth. They will wear some high, collar shirts and all that, and they will learn to survive with it. Am I clear, bache? Fine. So this is actually the electrolarynx, or this thing. But people learn to live with it. But I remember one patient who got super comfortable with the tracheostomy like this. Beta. He had laryngectomy done 6 months back. AIMS New Delhi OPD. Remember what he was doing there. In the OPD in the evening, he came for follow-up after 6 months of surgery. You know what he was doing? This bugger, he was smoking from here. इधर से बीड़ी पी रहा था, यहाँ से ऐसे रखे ना, इस होल में से, इधर से यहाँ से बीड़ी रखे, सिगरेट रखे, यहाँ से बीड़ी पी रहा है. इतना comfortable हो गया. So much comfortable that he started smoking बीड़ी from here. Then one of the PGs asked him, Baba, what are you doing? Again he started smoking. Baba was super cool, Baba. So Baba picked up his electrolarynx, switched on the electrolarynx, kept it over here, and he told him, in Hindi he said that. Hindi said, जो होना था हो गया, अब सब ठीक है. In English he said that, whatever had to happen has happened, now everything is all right. No problem, I'm absolutely all right. Now this PG said, Baba, you smoke from here now, you can get lung cancer also. Baba, तुम बीड़ी पीते रहे ऐसे, तुम्हें lung cancer हो जाएगा. Baba was super chilled out. Baba ने switch दबाया, Baba ने यहाँ रखा, and Baba says that, मुझे आप में पूरा भरोसा है, आप उससे मुझे बचा लोगे बेटा. In English he said that, I trust the doctors and they will save me from the lung cancer also. So I am absolutely all right. So the life goes on, beta. You feel that, after tracheostomy, this kind of permanent hole in the neck, the life is not really that great. After a few months, the people adapt to live with it and they start living the life pretty okay. Not great, but pretty okay. Okay. This is electrolarynx. This is a laryngectomy in 3 ways how you speak after laryngectomy. Okay. Ciao. Now let's go further, guys. Now the next one. Level of neck notes, beta. Level of neck notes. Okay, level of neck notes. 1A submental, 1B submandibular, beta. Neck note are 7 level, beta. Write down, beta, 1 to 7. 1 to 7, beta. 1 to 7. Total level neck 1 to 7. Pramod. Okay. 1 to 7. 1A submental, 1B, beta. Not LB, beta. 1B. 1 has got 2 types. 1A, 1B, beta. 1A, 1B. 1A is submental, 1B is submandibular neck notes, beta. Submental and submandibular neck notes, beta. Okay. Now, 2, 3, 4. All of you draw the muscle. This muscle is sternocleidomastoid muscle, beta. Sternocleidomastoid divide to 3 parts like this. 2, 3, 4. 2, 3, 4. 2, 3, 4. Upper deep cervical, middle deep cervical, lower deep cervical. Upper deep cervical, middle deep cervical, and lower deep cervical. Okay. Deep to which muscle? Deep to sternocleidomastoid muscle. So below the upper 1/3 are the level 2 upper deep cervical, below the middle 1/3 are level 3 or middle deep cervical, and below the lower 1/3 are lower deep cervical or level 4 beta. Level 5 is posterior triangle. Posterior triangle also called as supraclavicular. Supraclavicular lymph node beta. This is MCQ beta. Supraclavicular lymph node. Posterior triangle also called supraclavicular lymph node beta. Supraclavicular lymph node. Level 6 is anterior compartment or pretracheal, also called as Delphian lymph node. Delphian. Delphian lymph node, DELPHIN. Okay, level 6 is anterior compartment or pretracheal or Delphian, DELPHIN, Delphian lymph node, Delphian lymph node. And level 7 is mediastinal lymph node. Level 7 is mediastinal lymph node. Mediastinal lymph node. Level 7 is mediastinal lymph node, and a doctor must know these levels, neck node. Okay, anatomy and otherwise in your clinical life also you'll need it. We have another person to help us. Either better. Now, please see. Now, this is the mandible, beta. Mandible. This is 1A. 1A is submental. Okay. Then mentum is the chin. Mentum, submental. 1B is submandibular, beta. Okay. Here, when you touch this area, this is 1B. Now, look at this one, beta. Look at this one. What is this muscle, beta? Can you see this muscle? This muscle is sternocleidomastoid muscle, beta. Sternocleidomastoid. Now let us divide this muscle into 3 parts. Upper 1/3, middle 1/3, lower 1/3. Below the upper 1/3, when we palpate our finger like this is which lymph node? Level 2 or upper deep cervical. Then we come below the middle 1/3, when we palpate like this lymph node is level 3 or middle deep cervical. And then finally, below the lower 1/3, we have got level 4 or lower deep cervical lymph node. Deep to which muscle? Sternocleidomastoid muscle. Then we have another muscle here, beta. Please see, we have another muscle. This muscle is what? Trapezius, beta. You know trapezius? Sternocleidomastoid and trapezius. And this triangle is called posterior triangle. If you touch your posterior triangle, this is above the clavicle, beta. Clavicle. Now this is called level 5 or posterior triangle lymph node or supraclavicular, because this is right above the clavicle. And finally, level 6, beta. Level 6 is here, beta. Here. This is pretracheal. Pretracheal, also called as anterior compartment. Is it anterior compartment? Anterior compartment or Delphian lymph node, beta. Delphian lymph node. And level 7 you can palpate, that's in the mediastinum or in the thorax or chest, beta. So once again, beta, revise with me. 1A submental. Everybody, 1A submental. 1B submandibular. Now 2, 3, 4. 2 is upper deep cervical, 3 is middle deep cervical, 4 is lower deep cervical, and level 5 is posterior triangle or supraclavicular, and level 6 is anterior compartment or prelaryngeal or Delphian lymph node, and level 7 is mediastinal lymph node. Now what happens is, when you get a head and neck cancer or oral cavity cancer or laryngeal cancer or other cancer, all these cancer have a chance of metastasizing to the neck node, okay, neck node, and that's called secondary neck or the metastatic neck node. When you get a metastatic cancer or a metastatic neck node, you do a surgery called R&D. What is R&D? Radical neck dissection surgery, beta. Okay, radical neck dissection surgery, if you see the next topic, R&D surgery, the better. Radical neck dissection surgery, if you see this topic, R&D surgery, beta, it's a surgery, read your notes, beta, it's surgery done in metastatic neck nodes, beta. When you get secondary neck node, you do the surgery called R&D surgery or radical neck dissection surgery. Now look at the name, beta. Radical neck dissection means you clear the neck radically. You don't want to leave a single cancer cell in the neck. For that, you remove the neck nodes. You also remove all those structures which are coming in contact with these neck nodes, so that not even a single cell of cancer is left in the neck, beta. So what you remove is level 1 to level 5 neck nodes. Then you have to remove this muscle, beta. Write down the number 2. Number 2, fill in the blank, beta. Number 2, which is this muscle, beta? Sternocleidomastoid muscle, beta. Sternocleidomastoid muscle. Why sternocleidomastoid muscle is being removed? Because this muscle is coming in contact with 2, 3 and 4 lymph node, beta. Then which vein is there, beta? Which vein is there? Internal jugular vein, and most of the neck nodes are lying around the internal jugular vein like beads, beta, like beads. So you remove the internal jugular vein also. Then there is a nerve passing from here, 11th nerve or accessory spinal nerve. And then finally we remove one more muscle, omohyoid muscle is here, beta. Omohyoid muscle we also remove that. And finally 2 glands, beta. One gland is, which gland is this? Salivary gland. Which gland is there, beta? Yes, submandibular salivary gland. And this is parotid gland, the tail of the parotid gland. We are removing all these structures to clear the neck radically of all the cancer cell, and this surgery is called radical neck dissection surgery. Okay, thank you very much. Okay, radical neck dissection surgery. Okay. List of structures removed in R&D are level 1 to level 5 neck nodes. Number 2, sternocleidomastoid muscle. Number 2, sternocleidomastoid muscle, internal jugular vein, accessory spinal nerve, omohyoid muscle. Remember 2 muscle, beta, omohyoid muscle and sternocleidomastoid muscle. omohyoid muscle and sternocleidomastoid muscle are removed. Tail of parotid gland and submandibular gland. 2 glands, 2 muscles. Beta. Okay, tail of parotid gland and submandibular gland. Beta. These are 2 salivary glands. Beta. Basically, you are trying to clear the neck of all the possible cancer cells. Beta. Am I clear? Fine. Let's revise. What is R&D surgery? Beta. R&D surgery, radical neck dissection surgery. Everybody, what is the indication? This is done for metastatic or secondary neck nodes. We are removing lot of structure of the neck so that we clear the neck radically. We do not leave a single cancer cell in the neck. For that, we sacrifice a lot of structures. Beta. Number 1, level 1 to level 5 neck nodes. Number 2, sternocleidomastoid muscle. Number 3, internal jugular vein. Excessive spinal nerve, 1 nerve, 1 vein, 2 muscle. 1 nerve, 1 vein, 2 muscle and 2 glands. Beta. Okay. 1 nerve is excessive spinal nerve. 1 vein is internal jugular vein. 2 muscle are sternocleidomastoid and omohyoid muscle. And 2 glands are tail of parotid gland and submandibular gland. Beta. And level 1 to level 5. Not all. Beta. Level 1 to level 5 neck nodes. This question comes in general surgery. They say all of the following are removed in R&D except. So you should know all. 2 muscle are removed. Beta. Sternocleidomastoid and omohyoid. Beta. Okay, omohyoid. Okay, fine. Now, let us do the last topic of larynx is tracheostomy related question. Beta. Tracheostomy related question. Okay. Now, first of all, site of tracheostomy. Beta. Most common site of tracheostomy. Before that, let us see the basic steps of tracheostomy. Beta. Please see, this is your neck and tracheostomy is an emergency surgery for the airway. First, you give the incision on the neck. And then you open up the neck quickly. It's a very quick surgery. It's an emergency surgery. Patient is dying. You quickly open that. Then you see the fat over there, the fascias of the neck. Then you open that also. Then below that you see muscle of the neck. Which muscle? Strap muscle of the neck. You know muscle of the neck over there. You open them also. Then you just separate them. And then you see over there is a gland called, which gland? Thyroid gland. Thyroid gland. Then you cut it in between thyroid gland. This is purple is thyroid gland. And then you expose the trachea. Expose the trachea. Am I clear? Then you expose the trachea. Okay, now trachea has been exposed. Now, everybody, just see over here. Trachea has been exposed. Now, where to do the tracheostomy is the answer. Site of tracheostomy. Everybody, where to do the tracheostomy is the question now. Okay, now, please see on the screen. Please see on the screen. This is what you have achieved by now. Okay, now if you can tell you, please see, larynx is here, beta. Larynx is here. Okay. Okay. Now, this is your cricoid. After this is larynx. No? Cricoid is the final part. Now, then trachea comes. No? Trachea. First ring of trachea, second ring of trachea, third ring of trachea, fourth ring of trachea. First, second, third, fourth. Beta. Now, the question is, most common site of tracheostomy is the second and third tracheal ring. Beta. We make a hole at here. Beta. We make a hole in this area. Beta. Second and third tracheal ring. Okay. Beta. So, you make a hole at second and third tracheal ring. Beta. Just see on the screen, beta. Let me show you. Just see on the screen once again, beta. Please see on the screen the same thing. Now see over here, where you're making the hole between second and third. Notice, beta, over here, you make a hole between second and third tracheal ring. Bache. Am I clear, beta? Fine. Where you make the hole? This is cricoid. This is the first ring, second ring, third ring. You make a hole at second and third tracheal ring, and this type of tracheostomy is called mid tracheostomy. Mid tracheostomy, beta. Am I clear? Mid tracheostomy. Okay, bache? Mid tracheostomy. Now, all of you see the notes, beta. Also, this is the workbook. Now, this is called mid tracheostomy. Now, we leave the first ring to prevent damage to larynx. Beta. We leave the first ring to prevent damage to larynx. Okay? We leave the first ring to prevent damage to larynx. Beta. Now, there is something called high tracheostomy. This is the MCI question. Beta. High tracheostomy MCI question. High tracheostomy start from first ring. Write down. It is done at first and second tracheal ring. High tracheostomy is done at first and second tracheal ring. Beta. High tracheostomy means high. Mid is 2 and 3. High is first and second. High tracheostomy is done at first and second tracheal ring. This is done for cancer larynx, and this is the popular MCI question. Beta. What is the indication of high tracheostomy? Is cancer larynx. Beta. Okay. It is done for cancer larynx. Normal tracheostomy is mid tracheostomy, and this is done at second and third tracheal ring. And the high tracheostomy start from first ring. This is done for cancer larynx. Beta. Am I clear, beta? High tracheostomy start from first ring, and it is done at first and second tracheal ring, and mid tracheostomy is at second and third tracheal ring. 99.99% tracheostomies are done at second and third tracheal ring, but in cancer larynx we do high tracheostomy, and that is done at first and second tracheal ring. Am I clear? Now, next question. Tracheostomy reduces dead space by 50%. Very good. 50%. Tracheostomy reduces dead space by 50%. Tracheostomy reduces dead space by 50%. Now look at me, look at me. What is the dead space? Physiology, not ENT. I hope you know, from here to here, the air goes waste only. There's no exchange of gases happening in this area. The only exchange happens in the alveoli over here. Alveoli over here. Okay, the only exchange happens in the alveoli. So actual useful air is alveolar air. From here to here, the air goes waste in the passage. This is called dead space. Now when you make a hole here, you are breathing from here. At least this much effort is saved, but this much is still pending. Dead space is from here to here. When you make a hole over here midway, okay, and you breathe from the neck, this much dead space is, okay, 0 now, but this much is still pending. So tracheostomy reduces dead space by 50%, 50%. Now, tracheostomy is a temporary procedure, except after total laryngectomy, Remember, after laryngectomy, you will have permanent tracheostomy. I told you, after laryngectomy, there is a permanent hole in the neck. Otherwise, tracheostomy is only for few days or few weeks or few months, But after laryngectomy, you have got permanent tracheostomy. Okay, one question of NEET PG. Tracheostomy can lead to apnea. Apnea means breathing stops. If you don't know apnea, write down apnea in the sidebar. Use the sidebar. Apnea means breathing stops. Sometimes I've seen also, you give a cut on the trachea. Suddenly the breathing stops. Oh, breathing stops. Why? This is due to, technical word, this is due to CO2 washout. Tracheostomy will lead to apnea, MCQ, this is due to CO2 washout, carbon dioxide washout. But the technical word is CO2 washout, carbon dioxide washout, CO2 washout. Okay. Now what is CO2 washout? Everybody look at me, look at me. I hope you remember that carbon dioxide is a stimulus for respiratory center of the brain. CO2 in the blood is a stimulus for respiratory center of the brain. Now, patient was having difficulty in breathing. That's why you are doing tracheostomy. Due to difficulty in breathing, the body was having retention of CO2. Blood was having high CO2 levels. But when in the evening you gave a cut on the trachea, the whole CO2 leaked from the body in one instance. The whole CO2 leaked from the body in one go. It leaked. The blood CO2 level comes down. The brain respiratory center is stimulated by CO2 only. So CO2 stimulus is not there. For some time, the brain respiratory center do not get stimulated and the breathing stops for some time. But within few seconds, again CO2 accumulates in the body and again the respiratory center gets stimulated and the breathing starts again. But for some seconds after tracheostomy, breathing stops, and that is called apnea. Tracheostomy leads to apnea due to CO2 washout. Okay. Next question is, tracheostomy can lead to surgical emphysema. Surgical emphysema. Tracheostomy can lead to surgical emphysema. What is surgical emphysema? It is air in subcutaneous area. Air in subcutaneous plane, Air in subcutaneous plane, Air in subcutaneous plane. Tracheostomy can lead to surgical emphysema. Underline the word surgical emphysema, MCQ, MCQ. Let us not confuse emphysema with the emphysema of lungs. This is a very funny word. It's a very funny, confusing word, and you might write emphysema thinking it's a lung problem. No. Surgical emphysema means there is some collection of air below the skin. Air in subcutaneous plane is technically called surgical emphysema. Air in the subcutaneous plane is called surgical emphysema. What do you mean by this? Look at me, I hope you know, in tracheostomy you have made a hole in the neck of the patient, okay, in the trachea. Don't you think so? From that hole of the trachea, what will happen? Some air will leak and that air will collect below the skin, When you touch the skin of the neck, this air, this green is the air. Now when you touch the, look at me, when you touch the skin of this neck, you will feel air crackles over there, because from the hole of the trachea, some air leaked from that hole of the trachea and that started collecting below the skin of the neck, and this collection of air below the skin is called a surgical emphysema, or surgical emphysema is air in subcutaneous plane. In simple English, air below the skin is surgical emphysema. It has got no relation with the lungs, so don't confuse. Surgical emphysema is air below the skin. Okay. Now, the next question. Next question about tracheostomy is, tracheostomy tubes are, right? Give a heading, tracheostomy tubes. Tracheostomy tubes. Give a heading, tracheostomy tubes. Tracheostomy tubes of two types, on the side. A, PVC tube. PVC means polyvinyl chloride. PVC means polyvinyl chloride is the name of the material, The same material is used for the endotracheal tube also. PVC tube, polyvinyl chloride, PVC tracheostomy tube, PVC, polyvinyl chloride. Okay, fine. Polyvinyl chloride. Okay, can we go further? Now, this is of two types, uncuffed tube and cuffed tube. Without cuff and cuff. Cuffed are better. Cuffed are better. This is cuff, label it, this is cuff. Cuff is a balloon, This balloon is called cuff, This cuff is called balloon. This balloon is called cuff, Cuff is the balloon. There is a balloon around the tube. You can inflate the balloon, deflate the balloon depending on your need, but cuff tubes are better tube. Now I'll tell you what is the advantage of cuff. Cuff, C-double-F, cuff. Cuff is his balloon name, beta. This is a better tube. PVC cuff tubes are better tubes, beta. Okay. Now what is the advantage of cuff, beta? Read your note, beta. Cuff decreases aspiration but leads to tracheomalacia. What do you mean by this aspiration business, beta? This patient is actually unconscious, ICU patient, very sick patient. He might aspirate continuously and lungs might get pneumonia. But this cuff is going to help you to prevent aspiration, beta. Kaise? How? Look at screen, beta. Look at screen, everyone. This is the cuff tube, beta. Let me show you. This is the cuff. Can you see the cuff, beta? Beautiful cuff there. This is the balloon, is called the cuff. Okay. Now, can you see this cuff? This is into trachea. This cuff is actually sealing the trachea. Now, even if you have got some saliva over here, beta. Saliva. Unconscious patient, some saliva is collecting over here, but saliva will not be able to go down because this cuff is going to block the flow, beta. This cuff is sealing the trachea completely. This yellow saliva is unable to go down our lungs, beta, over there. So patient will be saved from pneumonia, which is due to aspiration, which is very common in ICU patient, beta. Okay, but can you see this cuff is putting continuous pressure on the walls of trachea, beta. Can you see this cuff is putting continuous pressure on wall of trachea, and this cuff can lead to tracheomalacia, beta. I can see that, beta. Look at me, beta. Don't you see though? The cuff is putting continuous pressure on the wall of trachea, and this pressure might weaken the wall of trachea, and weakening is called malacia. So the cuff has one disadvantage. It can cause tracheomalacia. All of you read your note, beta. Cuff has got one advantage, one disadvantage. The advantage is it decreases aspiration. Disadvantage is it makes the trachea weak due to pressure, and that is called tracheomalacia. So what shall we use, beta? So we should use high volume, low pressure cuff. Look at your notes, beta. High volume, low pressure cuff, beta. Okay. So we should use high volume, low pressure cuff, beta. Am I clear, beta? Fine. Hence, high volume, low pressure cuff is better, beta. Am I clear? Fine. Now, next one is B, metallic tube, beta. Metallic tube is, example, Chevalier-Jackson tracheostomy tube. Everybody speak with me one time. Okay, Chevalier-Jackson tracheostomy tube, beta. It has two tubes, outer tube and inner tube. Inner is longer, beta. Outer tube and inner tube, inner is longer. This is the outer tube, and inner is longer, beta. Tube in a tube, outer tube, inner tube. And why two tube, beta? Because when you send the patient to home, then patient attendant need to take care. They can easily clean the tube, beta. They just remove the inner tube, they clean it, put it back. There is no worry. Patient attendant are very confident. They remove the inner tube, they clean it, boil it, dry it, put it back. Okay, they don't remove the whole tube, beta. So it is an outer tube, inner is a longer tube, beta. What is the name of tube? Chevalier-Jackson tube, beta. Okay, one question very important, beta, and you should know this concept as a doctor, as an intern, because this is intern duty actually in the ward. Suction of the tracheostomy tube. The tracheostomy is full of secretion. You have to clear it, beta. With the suction, you have to clear it every 1 hour, 2 hours, you clear this, beta. If you don't do this, the secretion will get deposited in the tube and the tube will be blocked, beta. Blocked. And that is a serious situation. Okay. Now, write down, beta. Come to the notes. Write down. If tube is blocked, put an arrow. Why? Due to improper suction. If tube is blocked due to improper suction, you did not suction it. You are an intern, nursing staff or residents, they missed it. They just forgot to do the clearance, and the whole day nobody did the suction. Sister thought intern did. Intern thought PG did. Nobody did. I have seen this happening in the RBARD also. Sometimes it's a serious situation, but a tube getting blocked. The tube getting blocked due to secretion is a serious situation. But first of all, write down. It is a serious airway emergency. A blocked tube is a serious airway emergency. It is serious airway emergency, but it is serious airway emergency. It's a very serious airway emergency, beta, because tube getting blocked is a serious airway emergency. Okay. Now look at me, beta. Now look at me, everyone. Look at me. Now the problem. What is the problem, beta? What is the problem? Everybody look at me, beta. Now what is happening is this tube is blocked. You were breathing from air, and somebody did not do the suction properly, and the tube got blocked with the secretions. This is exactly the same feeling. I asked one of the patient also, how were you feeling when this happened, beta? He told me only one thing, Rajiv, the feeling was as if somebody has kept a pillow on my face and is pressing the pillow on my face, beta. Have you seen in movies also? They keep a pillow on the face and try to smother the patient, beta. And what does the person do when somebody tries to push the pillow on the face, beta? He just pushes the pillow away, beta. Okay, the same thing you should do also. If you're intern, remove it immediately. Treatment, immediate treatment is remove it immediately and put a new tube, beta. Even if the new tube is not available, don't wait for the new tube, beta. Don't wait for new tube. There's a hole in the neck. At least from the hole, you'll get proper oxygen, beta. So if you get ever a question, a high level question of NEET PG, if you get the practical question are coming now, if the tube is blocked, they made a story like this in NEET PG paper. Hear me out. Patient underwent tracheostomy 1 week back. He's admitted in the ward. He has developed respiratory difficulty. His oxygen saturation is coming down. You are the intern on duty. What would you do? A. Call the senior and wait for the senior to come. B. Start oxygen immediately. Why would you wait for the senior, beta? You are a doctor also. Intern is also a doctor. Why would you start oxygen? Where the oxygen will go? The tube is blocked. Even if you put the oxygen here, there is no channel there for the oxygen to go to the lungs, beta. Number 3, do suction. No, now the secretion are already dried up. Suction will not be able to clear it. 4th was remove the tube immediately. Intern must remove the tube immediately, beta. This hole in the neck will save the patient, beta. Okay? So this is the answer. Remove the tube immediately. Please answer. This is the practical question. You should know the doctor also. Forget about the exam. You are going to be future interns also. You should know it. Okay? Let's revise all the questions, beta. Let's revise all the questions of tracheostomy, beta. Let's revise all the questions of tracheostomy, everyone. Please look at the screen, beta. Let us revise, beta. Tracheostomy. Most common site of tracheostomy is 2nd and 3rd tracheal ring, and this is called mid-tracheostomy. Mid-tracheostomy. But in cancer larynx, we do high tracheostomy. High tracheostomy is done at the 1st and 2nd tracheal ring. I'm saying question, high tracheostomy, it is done for cancer larynx. It is done at 1st and 2nd tracheal ring. Tracheostomy reduces dead space by 50%. Tracheostomy is temporary procedure except after total laryngectomy. I know, after laryngectomy, you have got permanent tracheostomy hole in the neck. Tracheostomy leads to apnea, breathing stops. Technical word. Due to what? Due to CO2 washout. Tracheostomy can lead to surgical emphysema. What is surgical emphysema? It is air in subcutaneous plane. Air below the skin is technically called surgical emphysema. Tracheostomy tubes are of 2 types, PVC, polyvinyl chloride tubes or metallic tubes. The PVC tube are of 2 types, cuffed and uncuffed. Cuffed are better tube. Cuffed are better tube. The advantage of cuff is it decreases aspiration. But disadvantage is it leads to tracheomalacia. Therefore, we use high volume, low pressure cuff. Okay. The metallic tubes, example is Chevalier-Jackson tube, or it has got 2 tubes, outer and inner. Inner is longer tube. And if you don't do suction properly, the tube gets blocked. The question comes, what do you do immediately? Remove the tube immediately and put a new tube later. But answer is remove the tube immediately. Okay. This was the end of the larynx, beta. Now, before we go further, let us do some questions of the larynx, remaining question, beta. We have done few of them. Now, please help me with these questions, beta. Few of them we have already done. Yeah. In carcinoma larynx, CA larynx patient with stridor and respiratory difficulty, the tracheostomy is done at which level? Abhi humne kiya. Cancer larynx tracheostomy is done at high tracheostomy. High tracheostomy. It is done at 1st and 2nd tracheal ring, beta. Okay, don't write vertebra, beta. Don't write 1st and 2nd. This is a wrong choice, beta. Okay, it's not a vertebra. You don't do tracheostomy at vertebral level, beta. Okay, it is 1st and 2nd tracheal ring. The answer is C, beta. C. Okay, not this one, beta. Cancer larynx, high tracheostomy. High tracheostomy is done at 1st and 2nd tracheal ring. Am I clear, beta? Fine. Okay. Now, which is the narrowest part of infant larynx? Try, beta. Infant pediatric larynx, narrowest part. Can you remember that, beta? Yes. Try it, beta. Try it. 47. The answer is B. Subglottis. Subglottis, beta. Subglottis. When you are seeing this video, you can pause it and think, and then see the answer, beta. Okay. There's a suggestion. If you want to think about it, pause it, think it, and then see the answer. B. Okay. Subglottis is the narrowest part of pediatric larynx. Next one. I hope you remember adductor palsy. Adductor palsy, type 1 tharoplasty, medialization, beta. Adductor palsy, type 1 tharoplasty, medialization. We have done the false cord being used to produce sound is dysphonia plica ventricularis. Remember, a singer, he is found to have adduction of false cord while phonating. What the name of disease is? Dysphonia plica ventricularis, means production of sound from false vocal cord. Okay. Now, yes, chalo, here answer do beta. 20-year-old male patient has high pitch voice. Everybody, male with high pitch voice. What the diagnosis? Puberphonia. Puberphonia means a male speaking like a female. Laryngoscopy is normal. Clinician advice for speech therapy. In the speech therapy, he is asked to phonate while pulling the thyroid cartilage downward and pressing it backward, like this, pressing it backward. What is the name of the maneuver? What is the name of maneuver for puberphonia? Is Gutsman maneuver, beta. Remember, Gutsman. Oh, man have guts, speak like a man. Gutsman. Puberphonia, what is the name of maneuver? Gutsman maneuver. Can you see it's such a big statement written? But if you know, oh, this puberphonia, maneuver, Gutsman maneuver. Okay, a lot of time this, 3-4 liner question are one liner only, but they are only, expanded to make a story actually. But if you know, okay, puberphonia, Gutsman maneuver. Vocal cord lesion, all are true except, all are true except, which is not true, except. All are true except, which is not true. First one is glottic cancer is associated with poor prognosis. Wrong. Glottic cancer has got good prognosis. Why? Vocal cord cancer have got good prognosis. Why? Because vocal cord do not have lymphatics. Do not have lymphatics. Okay. And keratosis larynx is a pre-malignant condition. Remember, smoker mein hota hai. is seen in smokers. Yes, it can convert to cancer, beta. Rhynchedema is best managed with decortication of vocal cord. Correct. Decortication is other name of stripping of vocal cord mucosa. Stripping. Decortication is other name of stripping. It's written in your notes also, beta. And which laser is used to treat juvenile papilloma? CO2 laser, beta. Okay, CO2 laser is used to treat juvenile papilloma of larynx. The answer is A, beta. Glottic cancer has got good prognosis, not bad prognosis, beta. A. Which of the following can lead to rhinolalia clausa? Clausa means close. Nose is closed, beta. Close. Close nose, beta. Of course, it will be nasal polyp, beta. Polyp. Rhinolalia clausa. Nose closed, polyp, beta. Palate, palate, palate. Rhinolalia aperta. Aperta. Okay, aperta. Remember, palate problem, palate problem. This is also palatal weakness causes aperta. Nose closed, polyp, beta. Polyp causes rhinolalia clausa, beta. Answer is C. C, beta. Okay. Rhinolalia clausa. Nose is closed. Polyp, polyp, polyp. Yes. Treatment of singer's nodule. What is singer nodule? It is other name of vocal nodule. But anybody, write in the chat box. I'm waiting for you guys. Vocal nodule. The treatment of choices. What is the answer? Yes. Voice rest. No surgery. But D. Voice rest or speech therapy. D. Voice rest or speech therapy. Remember vocal nodule, small laddu, keep your mouth shut. Apna मुंह बंद रखना है. Voice rest or speech therapy. Surgery वजरी नहीं लिखना. Okay. What is not true about laryngomalacia? Laryngomalacia. What is not true about laryngomalacia? The laryngomalacia. What is not true is about this is we inspiratory stridor. Yes. Horse cry. Wrong. Cry is normal. Remember? Cry is normal, beta. Cry is normal, beta. Cry is normal. Cry is normal, beta. Okay. Treatment is conservative treatment. I hope you remember laryngomalacia. You just reassure parents, beta. It is self-limiting condition and omega-shaped epiglottis. Answer is B, beta. What is not true about laryngomalacia? I remember in laryngomalacia, it is weakness of supraglottis, omega-shaped epiglottis, but vocal cord are normal. So voice or the cry is normal in laryngomalacia. Okay, fine. I'm not expecting you to know the answer, beta. Believe me, you should not be knowing the answer at this moment. It's okay, no problem. But you should know the topic. Oh, this point was there in the notes. Only this much is required. Oh, this is to be observed in the notes, beta. This is what the utility of the MCQs. You must solve a lot of questions for every subject, beta. Reading notes is one thing, but solving question is also important. Solving question has got few advantages. What? Number one, you get to know which part of the notes are more important. Number two, what type of question are being asked out of those topics. Okay. Number three, what are the common silly mistakes I do while attempting this question so that I don't do this question in the exam, beta. Okay, and sometimes you get more clarity on the same topic while solving the question, and you get to know, oh, this point has to be compared like this with the other disease. So solving question, please do not really leave that every day. Please invest some time in solving question out of Telegram, out of the missed question PDF, out of Tuesday paper, out of the various YouTube previous year papers discussion. At least last 4 session question are important. Choose one thing, but every day you must do certain question practice for sure. Okay, now everyone, look at. Now everybody, this is a pediatric question, beta. In a child with suspected diagnosis of epiglottitis, indicate your first line of treatment. First line of treatment, beta. First line of treatment. Epiglottitis was an airway emergency. If you remember, it's a very sick baby, beta. It's a very sick baby, an airway emergency. So answer is airway by intubation, beta. Don't go for X-ray, don't go for the throat swab, blood culture, laryngoscopy. Straight away intubate the patient, beta, because it's a very sick baby. It's a serious airway emergency. Okay, answer is D, beta. Okay, fine, D. Which of the following airway obstruction causes inspiratory stridor? You know inspiratory stridor? Supraglottic obstruction causes inspiratory stridor. B. I hope remember supraglottic problem causes inspiratory stridor. Okay, inspiratory, biphasic, expiratory. And below that is rhonchi wheezing is something else, beta. Okay, fine. All are true but functional aphonia. Functional aphonia means drama, acting, hysterical aphonia. Except it's a psychological disorder. Yes. More common young female. Yes. 20-year-old. Yeah. Okay. Patient is unable to produce cough sound. Wrong. Cough sound is normal. Oh, normal. C is the answer, beta. Vocal movement are normal. Patient is unable to produce cough sound. No. Functional aphonia is drama, hysteria, hysterical aphonia, psychological problem. Patient has normal cough sound, beta. Answer is C. This is what is being asked in the exam, beta. Okay. We're done this one. Which of the following is the initial symptom of glottic malignancy? Initial symptom of glottic means what? Glottic means vocal cord cancer, beta. And this will be hoarse voice, beta. Glottic cancer, hoarse voice. Vocal cord problem, hoarse voice, beta. So very easy question to attempt. Glottic malignancy is hoarse voice, beta. Okay, fine. Now, eyelid treatment for T1, N0, M0, glottic cancer, beta. Glottic. T1 glottic cancer. I told you vocal cord cancer. Nowadays it has changed to Laser beta. I told you for T1 glottic cancer, laser is better than radiotherapy. I told you if T1 glottic cancer come, T1, T2 radiotherapy. Okay, but T1 glottic nowadays, laser is a better answer than radiotherapy. Beta. T1 glottic means vocal cord cancer, laser is better than radiotherapy. Beta. Okay, fine. You done this one. Now, 3-month-old baby with stridor, then cry of the baby is normal, stridor is less in the prone position. What is the possible diagnosis? Please see, this 3-month-old baby, inspiratory stridor, cry of the baby is normal, the stridor is less in prone position, that is for sure laryngomalacia. Laryngomalacia beta. Why it is not laryngotracheobronchitis? Laryngotracheobronchitis will be having fever and cough also. It's infection. This stridor is since birth beta. Whenever in any specialty the question says problem since birth, think of congenital anomalies of that problem. Think of when the problem is since birth, think of congenital disorders beta. And why it is not laryngotracheobronchitis beta? Because infection cannot be since birth. 3-month-old baby, he cannot be suffering from 3 months. Okay, fine. Cry of the baby is normal. Stridor is less in prone position. Stridor is since birth actually. In the first week of life it appears. All the things are pointed towards laryngomalacia. So now what I am getting is laryngomalacia is important topic. Same for medicine. CNS, when you do topic CNS question, Parkinsonism, epilepsy, stroke, multiple sclerosis, they'll come again and again and again. You get to, oh, Parkinsonism is important, epilepsy is important. So these things I should be doing better. Okay. So this is what the advantage of solving question is better. You get to know, not hard work, smart hard work better. Oh, this is more focus area better. Now, we've done this one. Which of the following cannot be seen on IL beta? IL. I hope you remember anterior commissure beta. I told you, remember, anterior commissure is hidden by the epiglottis beta. Okay, anterior commissure is covered by the epiglottis, na? Partially covered by the epiglottis, so you can't see anterior commissure beta. The rest of things can be seen beta. Okay, now, these are the various questions of the larynx. Pharynx, what is pharynx, everybody? Open up your notes again. Pharynx. I think pharynx must be second topic in your notes. Now, what is pharynx beta? Everybody, open up the pharynx topic. 1 second. Let me tell you the page number. Yeah. The pharynx page number is 39. 39 page number. Pharynx, the page number is 39. Let's start pharynx beta. What is pharynx? Pharynx is a fibromuscular tube from skull base to C6 vertebra. So pharynx is a tube beta, tube from skull base to C6 vertebra beta. Look at me beta, look at me. From skull base, what is my skull base? My hairline beta. My end of the hair actually is roughly my skull base. And what is C6 vertebra? C6 vertebra is the end of my neck, nearly end of my neck. C7, end of my neck beta. So look at me beta, from the skull base to C6 is my neck, And in the neck, whatever hollow column is there is called pharynx beta. Very simple concept. In the neck, whatever hollow column you have is your pharynx. Look at everybody, look at your hairline, look at the end of your neck. What is between the skull base and C6 is your neck beta. And neck has got a hollow column, and then that hollow column is called pharynx beta. So pharynx is a fibromuscular tube from skull base to C6 vertebra. 1 second. Hello. Is it on? Okay. Now, the muscular tube means it has got some muscles, and you see this picture and there are muscles over there. There are muscles over there, and let us understand this picture first, then we're going to really revise it again. Now when I say fibromuscular tube, pharynx is a fibromuscular tube in the neck of human beings. Now muscle means there are 3 muscles. What are the muscles? Constrictor muscle, constrictor muscles, and just understand first of all, and then you will see this picture, you will understand everything. There are 3 constrictors: superior constrictor, middle constrictor, inferior constrictor. Okay, pharynx is a fibromuscular tube. What type of muscle it has? It has got constrictor muscles. Okay, and constrictor means number 1 SC माने superior constrictor, MC माने middle constrictor, and number 3 IC माने inferior constrictor. Superior constrictor, middle constrictor, inferior constrictor. This is skull base. This is C6 vertebra. Can you see C6 over? This is your pharynx beta. This is your pharynx beta. Okay, from skull base to C6 is your pharynx. It is a fibromuscular tube. It has got constrictor muscle, superior constrictor SC, middle constrictor MC, inferior constrictor IC. Now let us see at the inferior constrictor beta. Now, inferior constrictor, look at screen. Inferior constrictor has got two type of fibers. One are oblique fibers, they are called thyropharyngeus. TP mane thyropharyngeus. And then circular fiber called cricopharyngeus, CP. TP plus CP is equal to IC beta. Inferior constrictor, once again speak with me. There are three type of muscles in the pharynx and all of them are constrictor muscles. What is the first muscle? SC. What is SC? Superior constrictor. Bolo beta, are you speaking with me? Number 2, MC mane middle constrictor. Number 3, inferior constrictor has got two type of fibers, oblique fibers and circular fiber. The oblique fibers are called thyropharyngeus and circular fiber called cricopharyngeus beta. Thyropharyngeus and cricopharyngeus. Everybody, TP and CP beta. Thyropharyngeus, oblique fiber, TP, thyropharyngeus, circular fiber, CP, cricopharyngeus. Thyropharyngeus plus cricopharyngeus is equal to inferior constrictor beta. Okay. Now, can you see between the thyropharyngeus fibers and the cricopharyngeus fibers, there is a triangular area which has no muscular layer beta. This triangular area has got no muscular layer. Okay. Okay. And this area is called Killian-Dyson's. Very famous question of your exam. Killian-Dyson's is ultra. Put a star over there. Killian-Dyson's. What is KD? Killian-Dyson's is a triangular area between thyropharyngeus and cricopharyngeus, and Killian-Dyson's has no muscular layer beta. Can you see? There is no muscle in Killian-Dyson's beta. It's a weak area. It's a weak area, means it's unsupported area. It means that there is a possibility of herniation of mucosa out of this area, and that is called pharyngeal pouch, or surgery question, Dr. Vineet's question, Zenker's diverticulum. Zenker diverticulum also called as pharyngeal pouch. So Killian-Dyson's is the site of formation of Zenker diverticulum or pharyngeal pouch. Lot of question here beta. Now one more thing over here you see. Let us finish this diagram beta. Pharynx is from skull base to which vertebra? C6 vertebra beta. And when pharynx ends, esophagus start beta. Okay, like pharynx and what start here? Esophagus start. Esophagus start beta. Am I clear beta? Esophagus start. Okay, fine. So the basic thing is very simple beta. Okay, now all of you read the notes over there beta. Everybody open up the notes. Come over here beta. It has three constrictor muscles. Three constrictor muscles beta. Did you eat something? Did you eat something before the class or no? Please do take care of your health also. You know, even I missed my breakfast today. You know what? We are not ideal people. You know, we do something wrong things, and I couldn't have my breakfast. I was just running, and if you don't have any time to eat, like what did I do today? I just had one handful of almonds and took that while coming in that cab actually. Do that. Just some maybe boiled eggs, maybe almonds, maybe walnuts, maybe a banana. That's not a bad idea. Okay. Superior constrictor SC, middle constrictor MC, inferior constrictor IC beta. Everybody, inferior constrictor has got two type of fiber. What are two type of fiber? Number 1, read beta. Oblique fiber called thyropharyngeus, circular fiber called cricopharyngeus beta. Okay, fine. Now Killian-Dyson's. It's a triangular area in inferior constrictor muscle. Okay, between the fibers of, fill in the blank beta, between the fibers of, everybody write down, thyropharyngeus, and cricopharyngeus. Thyropharyngeus and cricopharyngeus. Thyropharyngeus and cricopharyngeus. Okay, very important question. Put a star over here. Okay. So Killian-Dyson's is a triangular area between the fibers of thyropharyngeus and cricopharyngeus. This area lacks muscular support. Very good. This area lacks muscular support. Therefore, it's a weak area of pharynx. Okay. Okay. It's a site of formation of Zenker's diverticulum. Zenker's diverticulum, also called pharyngeal pouch beta. Zenker diverticulum, also called as pharyngeal pouch. Zenker diverticulum, also called as pharyngeal pouch beta. Okay. So I hope you know this topic, Zenker diverticulum beta, Zenker diverticulum or pharyngeal pouch beta. Okay. Because this area has no muscular layer. Killian-Dyson's has got no muscular layer. It is a weak area. It's a triangular area. So this is a site of formation of which diverticulum? Zenker. Z-E-N-K-E-R, surgery topic beta. Zenker diverticulum or pharyngeal pouch. Ultra famous question beta. Killian-Dyson's is a super duper favorite question. And second significance is, it is possible site of perforation during rigid endoscopy. When you're doing endoscopy in a patient, please be careful in Killian-Dyson's area. Why? It's easy to perforate in that area. Why? Because this area has no muscular layer. That's why it's a weak area of pharynx beta. Is the point clear to all? Okay. Now, everybody, let us see another topic now. The same diagram. Sinus of Morgagni. Sinus of Morgagni. Sinus of Morgagni. M-O-R-G-A-G-N-I. S-O-M. Where is sinus of Morgagni beta? Everybody look at the first picture. This one. Can you see S-O-M written over here? Everybody go to the first page of pharynx. Can you see S-O-M beta? Sinus of Morgagni. Can you see it is space between skull base and the superior constrictor muscle. This area. This Killian distance is the space between skull base and which muscle? Superior constrictor muscle. Something is passing through, that is Eustachian tube. ET. Eustachian tube is passing through that. ET. Eustachian tube. And there is a muscle around Eustachian tube that is also passing through sinus of Morgagni. Now look at your notes, everybody. SOM. Sinus of Morgagni is the space between skull base and upper border of superior constrictor muscle. Once again, what is SOM full form? Are you speaking with me? Are you imagining that you and me are sitting together? I'm not an educator. I'm not a teacher. I am a friend of yours who is discussing ENT with you, who is revising ENT with you, who is understanding ENT with you. Okay, fine. It's a space between skull base and upper border of superior constrictor muscle. What is SOM full form? Sinus of Morgagni. Okay, fine. What passes through sinus of Morgagni? Eustachian tube and one muscle. Which muscle? Eustachian tube and ET. Eustachian tube and which muscle? Tensor villi palatini muscle, also called as tensor palati muscle, passes through sinus of Morgagni. Okay, bache? Okay, bache, fine. Is it clear to all? Fine. Okay. Eustachian tube and tensor villi palatini muscle. There is a tube. There is a Eustachian tube. There is a muscle around the tube which open the tube. Which muscle? Tensor villi palatini muscle or tensor palati muscle passes through sinus of Morgagni. Passes through sinus of Morgagni. Okay, fine. Now, on the sidebar, please write down here. Sidebar, everybody please write a question here, beta. On the sidebar here, sidebar, please use sidebars, beta, to make summaries, to write down certain special points, to write additional points, so that you don't make the major body of the notes dirty, beta. Don't make them clumsy. This area, please keep it as smooth as possible. This area you might use it so that the notes are really clean and really, very, easy to revise again. Now write down most common site of, write down here, beta, MCQ, most common site of impaction of foreign body, most common site of impaction of foreign body in digestive tract. Most common site of impaction of foreign body in digestive tract. Most common site of impaction of foreign body in digestive tract. Can you see over here? Most common site of impaction of foreign body in digestive tract. Digestive tract is not aero tract. Digestive tract is cricopharyngeal sphincter. Most common site of impaction of foreign body in digestive tract is which sphincter? Cricopharyngeal sphincter. Cricopharyngeus muscle. Cricopharyngeus muscle. At the level of cricopharyngeus. Cricopharyngeus is what type of muscle? Circular muscle. Circular muscle make what? Constrictor muscle. They make what? Sphincters. Sphincter. Circular muscle make what? Sphincters. So most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter. Cricopharyngeal sphincter. Most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter. Cricopharyngeal sphincter. Okay, in the bracket C6 level. Cricopharyngeal sphincter in the bracket C6 level. So answer is most common site of impaction of foreign body in digestive tract is cricopharyngeal sphincter in the bracket C6 level. C6 level. Okay, C6 level. And okay, and to find out this and to find out the exact site of foreign body, we need X-ray, AP view and lateral view. To find the exact site of foreign body, we need X-ray. Yes, X-ray. Which view? AP view also and lateral view also. AP view also and lateral view also. AP view and lateral view also. AP view and AP anterior posterior view and lateral view also. Okay, bache, can you see the AP view? Can you see a foreign body here, AP view, and you would need a lateral view also, okay, bache, and you would see the lateral view also, because in the lateral view you see like this, Can you see this? This is the lateral view picture of the coin, Can you see coin in the esophagus? Okay, fine, this one, So which is vertebra? C6. Can you see C6, Pharynx is from skull base to C6. What is this level, C6, Okay, so very easy question. Oh, pharynx is from what to what? Skull base to C6 vertebra. At the C6, which muscle is there, The last muscle of the pharynx. What is the last muscle? Cricopharyngeus muscle. What type of muscle it is? Fiber it is. Circular fiber. I know circular fibers make sphincters, Sphincters. So the most common site of impaction of foreign body in the digestive tract is the cricopharyngeal sphincter. What is this level of vertebra? C6 level, C6 level. Am I C6 level, C6 level, Okay, bache, fine. Is it clear to all? Okay, fine. I hope you remember this X-ray was there in your last exam also, Okay, fine. Chalo. Let's go further, bache. Let's go further now. Now, next one, Everybody open up this one. Pharynx has got 3 parts, Pharynx has got 3 parts. Number 1 is nasopharynx. Number 2, oropharynx. And number 3, laryngopharynx, Nasopharynx, oropharynx and laryngopharynx, Laryngopharynx. Nasopharynx, oropharynx and laryngopharynx. Laryngopharynx is also called hypopharynx. Hypo means the lowest part. Laryngopharynx also called as hypopharynx. Hypopharynx. Now please understand. Jacket. Now everybody please see. Can you tell me what is the extent of pharynx? From what to what level? From skull base to C6 vertebra. Beta. Skull base to C6 vertebra. Now everybody look at me. Look at me. Beta. Look at me. Now, what is your skull base? What is your skull base? Just look at this. Skull base is this level, beta, where the hairline almost this level. And C6 is your neck, the end of the neck, beta. So, between the skull base and C6 is your neck. Okay. Now, I am saying that the pharynx has got is a fibromuscular tube from skull base to C6 vertebra. From skull base to C6 is your neck, and that the neck has a column called pharynx. And now you're saying it has three parts: nasopharynx, oropharynx, laryngopharynx. How to decide it, beta? Look at see. What is in the front in the body? Nose. Behind the nose is which part? Nasopharynx. And nasopharynx has got what? Adenoids, beta. Adenoid are part of nasopharynx. Then nature put the which cavity? Oral cavity. Behind the oral cavity is which part? Oropharynx. Where you have what? Tonsils, beta. Yes, tonsils. Okay. Then come what? Larynx, beta. Larynx. Like larynx over here. This is larynx, beta. Okay. So larynx, behind the larynx is laryngopharynx. Larynx is laryngopharynx, beta. Now. Okay. Now please see. Just see, now it's made better. Nose, nasopharynx. Oral cavity, oropharynx. Larynx, laryngopharynx. Okay. So, nature front put lot of things, but nasal cavity, oral cavity, larynx. Correspondingly, nasopharynx, oropharynx, laryngopharynx. Nasopharynx, what is the dominant thing over there? Adenoids in children. Oropharynx, what is dominant thing over there? Is tonsil, beta. When you see your tonsil, you're seeing the oropharynx, beta. Okay. And larynx behind that is laryngopharynx. That is a hidden area. I'll show you on that. Thank you. Now. Okay. Now everybody, let us start the laryngopharynx, beta. Laryngopharynx has got other name also, hypopharynx, beta. Everybody, hypopharynx. Laryngopharynx is also called hypopharynx, beta. Hypopharynx. Am I clear? It has three parts. What are three parts of laryngopharynx? Number one, pariform sinus right and left. पहले याद करेंगे, फिर समझ लेंगे फिर उसको, है ना? पहले just एक बार देख लेंगे पहले. Let us see it once. Then let us understand it. Let's revise it, beta. All these words may be new to you, beta. है ना? It has three parts: pariform sinus right and left. Beta. बोलो beta. Number one, बोलो बच्चे. पहले get used to the words. Pariform sinus right and left. PS. Number two, PCA. What is PCA? Post cricoid area. Behind the cricoid, beta. What is cricoid, beta? Cricoid is a ring-like cartilage of larynx. Behind the larynx. Behind the larynx, behind the cricoid. What is the PCA? Post cricoid area, beta. Okay. And third is posterior pharyngeal wall, beta. Posterior pharyngeal wall. Posterior pharyngeal wall, beta. Am I clear, beta? Posterior pharyngeal wall. Posterior pharyngeal wall. Okay. Now, in this picture, this is larynx. Everybody look at screen, beta. This is larynx, beta. Larynx in the center. And this red thing is laryngopharynx, beta. Laryngopharynx. Everybody clear? Laryngopharynx. Now, I could never understand this whole thing. Pariform sinus. In my MBBS days, I could not understand what is pariform sinus and all that. Where it is actually. Now, let us try to understand it. Now, imagine this, this remote is your larynx, beta. This remote is your larynx, beta. Okay. Imagine this remote is your larynx, beta. This remote. Can you see a remote over there? White remote, beta. Okay. Now, there's a balloon in my hand. The balloon filled with the air. The balloon is red in color, beta. Imagine the red color balloon. You know, Valentine balloon, beta. Valentine balloon. You know, red color balloon. Okay. Now, if I press this remote is what? Larynx. Balloon is what? Laryngopharynx. If I press this remote in the balloon, if I press the remote in the balloon, due to pressure of the remote, the balloon will be divided into three parts. Due to pressure of the remote, the balloon will be divided into three parts. One on this side of balloon, one on this side of the remote, one on this side of the remote, one behind the remote. Due to pressure of the remote, the balloon, the Valentine red color balloon, will be divided into three parts, beta. How? One on this side of the remote, one on this side of the remote, one behind the remote. The part which went this side and this side of the remote is called pariform sinus right and pariform sinus left. The part which went behind it is called post-cricoid area. Why post-cricoid? Because it is behind the larynx, beta. And you know, one cartilage of the larynx is cricoid. Post-cricoid area, behind the cricoid, beta. Okay. And the sheath of the balloon. The sheath of the balloon is called posterior pharyngeal wall, beta. The sheath of the balloon, mucosa of the balloon is called posterior pharyngeal wall. Posterior pharyngeal wall. Everybody, now get back to this picture again. I hope you can understand. This larynx is the remote, beta. Larynx has pressed the laryngopharynx. Can you see Valentine balloon, beta? Red balloon which has been pressed by the larynx, beta. What is PS? Pariform sinus right. What is other PS? Pariform sinus left. What is PCA? Post-cricoid area. It's behind the larynx, beta. Post-cricoid means behind the cricoid. The cricoid is a part of larynx, beta. Post-cricoid area, and the sheath of the balloon is called the posterior pharyngeal wall, beta. This sheath is called posterior pharyngeal wall. And what lies behind is vertebra, beta. Look at me, beta. What is your neck, beta? Larynx, laryngopharynx. And what is this, beta? Vertebra, beta. Which vertebra? Cervical vertebra. Look at your neck. Larynx, then laryngopharynx, and what is behind this is vertebra, beta. Okay, fine. Now, you say, Rajiv, this is a line diagram. In the reality, where we see all these things, beta? In the reality, do we see all these things? Yes, we do see. Everybody look at screen, beta. If you remember this picture, beta. If you remember this picture, this photo. Okay. Now, let me try another way. Okay. Yeah, that's better. Now, please see. You remember yesterday, last time class, larynx. This is what a epiglottis is visible to you. Epiglottis is visible to you. Now, everybody, I hope remember epiglottis is anterior. Now, everybody, I hope remember arytenoid is posterior. Okay. Now, everyone, this is your larynx, beta. Okay. This is your larynx, beta. Okay. Epiglottis anterior, this is posterior, beta. Epiglottis anterior, this is posterior, beta. Okay. This is your larynx, beta. And this is the area where the laryngopharynx is there. It is lying collapsed. It only opens when food passes through it. Laryngopharynx is a channel for the food. Larynx is a channel for the air. Okay. When you eat biryani, biryani is passing from here. Okay, air is passing from here, beta. Okay, this is what, beta, supraglottis, hai na? Now something will open over here, beta. Everybody focus in this area. Something is going to open in this area, and that will be laryngopharynx, beta. Everybody focus in this area, beta, where my hand is. Everybody focus in this area, and you will see something magical happening there, beta. Please see, you know, can you see 1, 2, 3? So can you see larynx? This is laryngopharynx. Did you see something opened over there? Okay, once again, beta, larynx. This is laryngopharynx. Okay. Larynx is there. Okay. Now something will open behind the larynx. On the side of larynx will be laryngopharynx, beta. Okay. 1, 2, 3. This is laryngopharynx, beta. Again, beta, larynx. Now something is going to open in front of you, beta. 1, 2, 3. Laryngopharynx. Very good, beta. Okay. Can you understand, beta? Can you understand? Air passes from here. Food passes from here. There is a lumen there. You can't see that. There is a lumen there. Air passes from here. The food passes from here. This pariform sinus right, pariform sinus left, post-cricoid area. This lumen. There is a lumen here, but and this mucosa is called posterior pharyngeal wall. Larynx, this is laryngopharynx, the pressed balloon, beta. Pariform sinus right, pariform sinus left, post-cricoid area, and posterior pharyngeal wall. All of these things end into esophagus, beta. Larynx end into trachea. The laryngopharynx end into esophagus, beta. Am I clear, beta? Larynx end into trachea. Larynx is the air channel. Larynx end into trachea. Laryngopharynx, food passes from here. When you eat biryani, some biryani passes from here, some biryani passes from here, some biryani passes from here, and all of these three channels end into esophagus, beta. Esophagus. You tell me, what is the extent of the pharynx? From skull base to C6 vertebra. C6 vertebra, beta. C6. At C6, pharynx ends, esophagus starts. So all these three things will end into esophagus, beta. Okay. Can you tell me larynx topic, beta? Anybody? What is the position of adult larynx? Remember, there is a table, pediatric larynx, adult larynx. Adult larynx position, bolo zara. Adult larynx position, bolo. Everybody put in the chat box. Adult larynx position is what? Try to C3 to C6. Adult larynx C3 to C6. So C6 is a very important vertebra, beta. At C6, larynx ends, trachea starts. At C6, pharynx ends, esophagus starts. C6, larynx ends, trachea start, because in our notes of larynx written that adult larynx is from C3 to C6, and we said today pharynx is from skull base to C6. So C6 is a transitioning vertebra where the larynx ends, trachea start, where the pharynx ends, esophagus start. So the food is passing from here, here, and here. There are three options. Air passing from here only, central column. Okay, am I clear, beta? Fine. Is it clear to all? Everybody? Wonderful. So I hope everybody clear. Once again, beta, this is your larynx of today. We are seeing what? 1, 2, the one which opening now, 1, 2, 3, slow motion. So this is laryngopharynx. There is a lumen there, but you can only see when food is passing through it. There is a lumen definitely there, beta. Okay, fine. Chalo. I hope you understood it, beta. Everybody write in the chat box, did you understand this or not? I need to know. Did you understand it or not, beta? Okay. Please write in the chat box. Did you understand it or not, beta? Okay. Now, if I give you this question of visual question, beta. Now, would you be able to answer this? What are these two arrows indicating, beta? What are these two arrows indicating? Piriform sinus right and piriform sinus left, beta. PS, beta. Ankul Chauhan, you have asked that how do you differentiate the foreign body in the trachea and esophagus? The answer is that you have to go do two views, beta, in the anterior posterior view and the lateral view. The radiology people will be discussing that in detail, also the foreign body interpretation. But the answer to that question is you need two views, the anterior posterior view and the lateral view also, beta. Okay, but don't worry, radiology will be touching that. Okay, fine. Okay, very good. Wonderful. Great. Juhi, thank you very much. Keep responding, guys. Keep responding. Be active in the chat box. That's good. Good. Be active in the chat box. It's good. It's good to know that. Very good. Okay, fine. Now, let's go further, beta. I hope you remember what are these two arrows indicating? Larynx. This is piriform sinus right, piriform sinus left. This area is called post-cricoid area and this mucosa is called posterior pharyngeal wall. Anterior, posterior. Okay, fine. So these two arrows are indicating what? Piriform sinus. Will you be able to answer this question for your visual question, beta? What are these two arrows indicating in your diagram? Is a piriform sinus, beta. Piriform sinus, beta. Okay, chalo. Now, one more thing, beta. Now, let me show you, beta, piriform sinus from what is normally there in piriform sinus is. What is there, beta? Can you tell me what is this arrow indicating? Everyone, can you tell what is this arrow indicating? One is this arrow, one is this arrow, beta. Piriform sinus. Is it clear? No confusion about this, beta. PS, beta. Okay. Now, what passes through this, beta, is food. And when you don't have food, what is there, beta? Saliva. So, saliva in piriform sinus, beta. One here, beta. One here also, beta. So, can you see saliva over there? Saliva means the digestive tract, na? Digestive tract contains saliva, na? So, air tract, digestive tract. Okay. So, this and this will end into esophagus, beta. If you see clearly, the little bit saliva here also, beta, in this area, post-cricoid area. Can you see this little bit saliva here also? The food has got three channels to pass. Piriform sinus right, piriform sinus left, this one, and there is area called post-cricoid area. All these three will end into esophagus, beta. Am I clear, beta? Fine. Now, everyone, now answer this question to me, beta. Now, what is this area, beta? The larynx, which area is in front of you right now? This is supraglottis. Okay. What is this? What is it, beta? Piriform sinus. Piriform sinus. I hope you remember, supraglottis, the sensory nerve supply of supraglottis is by internal branch of superior laryngeal nerve. Try to recall larynx class. Supraglottis, above the vocal cord, the sensory supply is by internal branch of superior laryngeal nerve, also called as internal laryngeal nerve. Okay. Now, please see, beta. Now, there is a nerve here, beta. There is a nerve here, and that gives the branch to larynx. This is the same nerve gives the branch to the piriform sinus also. Same here, beta. This is the internal branch of SLN. It gives the sensory supply to the supraglottis. The same nerve gives the branch to the piriform sinus also, beta. Can you see, beta? Supraglottis and piriform sinus are neighbors. So, they share the sensory nerve supply. From my larynx notes, I can recall that sensory nerve supply of supraglottis is by internal branch of superior laryngeal nerve, which is also called as internal laryngeal nerve. And this nerve gives sensory supply to two areas. Number one, yes, larynx topic, supraglottis. And number two, piriform sinus. Because today I am clear that supraglottis and piriform sinus are two neighbors of each other, beta. Okay, am I clear, beta? Fine. Now, open your notes, beta. Open your notes, beta. Please see. Most common site of hypopharyngeal malignancy is piriform sinus, beta. One line question. Most common site of hypopharyngeal malignancy is piriform sinus. Now, internal branch of SLN is equal to, write down is equal to, matlab, is same as, is equal to internal laryngeal nerve. It gives sensory supply to number one, A, supraglottis, and number B, piriform sinus. Okay. So, sensory nerve supply of piriform sinus is same as sensory nerve supply of supraglottis, and both of these are neighbors and they get the common nerve supply of sensory supply from the internal branch of superior laryngeal nerve, which is also called as internal laryngeal nerve. Internal laryngeal nerve. Now, all of you see how the question is asked, beta. How this question can be asked. A PG level question. A patient presents an emergency with throat pain due to accidental swallowing of fish bone, beta. Any Bengali here, beta? If there is any Bengali, please write in the chat box. Any bong brother? Any bong? Any bong here, beta? You know, you guys eat hilsa. There's a special fish available in Bengal, hilsa, full of fish bones. Beta. It's very tasty fish, but difficult to eat for a North Indian like me, because we are not trained to really, eat fish with too many bones in it. So if you eat some fish and the fish bone gets stuck and you have got a lot of throat pain, the surgeon removes the foreign body with the endoscope. But what happened is, surgeon removed the foreign body, but while removing foreign body, the surgeon accidentally injured internal laryngeal nerve. What is the key point? Internal laryngeal nerve. Internal laryngeal nerve is other name of internal branch of superior laryngeal nerve. Where was the foreign body stuck? Where was the foreign body stuck? Base of tongue, tonsillar area, pharyngeal sinus or esophagus? Oh, pariform sinus. Pariform sinus. Why? Because I know pariform sinus sensory nerve supply come from internal branch of superior laryngeal nerve. Am I clear, beta? That's how it's called applied anatomy, applied clinical anatomy, beta. This is what the future is, beta. The national exit test which they're proposing would be like looking like this, beta. And your exam also is already having the tilt or flavor of these questions now. You know it. So, but it's not that difficult. Let us trust our common sense. We are FMGs and we are proud to be FMGs, beta. This is what you should be within you. Yes, there's an exam which I'm finding challenging, but once I clear it, I'm as good as any other IMG or anyone like that. So trust your common sense, trust your acumen, and try to evaluate the question. Don't get scared by the body of the question, beta. Because sometimes you get so scared by looking at the length of the question, 4-liner, 5-liner, that you go, oh no, I'm used to 1-liner, beta. Sensory nerve supply of pariform sinus is internal laryngeal nerve. But the same question asked in a story form. The surgeon removed the foreign body fish bone, and while removing the foreign body, he has damaged internal laryngeal nerve. Where was the foreign body stuck? Pariform sinus. This whole question is asking what? Not a very huge difficult thing. It is only asking what? Internal laryngeal nerve gives supply to which area out of these 4 areas. If you look at this question carefully, it's not asking you rocket science. It's only asking you a question in a story form. But the essence of question is the internal laryngeal nerve supplies which area out of these 4 areas. Beta. That's all. So let us change the outlook towards the exam. Let us not feel scared. I'm not saying every question will be easy question. 75-80 question will be tough question, very tough. You will just not be able to really sort of know anything about them. Let me honestly accept it. That's the way paper is. But still there are 200-220 questions which will be at least partially known or known to you. Let us focus on them. And there are a lot of questions of simple category and little twisted category of this category. Even this we can handle better. If you ask yourself and write in the chat box, everybody, I want each one of you to answer in the chat box. Now please don't shy away from using chat box. That makes the things very difficult. How will I know that what you are feeling about the learning and understanding better? You tell me, is this question that difficult better or it is doable? Write your feeling that applied anatomy question, clinical anatomy question. I'm not saying all of them, but majority of them are doable question better. So write your feeling in the chat box so I know that are you able to get what I'm trying to convey to you. Okay, fine. Now everyone, let me check the chat box with it. Is the video working? Somebody said video. Check your connection is in my. No, is the video working, beta? Yeah, it's working. Yeah, it's working. Now let's go further, beta. Laryngeal crepitus. What is laryngeal crepitus, beta? Everybody, laryngeal crepitus, beta. Laryngeal crepitus. Laryngeal crepitus. Laryngeal crepitus. Laryngeal crepitus, it's a clicking sensation felt when larynx is moved over cervical vertebra. It's a clicking sensation felt when larynx is moved over cervical vertebra. Beta. Cervical vertebra. Clicking sensation felt when larynx is moved over cervical vertebra. Now, just stand over here. Now, just see everybody. This is your This is your larynx, beta. This is your larynx. Everybody try this with me. This is your larynx, and everybody hold your larynx and push it little behind and move it right, left, right, left. Don't move the neck nilana. Can you see, beta? Can you see? Everybody try this with me. Right now, where you are sitting in the room, hold your larynx and move right, left, right, left. Can you see that gritty sensation, beta? Can you see that gritty sensation which you are feeling as if your larynx rubbing over the vertebra, beta? That gritty sensation, that clicking sensation when larynx is moved over the vertebra is called laryngeal crepitus, beta. Can you see, beta? I'm doing like this, beta. Like doing like this. 1, 2, like this. I'm just pushing it behind and rubbing it over vertebra. This is called what? The laryngeal crepitus. Anybody? Can you see prominence of larynx in male is called what? Adam's apple. Can you see beautiful Adam's apple, beta? This is the Adam's apple. Prominence of larynx in male is called Adam's apple. Beta. Thank you, Lalji. Okay. Now, fine. Now, please see on the screen, beta. It is present in normal people. Write down. It is present in normal people. I hope all of you are normal people. We all are a little abnormal actually. But anatomically we are normal. It is present in normal people. Beta. It is present in normal people. Beta. Present in normal people. It is present in normal people. Beta. Okay. It is present in normal people. Okay, now it is fine, beta. Okay, very good. Normal people. It is absent in post-cricoid carcinoma. It is absent in post-cricoid carcinoma, beta. It is absent in post-cricoid carcinoma. This cancer called post-cricoid carcinoma. In this cancer, this crepitus is absent, beta. Okay. Now you say, Rajiv, how come this absent? Look at screen, beta. Anybody? Look at this diagram, beta. What is this PCA, beta? Everybody speak out. What is the PCA? Post-cricoid area. Post-cricoid area. Imagine if you have got a big cancer in this area, beta. If you have got a big cancer in this area, look at this, beta. If you got a big cancer in this area, post-cricoid area, can your larynx touch the vertebra? If there is cancer in which area? What is this area? Post-cricoid area. Can you see the purple cancer over there? If the post-cricoid area has a cancer, how can the larynx touch the vertebra? Because there is a cancerous mass between the larynx and vertebra. So now you cannot rub the larynx over the vertebra. So that is why the laryngeal crepitus is absent in which carcinoma? Post-cricoid carcinoma. And this absence of laryngeal crepitus is a sign. Beta. Look at your note. Beta. This absence of laryngeal crepitus is a sign called Moore sign. Beta. M-O-U-R-E. The absence of laryngeal crepitus is called Moore sign. M-O-U-R-E. Absence of laryngeal crepitus is called Moore's sign. M-O-U-R-E. Moore sign. Am I clear, bache? Fine. Very good. People are writing. The question was good and doable. Very good. No Bengali here. There is not even a single Bengali here. I'm amazed really. No Bong here. That's not possible. Yeah. Okay. Okay, fine. Now let us start the nasopharynx, beta. Nasopharynx. Behind the nose is nasopharynx. Yes. Behind the nose is nasopharynx, beta. Okay. To put it simply, the empty space behind the nose is nasopharynx, beta. Okay. It has two important landmarks. The nasopharynx has got two important landmarks. What are two important landmarks? Number one is eustachian tube. We'll call it ET. And number two, adenoid tissue, beta, which is more prominent in children, beta. Okay, I told you behind the nose is nasopharynx, where you have got the adenoids, which are more prominent in children, and one opening is eustachian tube opening. Now this is the look of the nasopharynx, beta. Everybody label it with the pen. This is the ET opening. This is adenoid. Beta. Eustachian tube opening and adenoid, beta. Oh yes, I found one bong. Chiranjit Ganguly, yes. Thank you, Chiranjit. Okay, very good. Very nice. Check your connection, beta. It's going. I'm checking it from my, because I'm seeing that. Check your connection, beta. It's working well over here. I'm simultaneously checking on my mobile also that how the video speed is going on. Okay, everybody clear, beta? Everybody clear? There are two important landmarks. Can you tell me what are two important landmarks? The two important landmarks are number one, eustachian tube opening, and number two is adenoid, beta. Okay, fine. Okay. Now, important concept, beta. Everybody focus on this area, beta. Now, everybody, can you tell me eustachian tube connects what and what? It connects middle ear with the nasopharynx, beta. What is the ME, beta? What is ME? Middle ear, beta. What is this, beta? ET. What is ET? Eustachian tube, beta. Eustachian tube connects middle ear with the nasopharynx, beta. Okay, bache, fine. Now, please understand, your middle ear is producing mucus continuously, beta. This pink is the mucus, beta. And that mucus comes via eustachian tube and goes to the pharynx, beta. Okay, let me draw with this other color, the green color, beta. This is the mucus, beta. Middle ear produces mucus and that mucus comes into your pharynx continuously, beta. Can you see, beta? This is a normal, natural design, beta. Middle ear is connected to nasopharynx via eustachian tube. Middle ear produces mucus continuously and this mucus is draining into the nasopharynx via this eustachian tube, beta. Now, can you understand, beta, if something blocks the eustachian tube, beta? For example, the adenoid became bigger in size, beta. This adenoid became bigger in size and it blocks the eustachian tube, beta. The adenoid or any other thing which blocks the eustachian tube opening. Now, the mucus cannot come down into your throat or throat pharynx. Now, this mucus will get collected in the middle ear, beta. The mucus will get collected in the middle ear and that mucus will become thick like a glue, beta. That mucus will become thick like a glue. This mucus will become thick like a glue, beta. There is a lot of mucus collection in the middle ear and that mucus will become thick like a glue and this disease is called glue ear, beta. Glue ear, G-L-U-E, glue ear, beta. Glue ear. Because you know what happens is, the eustachian tube connects middle ear to nasopharynx. The middle ear produces mucus continuously and that mucus is drained via eustachian tube into your pharynx. But if some mass blocks the eustachian tube opening, the mucus cannot come down into the pharynx. Now, this mucus in the middle ear will become thick and more thick and this becomes like a glue and that disease is called glue ear. And if your middle ear is full of glue, how can you hear properly? And then you'll be suffering from conductive hearing loss, beta. Okay, conductive hearing loss. Am I clear, beta? So middle ear full of glue and that will lead to conductive hearing loss. Everybody get back to your notes, beta. Now, same thing written over here, beta. Eustachian tube connects middle ear to nasopharynx. Therefore, nasopharyngeal diseases can lead to middle ear diseases. For example, glue ear also called as serous otitis media is equal to serous otitis media. Glue ear also called as serous otitis media, which leads to CHL. What is CHL? Conductive hearing loss. But it's a very important concept as a doctor, that the middle ear problems can be there if there is nasopharyngeal problem. Please understand, these all concepts are important for your clinical practice also. You are not medical student, you are medical professionals in the future. So if a patient comes to your clinic with a nasopharyngeal disease, you must expect, there can be middle ear problem, hearing problem also in that patient, because today I know as a doctor that eustachian tube connects middle ear to nasopharynx. Therefore, nasopharyngeal diseases can cause the middle ear diseases like glue ear. The glue ear is also called as serous otitis media, which leads to conductive hearing loss, we use the abbreviation CHL. Now, the next topic. The three topics in nasopharynx: adenoid, angiofibroma, and nasopharyngeal carcinoma. And if I put a star topic over here, I would not be wrong, but this is a star. This particularly angiofibroma and nasopharyngeal carcinoma. These are very, very important topics, very important topics. Now let us discuss adenoid one by one. Number one, put a number one here. Number one, adenoid. Okay, make your notes as logical as possible. Okay, three topics. Number one, adenoid. Let us start adenoid. Adenoid is also called as nasopharyngeal tonsil. Adenoid, the other name is nasopharyngeal tonsil. You say, Rajiv, tonsil are in the throat, beta. Tonsil are here, throat is tonsil. No, no, no. Tonsil is a general word which means lymphoid tissue deposit in the pharynx. I repeat, any lymphoid tissue deposit in the pharynx will be called tonsil. Even adenoid is a type of tonsil. The throat tonsils, which you call tonsil, are only a type of tonsil, beta. Okay, so adenoid is also a type of tonsil. It is called a nasopharyngeal tonsil because tonsil means lymphoid tissue deposit in the pharynx. So adenoid is a collection of lymphoid tissue in the nasopharynx. Okay, fine. First line clear, beta. Adenoid, what is the type of tissue it is? It is a lymphoid tissue in the pharynx. Okay, nasopharynx. It has no capsule, no crypts, no definite blood supply. It's a very ill-organized tissue. No capsule, no crypts, no definite blood supply. They are present at birth. What is adenoid, beta? Look at this picture, beta. Can you see, beta? This is your adenoid, beta. Just keep this picture in mind. Can you see this mass, beta, everybody? This is the adenoid, beta. This is adenoid, beta. This A mane adenoid. This A is adenoid. Okay, beta? Fine. Are they there at birth? Yes, they are there at birth. Read your notes, beta. Adenoid is present at birth. Yes. They increase in size up to 6 years of age. They start decreasing in size at puberty and they disappear by 20 years of age. Once again, beta, see. Adenoid is lymphoid tissue. Yes. It is very ill-defined tissue. Yes. It has no capsule, no crypts, no definite blood supply. Adenoid is there at birth. It increases in size in every child up to 6 years of age. It starts decreasing in size at puberty and it disappears by 20 years of age, beta. It disappears by 20 years of age. Everybody, it disappears by 20 years of age, beta. Now everybody, please see, look at the screen, beta. Everybody, now please see the two endoscopy picture, normal picture, beta. Number one, number two, beta. Number one, number two. Can you tell me which one is of child, which one is of adult, beta? In the chat box, please write down one child, two adult, or one adult, two child, beta. Please see two endoscopy picture. Let me go out of the picture, beta. You see, beta. Your question is, which one is child, beta? One is child or two is child, beta? Okay, which belongs to a child? Just write in the chat box write on one child or two child, beta. Okay, fine, everybody, fine. I hope you know. Oh, it is two is adult, beta. Why? In adults, we do not see any adenoid. In children, we see the adenoid, beta. Adenoid is there in children, yes, but they disappear by which age? 20 years of age. So this second endoscopy, this one is of an adult because here I am not able to see any adenoid. They have disappeared. Anybody, what is this opening? You take into opening. It takes you to where, beta? It takes you to the, yes, middle ear. Very good, middle ear. Wonderful, wonderful. Okay, so one is of child, two is of the adult. Okay, I hope you are writing in the chat box. Okay, chalo. Now, next topic, beta. Same topic continues, but under that heading, adenoid hypertrophy, beta. Everybody, next topic is adenoid hypertrophy. Adenoid hypertrophy is a disease of school-age children. It is a disease of school-age children, beta. First of all, adenoid is a normal tissue. Adenoid hypertrophy, too much enlargement, is a disease of school-age children, beta. Okay, now, it is more than physiological enlargement of adenoid. It is more than physiological enlargement of adenoid. I know adenoid increase in size in every child up to 6 years of age. But that is normal enlargement. Too much of enlargement is hypertrophy. It is more than physiological enlargement of adenoids, beta. Cause. Write down cause on the side, beta. Cause, beta. C-A-U-S-E, cause put an arrow, due to recurrent upper respiratory infection. I hope you remember, adenoid is what type of tissue? Lymphoid tissue. And you know, infection induces lymphoproliferation. Oh, okay. Lymphoproliferation means lymphoid tissue will get enlarged due to recurrent upper respiratory infection. Beta. Okay, upper respiratory infection. The infection will induce lymphoproliferation, and adenoid, the lymphoid tissue, recurrent infection. You know, some children get infection every now and then, every now and then, every now and then. So we would have in them we will have this issue that adenohypertrophy is there. Everybody, again you have a question to answer, beta. Simple question. I don't ask tough question. Now again, beta, you have got two things, beta. Number 1 and number 2, beta. 1 and 2. 1 and 2. Which is normal, beta? Which is normal, beta? 1 is normal or 2 is normal? Everybody look at this, beta. You have got 1. This is 1. This is one picture, and this is another picture 2. Which is hypertrophy, beta? Can you tell me which one is 1 normal or 2 is normal, beta? What is the 1? Normal. What is the 2? Adenoid hypertrophy. Very good. This is adenoid hypertrophy. Can you see, beta? Adenoid hypertrophy. This is normal, of course, beta. Normal, beta. This one is normal side, beta. This is adenoid hypertrophy side, beta. Can you see? The whole nose is blocked from behind, beta. The adenoid is so much enlarged over here that adenoid, there is no space, this end of the nose now. How can you breathe now? Here, at least you were able to breathe. You were able to breathe. Oh, this much air, the spaces go for the air to go inside your system. But here, if you see in this area, the whole adenoid are blocked over there. They are blocking the nose from behind. So that's why this child will always keep the mouth open. Can you see, beta? The child has to mouth breathe, beta. It's a mouth breathing child. So let me tell you one short question in your exam and short answer also. A mouth breathing child. Think of adenoid hypertrophy. There are clues, beta. There are clues. There's a YouTube channel of mine, Rajiv Dhawan ENT. I put a couple of things over there. Like I put 6-minute video and 10 clinical scenarios of ENT. Just here that was 6 minutes after the end of the class, not now. When the whole class finishes of ENT, if you hear those 10 clinical scenarios, 6 minutes, you'll revise a lot of things which can be asked in a clinical story, but they are easy to crack. But once you know them, they're easy to crack. But over there, okay. In that same channel, you have got some videos like 70 important questions of ENT, beta. And there is a 3-hour video. It's like a Netflix kind of thing. And 3 hour means that you will have total, discussion of those 70 questions to revise the ENT in the question format actually. Okay. There's another video of 1 hour bit over there, which is to be done in the month of end of May. End of May, you do this 1 hour video, and that is rapid review of ENT. Rapid review of ENT in 1 hour. In 1 hour, we do, in the end of the May, we'll do those videos. This all are available on the channel. It's my YouTube channel, ENT Rajiv Dhawan. If you write Rajiv Dhawan ENT, RAJIV, Rajiv Dhawan ENT, you find all these videos there. But don't watch too many videos, beta. Don't waste too much time. Only 3 videos are of your use, beta, over there. That's NEET PG videos and there. One is the 70 question video. Other is rapid review of ENT in 1 hour. And third is this, 10 clinical scenarios. And I'll keep posting a link on the Telegram channel. I think a lot of people have joined Telegram over there. So I'll keep posting at the right time to revise what actually. Not now. That 1 hour rapid review is for the last week of May. This 6 minutes is for any time you can use it. But anytime you're sitting in the toilet, you're not doing anything, you just put this for 6 minutes and you just see that video, and that will revise you 10 minutes better. Let us not waste too much of time in the social media stuff and all that. Let us keep an exact time every day. Okay, post lunch I can use Telegram, etc., or YouTube, some last session videos, last review question, 4 session questions of the FMG. But that's 1 hour after dinner. I can do that. But I don't keep on doing all these things throughout the day. It disrupts your usual study. It disrupts your notes revision. It disrupts your usual questions what you do. Let's fix that 1 hour. Post dinner 1 hour. You might keep it for the social media activity, but keep them limited only for academic purposes, beta. Only productive activity, beta. Only productive activity, no reproductive activities, beta. Sorry for that. Only productive activities, no reproductive activities. Everything is suspended till 4th of June. But 4th of June evening become what we are actually. Okay, that's what we are, proud to be imperfect. So this child is a mouth breathing child, beta. Okay. Now let's see the next part of your note, beta. The child is a mouth breathing child. This is the biggest clue in the question is this one, beta. Okay. Now, child has got adenoid face, beta. Let us write adenoid face, 4 features, beta. Number one is open mouth. Yes, I know now. Look at the picture in your notes of open mouth. Pinch nose, because the child is not breathing from nose, beta. The mouth is being used to breathe, beta. Open mouth, pinch nose. High palate, due to mouth breathing, the palate goes up. High palate. Number 1, number 2, number 3, and number 4, beta, malocclusion of teeth. There are 4 features of adenoid face, beta. Adenoid face is a typical look of the baby called adenoid face with the mouth breathing baby, and speak with me. What are the 4 features of adenoid face? Number 1, open mouth, because mouth is used for breathing. Nose is useless now. Pinch nose. Due to mouth breathing, the palate goes high. If the palate, look at me, if the palate goes high, the upper teeth will also go high, because upper teeth are attached to palate only. If palate goes high, upper teeth go high. Upper and lower teeth cannot touch each other, and how you see your upper and lower teeth touch each other, but in this child, however he may try or she may try, there will be some gap left between the 2 teeth. But upper and lower teeth cannot touch each other now, and this is called malocclusion of teeth. Why it is happening? Because palate goes up. Okay, now fine. Now this is your adenoid face. Adenoid face. Number 2, rhinolalia clausa. Always we will have active revision. Remember, rhinolalia clausa. Clausa means close. Close means the nose is closed. Yes, adenoid has closed the nose from behind. I just saw that picture. Adenoid is closing the nose. Rhinolalia clausa. Anybody? Is it hypernasality or hyponasality? Anybody? Can you write in the chat box, beta? Is it hypernasality or hyponasality? I'm waiting for you in the chat box, everyone. Please write in the chat box. Rhinolalia clausa is hypernasality or hyponasality, beta? Very good, beta. Very good. Everybody, you're responding. I'm so glad. Other people also, please do respond in the chat box. It makes the class interactive for you and for me also, beta. Is it hypernasality or hyponasality? Hypo or hyper? When nose is blocked, is it hyper or hypo? Nose is blocked, the clause one close. Hyper or hypo, beta? Hyper or hypo, beta? Everybody. Raghuvinder Singh, Keshav, think again, beta. Think again. Rhinolalia clausa. Nose is closed. Nose is closed. Nose closed will be hyponasality or hypernasality. Everybody, can you try it, beta? Again, go back to your larynx note and see over there. Yes, Pratibha, correct, beta. It's hyponasality. Everybody, please see your note. Adenoid is a cause of hyponasality, beta. Not hyper. Hyponasality. Everybody, you are allowed to commit mistakes, beta. Don't shy what other people will think. Even if you answer the question wrong, I'll be very happy at least you responded, beta. That's not a problem. I'm not here to assess you. I'm here to assist you. Even if you do something, if I ask you, I told you. If I ask you what is this bone, you said, sir, tibia. I don't have any problem. I don't have any problem. If you call this tibia, I'm glad that you're trying to learn. I tell no, bache, this is hired bone. And next time you know it's hired bone, and you revise and you know it's hired bone, beta. So don't shy away from committing mistakes, but try to recall, adenoid closes nose, closing nobler rhinolalia clausa, and clausa is hyponasality, beta. Everybody clear, beta? Everybody clear? Wonderful, beta. Yes, that's the way I want the chat box to keep booming, beta. That's what, wonderful. Plus minus glue ear, beta. Glue ear will lead to what is CHL, beta. CHL is what, beta? Conductive hearing loss. Okay? It is in the bracket mostly bilateral. Mostly bilateral, beta. Why? This is your adenoid. This is your adenoid. This is your eustachian tube opening, eustachian tube opening. The center adenoid, eustachian tube, beta. When adenoid hypertrophy happens, beta. When adenoid hypertrophy happens, then it is going to cause the blockage of both eustachian tube, beta. Both. Can you think of it? Adenoid hypertrophy is going to cause the blockage of both eustachian tube, beta. Because adenoid is in midline, it is going to cause the blockage of right side and left side also, beta. So I would always think that adenoid baby can have glue ear, beta. This is one thing you should keep in mind. Adenoid baby can have glue ear. It's a age-old MCI question. They make a story of adenoid and they combine that story with glue ear. But I know, adenoid baby can have glue ear because adenoid is a nasopharyngeal problem and glue ear is a middle ear problem. But I do understand middle ear is connected to nasopharynx via eustachian tube. But adenoid is going to cause the blockage of eustachian tube, and that's why in adenoid I will have glue ear also in the picture, and that is mostly bilateral. And at glue ear also called as serous otitis media, and that causes conductive hearing loss. Do not worry. We'll be discussing glue ear as a complete topic in the ear topic, beta, tomorrow. Okay? Fine. Chal. What is the name of surgery, beta? The treatment is surgery. The surgery is called adenoidectomy. Very good. The surgery is called adenoidectomy. The surgery is called adenoidectomy. Palpate adenoid before removal because you cannot see your adenoid, beta. Adenoid is right behind your nose, so check it once. Now, position of patient during surgery, beta. Right now, position of patient during surgery. Position of patient during surgery is called Rose position. Spelling beta R-O-S-E. Underline beta Rose position. What is the name of the surgery? Adenoidectomy. What is the name of position? Rose position. Can you see Rose position, beta? Look at the picture. The neck is extended, beta. Like Rose position, the neck extension. Can you see neck? This is a Rose position, beta. There is a shoulder bag. There is a neck ring, beta. There is a ring of the head, beta. You put a shoulder bag and you extend the neck. And this position is called a Rose position. The same position is used for tonsillectomy, beta. The same position is used for tonsillectomy, beta. But be careful. Be careful. Over neck extension. If look at me, beta. Look at me. Neck extension. But neck extension, beta. Neck extension. But if you extend the neck too much, it's a child, beta. Adenoid is a child. Tonsil is generally a child. If you extend the neck too much, there may be cervical vertebral dislocation, beta, or subluxation. Over extension of neck can lead to atlanto axial subluxation or C1, C2 subluxation, very serious complication, and this is called Grissel syndrome. 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 Overextension of neck will lead to atlantoaxial subluxation, and this is called Grissel syndrome. What is the method of surgery? Curettage. Curettage. We curate it out. Look at my hand. You remember curates? Curate, blind curate. Curettage, like this curettage. Name of instrument is St. Clair Thompson adenoid curate. Name of instrument, read it, beta. The name of the curate is St. Clair Thompson adenoid curate, beta. Name of the instrument is St. Clair Thompson adenoid curate, beta. Okay, can you see, beta, this curate, beta? Your instrument, beta. St. Clair Thompson curate is used for which surgery? Adenoidectomy. Once again, beta, what is the name of surgery? Adenoidectomy. What is the name of position? Rose position. Okay, rose position, beta. Okay, what is the rose position? Neck extension. Okay, overextension can lead to what? Which vertebral subluxation? C1, C2 or atlantoaxial subluxation, which is also called a bolo, beta, which is also called as bolo, which, speak it, which is also called as Grissel syndrome, beta. What is the method of surgery? Curettage. What is the name of instrument? Look at the name of instrument is St. Clair Thompson curate, beta. Okay, bache, fine. Chala. St. Clair Thompson curate. Am I clear, beta? Fine. Now, Rajiv, let me try to show you if it works. At least you have some idea. Can you see, beta? This is the patient under anesthesia. Patient under anesthesia. Can you see that? Patient under anesthesia. This is a patient under anesthesia. What is the position? This is a baby's mouth, beta. What is the position of the patient? Neck extension. What is the name of surgery? Adenoidectomy. What is the name of the method? Curettage. How we do the curate? Like this. Scoop it out blindly. What is the name of instrument? St. Clair Thompson curate, beta. St. Clair Thompson adenoid curate. St. Clair Thompson adenoid curate. Now look at this, beta. Can you see, beta? He's just curating that out like this, beta. Curettage, beta. Curating out. Can you see that? Curettage. Oh, curettage, beta. Okay. Fine, beta. Now this is your, like this you do, and you just curate it out, beta. Scoop it out. Oh, curettage. Am I clear, beta? Fine. Very nice. Very nice. Okay. Is it interesting? Tell me, are you enjoying the process of learning or no? Tell me in the chat box, beta. Okay. 1 second. Somebody asked a question. Sir, any, Ananya, we do X-ray, beta. For adenoid, we do X-ray. Any investigation, we just do X-ray and that's okay. That's why we palpate the adenoid before removal. Before removal, we check it, but yes, we get the X-ray done, bache. Everybody clear? It's hyponasality, beta. Okay, no problem, beta. Don't even think that if you wrote hypernasality, oh, I did a mistake. No problem. You are more than welcome to do mistakes with me. I'm not judging you. I'm not evaluating you. I don't give a damn about what you are really, thinking that, what you are really doing the mistakes. I don't have any problem in that, but I want you to do the mistakes now, so that on the exam day, you already know, oh, this is a common mistake we do. On the exam day, you know, I have done this mistake earlier, this time I will not do it. So with faculties, you need not really worry, beta. We are just one of you guys only. We have done, at least I have done so many mistakes in my life that I am okay with it. Honestly, I keep improving, I keep challenging myself, I keep fighting within myself that I have to really evolve further and further. But I've done so many mistakes in my own life that I don't really have any issue with anyone who's doing mistakes, because I am the last person to be judgmental about anyone. I think I'm okay with that. It's okay. Everybody has a process of learning. Everybody has got a graph of learning. Everybody has a, some points some people learn better, some points other people learn better. But let us do the mistakes now. It's okay. Perfect, beta. So do not shy away from answering any question, beta. Right, bindas, beta. Koi baat nahi. Let us discuss angiofibroma. Very favorite topic, angiofibroma. Very important topic, angiofibroma. Also called as, now the new name, please do remember, the new name is juvenile nasopharyngeal angiofibroma. JNA, beta. Juvenile, it happens in the younger boys, beta. Juvenile nasopharyngeal angiofibroma is same as angiofibroma, beta. JNA, juvenile, because it is seen in children, young boys, beta. Juvenile nasopharyngeal angiofibroma. Very nice. Can we start it, beta? Look at the name, beta. First of all, we are doing nasopharynx and put number 2. This is number 2, beta. Number 2 is second topic. The nasopharynx has 3 topics: adenoid, angiofibroma, nasopharyngeal carcinoma. The second topic is angiofibroma. Now let's do this topic, beta. Now angiofibroma, first of all, it's the most common benign tumor of nasopharynx, beta. It's a tumor of nasopharynx, not of So this is number 2, my dear friends. It is the most common benign tumor of nasopharynx. Very good. Site of origin is sphenopalatine foramen. Everybody revise with me. Site of origin is sphenopalatine foramen. It's a benign tumor of nasopharynx. It is the most common benign tumor of nasopharynx. Oma means tumor, benign tumor. Is it a tumor of nose or is it a tumor of nasopharynx? No, it's a tumor of nasopharynx. It is the most common benign tumor of nasopharynx. The site of origin is sphenopalatine foramen. It's a highly vascular tumor. Look at the name, angiofibroma. Look at the name, angio means blood vessels. Blood vessel, and look at it is not supplied by blood vessel only. It is made of blood vessels. It's a highly, look at the name, angiofibroma. So it is made of blood vessels. Angio means blood vessel. It is highly vascular tumor. It is seen in adolescent boys. Very, very important clue in the question is always adolescent boy. Boys 12 to 14 year. To 12 to 14 year boy, question in ENT is angiofibroma. You want to confuse yourself? You can. But you know what, there are certain things which do not have any challenge in the 12 to 14-year-old boy. Okay, think of angiofibroma. The tumor can extend to nose, cheek, orbit and brain. Nose, cheek, orbit and brain. Nose, cheek, orbit and brain. The tumor extends to nose, cheek, orbit and brain. It's a benign tumor. It can go to nose, cheek, orbit and brain. Anybody? Orbit. What will happen? Orbit. Proptosis. Anybody? What is proptosis? What is proptosis? Anybody? What is proptosis? Can you see? The eye comes out. Proptosis. Can you see the eye is protruding out? And this is called, fill in the blank. This is called frog face deformity. This is called frog face deformity. This is called frog face deformity. Frog face deformity. Frog face deformity. This is called frog face deformity. Everybody fill in the blank. This is called frog face deformity. Everybody write over here. This is called which deformity? Frog face deformity. Because eye comes out, which is called proptosis, and that is called frog face deformity. Frog face deformity. Called frog face deformity. Frog face deformity. Frog face deformity. That's better. Frog face deformity. Okay. Clear the picture. Now this is the star question of MCI. Many times asked. 12 to 14-year-old boy with nasal mass, because tumor come in the nose with profuse epistaxis. Let me tell you a short question of MCI and how to crack it. Young boy with nasal bleeding is angiofibroma. Young boy with nasal bleeding is angiofibroma. What is epistaxis? Nasal bleeding, na? So whenever you get any question in NEET PG, INICET, AIMS paper, MCI paper, USMLE, anywhere, anywhere. Young boy, why are you saying boy? Young boy with epistaxis is 100% angiofibroma question. Don't even really dissect the question too much. Do not go for rare answers. Do not dissect the question too much. Do not change the choices again and again in your paper. And you know from your past experience, if you've given the paper earlier, whenever you change the answers too many times, the answer goes wrong. Let us go with the common sense, with the common answer. Common sense, common answer is the right approach for MCI. It's a screening exam. They want you to know the commoner things more. Now, investigation. Would you biopsies? Not at all. Biopsy is contraindicated MCQ. Never biopsy angiofibroma. Biopsy is contraindicated. Okay. Now CCT, what is CE? Anybody? What is CE? Contrast enhanced CT. You know, contrast. Whenever you have to do vascular studies, it's a vascular tumor. For vascular tumors, you give contrast. Contrast enhanced CT scan shows what? A particular sign called. Speak up with me. Everybody speak the name of the sign. Hallman, Miller sign or antral sign. Hallman, Miller sign or antral sign. Everybody speak with me. What is the name of the CT scan sign or CCT sign in this patient is Hallman, Miller sign or antral sign. Radiology question, they'll describe the radiology, but let me tell what it is. It is anterior bowing or posterior wall of maxilla. Actually, antra means maxilla, that's why antral sign. Anterior bowing or posterior wall of maxilla is called Hallman, Miller sign or antral sign. This tumor pushes the maxilla forward, This tumor pushes the, look at me, What is maxilla? Already touch your maxilla. This is your maxilla in the cheek, This tumor is pushing the maxilla forward, forward. Maxilla forward, Come here. Now please understand, this is a radiology thing, but I can explain it to you if you want to understand. Now please see, I am the angiofibroma. Aham brahmasmi. You know aham brahmasmi? I am angiofibroma, I am standing in the nasopharynx. Okay. The tumor belongs to nasopharynx. If I come forward, I go to the nose, In front of nasopharynx, if the tumor can extend to number one nose, then it has to go to cheek, Okay. Look at me, This is your nose. This is your cheek, This cheek is here. Anybody, or can you tell me which bone is between the nose and the cheek? Which is this bone, Maxilla. Maxilla, all you touch your nose, then you touch your cheek. Which bone between the two is maxilla? Okay. Now, my friend represents maxilla. Lalji represents maxilla, Okay. Now, I am standing in the nasopharynx over here. I am the angiofibroma. This is cheek, This is cheek. Everybody, this is cheek. Okay. Now, this area is cheek, Lalji, my friend of mine represents maxilla, I am standing in nasopharynx. I am the angiofibroma. If I grow forward, I grow to the nose, Now, I have to grow here, What is this area, Cheek. What is between nose and cheek is the bone called maxilla. Okay. Now, Lalji, my friend represents maxilla. I have to cross behind the maxilla. I have to grow over here, beta. I have to grow behind the maxilla first of all. I have to grow in this area behind the maxilla. Then only I can grow into the cheek, beta. Okay, you understand? From nasopharynx, if I have to grow into the cheek, this front represent maxilla, I have to grow first of all behind the maxilla over here. I keep growing for months and months and months over here, and then one day I come out of this area and reach over here, and then I reach the cheek, beta. That's why say the tumor goes to the nose to the cheek, beta. Now when I'm growing over here, look at it from the side, beta. His maxilla and the tumor. Okay, I'm growing over here for last 2-3 months. What I will do, look at this black line. This black line represents the posterior wall of maxilla. Posterior wall of maxilla, this line. Okay. Now what I will do, I will be growing over here. I will push the posterior wall of maxilla forward, like this. I'll push the posterior wall of maxilla forward, and this sign can be seen on CT scan. And this is called antral sign or Hallman-Miller sign. What is it, beta? It is anterior bowing of posterior wall of maxilla. Matlab, the tumor is pushing the posterior wall of maxilla forward like this, beta. And that is called Hallman-Miller sign or antral sign. Thank you, Lalji. Okay. Now everybody look at screen, beta. You might say, Rajiv, can we see that on CT scan? They will teach you in radiology. But let us challenge ourselves over here, beta. Everybody, look at screen. Okay, I leave it with this. This is CT scan, very high level, AIMS level question. Now please see, this is the cut of CT. You know, CT is cut. This is the axial cut like that. Axial cut like this kind of cut. Okay. Now see, this is the normal side, beta. This is the normal side, beta. Normal side. Now this is which bone, beta? This is maxilla, beta. You know, maxilla contains maxillary sinus. This black thing is maxillary sinus, beta, maxilla. Okay. Can you see, this is disease side, beta. D means disease side. Can you see, this is the posterior wall of maxilla here, beta, normal side. But can you see posterior wall of maxilla here, beta? This is the tumor. Okay, tumor. Tumor has pushed the posterior wall of maxilla forward, beta. Normal side, posterior wall is here. This is the maxilla containing maxillary sinus, and this is normal side. This is the posterior wall of maxilla. But here, this is tumor, beta, and the red arrow is showing the tumor is pushing the posterior wall of maxilla forward, and that is called Hallman-Miller sign or antral sign, beta. Okay, once again, beta, Hallman-Miller sign or antral sign is a CT scan sign of angiofibroma. It means that anterior bowing or anterior pushing of the posterior wall of maxilla forward, beta. Okay, anterior bowing of posterior wall of maxilla forward as compared to normal side. This is posterior wall of maxilla, and here this is posterior wall of maxilla. There is a difference in that posterior wall of maxilla, and this is called Hallman-Miller sign or antral sign, beta. Am I clear, beta? Fine. Now number 3 is angiography, beta. Of course, a vascular tumor, you would need angiography also. Angiography will be required. Then angiography will be required, beta. Angiography. And treatment is surgery, beta. Treatment is surgery. Okay, fine. This was the angiofibroma. Angiofibroma. Okay, so angiofibroma is the most common benign tumor of nasopharynx. Points to remember. It is a highly vascular tumor. It is seen in adolescent boys. It can extend to nose, cheek, orbit and brain. The orbit part will cause proptosis, and that will lead to a typical deformity called frog face deformity. The typical MCQ will be 12 to 14-year-old boy with a nasal mass and profuse epistaxis. I know, young boy with epistaxis is 100% angiofibroma. Young boy, epistaxis is 100% angiofibroma. Angiofibroma is also called as juvenile nasopharyngeal angiofibroma. Juvenile, why? It's seen in adolescent boys. Nasopharyngeal, why? It's the most common benign tumor of nasopharynx. And biopsy is contraindicated. It's a highly vascular tumor. And the CT scan or CCT will show Hallman-Miller sign or antral sign. You also do the angiography, and the treatment is surgery. Okay. Now let us start the third topic. Is nasopharyngeal carcinoma. Third topic is NPC, nasopharyngeal carcinoma. We call it NPC, beta. Nasopharyngeal carcinoma. Okay, right. See your notes, beta. Number 3, third topic of nasopharynx. Write down number 3, bache. Number 3, we said that there are 3 topics in nasopharynx. One is adenoid, angiofibroma, benign tumor. Now comes the cancer, beta. Nasopharyngeal carcinoma is more common in China. Etiology. This cancer is more common in China. Agar China hai, to etiology koi virus hi hoga. If it is China, the etiology will be some virus only, na? Which virus? EB virus. Very good. EB virus. Epstein virus. Where you see this red color box means MCQ already come or can come in future, beta. This red box I put very selectively at couple of places, beta. This question has come or can come in the exam, beta. Okay. Now, site of origin is fossa of Rosenmuller. Fossa of Rosenmuller. Site of origin is fossa of Rosenmuller. Try to recall, beta. Angiofibroma, the site of origin was sphenopalatine foramen. Look above, beta. Look above your notes, beta. Look at angiofibroma. Look at everyone. Angiofibroma, please see. Site of origin is sphenopalatine foramen. Sphenopalatine. Site of origin of angiofibroma is sphenopalatine foramen. But site of origin of nasopharyngeal carcinoma is fossa of Rosenmuller, beta. Okay, bache. Now, where is this fossa? Look at this, beta. This is the fossa, beta. Can you see? What is this opening, beta? Anybody? What is this opening? Anybody? What is this opening, beta? Eustachian tube opening. Can you see a yellow arrow there? This is fossa of Rosenmuller, beta. Okay, label it, beta. This is FOR. What is FOR? Fossa of Rosenmuller. FOR. Everybody label it fossa of Rosenmuller, beta. Fossa of Rosen. FOR. What is FOR? Fossa of Rosenmuller. It lies just above eustachian tube opening. Now everybody get ready to apply your clinical orientation now. Everybody. Now please see. Now a cancer is starting from this area, beta. The cancer is starting from this area. And it blocks the eustachian tube opening. Now if a mass blocks the eustachian tube opening, what will happen in the middle ear? Which disease? Bolo beta, which disease? If something blocks the eustachian tube opening, which disease will happen in the middle ear? Glue ear. Glue ear is also called as serous otitis media. And glue ear will be causing what type of loss? Conductive hearing loss, beta. You know? So this patient will be having conductive hearing loss also. So nasopharyngeal problem can cause middle ear problems like glue ear, which called CHL. What is CHL? Conductive hearing loss, beta. Okay, beta, fine. Now, will it happen on both sides or one side? One side. Cancer is mostly unilateral. Adenoid is bilateral. Adenoid will cause glue ear both sides. But nasopharyngeal carcinoma will cause glue ear only on the one side, beta. Okay. Now look at screen, beta. This fossa lies just above ET. Opening, beta. Write down opening. This fossa just lies just above ET opening, beta. ET opening. This fossa just lies above ET opening. It will cause unilateral ET blockage. That will cause unilateral glue ear. Oh, my concept. Nasopharyngeal problem cause a middle ear problem like glue ear, also called as serous otitis media. And that will lead to conductive hearing loss, beta. CHL. CHL, again unilateral. Highlight the word unilateral. It will be one-sided, beta. Okay. Unilateral, beta. Okay. Unilateral. Unilateral conductive hearing loss due to unilateral glue ear, beta. Okay, bache, fine. Now, right on the side, beta. NPC is a hidden cancer. NPC is a hidden cancer, beta. Hidden cancer means occult primary. It's written in your notes also, but I want you to highlight this point, beta. NPC is a hidden cancer. Hidden means occult. Occult means hidden. Primary means cancer. Occult primary, hidden cancer. Why? Can you see behind your nose, beta? You tell me. Every day you see behind your nose, beta. Have you ever seen behind your nose, beta? Do you know what lies behind your nose? No. But do you see your tongue every morning? Yes. If you have got a minor ulcer on your tongue, look at me now. If you have got an ulcer on your tongue, here, the ulcer on the tongue, every morning you will, when you're brushing, it's paining, you'll see in the mirror, why there is ulcer. At least you will show the doctor faster. Okay? But behind the nose, कुछ चल रहा है, किसी को क्या पता क्या चल रहा है? क्या चल रहा है? नाक के पीछे क्या चल रहा है? कोई दुनिया में कोई नहीं जानता. Nobody knows what goes behind the nose. It's a hidden cancer. So what happens is, the most common clinical presentation or manifestation of nasopharyngeal carcinoma, very, very important question. Most common manifestation of nasopharyngeal carcinoma is, write down, is metastatic cervical lymphadenopathy or secondary neck node. Most common manifestation of nasopharyngeal carcinoma is a metastatic cervical lymphadenopathy or secondary neck node. Secondary neck node. Metastatic means secondary, cervical means neck, lymphadenopathy means node. Secondary neck node is a layman term. The technical word is metastatic cervical lymphadenopathy. Guys, please understand. When primary is hidden, the manifestation is secondary neck node. When primary is hidden, the manifestation is secondary neck node, beta. So what is actually happening? What I'm trying to say, this patient does not know he has a cancer. Then one fine day he notices that he has got neck nodes like this, beta. Can you see, beta, neck nodes, beta? Neck nodes. Why? Because what happened was the cancer was behind the nose going on here, beta. Nobody knew that. Nobody knew it. It's an occult primary behind the nose, but it already metastasized to the neck node. And poor chap does not know that he's suffering from cancer. He comes to the clinic and he said, "Doctor, I've got a neck swelling." And then retrospectively, when I put my endoscope in the nose, I find, oh my goodness, there's a cancer there. That's a very scary part of the story. That's why the commonest question asked in MCI of nasopharyngeal carcinoma is this one, beta. Most common presentation or manifestation or of clinical manifestation of nasopharyngeal carcinoma. Most common clinical manifestation of nasopharyngeal carcinoma is metastatic cervical lymphadenopathy or secondary neck node, because this is a hidden cancer behind the nose. Nobody knows it, beta. Now, NPC can cause cranial nerve palsies also, beta. NPC can cause cranial nerve palsy also, beta. Next one. This tumor can cause paralysis of all cranial nerve, beta. Write down all except 7th and 8th, beta. All nerves except 7th and 8th. This tumor can cause paralysis of all cranial nerves except 7th and 8th. 7th and 8th beta. Okay, bache, 7th and 8th. And this leads to, why cranial? Look at me beta. What lies above the nasopharynx? Brain. Look at me beta. What lies above? This is nasopharynx. What is the pharynx upper limit? Skull base to C6 vertebra. Skull base beta. Skull base has got foramina of cranial nerves beta. So tumor, look at me beta. I am nasopharynx. If I go up, it's brain beta. Okay. I can eat away the cranial nerve. So it can cause paralysis of all cranial nerves because nasopharynx roof is brain beta. Okay. So it shows a triad called Trotter's triad. This is a very important question beta. Trotter's triad of NPC beta. And what is NPC? Nasopharyngeal carcinoma. And the good thing is the mnemonic is also NPC. Write down NPC beta. The mnemonic is also NPC. Trotter's triad is seen in NPC. What is NPC? Nasopharyngeal carcinoma. What is NPC? Triad. The triad mnemonic is also NPC beta. N mane neuralgia of temporoparietal area. Of temporoparietal area due to 5th nerve involvement. Palatal palsy due to 10th nerve involvement. Vagus. And conductive hearing loss beta. All unilateral beta. All are unilateral feature beta. All unilateral feature. Once again beta, Trotter's triad of nasopharyngeal carcinoma, NPC, has a mnemonic of NPC. What is N? N means neuralgia in temporoparietal area. Due to which nerve involvement? Trigeminal nerve involvement. Why nerve involvement? I told us nasopharyngeal carcinoma can cause paralysis of cranial nerves beta. So 5th nerve involvement cause neuralgia in temporoparietal area. And P mane palatal palsy due to 10th nerve involvement, vagus involvement, and C mane conductive hearing loss. And all of these features are unilateral. Now treatment is chemoradiation is a better answer than radiotherapy beta. Okay, so please, there are 2 MCQs possible. Whenever this symbol comes beta, whenever this symbol comes, this symbol means that if this is not given the choice, please mark radiotherapy. Okay, don't think of surgery, don't think of chemotherapy. Either they will give best answer, chemoradiation, or the second best answer is radiotherapy beta. Radiotherapy. Am I clear beta? Okay, fine. This is nasopharyngeal carcinoma beta, NPC beta. Guys, let us see which virus is causing nasopharyngeal carcinoma. Epstein-Barr virus beta. Okay, site of origin is fossa of Rosenmuller beta, and you know it causes unilateral conductive hearing loss due to glue ear. Now I know it's a hidden cancer, that is why the presentation most common is metastatic cervical lymphadenopathy or secondary neck node is a very important question. Then Trotter's triad beta. Let us revise Trotter's triad. NPC neuralgia of temporoparietal area, P mane palatal palsy, C mane conductive hearing loss, and chemoradiation is the best treatment, and second best answer of the question is radiotherapy beta. Let us start the oropharynx now. Everybody, let us start the oral. Pharynx has got 3 parts: laryngopharynx, nasopharynx. Let's start oropharynx beta. Oropharynx, it has following parts. First of all, where is the oropharynx beta? Now let me show you the oropharynx beta. What is the concept of oropharynx beta? Everybody look at screen beta. What is the concept of oropharynx beta? Please see. This is oral cavity beta. You know, teeth are part of oral cavity. Okay, hard palate, oral cavity. Anterior 2/3 of tongue, oral cavity. Up to teeth is oral cavity beta. Above, down, middle, whatever is there. Up to upper teeth, lower teeth. Just think teeth. Just think the teeth as the boundary of the oral cavity beta. Up to the teeth, upper teeth, lower teeth. Okay, can you see upper teeth, last tooth beta. Okay, can you imagine a line over here beta? A line over here. Can you see the last tooth, the lower one beta? Okay, now in front of this is oral cavity. Behind this area, this uvula, soft palate, behind this area is oropharynx beta. Okay, now look at screen beta. This is the real picture of oropharynx beta. Now this is what the oropharynx is. In front of this oral cavity. Now mind you, hard palate, look at beta. Hard palate, teeth wala part, oral cavity. Soft palate, oropharynx. Anterior 2/3 of tongue, oral cavity, teeth wala part. But posterior 1/3 of tongue, this last part of the tongue, posterior 1/3 of tongue is oropharynx beta. Tonsil is a part of oropharynx. Uvula is a part of oropharynx. There are 2 pillars of tonsil, anterior pillar, posterior pillar, oropharynx beta. Okay, so everything is oropharynx. This is a picture of oropharynx beta. Okay, now let us read your notes and let us see various parts of pharynx beta, oropharynx beta. Understanding is very important beta. Then only you get, you know, now I know, oh, it has following parts beta. Look at this picture beta. Okay, number 1 is soft palate. Number 1, soft palate. Oh yes, I remember hard palate is oral cavity, soft palate is oropharynx. Uvula. Everybody keep looking at this picture also beta. Number 1, soft palate. Number 2, uvula. Number 3 beta. Look at this, number 3. Can you see pillars beta? Between the interior pillar, posterior pillar. Between the 2 pillar there is tonsil beta. Number 3 is anterior and posterior tonsil pillar, and number 4 is tonsil. I told you the throat tonsil is a type of tonsil, and this tonsil is actually called the palatine tonsil. Palatine tonsil. The actual throat tonsil is a type of tonsil which its complete name is palatine tonsil. Okay beta, palatine tonsil. Now, next one. Posterior 1/3 of base of tongue beta. Can you see posterior 1/3 of base of tongue? Yes. Posterior 1/3 of base of tongue beta. I told you anterior 2/3 of tongue, oral cavity. But end of the tongue, posterior one third of tongue is the oropharynx, also called as base of tongue, the end of tongue, base of tongue, or posterior one third of tongue is part of oropharynx. Beta. Okay. Now number 6, beta. Lingual tonsil. Can you see? On the tongue, number 5 is the tongue, posterior one third of tongue. On the tongue, there are some lymphoid tissue deposits. This is called number 6, lingual tonsil. Again, tonsil means lymphoid tissue. Even tongue has got some lymphoid tissue at the end, and that's called lingual tonsil. Beta. Okay. And number 7 is the posterior pharyngeal wall. Beta. Number 7 is posterior pharyngeal wall. Look at screen, everyone. This is posterior pharyngeal wall. Beta. Okay. Everybody, can you tell me what is this? Beta. This is U money. What is U? Beta. U is what? Uvula. What is SP? Soft palate. Yes. What are these two, beta? These are two anterior and posterior tonsillar pillars. Between the two pillars, there is what? Tonsil, beta. Okay? Tonsil. What is this, beta? This is base of tongue or posterior one third of tongue. On the base of tongue, we have got small lymphoid tissue called lingual tonsil. And this is called number 7, beta. Number 7 is posterior pharyngeal wall. Can you see, beta? This is posterior pharyngeal wall. Behind this is vertebra, beta. Everybody imagine posterior pharyngeal wall. Behind this is what? Vertebra. Okay? Fine. This is oropharynx, beta. Unclear? Number 8, beta. Yes. One more thing is there, right? On number 8, that's a question also. Number 8 is vallicula. Number 8 is vallicula. Right on vallicula. Vallicula is MCQ, but put a star. Vallicula is a question. It is space between base of tongue and epiglottis. Vallicula. What is vallicula? It is space between base of tongue and epiglottis. It is space between base of tongue and epiglottis. Base of tongue and epiglottis. Now, what is the base of tongue and epiglottis? Oh, epiglottis, yes, day before yesterday. Base of tongue we saw today, beta. Okay. Vallicula is a valley, beta. Look at my hand, beta. Look at my hand, beta. When the base of tongue ends in your throat, epiglottis seems to start over there, beta. Epiglottis is a leaf-like cartilage. When the base of tongue ends like this, epiglottis is starting like this. There is a valley between them. There is space between the base of tongue and epiglottis, and that valley between the epiglottis and base of tongue is called vallicula, beta. Vallicula. Okay, let me try to show you this one if possible. Everybody, please look at the screen, beta. Can you see, beta? This is your oral cavity, beta. Can you see anterior 2/3 of tongue? Can you see the last tooth over there? Can you see the last tooth over here? Here. What is it, beta? This is what, beta? This is what, beta? Uvula. Can you see soft palate? Can you see two pillar, anterior pillar, posterior pillar? What is it, beta? Tonsil, beta. Once again, beta, please see. Beta. Oh, soft palate, uvula, one pillar, anterior pillar, one this pillar, posterior pillar. Between the two pillars, there is what, beta? Tonsil. What is this, beta? This is base of tongue. Base of tongue, also called posterior one third of tongue. It has got small lymphoid tissues, which are called lingual tonsil. The lingual tonsil, beta. Okay? Fine. Now, let me take you further, beta. Oh, वो नीचे कोई दिख रहा है? Can you see below there in the well? कुएं के अंदर, in the well. What do you see over there? A leaf-like structure. Can you see over there? Oh, it is written there. What is that, beta? This is what? Epiglottis, beta. Can you see? This is the base of tongue. This is the epiglottis. Can you see the space over there? This space is called vallicula. Vallicula, beta. This is the base of tongue, the epiglottis. This is vallicula, beta. Okay, once again, let us see from this angle also, beta. Okay, let us go from this. Oh, yes, I can see that. Oh, this is the base of tongue, end of tongue, beta. Okay, and this is the epiglottis. This valley between the two, this is called a vallicula. Okay, vallicula is a part of oropharynx, beta. I hope you could conceptualize. Okay, are you learning it or not? Please write in the chat box. Are you able to conceptualize? Because all these things in my MBBS days, I could not even conceptualize. What the bloody hell is pariform sinus? What is vallicula? It was very tough for me, honestly speaking. I could not conceptualize anything. I hope you are able to understand, beta. Before you jump into your PG and all that, you have some clarity. Share your thoughts on this in the chat box. Are you able to understand the concepts in a proper way or not? Okay. Now, next question, beta. Vallicula, please do remember vallicula, beta. Now, bed of tonsil. Next topic, beta. Bed of tonsil is made by superior constrictor muscle. I hope you remember the tonsil, in the part of pharynx. Pharynx are three muscles: superior constrictor, middle constrictor, inferior constrictor. Bed of tonsil. Look at everybody touch your bed of tonsil. This is your bed of tonsil. This is your bed of tonsil. Bed of tonsil is made by superior constrictor muscle. Bed of tonsil is made by superior constrictor muscle. Now, styloid process and glossopharyngeal nerve lie in bed of tonsil. Styloid process and glossopharyngeal nerve lie in the bed of tonsil, beta. Everybody draw here, beta. This is a normal side, beta. Everybody draw. styloid process. This is the ninth nerve, beta. This is normal picture, beta. Normal. This is normal, beta. Draw a line. Normal. Okay. This is disease, beta. Disease. Okay, have you drawn it, beta? So please see, normal people, two things are here. Everybody touch your bed of tonsil. You should know as a doctor, this is your bed of tonsil. Beta. This is your bed of tonsil. Please know it as a doctor. This is my bed of tonsil, my dear friends. Okay, my bed of tonsil is this one. You should know. When you have tonsillitis, where is the pain? Pain is here, beta. This is the bed of tonsil. It is made by which muscle? Superior constrictor muscle. Now, two structures are here. One bony process called styloid process. And which nerve is here, beta? Glossopharyngeal nerve, ninth nerve. Now, what happens in some people, disease, beta, styloid process become very long, beta. Styloid process become very long. Can you see? Styloid process become very long and it start pressing which nerve? Ninth nerve. Glossopharyngeal nerve. Styloid process which is getting elongated and it is pressing the ninth nerve, that will lead to throat pain referred to ear. Throat pain referred to ear, beta. Okay? Can you see, beta? Long styloid process touching the ninth nerve. Okay? This will lead to throat pain referred to ear. It's a disease. This is a disease, beta. It's a disease. It's a disease called eagle syndrome. Oh. Eagle money, you know, eagle bird, eagle syndrome. This is called eagle syndrome, beta. Eagle syndrome, beta. Eagle syndrome is MCQ, beta. Now, how to remember eagle bird, beta? Eagle. Everybody, how to remember eagle bird, beta? Eagle syndrome. Look at me, beta. Can you see eagle, beta, over here? Have you seen eagle while flying? With its sharp claws, it holds the snake and flies away. Okay. Now, can you see over here? The sharp claws of eagle represent the styloid process, okay, and the snake represents the ninth nerve, beta. The snake represents the ninth nerve, beta. Can you understand? The sharp claw of the eagle represents the styloid process, which is elongated. It's holding the snake, and the snake is representing the ninth nerve, beta. So just to make a story, eagle syndrome, eagle has a sharp claw, and with the sharp claw, it holds the snake. The sharp claw represents the long styloid process, and the snake represents the ninth nerve, beta. And this is eagle syndrome or styalgia. So you have a styloid process, yes. You have a glossopharyngeal nerve, yes. But in some people, the long styloid process can press the ninth nerve, and that leads to throat pain referred to ear. Very good. Okay. Now, let's go further, beta. Can we go further? Let's go to tonsil, beta. Tonsil is equal to palatine tonsil, beta. Tonsil is equal to palatine tonsil. Okay, palatine tonsil. Tonsil is equal to palatine tonsil, beta. Palatine tonsil, beta. Palatine tonsil. Now, please understand, tonsil has capsule, it has crypts, and it has definite blood supply, beta. Everybody underline, tonsil has capsule, crypts, and definite blood supply. Oh, I am able to recall something. What? Adenoid is same lymphoid tissue, but adenoid has no capsule, no crypts, no definite blood supply, beta. But tonsil is same lymphoid tissue, which is more organized. It has got capsule, it has got crypts, it has got definite blood supply. You say, Raji, what the hell is crypt, beta? Now look at this picture, beta. Look at this. The tonsil surface is not smooth, it's corrugated. Corrugated, beta. You say, Raji, where is the actual crypt in the real life, beta? In the real life, where is the crypt, beta? This is the look of the, this is the tonsil, beta. This is the tonsil area. Okay, let me change the color. This is the tonsil area, beta. This is the. Do you say, Rajiv, still crypts are not visible? Don't worry, I brought something else for you. Can you see, beta, over here? This is the tonsil and this is the crypt. Can you see crypts, beta? There's small depression in the surface of the tonsil, beta. Can you see crypts, beta? Crypts. There, can you see the arrow, beta? So there are crypting depression like that. Okay, surface got in, the epithelium goes inward like that. Okay, there is one crypt which is deepest, and the deepest crypt is called crypta magna. Look at the notes, beta. The deepest crypt is called crypta magna, beta. The deepest crypt is called crypta magna. Okay, one crypt goes very deep, and that is called crypta magna. Okay, the main blood supply of tonsil. Very last time question of MCI, beta. Main source of blood supply of tonsil. Write down, beta. It is tonsillar branch of facial artery. Is tonsillar branch of facial artery, beta. This was the last time question of MCI, beta. Very important question, already came. Repeat question, tonsillar branch of facial artery. The main blood supply of tonsil is tonsillar branch of facial artery, beta. Tonsillar branch of facial artery, okay? Tonsillar branch of facial artery. Next is venous drainage of tonsil beta. Paratonsillar vein. Paratonsillar vein beta. Paratonsillar vein. Paratonsillar vein beta. Paratonsillar vein beta. Paratonsillar vein. Paratonsillar vein. Okay. Now, what is the significance of this vein? This vein is the main source of bleeding during tonsillectomy. You know, tonsillectomy is a bloody surgery, but a lot of bleeding happens during tonsillectomy. But the main source of bleeding is not arterial; it's venous. And the main source of bleeding during tonsillectomy is actually the paratonsillar vein. Paratonsillar vein is the main source of bleeding during tonsillectomy. Oh, fine. Let us see the tonsil once again. Tonsil, the complete name is palatine tonsil. Tonsil has got capsule, it has got crypts, and it has got definite blood supply. Crypt मतलब depression like that, and the deepest crypt is called crypta magna. The main blood supply of tonsil is MCI question, tonsillar branch of facial artery. The venous drainage of the tonsil is paratonsillar vein. It's the main source of bleeding during tonsillectomy. I was trying to tell you that tonsillectomy is a very bloody surgery, beta. It's a very bloody surgery. A lot of bleeding happens during tonsillectomy, and you should know that, you know, this is your, this is not this coagulation, this one. Please see, this is the tonsil being done. No, not this one. This one. Please see, can you see somebody is holding a tonsil? Somebody holding a tonsil with the tonsil. This is the patient under anesthesia. What is the name of position? Rose position. What is rose position? Neck extension. What is the same position used for adenoidectomy? The same position used for tonsillectomy. Can you see tonsil? Laddu beta, laddu. Okay. Now you are giving a cut on the anterior pillar of the tonsil beta. You want to separate the tonsil from its bed. It's tonsillectomy being done. Tonsillectomy. Okay. What is the name of surgery right now being done? Tonsillectomy. You're holding tonsil with the forceps and you're trying to separate the tonsil from its bed. But you will see continuously some bleeding will be on and on. And you have to put a cotton over there to press it. Cotton over there to press it better. To control the bleeding. And you do the surgery. You separate the tonsil from its bed. Can you see tonsil is being separated from its bed? Can you see the laddu is coming out? Laddu is coming out beta. And then you separate the laddu completely beta. Oh. Can you see beta? You have separated the laddu completely. Now you pass a wire around that. This is called snare. Snare beta, snare. And then you apply the snare. Can you see the wire beta? Wire. You want to just crush the base and cut it now. This wire is called snare beta. Then you put that wire around the bed of the tonsil beta. Please see, again snare. This is snare wire. And then you just go there, tighten it, tighten it, tighten it. And you have to bring the laddu out beta. Okay, laddu is the tonsil beta. Can you see the wire there beta? Can you see the wire there? This wire is there at the end of the tonsil beta. You are trying to cut the pedicle now. Okay. Now you're holding the tonsil, and now please look at my hand. You're applying the force on the wire. Cut, and final pressure comes. Tuck sound comes, and laddu comes out. This is laddu comes out, and then the bleeding has to be controlled. Or this bleeding, put a cotton over there, put a stitch over there to tie the vein, beta. Okay, you have to apply a stitch to tie the vein, and this main source of bleeding is what? Is the paratonsillar vein, beta. Now the next topic, hemorrhage in tonsillectomy. Hemorrhage in tonsillectomy, beta. On the sidebar, write down. On the sidebar, write down. On the sidebar, everybody write down. Tonsillectomy, most common method. Most common method of tonsillectomy. On the sidebar, write down. Tonsillectomy, most common method. Most common method is dissection and snare method. You dissect it, and what is the name of the instrument? Wire beta. Wire, what is wire called? Snare. Dissection and snare method. A very simple concept. First you dissect the tonsil from its bed. Then you apply that wire at the end of the tonsil to cut that pedicle of tonsil, and that wire is called snare beta. Snare wire. Dissection and snare. S-N-A-R-E. What is snare? Snare means that wire which you use to cut the pedicle of the tonsil. Okay. So dissection and snare method is the commonest method used for tonsillectomy. Problem with tonsillectomy is a lot of bleeding happens beta. There are 3 types of hemorrhages beta. Everybody, there are 3 types of hemorrhages. 3 types of hemorrhage. Primary hemorrhage, reactionary hemorrhage, secondary hemorrhage, 3 types of hemorrhage and 2 MCI question. Can you make such a high yield question, beta? 3 hemorrhages and 2 MCI question, beta. Primary hemorrhage, reactionary hemorrhage, secondary hemorrhage. Now let's understand, beta. Hemorrhage in tonsillectomy is of 3 types, beta. Primary is during surgery, beta. Whatever bleeding you saw during surgery on the screen, primary hemorrhage. You controlled it with the stitch you applied. You tied the vein with the cotton pressure. You control the bleeding. Patient came out of the operation theatre in the ward now. If again bleeding start in the ward, when the patient has been shifted out of the operation theatre, that's called reactionary hemorrhage. Reactionary is, write down in the bracket, it is post-operative hemorrhage. Within 24 hours of surgery. You send the patient to the ward in the afternoon. At night you got a call. Doctor, nurse calls, she's scared. Doctor, the patient is bleeding from mouth. At night. You operated in the afternoon, bleeding started in the night. Within 24 hours surgery. It is due to slippage of ligature. Ligature means stitch. You use the stitch to tie that vein, beta. You applied a ligature. Ligature means stitch. Stitch means silk stitch, beta. Okay, suture. You applied that suture to control the bleeding out of the vein, but that stitch was a loose stitch, it came out. It's an emergency. Patient is puking blood, vomiting blood, beta. It's an emergency. It's an emergency, beta. It's a big emergency. It's an emergency. Okay? Treatment is re-exploration. Don't worry, we'll control it, beta. Re-exploration, matlab reapply the stitch. This is MCI question, beta. Re-exploration. How to remember it, beta? R-E-R-E. Reactionary, re-explore, beta. How to remember it, beta? R-E, reactionary, R-E, re-explore. Kabhi galat nahi hoga. This question will never go wrong, beta. Reactionary hemorrhage, re-explore. Reactionary hemorrhage, re-explore, beta. Reactionary hemorrhage, re-explore. Re-explore means reapply the stitch, beta. It's a serious emergency, beta. It's a patient is vomiting blood. Re-explore. Apply the stitch again, beta. Then is secondary hemorrhage. Again, post-operative. After 24 hours, any bleeding is secondary, beta. Mostly after 5th day of surgery, yes. Patient comes back from home. The clue is, patient has already gone home. You know why? Tonsillectomy, we discharge the patient next day, maximum. We just keep it for one night. Sometimes we don't keep it for one night also. Patient has gone home. After 5th day, he comes back to the hospital. Doctor, I'm bleeding from the mouth. Now, what is the cause, beta? Cause is infection of tonsillar fossa. The tonsillar fossa, that gadda, from here you remove the tonsil, that got infected. Sometimes patients do not take care, beta. They don't do gargles. The children don't do gargles, betadine gargles. They don't do that. You tell them eat ice cream, don't eat anything hard. They order biryani. They open up Zomato. There's offer over there, 1 for 1 biryani free. You know, can you understand? You know how tempting it is. Hyderabadi biryani. You know what? Bawarchi biryani, talapkatti biryani of Chennai. You know what? They're like, you will order biryani and the biryani rice will get stuck into your tonsillar fossa and pus will form over there. But fortunately, it's a mild bleeding. Right on the side. It's not a serious bleeding, beta. It's a mild bleeding, beta. It's a mild bleeding only. It's a mild bleeding only, beta. It's a mild bleeding. Treatment is readmission. Oh, admit the patient back and intravenous antibiotics. Very important question. Readmission and intravenous antibiotic, beta. You have to inject infection. Huh? It's a mild bleeding, beta. Doctor, it's not vomiting blood. Doctor, when I spit, there's a red color in that spit. That's all. Doctor, when I spit, there's a red color in the sputum. This much blood, little bit blood. Mild. Patient will not die of this problem. This reactionary was serious problem. This is just a mild bleeding. Admit the patient and start intravenous antibiotic. Okay? Can we revise this hemorrhage, beta? It's important topic, beta. Let us revise the hemorrhage. What are 3 types of hemorrhage, beta? Bolo, beta. 3 types: primary, reactionary, secondary. Primary, during surgery. Reactionary, post-operative, within 24-hour surgery. It is due to slippage of ligature. It's an emergency. Treatment, re-explore, beta. RE, reactionary, RE, re-explore. Number 3, secondary hemorrhage is again post-operative after 24 hours, mostly 5th day after surgery. Patient comes back from home and it's a mild bleeding. It is due to infection of the tonsillar fossa. So readmit the patient and start intravenous antibiotics, beta. Start intravenous antibiotic. My dear friends, is it clear to all, beta? Start intravenous antibiotic, beta. Intravenous antibiotic. Everybody, just let me tell you how the question can come, beta. Now read it, beta. Read it, beta. This question of hemorrhage, how it can come. Let us see, let us see. Oh, yes. Let us read this question, everybody. Read with me. Let me read it for you. 17-year-old male patient underwent tonsillectomy on Monday. Monday. The first day of the week he got operated. Monday. He operated on Monday. Okay. His post-operative period was uneventful. So he got home. He was discharged on next day. Went home. On Sunday morning. Monday got operated. Sunday morning he presented in emergency with complaint of mild bleeding, beta, from oral cavity. First of all, tell me, what type of hemorrhage it is? Reactionary, primary, secondary. Monday you got operated. Sunday you presented to the emergency again with mild bleeding. Can you tell me what type of hemorrhage? Write in the chat box, beta. Primary, reactionary, secondary, beta. Everybody, can you write in the chat box? Yes, it is secondary bleeding, beta. It is secondary hemorrhage. What is the answer? Admission and antibiotics. What is the answer, beta? Admission and antibiotic, beta. What a choice. It is normal to have mild bleeding? No, it's not normal to have bleeding after 7 days, beta. Admission and re-exploration, never do that. Oral hematinics, why to give hematinics? Iron, why to give iron, beta? Can you solve this? This looks like a scary question, but when I know the logic, could you answer this question? Tell me in the chat box, writer. Could you answer this question? This question was looking scary question, long question, but when we know the story, we know the answer, beta. We know the answer. Monday you got operated. Sunday you are bleeding again after 24 hours, mostly after 5th day, and other clue is mild bleeding, beta. Mild bleeding, and treatment is readmit the patient and antibiotics, beta. Okay, is it clear? Everybody, no problem? Okay, fine. After the hemorrhages, let us do the next topic now. There are a couple of questions possible. First of all, see this next picture now. Whitish membrane on tonsil, beta. Whitish membrane on tonsil, very common thing. Whitish membrane on tonsil. A lot of time we get this whitish picture on the membrane on the tonsil. What are the various causes of that? Let's do that now. Number one is acute membranous tonsillitis. Beta. Acute membranous tonsillitis, first of all, it is the most common cause. Beta. Acute membranous tonsillitis is the most common cause. Beta. Most common cause, and it is caused by, it is caused by Streptococcus pyogenes. Streptococcus pyogenes. Beta. It is caused by Streptococcus pyogenes. Beta. Streptococcus pyogenes. Beta. Okay. The most common cause of the membranous tonsillitis or the tonsillitis in general, which we see in the clinical practice, the whitish membrane on tonsil will be actually most commonly due to acute membranous tonsillitis caused by Strep pyogenes. Beta. Number two, infectious mononucleosis caused by Epstein-Barr virus. Beta. EB virus. EB virus. Okay. Number three, diphtheria. Now, diphtheria is important. Beta. Diphtheria. Everybody, write on the sidebar, diphtheria. What are things to be looked for diphtheria? Beta? Diphtheria. How to really conceptualize diphtheria for the ENT questions? Diphtheria, first of all, is a sick baby with fever, with bull neck. Sick baby with fever with bull neck. What is bull neck in the bracket? Cervical lymphadenopathy. In diphtheria, there are big lymph node in the neck, and literature says that as bull neck. Beta. Bull neck means cervical lymphadenopathy. How the question of diphtheria would be picked up in pediatrics or ENT? Sick baby with fever, with bull neck, and now two things can be there. Beta. Two things. Two questions can come in ENT out of diphtheria. Sick baby with fever with bull neck. What is bull neck? Bull neck is cervical lymphadenopathy. Two questions can come in this. Number one, if you remember unilateral vocal cord palsy. Try to recall the larynx topic. Beta. Diphtheria can be cause of unilateral vocal cord palsy. Unilateral vocal cord palsy. Beta. Okay, unilateral vocal cord palsy, and the treatment is conservative. Treatment is conservative. I know there are a couple of questions in the chat. I will take it little later after this topic. Treatment is conservative. Beta. Okay, and then this is MCQ. Beta. We have discussed this already. Beta. In larynx topic, we said that unilateral cord palsies are to be treated conservatively. The second one is membrane over tonsil. Membrane over tonsil. Membrane over tonsil extending to palate. Beta. Extending to palate. This is the biggest clue. Beta. Membrane over tonsil extending to palate. Put an arrow. And this membrane bleeds on removal. Beta. Last year question. Bleeds on removal. This membrane bleeds on removal. The membrane of the diphtheria is on the tonsil extending to palate, and it bleeds on removal. It bleeds on removal. Beta. Bleeds on removal. Beta. It bleeds on removal. Okay. Okay, fine. You say, Rajiv, where is the diphtheria membrane? Can you see the diphtheria membrane, beta? Can you see diphtheria membrane is extending from tonsil to palate, beta? I think it's very clear in this picture also. The membrane of diphtheria is extending from tonsil towards the palate, and once you remove it, there will be bleeding on removal, beta. So, 2 points to remember about diphtheria membrane. Number one, it extends from tonsil to palate, and number two, when you remove it, there's a bleeding over there. So, diphtheria has got clinical scenario: sick baby with fever, with bull neck. And two questions possible in ENT. One is unilateral vocal cord paralysis. For that, the treatment is conservative. Second is membrane question. The membrane of diphtheria extends from tonsil to palate, and it bleeds on removal, beta. This is what you need to do. Okay. Okay. Then what are other causes, beta? Diphtheria done. Diphtheria. Then candidiasis. Candidiasis, beta. Then Vincent angina. Malignancy of tonsil. Leukemia. Leukemia. Leukemia, beta. Once again, let us revise the various causes of whitish membrane on tonsil, beta. Speak with me, beta. Speak with me. The whitish membrane tonsil, the most common cause is number one, number one, acute membranous tonsillitis caused by Streptococcus pyogenes is the most common cause. Number two, infectious mononucleosis, which is caused by Epstein-Barr EB virus, beta. The third is very important, diphtheria. Diphtheria, the 2 points to remember is, number one, the membrane extends beyond tonsil to the palate. Number two, it bleeds on removal. Number 4 will be candidiasis. Number 5, Vincent angina. Number 6, malignancy of tonsil. Number 7, leukemia. Leukemia, beta. Okay? All these points are clear, beta? Now, before we go to the next topic, Walder ring, let me take a few questions, beta. Let me take a few questions. It needs to be clear, so we can use it. Srinivas Manikanta says that that yes, it is due to bacterial infection. Mild bleeding means that, you know, the infected area is bleeding, so that's why you need Srinivasa. We need antibiotic for that, beta. Lakshmi Narayan, if the bleeding would have been on Tuesday, then of course it is reactionary hemorrhage, beta. If the bleeding is within 24 hours, it is actually the reactionary bleeding, which is 24-hour bleeding, beta. Then in that case, you have to go for the re-exploration. Within 24 hours, reactionary bleeding, re-exploration, beta. Srinivasa, you say that in the class you understood everything, but then you forget it. Revision, revision, and revision is the key to success, beta. Okay, perfect. A lot of people answer correctly. Secondary hemorrhage. Then Srijit, thank you very much for your kind words. Rajput, Rahul Singh Rajput, you said that, explain the question again. If you remember, the question was that, you know, the patient was operated on Monday. Look at it, Monday. Patient started bleeding on Sunday. After 6 days, beta. After 6 days, any bleeding. After 24 hours, any bleeding is reactionary or secondary. It's a secondary bleeding. Secondary is a mild bleeding, mild bleeding also. Secondary hemorrhage, you go for admission and antibiotic. Monday you got operated. Sunday you are bleeding after so many days. Of course, the secondary bleed actually, which is a mild bleed and due to infection. That's why admission and antibiotics, beta. Okay, fine. All good. Ananya, you asked adenectomy. The commonest complication is hemorrhage, beta. Adenectomy, Ananya. The adenectomy, the most common complication will be hemorrhage. When you bleed, when you remove the adenoid, there is a lot of bleeding sometimes. But hemorrhage is the commonest complication. Very good. If any other question is left in the break time, you can put any other question in your mind. In the break, you put lunch break, you put that. I'll answer after lunch break. All the question again. All the questions are answered till now. Okay, beta. Let us do next concept. Walder ring. Walder ring. Walder ring. Write down. It's a ring of lymph tissue in pharynx. It's a ring of lymph tissue in pharynx. I think by now you are seeing there are many lymph tissue in the pharynx. Adenoid is a lymph tissue. Tonsil is a lymph tissue. Lingual tonsil is a lymph tissue. All these make a defense ring in your system, and that ring of defense of lymph tissue is called Walder ring. So, ring of lymph tissue, it has got 6 parts. 6 parts. 6 parts. Number 1, adenoid. Number 1, adenoid. Number 2, tubal tonsil around the eustachian tube. Around eustachian tube also there are small lymph tissue. Tubal tonsil. Why tubal? Because around eustachian tube. Number 3, palatine tonsil, and I'm sure you know palatine tonsil is equal to tonsil. The real tonsil, the one tonsil you think as tonsil, is called palatine tonsil. Even adenoid is a type of tonsil. Then number 4, lingual tonsil. I remember even tongue has got some lymph tissue called lingual tonsil. Number 5, and this is minor, beta. This is minor part. Number 5, number 6 is minor part. Some lateral pharyngeal bands, some lymphoid follicle on posterior pharyngeal wall. Lymphoid follicle on posterior pharyngeal wall, beta. Okay, fine. Okay, let us revise this ring, beta. This ring is called Walder ring, beta. This picture is also there, beta. Walder ring, beta. 6 parts. Walder ring is a ring of defense, beta. It's a ring of defense. It's a ring of lymph tissue in your pharynx. It has got these parts. Number 1, adenoid. Number 2, beta. Look at around adenoid, which tube is there? Eustachian tube, and that has got some lymph tissue called number 2, tubal tonsil. Then number 3, beta. Number 3, the real tonsil or the palatine tonsil. Number 4, lingual tonsil. They are the main part. Number 5 and number 6 are minor part. Number 5 is lateral pharyngeal bands and lymphoid follicles on posterior pharyngeal wall. Okay, so all these make a ring of lymph tissue defense system of your body. It's called Walder ring. That's given in the image in your notes as well. Okay, bache, fine. Now, let us go further, beta. Now, very important topic, quinsy, beta. Everybody, this is a star topic. Please put a star here. Very commonly asked topic, beta. Quinsy is a very popular topic. Look at the name, beta. Quinsy. Everybody speak about the name of abscess, beta. Quinsy. Bolo, beta. Muh se bolo. Try to speak when you hear the new word. Quinsy is also called peritonsillar abscess. Now think about it. Peritonsillar. Peritonsillar means around the tonsil, outside tonsil. Beta. It is not intratonsillar abscess. It's peritonsil. Peri outside tonsil. It's collection of pus between tonsil and its bed, beta. It's collection of pus between tonsil and its bed. Anybody, which muscle makes the bed of tonsil? Everybody, this is the bed of tonsil, beta. Here. Which muscle is making the bed of tonsil? Revise it. Superior constrictor muscle. So it's collection of pus between tonsil and its bed. It is more common in adults and it's mostly unilateral. It's only on the one side, beta. Okay. Now let me show you how does the abscess look like, beta. Everybody look at the screen here. This is the abscess beta. Please see, where is the pus? The pus is in the this space beta. This space. This is the pus beta. Look at this beta. This is the pus. It's collection of pus between tonsil and its bed beta. Don't you think so? This pus is going to push everything on the other side beta. Can you see? There are two findings beta. If you see your notes, the written beta, two finding beta. Number one finding is this one beta. Tonsil is pushed medially. And number two finding is uvula pushed to other side. Tonsil pushed medially, uvula pushed to other side beta. Tonsil pushed medially, uvula pushed to other side. Tonsil pushed medially, uvula pushed to other side beta. Okay, tonsil is pushed medially and uvula is pushed to the other side. This is the actually, you can say, the two finding. Now read your notes beta, read your notes. Everybody, can you see beta over here? Tonsil is pushed medially, uvula is pushed to the other side beta. Two finding. This is the very important thing, and very important thing is the diagram beta. This diagram. This is a very vital diagram, and this is a VQ1A visual question also beta. Nobody should forget this question beta. If uvula is pushed to other side, if uvula is angulated, think of quinsy beta. अगर uvula टेढ़ा है तो मेरा है, टेढ़ा है तो भी मेरा है ना. uvula टेढ़ा है, अगर uvula pushed है, uvula angulated है. If uvula is pushed, uvula is angulated, think of quinsy beta. One important thing is there is no outer neck swelling in quinsy. Please understand, this is very important thing. No outer neck swelling in quinsy beta. Quinsy is inside the mouth. Here, nothing is there. No outer neck swelling in quinsy. Okay, fine. Now, what is the chief complaint? Chief complaint is trismus. Trismus beta. Everybody, bolo beta, what is the name of the word? Trismus. What is trismus? Trismus is, look at me beta, difficulty in mouth opening. It's so much painful, there's spasm over there, you're not able to open the mouth even. Trismus is difficulty in mouth opening. It is due to spasm of, MCI question, it is due to spasm of medial pterygoid muscle. MCQ, it is due to spasm of medial pterygoid muscle beta. It is due to spasm of medial pterygoid muscle beta. Medial pterygoid muscle. It is due to spasm of medial pterygoid muscle beta. Okay, bache? Medial pterygoid muscle. I hope you remember pterygoids, but a masticatory muscle. The trismus, look at it. I'm not able to open the mouth because my muscle has got into spasm due to infection. What is the name of muscle? Medial pterygoid muscle. Oh, hot potato voice. फिर से आ गया. Hot potato voice or plummy voice, also called as muffled voice. Muffled. M-U-F-F-L-E-D. Which voice? Muffled voice. Plummy voice. Hot potato voice. Okay, bache. If you are able to recall this word, oh, I've heard this word somewhere earlier in larynx also, but you're not able to recall which topic you actually read it, it means that your brain is perfectly normal brain. But if you are doing active revision, the way I'm now telling you guys, active revision means wearing the sports shoes better. Sports shoes, and that's active, active. Just go back, oh, larynx, hot potato voice came in epiglottitis. Hot potato voice came in supraglottic cancer. Hot potato voice is seen in quinsy also better. This is a classical word, hot potato voice. If one thing you have to choose, if they give hot potato voice seen in 4 things, and you are confused, quinsy is the most hallmark thing better. If they give you hot potato voice is seen in, if you are having 2-3 overlapping choices, mark quinsy better. Quinsy is the classical thing where this word is used better. Okay, this is this disease better. Okay, better, hot potato voice or plummy voice or muffled voice better. Okay, bache. Am I clear? Fine. Okay. Treatment. Per oral IND. What is IND? Incision and drainage. Per oral IND, beta, incident training. Why I'm saying sports shoes culture, beta, sports shoes. I'm wearing sports shoes, beta. I cannot show you, but I'm wearing sports shoes, I prefer that because that keeps me a bit more, active mentally as well. This is probably a habit I developed in my PG days. Like that, in the PG, a lot of work you have to do, first year, second year, a lot of work you have to do. When you are wearing, like sports shoes, I think I feel more energetic. Are you noticing one thing? If I don't know whether you notice it or not, I'm standing. It's not easy to stand. Do you think so? But it is not that difficult to also stand. Standing means that you are attentive, you are more energetic, you are more, free-flowing and all that. Everybody has got different ways of remaining active. I'm not saying you stand up while studying. It's not possible for everyone. But you must be knowing that which thing keeps you active. Because why I'm standing? Because I'm damn excited to interact with you. This is what is not, I'm not doing that I have to finish it. I'm absolutely excited to be with you guys. I hope that is visible on my face too. Because this is what I'm really thoroughly enjoying what I'm doing right now. This is what I'm really putting my energy, heart and soul into it. And I want to be active for that. For that I'm standing. I'm standing. Why? Because I want to give my 100% to you. Same for you guys, beta. When you revise, I want you to give 100% to revision. 100% to revision means full focus on revision. Mobile phone off. Sitting on the chair with sports shoes means that brain is alert. Let us create deeper impression in the brain, beta. These are tricks and hacks which brain would really not be able to really catch actually. Brain wants to make babies, what. For brain, productivity is 0. Reproductivity is very much natural. Productivity, brain doesn't care much actually. Brain wants to do 100 things to take you away from the books, 100 things to take you away from the study. And you have to confuse the brain by doing some hacks over there, by becoming more alert when brain is really trying to give you a luring advice to sleep tonight. So you just confuse the brain better. Confuse the brain and let us really, and it's not that sleeping is really going to create a lot of activity in your life. Have you ever seen, if you sleep for 10 hours, do you feel more fresh? Do you feel more fresh, beta? Do you feel more fresh when you sleep for 10 hours? Not at all. Not at all, beta. You feel more dull. More dull. More, if you sleep for 10 hours, do you think it's going to add really freshness to your day? Absolutely not, beta. Absolutely not. People might say 8 hours sleep is mandatory for good health. They say that in the Times of India, Google, etc., all the articles and all that. They keep saying that 8 hours sleep is mandatory for good health. Where it is written? Where the hell it is written that 8 hours sleep? 8 hours sleep means 1/3 of your day goes to sleep. It's not like that, but honestly not like that. From my personal experience, I tell you that sleep 5.5 hours is absolutely okay. I have been sleeping for this much for last 21 years now because I changed my habits in the time when I prepared for PG. In 1999, I think I changed my habit of sleeping too much. I was a very lazy kind of guy. And I changed my habit from sleepy to activity. I reduced my sleep quota gradually. But otherwise people will say, if you don't sleep for 8 hours, you will get dull, you get very, very slow, very low, or you will get hypertension, you get diabetes, you get impotence. I don't know what all they will say. Infertile, all the stupidity they keep telling you. And we get really so scared. But don't worry, but I have been sleeping for 5.5 hours for last 21 years. And I have 2 children also, by the way. So it works. The sleep, less sleep also works very well. What keeps you the fresh during the day is, are you doing what you expect to do? Are you honest with your day? Are you doing 100%? Did you fulfill the promises you made to yourself previous day? Did you read that much as you decided? And then today is the fresh day. If you fulfill the promise made to yourself yesterday, you fulfilled all the revisions, you did that with focus, you did that with a lot of attention, then today is a very bright day. But that doesn't matter how many hours you slept. I'm not saying from 8 hours you come to 5 hours. You don't copy me. Don't copy anyone in life. Nobody is that great that you should copy. You are a great creation of the nature. Never look up to anyone. But never get impressed with anyone. Look within. You know what is right. You don't need any motivator. The motivation I don't really like. What is motivation? Stupidity. You know what? Nothing. Nobody can motivate anyone. You are the real motivator for yourself. You know what is right and what is wrong for you. You are a unique creation, has got a unique kind of needs. Early risers. Some people are late sleepers. It's okay. Whatever your body is conforming to. But we can, have ideas from other people. 8 hours sleep, bring it to 7.5 hours. Bring it after 2 weeks, 7 hours. Then 6.5 hours after 2 weeks. So that close to the, beginning or you can say May, you are sleeping for maybe 5.5 hours. And rest of the time you devote to your studies. And after 4th June, evening, you sleep for 24 hours a day. I don't have any problem. You are unique creation, respect that. That's not a problem. I'm telling you how to increase the productivity in these days, because right now I'm saying 3 revisions. 3 revision. How can you do 3 revisions in these 3 months when the classes are on and everything? You have to add on number of hours here and there. And how to add the number of hours to really decrease the quantum of sleep actually. But it cannot be done abruptly tomorrow. It has to be decreased gradually, one by one. 30 minutes, decrease it after one week. Believe me, you will feel very good. If I have slept for 5 hours, last night I slept, it was Shivratri, I was awake till late. So I slept maybe 5 hours maximum. And that's the way I've been doing actually. If I can do, you can also do. Never look up to anyone, look within. You are your own prime motivator. You know what your design is. You know how can you really channelize your energy. So just try to make sure these 3 months you are super productive. That's why all this, sports shoe culture and all that I'm trying to really introduce you to. Maybe you like the idea. Don't get motivated. But okay, you're a grown-up adult actually. Nobody can force you. I cannot force my idea onto you. You might like an idea and might dissect it out, evaluate it. Some of you might like that idea. Some of you might start using that idea actually. So that's what I'm sharing with you. From my failures to how to really proceed to success side actually, to bring certain changes in myself actually. That's what I'm sharing with you. No motivation. I don't like motivation. I don't know what is motivation, Motivation means you hear YouTube, wow, what's the nice thing. And after evening, you're doing the same thing. You know it. When you hear the YouTube, yeah, sahi to bol raha hai, theek bol raha hai, right is. But in the evening, you do the same things. Why? Motivation has to erupt from within. Then it is sustainable. Then it's permanent. Okay? Per oral IND and remove tonsil after 6 weeks. Corrected, not creaks. W. 6 weeks, W weeks. 6 weeks. This is called interval tonsillectomy. Because you are doing it after 6 weeks interval, this is called interval tonsillectomy. It's called interval tonsillectomy. Some surgeons remove tonsil at the time of abscess drainage. This is called abscess or hot tonsillectomy. This is called abscess or hot tonsillectomy. Okay, abscess or hot tonsillectomy. This is old concept beta. In the bracket go, old concept. We are not doing it nowadays, not done these days beta. Old concept. We are not doing it nowadays beta. It is preferable to wait for 6 weeks and then do the tonsillectomy, and that's called interval tonsillectomy. This abscess tonsillectomy means along with the abscess drainage, at the same time you remove the tonsil also. This is an old concept, we don't do it anymore because there's a lot of bleeding in this type of tonsillectomy. Okay, so quinsy, the tonsillectomy is done after 6 weeks, and that is called interval tonsillectomy. Now you tell me, in quinsy, is there any neck swelling, outer neck swelling? No. No. Did you notice one thing? In quinsy, there is no outer neck swelling beta. Okay, now look at screen beta. This question beta. If same history, everybody look at screen beta. If same history and examination finding as of quinsy are given in the question, plus outer neck swelling close to angle of mandible, the answer will shift to parapharyngeal abscess beta. Parapharyngeal abscess beta. Please understand this question. Quinsy question will never have a neck swelling. But if quinsy like question is given, along with that he mentions there is outer neck swelling close to angle of mandible, then the answer will be parapharyngeal abscess beta. Look at me beta, parapharynx beta. What is parapharynx? Lateral to pharynx beta. Either pharynx, lateral to pharynx beta. Pharynx, lateral to pharynx. This one, parapharyngeal abscess beta. So very simple question. If the question is looking like quinsy, uvula is angulated, trismus is there, plummy voice is there, but must make sure in quinsy, if you're marking answer quinsy, there should be no outer neck swelling beta. In quinsy, there is no outer neck swelling beta. Okay, but if the question is looking like quinsy, but along with that there's an outer neck swelling given close to angle of mandible also, then the answer will be parapharyngeal abscess beta. Parapharyngeal abscess. Now one more word which is similar to quinsy is Quincke disease beta. Quincke. Don't confuse this word with quinsy. Quincke disease is idiopathic edema of uvula beta. Idiopathic edema of uvula is called Quincke disease beta. Can you see uvular edema beta? Okay. Write down very clearly over here. Don't confuse with quinsy. Spellings are almost same beta. This is the importance of this word is sometimes they might confuse you. Quincke and quinsy are different. Quincke is edema of uvula beta. Uvular edema. Can you see the picture beta? Only uvula has got edema beta. Uvular edema beta. Uvular edema. Am I clear beta? Fine. Can we go further? So quinsy is important, very important clue beta. Uvula teda hai. Uvula angulated, plummy, hot potato voice, trismus is quinsy beta. Very simple. If you see the picture, uvula is angulated, quinsy. But only one thing you make sure. In quinsy, there should be no outer neck swelling. If in the question of quinsy, similar question of quinsy, but along with that he mentions there is a neck swelling close to angle of mandible, then please change the answer to parapharyngeal abscess beta. Parapharyngeal abscess beta. Chalo. Now let's go further beta. Retropharyngeal space. Retropharyngeal space beta. Retropharyngeal space beta. Retropharyngeal space. Okay. Fine. Now, the space is divided into two halves by a midline band. Everybody draw a diagram here, beta. Small diagram here. Behind the pharynx, this is the retropharyngeal space, beta. Draw a small vertebra here. Retropharyngeal space, draw the side diagram. Retropharyngeal behind the pharynx, beta. Retropharyngeal behind the pharynx, beta. Okay. Now, it has got two halves. Divide this in two halves. Okay. Fine. Okay. These two halves are called spaces of Gillette. Gillette Mac 3 wala beta. Gillette Presto. Gillette Mac 3. Retropharyngeal space is divided into two halves by midline band. These two halves are called spaces of Gillette beta. Now, all of you draw beta. In these spaces you draw some lymph node beta. Lymph node. Can you draw some lymph node there beta? Okay. Now, these spaces have retropharyngeal lymph nodes. Retropharyngeal space have retropharyngeal lymph node, also called as lymph node of Rouvier. Lymph nodes of Rouvier. R for retropharyngeal, R for Rouvier beta. Retropharyngeal space has got two halves which are called spaces of Gillette. Gillette is Gillette Mac 3 wala spelling. Retropharyngeal space has got retropharyngeal lymph node, also called as lymph node of Rouvier. Lymph node of Rouvier beta. Okay, beta, lymph node of Rouvier. Okay. Now, infection of this lymph node will lead to acute retropharyngeal abscess. Infection of this lymph node will lead to acute retropharyngeal abscess beta. Look at screen everyone. This is your retropharyngeal lymph nodes. By chance, the pus form in this beta. Can you see beta? the pus form in one of the lymph node over there, and this will lead to which abscess? Retropharyngeal abscess. Infection of these lymph node will lead to acute retropharyngeal abscess. Okay. Now, clinical picture. 2-year-old child with respiratory distress, comma, drooling of saliva, comma, and inspiratory stridor. Inspiratory, add the word inspiratory stridor. What is stridor? What is stridor? Noisy breathing, beta. Stridor, noisy breathing, beta. You know, upper part will lead to inspiratory stridor, lower part expiratory stridor, middle part biphasic stridor. Pharynx is upper part, na? Supraglottis, upper part, na? Supraglottic problem, inspiratory stridor. Pharynx, inspiratory stridor. Okay. X-ray neck will show widening of prevertebral shadow. X-ray neck will show widening of prevertebral shadow, beta. Okay. Can you see, beta? This is your vertebra. This is your vertebra, beta. This is your vertebra. X-ray neck is there. Okay. This is your pharynx area. Behind the retropharyngeal space is here, beta. Behind the pharynx is retropharyngeal space, and then behind that is vertebra, beta. Look at me, beta. Pharynx, retropharyngeal space. What is there, beta? Vertebra, beta. So this is pharynx area. This is the area of the abscess, beta. Behind the pharynx there is a big white shadow. This is called widening of prevertebral shadow. Let me put a star over there. This is what I am telling, beta. This one. This is the widening of prevertebral shadow. Look at the complete X-ray, beta, like this. Please mark it. This is the area I am saying. Okay, widening of prevertebral shadow. This is the finding, beta. Treatment. Number 1, of course, airway management, beta. Airway management. Don't think it's a very respiratory distress. Whenever there is respiratory distress, don't think of antibiotic and other thing. Think of as airway management, beta. Airway management. Number 2, incision and drainage. IND, beta. What is IND? Incision and drainage. IND, beta. Incision and drainage. Okay, bache. So retropharyngeal space has got a retropharyngeal lymph nodes. Retropharyngeal lymph node getting infected will lead to retropharyngeal abscess, and that will be typically a child with difficulty in breathing and stridor. It's a X-ray will show widening of the prevertebral shadow like this. In front of vertebra, you will have a big shadow like that, and the treatment is airway management because patient has got respiratory difficulty, and incision and drainage. Okay. Now, let's go to the next topic. Everybody open up the next topic. Ludwig's angina. Ludwig's angina. Ludwig's angina. Everybody open up the topic. Ludwig's angina. It is infection of floor of mouth, also called as submandibular space. Infection of floor of mouth, also called submandibular space. Submandibular space. Floor of mouth is made by mylohyoid muscle. Floor of mouth is made by which muscle? Mylohyoid muscle. Anatomy question. Floor of mouth is made by mylohyoid muscle. Mylo means mandible. Mandible. Can you see mylohyoid muscle? Everybody look at screen. This is your mandible, beta. M mane mandible. Okay, mandible. What is this, beta, bone? H. What is H? Hyoid. Can you see, beta? There is a muscle here and here. What is the name of this muscle? Mylohyoid muscle. I know. Mylo means mandible, hyoid. Look at me, beta. One mylohyoid here, one mylohyoid here, beta. This is the floor of mouth. Yeah. Floor of mouth is also called submandibular space. This area below the chin, and this floor of mouth is made by which muscle? Mylohyoid. Mylo to hyoid. Mylohyoid muscle, beta. Mylohyoid muscle, beta. Okay, bache? Fine. Now, next line. Source of infection is dental caries. Source of infection is dental caries, beta. Dental caries, beta. Source of infection is dental caries, beta. Look at the screen, beta. Can you see this is mandible, beta? Can you see mandible? I hope you know mandible has got molar, premolar. One of the molar or premolar got some caries, beta. Infection, and that comes from here. Oh, the story will always start with dental infection. The story will be dental infection, beta. Okay, dental infection. Dental infection. Okay, now next bacteria. Which is the bacteria causing it, beta? Now, guys, wherever the bacteria comes, don't write only Staph aureus, Staph aureus, Staph aureus. No. Bacteria, every bacteria is not Staph aureus, beta. Hai na? Oral bacteria, oral, not skin. Oral bacteria, Streptococcus. Bacteria, microbiology question. Bacteria is Streptococci plus anaerobes. Streptococci plus anaerobes, beta. Means mixed bacteria, beta. MCQ and microbiology question. It's a mixed bacteriology, aerobe and anaerobes. Okay, bache? Fine. Mixed bacteria. Chief complaint. Chin swelling and trismus. What is trismus, beta? Chin swelling and trismus, beta. What trismus? What is trismus? Difficulty in opening mouth. Trismus is difficulty in opening mouth. Chin swelling and trismus, beta. Chin swelling and trismus, beta. Okay, fine. Now, treatment is external INT, beta. Incident drainage. Let's see the main point of this topic, beta. Ludwig's angina. Everybody speaks that every angina is not cardiac angina, beta. Don't think every angina cardiac angina. Ludwig angina means something related to ENT, beta. After dental infection, patient develop chin swelling and trismus. This is infection of floor of mouth, beta. Floor of mouth. The story will start from dental infection. After dental infection, the patient develop chin swelling and trismus. Is Ludwig angina. Which bacteria is causing it? Streptococci plus anaerobes, beta. That's all. Okay, fine. Now these are some things you need to just cram up, beta. No need to discuss. It's just some miscellaneous thing I wrote over here. You just for your this thing, whenever you are revising this, at the end of the ENT, you just read all these things. It's okay. But I want to discuss something else, beta. Come over here, beta. Come over for this spot, beta. Everybody, Dharma question. For this spot is ectopic sebaceous gland in mucosa. For this spot is ectopic sebaceous gland in mucosa, beta. Everybody, can you tell me? Sebaceous gland, look at me, sebum. Can you see my sebum, beta? Sebum. Sebaceous gland are part of skin, not of mucosa, not inside the mouth, beta. If by chance sebaceous gland form in the mucosa, they are called Fod's spot, beta. Fod's spot means ectopic sebaceous gland in mucosa, because I know sebaceous gland are part of skin, not of mucosa, beta. Okay, ectopic sebaceous gland in mucosa is called Fod's spot, beta. Okay, reverse smoking is sutta. Sutta, beta, sutta. Reverse smoking is sutta, beta. Reverse smoking means the burning side of cigarette is inside the mouth. Oh. People are crazy, people are crazy. The burning side of cigarette inside the mouth, it's a risk factor for hard palate cancer, beta. Why? The fuming heat will irritate your hard palate, because the burning side of cigarette is inside the mouth, and that can be a risk factor for hard palate cancer, beta. Okay? Now, most common site of oral cavity cancer is lateral border of tongue. If the question says that, what is the most common site of oral cavity cancer? Oral cavity, in general, in the whole world statistics, lateral border of tongue. But most common site of oral cavity cancer in India, India is different, beta. We are having a habit of chewing everything on the planet, beta. We want to chew whole planet, I guess. Tobaccos, katha, chuna, supari, betel nut, pan. We want to chew the whole planet, I guess. You know what? India is different that way, you know what? So, in India, the oral cavity cancer are different from the whole world. So, what is the difference? In the world statistics, the most common site is lateral border of tongue because of smoking and all that. But here, what we do is, look at me, beta. Have you seen people doing pan masala, rajnigandha? Name is ganda, beta. Rajnigandha. Naam hi ganda hai. Naam hi ganda hai. Rajnigandha. How can it be safe for you? Even supari is a very dangerous thing, beta. Now you put that in tobacco and all that, then you do for 5 minutes, they keep doing like this, and then they do that, and then they transfer everything in this gutter. What is this gutter? This gutter is gingivo-buccal sulcus. What is this gutter, beta? This first is gingivo mane gum, buccal mane cheek. This sulcus is gingivo-buccal sulcus, and there you put that whole masala over there. And this masala is the site of the cancer, beta. So most common site of oral cavity cancer in India is different from the world. In the world, it is lateral border of tongue. And in India, particularly if questions, till the time question says in India, don't think India, beta. When the question says in general thing, except PSM. PSM is India specific, beta. But otherwise, if the question is silent about which part of world, it is world statistic, beta. So most common site of oral cavity cancer in general is lateral border of tongue. But in India, it is gingivo-buccal sulcus of buccal mucosa. Gingivo-buccal sulcus of buccal mucosa, beta. Yaad rakhe, beta. They are two different. India is different. We are chewing tobacco. Pan masala, pan parag, rajnigandha, vimal, shikhar, and all that. How many people have died out of this vimal, shikhar business, beta? People think they're eating kesar, beta. They're eating kesar. This, that, what is the name of the actor, What is the name of the actor? Stupid actor. I'm not able to recall his name, actually. That big hoarding. When I go to any city, Ajay Devgan. Ajay Devgan is making people believe that when they eat this vimal, shikhar and all that, they're eating kesar, beta, kesar. You know what? Have you seen that comedy? You know what? Some lady was pregnant and she says, I want very fair child. You know what? Somebody told her that, you should eat kesar in the milk. I will put some kesar in the milk. Morning, evening, you take kesar in the milk, actually. And she saw Ajay Devgan, kesariya, you know what? And she brought this vimal shikhar. And every day she used to put, one pouch in the milk and stir that and drink that. And that's a comedy, you know what? But people get influenced by these people, you know what? That's why they are really causing so much harm to society by propagating something which is dangerous. If Ajay Devgan gets cancer today, he will get to the best hospital of the world, Sloan Kettering, MD Anderson Clinic, to get the surgery done. This Sharad Pawar got the surgery done. But if a rickshaw puller who is impressed by looking at Ajay Devgan's hoarding in the street and he start eating this Vimal Shikhar and all that, if he gets the cancer, where he goes? AIMS Delhi or CMC Bellore or Jibbar Pondicherry or Tata Memorial Mumbai. The waiting list is what? 1 month. Minimum waiting is 1 month for the cancer surgery. In 1 month, a T2 will become T4 and the story changes a bit over there. So this India has got different, there's a lot of, this thing is, oral cavity cancer is very, 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 very important thing, very common thing in India, beta. So one question, most common, add one question, beta. Most common head and neck cancer in India is oral cavity cancer. Most common head and neck cancer in India is oral cavity cancer, beta. Most common oral cavity cancer in India is most common head and neck cancer in India is oral cavity cancer, beta. Oral cavity cancer. Oral cavity cancer, beta. Okay, fine. Somebody asking fire pan. Can it become a risk factor for you? Fire pan, if you are daily eating every day, 2 to 3 times, it can become risky. 1 or 2 times you can try it. We all try. We are not saints here. We are not a saint over here. We are here to try a couple of things. Fire pan, like CP has got one shop with fire pan. 1 or 2 times in a year you can try that. But if you are eating fire pan morning, evening, night, TDS for next 2 years, then you are troubling yourself for sure. Okay. Commando operation, beta. Commando operation is oral cavity cancer. This surgery is done for. Write down. It's a surgery. This surgery is done for. This surgery is done for oral cavity cancer. This surgery is done for oral cavity cancer. This surgery is done for oral cavity cancer. What is the name of surgery? Commando operation. Full form is combined oromandibular resection with reconstruction. 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 With reconstruction. Okay, bache, fine. Is it clear to all? So just couple of statistics over there. Okay. Once again, beta, most common oral cavity cancer in India is gingivo-buccal sulcus of buccal mucosa. But most common oral cavity cancer in general is lateral border of tongue, beta. Okay. Now, next one is that the Fod's spot is ectopic sebaceous gland in the mucosa. Okay, because sebaceous gland are part of the skin, not of mucosa, beta. Okay. Now, next one is commando operation is done for oral cavity cancer, beta. Commando operation is done for oral cavity cancer. It is combined oromandibular resection with reconstruction, beta. Combined oromandibular resection with reconstruction, and this cancer is done for, this surgery is done for oral cavity cancer, beta. Okay, bache, fine. Chalo, everybody. Let us open up the third part now of ENT. Go to the page number first segment of the PDF, and the topic name is nose and paranasal sinuses. Nose and paranasal sinuses. Everybody open up nose and paranasal sinuses. Everybody open up the first page of your this workbook, and let us start the third topic of ENT, and the third topic is nose and paranasal sinuses. Okay. After every major segment, there is one page left over there as a blank page. You can write any additional point over there, beta. Okay. Let us start now. Nose and paranasal sinuses. Everybody open up this one. PNS. Nose and paranasal sinuses, beta. This is my email ID again, drajidhanent@gmail.com. However, the best thing is to write it on Telegram so that everybody can know it. Telegram is the best way. If you have got any question, any query, after you use the chat box. If chat box is not being used by you and you're revising and you want to put a question, Telegram is a wonderful thing to really use. I can put an audio there. You can hear it. Other people can also hear it better. Okay. But still, if you've got a personal question which you don't want to discuss with anyone, if you have anything like that, then you can mail me on this email ID. Okay. I wish you were here. We would have really chatted in person, but it's okay. Now, the next topic, nose and paranasal sinuses. Let us start this one, beta. Are you ready? Everybody, are you ready with the nose and sinuses topic now? We've done larynx, done pharynx, and now the first topic out of nose and sinuses is external nose, beta. Are you ready for that? Write in the chat box. Are you ready to learn the third topic? Are you excited to learn the third topic? Write in the chat box, beta. Forget about attending classes, finishing a subject. My question to all of you is, are you excited to learn the third topic of ENT? Because are we just working at a spinal level, Or are we able to create interest in your mind to learn the subject, to know the clinical things, to know the anatomical things, to become better doctor of the future also? My concern is not just FMG. That's one step. After that, I want you to become able practitioners, good doctors of your society, wherever you belong to. Okay? Are you excited to learn the third topic? Thank you, Rajput. Very good. Very nice. Okay, so let's start the first topic. Beta. The first topic is external nose. Beta. Now, external nose is made of 4 paired structures. Everybody, external nose is made of 4 paired structures. But first understand and we'll see the notes. Beta. External nose is made of 4 paired structures. Thank you, Tejaswani. Thank you, Rahul. Thank you to Rahul. Okay. Now, what are the 4 paired structures? 4 paired structures. Beta. 4 paired structures. Nasal bone. This is nasal bone, beta. This area is nasal bone, beta. Look at this, beta. Guys, this is what you have to really understand. This is external nose, beta. Everybody, this is external nose. Everybody is so particular about this nose, beta. Everyone, we keep looking in the mirror. Oh, it's a straight nose, or a deviated nose, or a mota nose, or a patla nose, or a sharp nose. This is very much, very much we are concerned about this outer look of our body. You know what? This is very much, everybody look in the mirror like that. Na, hai na? Teda hai, whatever, seedha hai, acha hai, tikha hai, mota hai. But don't worry, just 5 millimeter deep to the skin. Everyone is same. Everyone is same, beta. Just 5 millimeter deep to the skin. Everyone is like this only. Don't worry. Outer thing is anything. What counts is what you are inside, not outside. Outside, everybody wants to look perfect. I am the most perfect person on the planet. I want to prove it to the other people. I don't know why we want to prove it. Nobody gets convinced by your this thing, beta. No one is perfect. What matters is what you are doing, because you know what you are. You know what you are. Why to prove to other people? Why you want to prove it to other people? It's okay. Whatever. You are concerned about your relatives. You know what? Oh, what will they feel if I do not pass? They won't feel anything. They feel, most of them will be happy. Most of them will be happy, unfortunately. I'm sorry to say that, but that's a fact. Why to bother about those people who are happy with their failure? I have a question to all of you. We're too concerned about other people. We're too concerned about what people feel about us. We're too concerned about what they will feel with our failure. They will not feel anything. At the most, they'll feel happiness. Most of them. Except for few people, few friends. Mother, father, siblings. They're the ones who stand with us. Let us be bothered about them, not about 99.9%. So your fear is that what if fail, what do they feel? Nothing. Don't worry. You are doing it for yourself, your own life. The moment you clear the exam, you become financially independent. I'm not saying you become rich, but at least you start earning 60, 70,000, and in Delhi you start earning 90,000 rupees as a JR after internship. Not a bad money. Within 3 months you earn 2,70,000. Not a bad money. It's good money. When the first salary came in my account, when I was doing PG, of 3 months salary, I suddenly felt, I am Tata, I am Birla. I'm Ambani, I'm Adani. That typical feeling of Aham Brahmasmi, Aham Brahmasmi. This exam will give you financial independence. You're not dependent on anyone. Not anyone, beta. Doctors never die of hunger. Doctors never die of hunger, beta. Have you ever seen a doctor dying on the road or died on the road with kwashiorkor or marasmus like that, with the bones like out? Have you seen a doctor, a picture in a newspaper who died of hunger? Hunger. The major worry of the human is hunger. I should not die of hunger. Okay? But doctors never die of hunger, beta. We have got sufficient things. So this exam will make sure that you get sufficient money to survive yourself. For females, it's very important. No female should be dependent on a male, actually. No female should be dependent on a male for anything. Anything means anything. Nobody should marry someone and be in the marriage because somebody else is earning for you. A female should be independent. Independent. I can survive on my own too. I'm living with you by choice. Two people should live together by choice in a marriage. Not that one person is dependent on the other person. My wife earns 3 times more than I do. She can kick me out of the house anytime, actually. That's a dream I have for you also. May God bless you. This is a dream I have for you also. May you become financially independent. I'm not rich. May God give you richness also if you want it. But at least becoming financially independent means that I'm not dependent on anyone. I can maintain my own things on my own. Basic things, food, AC, rental, maybe a small car, etc. I can manage on my own, actually. This exam is going to give you that financial independence after your internship is over. So let's work for ourselves, not for others. Let's not look outside what people will feel. Let's look at us, that it's one life to live, one life to love. I want to do it fully. Yes, I failed last time, okay. This time I want to really try my level best to make it happen. This is my first time I'm appearing in the exam. I want to finish in the first go itself. I want to start my life at the earliest possible. So, not outward thinking, but inward thinking. Inward, everybody is same. And you know what you are inside, actually. So, external framework is made of 4 paired structure. Beta. Number 1 is nasal bone. Beta. Can you see, beta, this point number 17? This is your nasal bone, 17 number, nasal bone. After that is some cartilage over here. Beta. What are the cartilages? Please see over here. This is nasal bone area. This upper lateral cartilages. Then we have got lower lateral cartilages. Okay. Then we have got small cartilages which are called lesser alar or sesamoid cartilages. Lower lateral, also called as alar cartilages. They look like this U. They form the external opening of the nose. The lower, this is lower lateral cartilages. Look at me, beta. Look at me. This is a lower lateral cartilage. This is one cartilage here. So nasal bone, upper lateral cartilage, lower lateral cartilage, beta. Okay. Now let's come back to the PDF, your workbook, beta. External nose is made of 4 paired structures. Number 1, nasal bones. Number 2, upper lateral cartilages. Number 3, lower lateral cartilages, also called as alar cartilages. ALAR. They form external opening of nose, beta. Add the word of nose. They form external opening of nose, beta. They form external opening of nose, beta. They form external opening of nose, beta. Okay. Number 4, lesser alar or sesamoid cartilages. These are small cartilages between upper lateral and lower lateral cartilages. These are small cartilages between upper lateral and lower lateral cartilages, beta. Okay, fine. Let's revise once again, beta. Now this picture describes everything, beta. Everybody, this picture describes everything. External nose is made of 4 paired structure. Number 1, bolo beta, bolo speaker beta. Number 1, nasal bones. Number 2, upper lateral cartilages, a major chunk. Number 3, this lower lateral or alar cartilages or alar cartilages, they form external opening of nose. And number 4 is lesser alar or sesamoid cartilages. These are small cartilage between upper lateral and lower lateral cartilages. That's external nasal framework. Okay. Now let's go further, beta. Next is nasal valve. All of you touch this area with me, beta. All of you touch this area. Everybody look at screen, beta. Look at screen. And everybody, I'm putting an arrow and you touch that area, beta. This area. All you touch this area. This area, you can feel the junction of upper lateral and lower lateral cartilages. This area is labeled as nasal valve area, beta. Nasal valve, it's a junction of upper lateral and lower lateral cartilages. It's junction of upper lateral and lower lateral cartilages. Now, sometimes what happens is the nasal valve can be collapsed, beta. Can you see? What is nasal valve? Junction of upper lateral and lower lateral cartilages. This is, can you see the nasal valve is collapsed, beta? Look at screen, beta, everyone. Can you see nasal valve collapse? Oh, this is normal side, this is a collapse side, Now, how to check the problems of nasal valve or how to check the obstruction at the level of nasal valve is a test called Cotter's test. Cotter's test is done to check the blockage of nasal valve. Cotter's test is done to check the blockage of nasal valve, beta. Look at screen, beta. First of all, understand Cotter's test, C-O-T-T-L-E. Look at me. How we do it? Look at me, beta. Look at me. We keep the 2 finger on the cheek and pull it outward, beta. If this makes the breathing better in this patient of nasal valve collapse, mean nasal valve is obstructed. Okay. So Cotter's test, C-O-T-T-L-E. C-O-T-T-L-E. Cotter's test is done to check. Write down. This is Cotter's test, beta. This is Cotter's test. Is done to check blockage of nasal valve. Cotter's test is done to check the blockage of nasal valve. This is the MCI question. I mark it MCI question. Cotter's test is MCI question, beta. Okay, beta, MCI question. This is a VQ, mane visual question also, beta. Okay, bache. Cotter's test is done to check the blockage of nasal valve. What is nasal valve? Again, repeat with me. Nasal valve is junction of upper lateral and lower lateral cartilage. This is the nasal valve area. Sometimes this valve can be collapsed. Which test we do to check the blockage of nasal valve is called the Cotter's test. And how we do it? We keep the 2 finger on the cheek and lift it outward, beta. If this makes the breathing better, then nasal valve collapse is the problem, beta. Okay. So Cotter's test is a visual question, is a one-liner question also, beta. Let us go further, beta. Now saddle nose. Saddle nose, beta. Saddle nose is depressed nose, beta. Can you see saddle nose, beta? Can you see there is a depression here, beta? What is saddle, beta? In English, saddle is horse's saddle. You know, घोड़े की काठी, horse's saddle, beta. You know, horse's saddle. You know, horse has got a saddle means जिसमें घोड़े पे बैठते हैं ना, saddle. Saddle means depression. Saddle nose is depressed nose, beta. What are the causes of the saddle nose? Very common problem in our practice. But we see, number 1, trauma, leprosy, tertiary syphilis. Put in a question, beta. This is the MCQ, beta. Tertiary syphilis and septal surgery, beta. When you are operating the nose, you may destroy the septum too much and there will be depression of the nose, beta. Okay, bache, fine. Treatment is augmentation rhinoplasty, surgery, beta. SX1 is surgery, augmentation rhinoplasty by using iliac crest graft. augmentation rhinoplasty by using iliac crest graft, beta. Iliac crest graft, beta. You know iliac crest, beta? Where is iliac crest? On the hip bone, beta. Look at me, beta. This is iliac crest, na? Here. You take a graft from here and you make a small bony graft and put in this area to fill the defect, beta. Augmentation means to fill the defect. Augmentation. Augment means to fill the gadda, to fill the defect. Augmentation rhinoplasty by using iliac crest graft, beta. Okay, fine. Now, next, rhinophyma. Rhinophyma. Very important. VQ, beta, dermatology visual question, beta. VQ means visual question of derma. First of all, see this, beta. Can you see, beta, over here? The rhinophyma, beta. This picture, don't forget. No, nose having, irregular kind of swelling here and there. The rhinophyma, okay? Rhinophyma also called as potato nose, beta. Potato nose. Potato nose, beta. Okay? It is hypertrophy of sebaceous glands of skin of external nose. That's MCQ, beta. It is not a tumor. It's only hypertrophy, beta. Please don't forget rhinophyma, beta. Rhinophyma, potato nose, it is hypertrophy of sebaceous glands of skin of external nose, beta. It's not a tumor, okay? Only a cosmetic problem. It's more common in males, beta. It's more common in males. If you remember, Om Puri, a Bollywood actor. Om Puri, a Bollywood actor, had the same kind of nose, beta. If you remember, Om Puri had smallpox also, by the way. Om Puri had got this kind of nose also. More common male. Males, Om Puri, male. Hai na? It's more common males, beta. Okay? It's not a tumor. It's only a cosmetic problem, beta. Okay? Fine. Rhinophyma, also called as potato nose, beta. Okay, will you remember it, beta? Don't forget this picture, beta. Please make a mark in your brain. Some nose with this kind of appearance, it's not a tumor. It's only hypertrophy of sebaceous glands of the skin of external nose, and it's called rhinophyma. PHYM, rhinophyma or potato nose, beta. Potato nose. Now, one more question of VQ, beta. Derma question, beta. Visual question. Most common malignancy of skin of external nose is basal cell carcinoma, also called as rodent ulcer. BCC, basal cell carcinoma or rodent ulcer. How present, beta? Write down non-healing ulcer with rolled out edges. Non-healing ulcer with rolled out edges, beta. Non-healing ulcer with rolled out edges. Non-healing ulcer with rolled out edges, beta. Can you see, beta? Can you see there is ulcer here at the nose and the edges are rolled out edges. Non-healing ulcer with rolled out edges, beta. Okay, bache, fine. Am I clear, beta? Non-healing ulcer with rolled out edges, beta. Write down. The same lesion can be seen on pinna of ear also, beta. Pinna of ear, beta. So, basal cell carcinoma or rodent ulcer, they can give you at two places, beta. One is nose, other is pinna of the ear, beta. So, this kind of ulcerative lesion which is non-healing with rolled out edges, any non-healing ulcer shown on the nose or pinna, please mark it basal cell carcinoma or rodent ulcer, beta. Don't dissect the question too much. Don't over and think and change the question answer to a rare answer and mark the answer wrong, beta. Don't do that. Any non-healing ulcer shown on the pinna or on the nose, please think about basal cell carcinoma or rodent ulcer, beta. Okay, bache? Fine. Chalo. Aage chale, beta. Visual question, beta. Now, one next is rhinolith. Rhinolith, beta. Rhinolith is formation of stone in nasal cavity. Formation of stone in nasal cavity. Formation of stone in lith. What is lith? Lith one is stone, beta. Formation of stone in nasal cavity. Now, okay, am I seeing this in the OPD? It's a very common thing, beta. Some stony kind of mass form in your nose. From where this, all the material comes? Air. Air has got multiple impurities of different salts. They come and deposit in your nose through air and they start getting bigger and bigger and bigger in size, and this is what the picture is. Now you think like a doctor, you're future doctors, think like a doctor. If you've got a stone in the nose, what symptom it will generate? Number one, pain. So pain, headache. The pain will go to the head also, headache. Nasal blockage. Bad smell from the nose, foul smell from nose. Why? It's a foreign body kind of thing, no? Bad smell from the nose. And epistaxis, bleeding also. Can you see? It will touch the mucosa and that will be starting bleeding, epistaxis. Read the symptom, nasal pain, headache, blockage, foul smell, epistaxis. Treatment is endoscopic removal. Endoscopy removal. Very simple question, it's not never, this question has never come in the exam, but you should know a couple of things just like that also. It's not everything exam. Rhinolith, stone in the nose is a possibility clinically, beta. You should know. Now, the next one, very common thing, very common is, I think this one you would have maybe seen or you would have will see. Can you see foreign body in the nose, beta? Can you see this P color? Can you see some color thing has foreign body in the nose, beta? Foreign body nose, it is more common in school age children. Foreign body nose is more common in school age children, beta. Foreign body nose is more common in school age children. Foreign body nose is more common in school age children. Guys, do you remember school age, beta? School age, the most wonderful age, school age. You know, school, you use a pencil box, beta, pencil box. And that pencil box had got a lot of things, you know, erasers and pencils and scale and whatnot. And if you remember, in those days, we used to have pencils with inbuilt eraser at the end, beta. Pencil ke piche eraser laga hota tha, inbuilt eraser. In those days, even that pencil with eraser was a big thing for us. But today, even the iPhone is a basic thing for us. Even iPhone is not a big thing here. It's iPhone, not a V phone. iPhone Pro, iPhone 12, iPhone 13, I don't know where we are going actually. Nothing gives us a kick now. That's a very sad thing, unfortunately. But in those days, I remember, even a pencil with eraser at the back used to be a big thing. I don't know which school you studied. I studied from a government school. So government school are real different schools, you know what. In government school, I remember, you know what, teachers are roaming around here and there, you know what, and some kids are busy in their own world. And you know what they're doing? They're rotating that eraser in the nose. They're having very good time. They're rotating the eraser in the nose, and the teacher would take a round in the class. He will look at the student who is rotating the eraser in the nose and is having good time, and teacher doesn't want students to have a good time. He slaps him in the face from the side. What are you doing? And this poor chap removed the pencil and he says, oh, eraser is still inside the nose. Eraser is still inside the nose, beta. And now he's scared. He doesn't want to tell his dad or mom that, oh, eraser is in the nose. He wants to keep quiet because, you know, if he tells his dad that, you know, eraser is in the nose, another slap from the father also. He doesn't want that. He keeps his mouth shut. 3-4 days passes. The foreign body in the nose, eraser gets infected. So, from the infected foreign body, the pus comes, the smell comes, the blood comes, and the same question comes in MCI. MCI, beta. Read the question, beta. 7-year-old child presenting with 7-year-old child presenting with unilateral, foul-smelling nasal discharge. The key word is highlighted word unilateral is the key word. 7-year-old child, the key word is unilateral, foul-smelling nasal discharge and epistaxis. Single side smell, single side discharge, single side bleeding. Beta. Why single side? Because it is due to foreign body in the nose. Beta. Due to foreign body in the nose. Beta. Treatment is endoscopic removal. Treatment is endoscopic removal. Beta. Endoscopic removal. Treatment is endoscopic removal, beta. Put an endoscope, pull it out. Lot of foreign body we remove, beta. Lot of foreign body we remove. You know, foreign body, like, you know, this is very common. Eraser are very common. Wax color are very common. You know, wax color, they put in the nose. This is very common. This, for example, you know, pea seed, mutton, rajma, tamarind seed. The children keep putting something else in the nose. I don't know what they want to do. But some children have a habit of putting one or other thing in the nose, beta. Sometimes rajma, sometimes tamarind seed, sometimes pea seed or whatnot. I don't know what they want to grow in their nose, beta. But they keep trying it. You know, probably they want to trouble their parents, I guess. You know what? That's what they are feeling. I remember one child, you know, in my clinical practice, Lady Harding Medical College, you know. I was removing foreign body from the nose. There's so many paper, beta. Papers here, paper. Whole nose is full of paper. So many paper. It took me time to remove all the papers. So many paper, not one paper. Many paper folded here and put in there. Every paper. We removed it, we washed it, and then after in the evening, I met that child in the ward before discharge. I said, what's your name? He said, Atul. My name is Atul. I said, Atul, come here. I said, what was that paper? Tell me, what was that paper? He looked around that his father is not there. And then he told me, coming close to me and said, doctor, uncle, it was my mark sheet. It was my mark sheet. He didn't score well. He wanted to remove, teacher must have given the mark sheet to get signed by his father or mother. He tried to just, you know, evaporate the evidence totally. He just tore the mark sheet apart and he put everything folded, didn't throw in a dustbin, I don't know why, but he put everything in the nose. Sometimes they have the habit like that. Endoscopic removal. Okay, we have to do endoscopic removal. This is a star question of MCI, beta. If you ever get a younger child, 6-year, 7-year-old child with single side smell, single side blood, single side discharge, it's 100% foreign body in the nose. Now on PG level question. If there's a disc battery, read the question, beta. If there's a disc battery in nose, ear or esophagus. Disc battery in nose, ear or esophagus, beta. Have you seen a disc battery, beta? You know disc batteries? You know, calculator batteries, watch battery, small disc batteries. Now these are active batteries, beta. These are active batteries. These are alkaline batteries. They're coming in contact with the mucosa or skin or anything. They will start leaking the alkali, beta. And the alkali can damage the human tissues. And the alkali will cause necrosis. Can you imagine a child swallowed this disc battery? It's active battery, he swallowed it. It goes to esophagus. If you don't remove it urgently, then this may lead to leak of alkali in the esophagus, and that can lead to esophageal perforation. Esophageal perforation. Esophageal perforation. That may lead to esophageal perforation, beta. Esophageal perforation. That may lead to esophageal perforation, beta. Am I clear, beta? Esophageal perforation. Esophageal perforation, beta. Okay, beta, fine. Okay, done. Cha. Go to your notes, beta. And EPG question. If the disc battery nose, ear or esophagus, treatment is urgent removal. Write down urgent removal, beta. Not removal. Urgent removal because these are dangerous batteries, beta. They are active batteries. They may release alkali and alkali cause necrosis, beta. And you read esophagus can lead to perforation, beta. Write down perforation. They can cause perforation of esophagus, beta. They can cause perforation of esophagus also, beta. Am I clear, beta? Urgent removal. Perforation can happen. Okay. Let's go further. Myiasis. Myiasis, beta. What is myiasis? Presence of maggots in nose, beta. Maggot. Presence of maggots in the nose, beta. Maggot. Maggot in the nose, beta. These are maggots, beta. Can you see, beta, maggots, beta? These are maggot, beta. Maggot, beta. Dekh ke acha laga? Are enjoying it? Can. These kind of keede makoode in the nose, beta. Maggot. What is a maggot? Maggot. Right, just read that. Maggots are, what are maggots? Maggots are larvae of housefly, beta. Maggots are larvae of housefly, beta. This is maggot, beta. This is maggot. Maggots are larvae of housefly. Okay. The maggots are larvae of housefly, beta. Housefly, you know housefly? You know, the flies are in every house and the foul smelling condition lead to myiasis, beta. You have a foreign body or anything which emits bad smell and the flies are attracted by the bad smell. They enter the nose. Inside the nose, they lay eggs. Inside the nose, they lay the eggs. From the eggs, the larvae come out and those larvae are called maggots. Maggot is larvae of housefly and the scientific name of housefly is Chrysomia, beta. Chrysomia. Chrysomia is the name of the family, beta. I hope you remember the 11th class torture, zoology. Zoology, beta. Remember housefly, the commonest housefly is Musca domestica. Musca domestica, beta, if you remember. I know I remember it still. I think I studied a lot in my MBBS preparatory days and then in my PG preparatory days. 2 times I studied a lot in my life actually. And I still remember those all bryophyte, pteridophytes, gymnosperms, angiosperms. You know, I think I still remember them because at that time I had to study. I told you that I had no option of going out of the country to study. When my dad said only one thing, one chance to study. One chance only, you know what. Otherwise you have to sit in the shop, you know what. You know, that's that. I was really not keen to do that. The shop thing and all that. So I really had to study a lot. So this is still within me, Musca domestica, Mangifera indica, you know what, like that. So, but you know, if you remember, we used to taxonomy. If you remember taxonomy, you know, the species, the genus, the the phylum, the family, the order, and the the kingdom. You know what? So family, the family of the housefly is Chrysomia, beta. Foul smelling condition will lead to myiasis, beta. Now treatment. What if you have got some insect like this in your nose, beta? This is there in your nose. Would you adopt them? No, you have to kill them. Of course, kill them, na. However kind you may be, you can't adopt them in your body. You have to kill them. But killing doesn't mean that you put the black head spray in the nose. You know black head spray? Head spray. Don't put the black head spray in the nose, boss. 10 spray. No, that's toxic for the humans also. For killing them, you have a special oil called maggot oil. Now, maggot oil contains what? Maggot oil contains chloroform. Right? Now, maggot oil contains plus turpentine oil, beta. MCQ, beta. Chloroform is the main thing, beta. Oil can be any. Maggot oil contains chloroform plus turpentine oil, but main thing is not turpentine oil. Main thing is highlight the word chloroform. Chloroform is the main ingredient which kills the larvae, beta. Chloroform, beta. And use mosquito net also, of course, because you have to keep the flies away from the patient. Chloroform. Chloroform is the main energy. Oil can be any, beta. Okay, chloroform is the main thing. Actually, you cannot put the pure chloroform in the nose, beta. Why can't you use the pure chloroform in the nose, beta? I hope you know chloroform is anesthetic agent. Anesthetic agent. If you put pure chloroform in the nose to kill the larvae, in the overdose, it may kill the patient also. In the overdose of the chloroform, it may kill the patient also, beta. Then attendant will ask you, sir, maggot, मर गए. Patient, वो भी मर गया. तो क्या बोलोगे? यहाँ भाई थोड़े side effect तो हैं इसके. नहीं ना? You can't do that, na? So better dissolve the chloroform in the turpentine oil. When you dissolve the chloroform in turpentine oil, it cannot evaporate. Then it is not an anesthetic agent. Okay? Next one. Nasal bone fracture. Next topic, but everybody get back to the next topic. Nasal bone fracture. Nasal bone fracture. It is the most commonly fractured bone of face. Yes. Nasal bone is a very delicate bone, beta. I showed you, very delicate bone. It's the most commonly fractured bone of the face, beta. Okay. Now please look at the screen, beta. Let me show you. Sometimes this bone, beta. Can you see point number 17, beta? It's a very thin bone, beta. something got hit on the nose and the bone got fractured. And when you see the patient, it looks like this, beta. Okay, can you see the deformed nose, beta? Deformed nose. And when you move the, fractured bone, there's a click, click, click kind of sensation that is called crepitus. Crepitus, beta. Okay, orthopedic radius got fractured. If you do click, 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 if the bone is fractured, if you move the fractured part, tick, click, click, click kind of sound is called crepitus, beta. Write down on the side, write down. Clinical picture: nasal deformity, crepitus, plus minus swelling in the bracket in late cases. If patient come next day, then swelling also. So patient has nasal deformity, crepitus, plus minus swelling in the late cases, beta. Okay. Now, treatment. Write down treatment A and B, beta. A and B. A is immediate close reduction before edema starts using Walsham forceps. WALSHAM. Walsham forceps, beta. Using Walsham forceps, beta. WALSHAM. Walsham forceps. But B, if edema is already there, then wait for 7 days and then reduce fracture. So 2 questions, beta. If edema is not there, if swelling is not there, then you have to do immediate close reduction before edema starts using Walsham forceps. But B, if edema is already mentioned in the question, then wait for 7 days and then reduce the fracture, beta. Okay. Why wait for 7 days? Wait for 7 days for edema to subside. Why wait for 7 days for edema to subside, beta? Why wait for 7 days for edema to subside, beta? To subside. For edema to subside, beta. Let's see the patient, beta. Let's see the patient, everybody. This is your patient, beta, who got the nasal fracture, who got the nasal deformity. There is a crepitus also. There may be swelling, there may not be swelling. Swelling come in the late stages. And this patient, if you do the X-ray, beta, can you see? Write down one word over there in the sidebar. Write down side word. Write down on the here. Write down investigation, beta. Investigation will be X-ray nasal bones, beta. X-ray nasal bones, beta. X-ray nasal bones, beta. Okay. Now how the X-ray look like, beta? Look at screen, beta. How the X-ray look like? Please see over here, beta. Now please see over here X-ray. Can you see? This is your nasal bone fracture, beta, over here. This is your nasal bone fracture over here. Am I clear? Fine. X-ray. This is the, can you see the bone is fractured at the white arrow, beta? Okay. Now the treatment is of 2 types, beta. If the question has got no mention of swelling, then you do immediate close reduction before edema start using which forceps, beta? Using which forceps? Walsham forceps. Using which forceps? Walsham forceps, beta. Walsham. Can you see Walsham forceps? But if the question says that if edema or swelling is already present, then wait for how many days? 7 days for edema to subside and then do the fracture reduction. Okay, beta. Now how we do it? Let me show you, beta. Let me show you. If you see this one, this is your fracture reduction, beta. Please see, this is your trauma point. Can you see the black trauma point, beta? This is your trauma point. Patient is under anesthesia. This is close reduction, beta. What is the name of the forceps? Walsham forceps. Close reduction means you are not giving a cut on the skin. And then with the finger, you bring the bone back to original position, beta. This is immediate close reduction before edema start using Walsham forceps. But if edema is already there, then you wait for 7 days and then do the fracture reduction, beta. What is the name of forceps? Walsham forceps, beta. Okay, can you see Walsham forceps, beta? Okay, now let's do further. Next is septum fracture, beta. Everybody, next is nasal septum fracture. Nasal septum fracture, it's of 2 types, beta. Look at me, beta. It's of 2 types. Look at me, everybody. Nasal septum fracture is of 2 types. Now, where is the septum, beta? Idhar dekho. Where is the septum? Over here. This is septum, beta. This is septum. Am I clear? Now, the fracture can be of 2 types. If the force is from front, like this. If force is from like this, beta. Force is, look at me, beta. If the force is from front like this, from front, it will cause horizontal fracture. But if force from below, like this, from below, it will be vertical fracture. From front, horizontal fracture septum. From below, vertical fracture septum. So if force is from front, horizontal fracture. And that's also called Zar-Za-Wave fracture. Bolo beta. If force is from front, it will lead to which fracture? Horizontal fracture. What is the name of fracture? Bolo. Speak up. Zar-Za-Wave fracture. And if force is from below, If force is from below, beta, from below, it will lead to vertical fracture, also called as Chevrolet fracture. Chevrolet fracture. So two type of fracture, beta. Force from front, horizontal fracture or Zaza fracture, and force from below, vertical fracture or Chevrolet fracture. Treatment is fracture reduction. Fracture reduction using ASH forceps, beta. ASCH. Fracture reduction using ASH for ASCH. Fracture reduction using ASH for ASCH. Fracture reduction using ASH for ASCH. ASH for. Anybody, what is the name of the forceps for the nasal bone fracture reduction? Was Walsham forceps. Walsham. What is the name of the forceps for the fracture reduction of the septum? The for the septum we have got ASH for ASCH. ASH forceps. Can you see what Walsham forceps, ASH forceps? Walsham forceps are for the nasal bone fracture reduction. ASH forceps are for the septum fracture reduction. Okay, let us go further now. Everybody, let us go further. Next one is zygomatic fracture or tripod fracture. Beta. Next topic, beta. Everybody open up now. Everybody go open up. Zygomatic fracture or tripod fracture, beta. Tripod. This is a question, beta. Tripod fracture, zygomatic fracture, tripod fracture. It is the second most commonly fractured bone of face, beta. Everybody, can you tell me what is the most commonly fractured bone of face? Nasal bone. But second common is the zygomatic fracture or tripod fracture. Everybody, can you tell me where is your zygomatic bone, beta? Can you look at the, everybody touch this area, beta. Everybody, can you touch this? Can you see the white arrow, beta? This is your zygomatic bone, beta. Everybody, zygomatic bone. This is the zygomatic bone. This is the body of zygoma. Okay? This white arrow represents the zygomatic bone now. Now let us look at this bone from the side angle, beta. Let us look this bone from the side angle, everybody. You will see that this patient would be having, this is the body of zygoma. Okay? Please understand, now this bone has got a body and this bone has got three processes, beta. Now look at it, number one. Number one makes the infraorbital margin. Number two makes the lateral orbital margin, and number three makes the zygomatic arch. You know, side on the side of the arch, beta. So one, infraorbital margin. Two, lateral orbital margin. Three, zygomatic arch. Because this zygomatic bone has got three processes. That is why this is called tripod fracture. Tripod fracture. Okay. Now let me tell you one clinical anatomy thing over here, everybody. Clinical anatomy thing over here. Please see on the screen, beta. Everybody look at the screen. Now what happens? Can you just see and see there is a foramen over here, beta. This is a foramen over here, this one. Let me enlarge for you. Below the orbit, there is a hole over here, and this foramen is called infraorbital foramen. I'm clear, beta? It's called infraorbital foramen, beta. Okay? Infraorbital foramen. From infraorbital foramen, one nerve comes out, and that is called infraorbital nerve, beta. The foramen is called below the orbit, infraorbital foramen, and the nerve is called infraorbital nerve. Now, first understand it. All of you touch your cheek, this cheek, brother. All of you touch your cheek, and today you learn it. The sensory supply of the skin of the cheek is by infraorbital nerve. The sensory supply of the skin of the cheek is by infraorbital nerve. Now, if any disease damages this nerve, then patient is going to suffer from anesthesia of the cheek. What all diseases can damage this infraorbital nerve? Number one, please see on the screen first of all. If somebody got a zygomatic fracture, don't you think so? Zygoma got fractured. The nerve got cut. Then somebody got maxillary fracture. The maxilla bone get fractured, the nerve is cut. And third thing, important thing, somebody got a cancer, beta. Cancer of this area. The cancer of the maxillary sinus, beta. That is also going to damage the infraorbital nerve, beta. So three things can damage the infraorbital nerve. Number one, the zygomatic fracture. Number two, maxilla fracture. Number three, cancer of the maxillary sinus. All these three things will damage infraorbital nerve, and that leads to anesthesia of cheek. Now you read your notes, beta. Now you read your notes, everybody. Open up the PDF, the workbook, and see, beta. Now, injury to infraorbital nerve is seen in three situations. Label, beta, number one, zygomatic fracture, maxilla fracture, and carcinoma of the maxillary sinus. Okay, write down. Chief complaint, cheek anesthesia. Cheek anesthesia due to injury to infraorbital nerve. Now, this is a clinical anatomy based question. This is a clinical anatomy based question. Cheek anesthesia due to injury to infraorbital nerve. Cheek anesthesia, infraorbital nerve. So, will you be able to handle this question in the exam of clinical anatomy? That cheek anesthesia due to injury to which nerve happen? Infraorbital nerve. In three clinical scenarios, it can be asked: zygomatic fracture, maxilla fracture, and the cancer of maxillary sinus. Now, the next question. Most commonly fractured part of mandible is condyle or subcondylar fracture. One question, beta. Most commonly fractured part of mandible is condyle or subcondylar fracture. Condyle or subcondylar fracture, beta. Am I clear, beta? Fine. Okay, just a one-liner question, beta. Okay, now comes up NEET PG level topic, but you should know it. Mid-face fracture. Everybody look at the beta. What is the mid-face, beta? This is maxilla. This is what is the middle part of face? Which bone? Maxilla. First line. Mid-face fracture means fracture of maxilla, beta. Fracture of maxilla. Now, these fracture of three types. Get used to this word, beta. Bolo mere saath. Leaford 1, Leaford 2, Leaford 3. Everybody, mid-face fracture are fracture of which bone? Maxilla fractures. And these are three types. Leaford 1, bolo beta, which word? Leaford 1, Leaford 2, Leaford 3. Are you speaking when I'm saying it? I want you to hear from your side in the chat box or in message from Telegram or any. Use Telegram today. Let us use it for this group only. If you are not comfortable with the chat box, come over there and tell me, are you speaking when I'm saying you to repeat or not? Give me some visual, evidence that okay, you are doing the same thing, because at least I am imagining that we are together in room. I am imagining together that we are in one room. I hope you are imagining that we are together in one room, because that's what I want to release. How powerful this medium can be, I need to understand from you. So help me understand that. Is it really effective tool of teaching? Please share your views on Telegram or wherever. Are you able to really relate that okay, this cannot be the live class, I understand. This cannot be face-to-face class, but is it getting close to that? Please share your views on either of these channels, because this will help me to decide that okay, how really how these classes can be improved further, or how we can do really further things and all that. Are you getting that we are together? Because this is what it's not a recorded lecture, it is a very live lecture. So are you getting the feel or not is very important for me to learn. Like you want to learn something from me as an ENT, I want to learn from you guys that what is your in general how you are really getting this, because for me teaching is not a profession. For me, teaching or sharing the knowledge is a passion actually. The passion means that I want to transport my data into your head. It's a very clear-cut thing for me. I want to transport my concept into your head actually. That's what I'm trying to interject actually. So please give your feedbacks on that. It's very important. Even I would like to learn from you. Okay. So there are three types of fractures. Speak up with me. Leaford 1, Leaford 2, Leaford 3. Now let us understand Leaford 1, 2, 3 beta. Leaford 1, Leaford 2, Leaford 3 beta. Oh yes, people are writing on wonderful. People are already writing on this thing. That's very good. Okay, I'll take the question also. Okay. Now everybody look at the screen, beta. Please see. This is your skull. This is my skull, beta. Now please see in the screen, beta. Everybody. Leaford 1 is like this, beta. Leaford 1, everybody. This is the Leaford 1. Now read your note, beta. Leaford 1 is called transverse fracture. Transverse fracture. And it passes through along what? Palate, beta. Palate is there. Leaford 1 is transverse fracture. It passes along the palate. So it has two signs, beta. Number 1, floating palate, because it is fracturing the palate. So palate start floating. Palate got separated. Floating palate. Number 2, ecchymosis on the palate, beta. Number 2, ecchymosis on the palate. Ecchymosis means blue color, beta. I hope you know. Ecchymosis means blue color, na? Blue color. When you get trauma, somebody hit you over here, you get a blue color in the morning, beta. That beautiful bruise comes. Bruise. Bruise? Somebody hits your face, there's a blue color over here, beta. Okay? Ecchymosis is blue color, okay? On the palate, and this is called the Guerin sign, beta. This is called Guerin sign, beta. G-U-E-R-I-N. Guerin sign, beta. This is called Guerin sign, beta. Okay. This is called Guerin sign. G-U-E-R-I-N. Blue color on the palate. Ecchymosis means blue color on the palate due to hematoma or trauma. Guerin sign. Leaford 2. Everybody look at screen, beta. Leaford 2 is pyramidal fracture, beta. Look at screen, beta. This is Leaford 2, beta. Leaford 2 is this one. Can you see pyramidal fracture? Can you see pyramid? The yellow color is pyramidal. Leaford 2, beta. Okay. Now Leaford 3. Please see on the screen. Leaford 3 is very dangerous fracture, beta. It is like this, beta. Leaford 3, the black one. Black one. Now Leaford 3 is actually craniofacial disjunction. Cranium means skull cap. Facial means lower part of the skull. Craniofacial disjunction. You know why? This fracture went through and through. The whole of the skull cap got separated from the lower part of the face, beta. And craniofacial disjunction. Oh, very dangerous, beta. Now can you see one thing, beta? Roof of nose is base of brain, beta. This is brain, beta. Brain. And can you see Leaford 2 and Leaford 3 are passing through the roof of nose. Roof of nose is equal to base of the brain also. Now Leaford 2, the yellow one, and Leaford 3, the black one, they are passing through the base of the skull. So in Leaford 2 and Leaford 3, what will happen is, because brain has got what? CSF, beta. The CSF will start flowing from the nose, beta. The CSF will start flowing from the nose, beta. CSF, very risky problem, that if this happens, beta, if this happens, what will happen is, from the nose, what will happen? The CSF will start leaking like this, beta. Let me show you. Can you see it over here? CSF rhinorrhea, beta. CSF rhinorrhea, beta. Can you see? CSF rhinorrhea? CSF rhinorrhea. The drop by drop by drop, the CSF start coming from the nose. Now read your notes, beta. Everybody read your notes. Please see on the notes, beta. Now please see, Leaford 2 is called pyramidal fracture. Leaford 3 is called craniofacial disjunction. Now leaf 2 and leaf 3 passing through the base of skull. So there is a possibility of, write down, there is a possibility of CSF rhinorrhea. So there is a possibility of CSF rhinorrhea. CSF rhinorrhea. There is a possibility of CSF rhinorrhea. Okay, CSF rhinorrhea, and this is called traumatic CSF leak. This is called a traumatic CSF leak, beta. Due to trauma, this is called traumatic CSF leak. So leaf 2 and leaf 3 can have CSF rhinorrhea, and this type of leak is called a traumatic CSF leak, beta. Traumatic CSF leak. Can you see this picture, beta? Let us revise, beta. Mid-face fracture or maxilla fracture are of 3 types. Leaf 1, leaf 2, leaf 3. What is the shape of leaf 1? Transverse fracture. It passes along the palate. So it gives 2 signs. Number 1, floating palate. Number 2, ecchymosis of palate, which is called which sign? Grin sign. Leaf 2 is called pyramidal fracture. Can you see pyramid, beta? Pyramidal fracture. And leaf 3 is craniofacial disjunction. Can you see cranio? The whole thing got separated. This and this got separated, beta. These are risky fracture, beta. Why? Leaf 2 and leaf 3 pass through base of skull. So there is a possibility of CSF rhinorrhea, and this CSF rhinorrhea is called traumatic CSF leak, beta. Because naak se CSF aana is CSF rhinorrhea, and that called traumatic CSF leak, beta. Am I clear, beta? Traumatic CSF leak. Now, everybody, let's go forward. Now, one ophthalmology question. One ophthalmology question. Ophthalmology question. Now, write down blowout fracture of orbital floor, beta. I'm sure you would have done in ophthalmology also. Blowout fracture of orbital floor. Blowout, right on the side, beta. Just on the sidebar somewhere, write down. You always have one page at the end also of every chapter. You can use that space also. Okay, but side पे लिख लो चाहे. Blowout fracture of orbital floor. Write down cause. Cause is large blunt object striking the globe. Okay. For example, golf ball. Golf ball, beta. Large blunt object striking the globe. For example, golf ball. The typical question of the ophthalmology will be golf ball injury to the orbit, beta. Golf ball is a very heavy ball, rounded ball, and just suddenly hits the globe. And which floor gets, which wall gets fractured? Floor gets fractured. So one question is this question. MCQ write down. Blowout fracture is fracture of which wall of the orbit? Is the fracture of the floor of the orbit or the inferior wall of the orbit? Beta. Okay, am I clear, beta? First of all, this is clear. Blowout fracture is due to fracture by some large blunt object striking the globe. For example, golf ball. Okay. Now. Okay. Now. Everybody look at screen, beta. Please understand it. Now this is your orbit, beta. This is your globe. Globe, beta. Orbit, globe, beta. Now please see the screen. And I'm sure you know it, that you have got extraocular muscles. Then you got periorbital fat. Okay. Now, this is the fracture, beta. I hope you know, in the maxilla, we have a sinus called maxillary sinus. Maxillary sinus, beta. Now this is the fractured floor of the orbit, beta. Now from this fractured floor of the orbit, what happens is, the orbital content, they start prolapsing into the maxillary sinus, beta. The orbital content start prolapsing into the maxillary sinus, beta. Like this. The orbital content start prolapsing into the blue color is what? Maxillary sinus. Everybody look at this area, beta. Everybody look at this area. Can you see over there? It's appearing as if a drop of tear is about to fall in the on the maxillary sinus. Look at the black arrow. It is appearing as if a drop of tear is about to fall in the maxillary sinus. This finding, when seen on radiology, is called teardrop sign, beta. Teardrop sign, beta. Now, first of all, see and then we write down. Compare it, beta. I would not say anything. You see it, beta. I would not say anything. Let me be out of the picture totally. You are very able people. Let me be away from you. And you see, and where is the teardrop sign being visible, beta? Teardrop sign being visible where, beta? Let me mark it for you, and you ask yourself, were you not seeing in the same area, beta? Is it that difficult to understand? A teardrop, you don't need me, beta, to understand it. I'm out of the picture right now. You know, I'm out of the picture. You can see, oh, teardrop. The floor of the orbit is fractured, and from that fractured part, the orbital content are prolapsing into the maxillary sinus. It's appearing, look at the yellow arrow, it's appearing as if a drop of tear is about to fall in the maxillary sinus, beta. And this is called teardrop sign. Right now, the CT scan shows teardrop sign. Beta. CT scan or X-ray also, beta. CT scan or X-ray shows teardrop sign, beta. CT scan or X-ray shows teardrop sign, beta. Teardrop sign. Ophthalmology question, radiology question. Ophthalmology question is blowout fracture of orbit is fracture of which wall of orbit? Floor of the orbit or the inferior wall of the orbit? What is the mode of injury? Golf ball injury. Radiology shows which sign? Teardrop sign. That's all. That's all, beta, है ना? We can do these things. They're not that difficult as the books say.